മാറുന്ന ലോകത്തിൽ മാറ്റമില്ലാതെ തുടരുന്ന വിശ്വാസ
facilities, guests and delegates. I feel very joy and privileged to extend my warm welcome to all are presented here for Cor-Kram. Let's begin with the prayer.
Showers of blessings we need. Mercy drops round us are falling. But for the showers we plead. There shall be showers of blessing. Precious reviving again. Over the hills and the valleys. Sound of abundance of rain. Showers of blessings, showers of blessings we need. Mercy drops round us are falling, but for the showers we plead. But for the showers we plead. But for the showers we plead.
Now, I invite Dr. Preeta and Dr. Tamanda for the academic session.
Respected seniors, teachers, and my dear friends, a very good morning to all of you. On behalf of Abate AS Al Salama Eye Hospital, I extend a warm welcome to all of you to Cor-Kram, our CME being held in association with the Malappuram Ophthalmic Society under the aegis of Kerala Society of Ophthalmic Surgeons. Inherently a brainchild of Dr. Shaji Hussain, I was wondering, like a lot of you must be wondering, what is Cor-Kram? So I called him up, and on a lighter note, he let me know that it's basically a pun on in Malayalam as well as English. It is cornea kramigarikia, so that is Cor-Kram. Anyways, Cor-Kram is inherently envisioned as an academic feast, predominantly focusing on cornea, cataract, and refractive surgery. We are fortunate enough to be blessed with a plethora of eminent speakers on these topics, and we look forward to partaking in this rich academic feast.
Abate Al Salama has always been on the forefront conducting academic programs so that professional brethren and our own staff are well equipped to face the challenges of this profession. COVID has somewhat played a negative role in imparting this knowledge. But I'm happy today that we are all here in this offline meeting, taking us back to the original intentions of these CMEs. Once again, a hearty welcome to Cor-Kram, and I hope that after this conference, we'll be more equipped to provide our patients with better care.
We can move on to our first session, which is predominantly cornea session, cornea-based session. Our first speaker, I have the privilege to invite upon stage Dr. Mohammad Swadik. Swadik sir is the backbone of Abate AS Al Salama Eye Hospital. Sir has done his graduation from Kozhikode Medical College and has been a proficient surgeon, cataract surgeon. He's done his training in Shankar Netralaya in phacoemulsification. He's proficient in almost all types of cataract surgeries. He's also a corneal as well as a refractive surgeon, a glaucoma surgeon, you name it, sir does it. With more than 25 plus years of clinical experience and nearly 18 plus years of teaching experience, sir is a sort of a legend. I can attest personally to the fact that sir is an extremely selfless and encouraging teacher. He's my LASIK guru. It is with great, sir is also a fellow of the Royal College of Surgeons, Edinburgh, fellow of the Royal College of Surgeons and Physicians, Glasgow, as well as a fellow of the Royal College of Ophthalmologists of UK. He's a examiner of various graduate and undergraduate and postgraduate universities and examination boards. He's also regional coordinator for the International Council of Ophthalmology Exams. In short, if I start enumerating, it's not going to get over. So with great pleasure, sir, inviting you to share your views on keratoconus.
Hello. Let me start in the name of God, who is the creator and sustainer of the universe. And thank you, Prida, for the nice words. So straight away coming to the point, keratoconus is a common condition, it's a prevalent condition in the community, but it's quite underdiagnosed, underdetected, and quite often misdiagnosed as amblyopia or something like that, especially in the rural areas and clinics where topography is not available. And a little bit of awareness is required in this area. We have to doubt a keratoconus whenever there is a young teenage boy or girl comes with a decreased vision, high cylinders, frequent change of glasses, history of ocular allergy and eye rubbing. So a little bit of suspicion is required to diagnose. And even if centers, you don't have a topographer, you can do a careful slit lamp examination as well as a retinoscopy where you will be able to diagnose most of them, even though the subclinical cases could be missed out. Nowadays, the technology is much advanced, and we could detect more and more cases with the newer topographers and newer techniques. And coming to the clinical features, clinically we could stage it into subclinical, early, moderate, and severe based on these features. And I shall rush through some of the common findings which you can get on slit lamp, like oil droplet sign, walk striae, which is a pressure lines in the cornea, Fleischer ring, and Rizzuti sign, Munson sign, and in frank cases of hydrops, you could get a picture, very obvious picture. And coming to the subclinical, preclinical cases and form first keratoconus, it's a little bit confusing terms. And when you have a frank keratoconus in one eye and the other eye is absolutely normal on clinical examination as well as on topography, you can name it as form first keratoconus. And the other eye, when it's clinically on slit lamp examination, there are no findings, absolutely normal. At the same time, some suspicion on the topographer, you could name it as preclinical or subclinical. And there are different parameters useful for diagnosing a case. The thickness of epithelium as well as stroma. You can get a thinning of the epithelium as well as stromal thinning in the inferotemporal quadrant and thickening of the stroma superiorly. And tomographic features you could measure with Scheimpflug imaging, slit scanning tomography or OCT. And posterior elevation is a feature you could elicit with these methodologies, where if you get an elevation of more than 12 microns, needs to be considered significant, and anything less could be normal. Then corneal surface area, ratio of the anterior corneal surface to the posterior corneal surface is significantly decreased in keratoconic patients. Then coming to the optical parameters, anterior corneal higher order aberrations measured over 6 millimeter of corneal diameter, the vertical coma, root mean square of coma, and root mean square of third order aberrations, these are all altered in case of keratoconus. And higher order aberrations which you get in different stages of grades of the keratoconus. Posterior corneal higher order aberrations are less, comparing to the anterior, it is rare, and total ocular aberrations also increased in case of keratoconus. Corneal biomechanics needs an ocular response analyzer, and it's not that available in our places. Coming to the classification, Amsler chromia classification is the most frequently used, but nowadays it is getting outdated because of availability of newer ones. According to Amsler chromia, we can grade from 1 to 4, and the parameters considered are corneal steepening, the refraction value, the central corneal K value, and thickness of the cornea, and presence or absence of the scar. And newer and more widely accepted classification would be the ABCD classification, where A is the radius of curvature of anterior radius of curvature in the 3 millimeter zone centered at the thinnest part of cornea. And parameter B is the posterior curvature in the same fashion. And C is the pachymetry in microns. And D is the visual acuity, corrected visual acuity. And you get a a chart like this, ranging from 0 to 4 with these parameters. And this incorporates different parameters, and it would be a better description and classification of keratoconus. And with this classification, we can make a progression analysis display on subsequent visits. Here you can see the parameters A, B, C, D, and these corresponds to the subsequent visits. And you can see both A as well as B is increasing in the second and third visits. In this progression analysis, the anterior, the A remains stable or less, but the B, the posterior elevation, is on an increase in the second and third visits. So this is in brief about the classification ABCD system. You can stage it to 5 stages, staging from 0 to 4. How to detect progression? In less than 1 year duration, if you find an increase in astigmatism of more than 1 diopter or a significant change in the axis or a decrease in thickness by at least 25 microns should be considered as significant. And this was a consensus among it's a global consensus in keratoconus and ectatic disease in 2015 that change in at least 2 of the following parameters: thinning of the cornea, steepening of anterior corneal curvature, steepening of the posterior curvature, and increase in the rate of corneal thickness, the change of corneal thickness from periphery to the center of the cornea, to the thinnest point. Any 2 of these following parameters, if present, should be considered as a significant progression determinant. Briefly about the management. First, we have to decide whether the keratoconus is stable or progressive. If it is progressing, we could take it up the patient for cross-linking. And the cross-linking has revolutionized the management of keratoconus in the immediate past, where we could limit the progression and save the patient from going into significant visual loss and hence doing a keratoplasty. Those who are stable, we could first try with spectacle correction, and those who are not suitable for spectacle correction or not getting corrected with spectacles, we could consider scleral contact lenses, corneoscleral contact lenses, RGP lenses. These patients, mostly they don't tolerate RGP lenses. And scleral contact lens, it wasn't available in India in the past, but nowadays it is freely available in India, and it's a good thing for the patients. And those who are satisfied with contact lens, we can follow them up in 6-monthly interval. And those who are not tolerant to contact lens, we could take them up for either intracorneal rings or keratoplasty, either a DALC or PK. So that's in brief. You are going to hear more from the experts. Thank you.
Thank you, Dr. Swadik, for that wonderful opening lecture. Next, we have Dr. Shaji Hussain. Dr. Shaji is a very enthusiastic ophthalmologist with expertise in cataract and corneal surgical skills. He did his cornea fellowship under Dr. Srinivas K. Rao. He has also received his fellowship from the Royal College of Surgeons of Glasgow. He has many publications in various ophthalmic journals and he is actively involved in teaching and academics. He is also the first ophthalmologist to perform Presbyon LASIK surgery in Kerala. Like Dr. Preeta said, Cor-Kram was basically his idea, and it was his dream to bring his mentors, Dr. Swadik and Dr. Srinivas K. Rao, in one stage. He's currently working as cataract and refractive surgeon at Abate Salama Eye Hospital. So without due delay, sir, over to you.
Mic set. Okay, screen. As Tamanna rightly said, this is in fact a dream come true. A wish made in 2015 to bring my SKR and my Dr. Swadik under one roof in Perindalmanna. At that time, we didn't have a grand auditorium like this, but that wish was made. It was taken up by the Almighty, and today we are witnessing that wish and my dream. So thank you to both my mentors for being here. So with that, I'll start my talk. Okay, so this is the presentation of what or why Pentacam. I had a Placido-based topo with me, and there were a lot of patients I couldn't take up for LASIK because I wasn't sure, am I looking at a keratoconic patient, or is this going to progress further on? There were a lot of data that were missing, one. Second, I had to make the patient run to the OCT machine, get the PACI, or to another room to get the ultrasonic PACI done, then to the other sessions. So in fact, it used to increase the time I used to evaluate my patients before my LASIK surgeries. On the contrary, Pentacam has made things a lot faster for me. So I'm going to tell you why. So when you hear about Pentacam, the terminology that should strike you first is, this is a tomographer. Now, when you hear the word tomo, you will be confused about what is topo then. So topo is actually a 2D imaging system. As you can see, you can only see it from the surface. You don't know what is down beneath. So what tomo tells you is a 3D appreciation, and when you talk about cornea, it is corneal tomography. So you can know the undersurface of the cornea as well. So with the undersurface of the cornea means this is about the posterior curvature of the cornea. Why is the posterior curvature important? The last case that I will be giving you will give you that answer. So there is an entity called as posterior cornea. If you happen to miss it, there are all possibilities that you may proceed this patient for LASIK and later on he may land up in post-LASIK ectasia. So going on, for the books, again, Pentacam is the true tomographer. It is based on the Scheimpflug principle. Then the doubt arises, what is OBSCAN? See, OBSCAN is based on slit scanning and it is not a true tomographer. There are a lot of flaws to the evaluations, especially with regard to the pachymetry or the corneal thickness assessment. This is Scheimpflug's principle. You must have heard it in a lot of presentations. Don't worry, I'm not going to explain it. Now, this is what I'm assigned for. If, as general ophthalmologist or corneal surgeon, okay, as a corneal surgeon or as a general ophthalmologist, if you happen to see this paper in your hand, you should be able to solve it. Let you be a general ophthalmologist, you can be a pediatric ophthalmologist, you may be an optometrist, but I want to solve this mystery for you because it was a mystery for me long ago. So I have done my level best to simplify this page for you. So to start with, that is the first thing you have to look at. This is called as the demographic. There, the patient's name, the date of birth, which eye has been examined, what date was it examined, and what time was it examined is given. In this, it's mainly the eye and the date of birth of the patient is what is important. Next, it's this. That is telling you about the anterior cornea. What is the K1? What is the K2? What is the K-man? Then what is the astigmatism? Also, this is an important thing to look at, that is the quality of assessment. If this is an okay here, you are looking at a good scan. The asphericity or Q value is also important, but it's more important in the next segment. That is this. This is giving you the posterior cornea. So you are given the detailing about the anterior cornea. This is going to give you the detailing about the posterior cornea. Now this is why Pentacam is the man, because it is giving you the detailing about the posterior cornea, surface of the cornea. Here the values are all important, especially if you want to take up this patient for a toric IOL, let's say. That surface is very important. If you are planning a topo-guided LASIK surgery, then that is important. And to detect a case of early keratoconus, that is important. Also, the quality of vision assessment and as well as the quality or the amount of asphericity is all important. That is going to tell you much about the corneal flattening towards the periphery. Also, there is that. Okay, fine. Now the next is the miscellaneous segment, that is way down. So here you are going to get a few more data. So for that, this area of the Pentacam is important. You have to compare this to that. So about the miscellaneous segment, if I summarize, cut it down, I have zoomed it in. There are three thickness maps you can see: pupil center, pachy-apex, and the thinnest location. You have to see how much is the pachy mentioned there. There should not be a difference of more than 20 microns there. So, and you have to make sure, like a map, the x-axis and the y-axis, the coordinates are telling you it's exactly starting from the same point. It should not be at different areas. If it's from a different area, that means you may be looking at a patient with keratoconus. And that, K-max. It's told, now it's a myth, but still that is told to be significant if the value is more than 47. That is telling you, you may be looking at a patient with keratoconus. Also, if you want to take up this patient for femto LASIK, that value is important. You don't prefer to use keratome in a patient who is having a value more than 47 there. Now, that area is not important from the corneal aspect or from the LASIK or from keratoconus. Pentacam means LASIK, keratoconus. Now, that area is for doing ICL surgeries. You should know how much is the AC depth. And mind you, the AC depth has to be assessed from endothelium below. That is called as the internal anterior chamber depth. So, then we are jumping on to the curvature map. This is called as the curvature map. As you can see, this is giving you the curvature of the cornea. This is how it is curved. This is the steeper axis. This is the flat axis. So you have to see how much is the value. Is the value range between 42 to 46 is what you have to assess. I can see many of you writing notes. There will be a recorded session of this being shared on the WhatsApp group that we have made for delegates. So, before I go into the detailing about curvature map, we'll just start with a few examples. Case number 1, Muhammad, 16-year-old male, of course, -3 diopter sphere in both eye. Will you be doing a topo here? Any of the delegates want to take up? Can I call up names that I know? Yes, my dear DNB resident, my first one, yeah, Sonal. Yeah, okay. So the answer is no. Why? Because it's a -3 diopter sphere. But I haven't told you why have the patient come to me. You want to know? He has come to do LASIK. So, would you? It's been 15 years. So see, the reason is for a spherical power we don't usually do. But as I said, this patient has come to me for LASIK, which means we can't go without doing a pentacam here. We have to know how much is the corneal thickness. We have to know, are we missing a posterior keratoconus. So yes, if the patient has come to you just like that as a routine general patient, no for a pentacam. Or let's say he wants to do a LASIK, yes, I will do a LASIK for him. Don't mind this, I couldn't easily source a normal one. So anyway, let's imagine that is green. Okay, so the idea to be taken home is a spherical power, you in the curvature map, the discussion is all about the curvature map. So in the curvature map, you're going to see it all green in a spherical power, okay, provided the other things are normal. So here, this patient has come to me for LASIK. I will be assessing all the required data that I need and then go ahead and do LASIK for him. Case 1 closed. Case 2, Muhammad Shafi, 60 years, -3 diopter sphere, -2 cylinder at 180, both eye. Will you do a pentacam for him? Any takers? This has to be an interactive session. Yes, Salman bhai, what do you think? Will you? Okay, mic on. Mic on. Yeah. Will
Yes,
you?
sir, but my question is, means age is 16, sir, so how we can proceed for LASIK?
No, he has not come for LASIK.
Okay.
He has just come as a routine patient to you. He doesn't want LASIK. He's just come to you. Will you do a pentacam? That is the question.
If vision is 6 means I want, sir.
Yeah, okay. Why? Because this is a straightforward cylinder. 180, 90. These are common astigmatic errors you usually see. Okay? But maybe later on, he may come to you 6 months later. The dictum is, if you are seeing a higher cylinder, more than 1.5, and you can take up a retinoscope if you have one, do a reflex if you have any suspicion for a scissoring. Or on the other side, if money is not a factor, then also you can ask for a pentacam. Because there could be a possibility when the cylindrical values are more than 1.5, there is probably a need for keratoconus. So let's say this is not the same patient. I'm just trying to give you or bring you all into pentacam. This is the curvature map of the patient. What do you infer? This is a normal. This area of the cornea is curved out, which is normal. That is with the rule. In normal patients, you see that this area, the vertical area or the 90-degree area, is usually more curved than the 90-degree. That is relatively more flatter, and that corresponds to the power. That is 180 axis means the vertical entity of the cornea is more curved. So we are looking at a corneal astigmatism. Why? Because 43, this is 41, difference is almost nearly 2. So the astigmatism that we are seeing there is probably because of the corneal reason. So we call it a corneal astigmatism with the rule. Muhammad Shafi Habib, 16 years, -3 diopter sphere. Now we are splitting the both eyes. Right eye is -2 cylinder at 40, -3, -2 cylinder at 140 in the left eye. Will you do a pentacam or a topo? Yes, Alia? Yeah. Why? Axis is oblique. You suspect keratoconus here? You will suspect keratoconus. Okay. So, thank you. So see, one dictum to be taken from the cylindrical powers are, how is the axis? When you sum up the axis, this is 40, this is 140. How much are you getting, Alia? 180. So if you're getting a value with the axis numbers at 180, you need not worry about keratoconus because it's summing up to 180. So -2, anyway, cylinder more than 1.5, you have things in the oblique segment, and the summing up is 180. I didn't worry about a keratoconus here, but still, I would ask for a pentacam. So let's just take one eye here. And this is how I would be seeing the curvature map. The axis is at 140, that is this. This is for the left eye, and 0 starts from here. So 140 will be there, and this is how the axis would be, that is at more steeper in the 40 degrees. That is why you're getting the axis at 140. This is how you are expected to see the curvature map. So this is a corneal astigmatism again, because there is a difference in the curvatures, and we call this as an oblique feature, because this is not in that 180-90. 180 plus minus 20 up and down. 180 to 160 and to 20, and on both sides are fine. Also 90 from minus 2, that is 70 to 110 on both ends are fine. This is either with the rule or against the rule. If it's not in those numbers, then you are probably looking at a oblique astigmatism. And I say oblique astigmatism because I can sum this two into 40 and 140 as 180. Case number 4. Ajit എന്താ പുറത്ത് നിൽക്കുന്നത്? അജിത്തിനോട് ഉള്ളിൽ വരാം. ആ പുറത്ത് നിന്ന് ആരും സംസാരിക്കണ്ട, ഒരു ഡിസ്ട്രാക്ഷനാണ്. Okay, case number 4. Mohammad Shafi Habib Altani. Yes, he is from the Middle East. 16-year-old. The powers are minus 3, minus 2 cylinder at 40, minus 3 diopter, minus 2 cylinder at 60. Of course, this is not summing up to 180, and the cylinders are on the higher end. Definitely, I will ask for a pentacam. Okay, so this is what you may probably see. This is the one that we saw previously. This is a symmetric bow tie. It's symmetrical at both ends. The sizes are equal, and there is no skewing. The line you draw straight is having a defect of 20 degrees. Also, the curvature, if you compare superior and inferior, there is no difference of more than 1.5. But if you take this for the right eye, this is not a symmetric bow tie. This is small here, bigger here. The values is 44. This is 1550s. Definitely difference is more than 1.5. And you can see this is the one axis going for this center, and this is definitely more than 20. So all that is telling you, you may be looking at a case of, or you are definitely looking at a case of keratoconus, but you have to get this in association with your Pachy, the anterior curvature, anterior elevation, posterior elevation, and clinically has to be correlated. But if you are talking only about the curvature map or the sagittal curvature map, or also axial, so that is telling you, you may be looking at a case of keratoconus. So this is the comparison. That is normal with the rule astigmatism. This may be a case of keratoconus. That's about the curvature maps. Any doubts? You're all with me? Can I go on? Yeah. Thank you. Now these two. These are the elevation maps. This is anterior. This is the posterior. Now why elevation map? Elevation map is based on the concept of best fit sphere. 8 millimeters radius of curvature, a sphere is kept, and this cornea is compared to that curvature. This will be a smooth 8 millimeter curve. The normal corneas may go up a bit, go down a bit. So accordingly, if it has gone down, it will be blue. If it has gone up, it will be in red. Now, as you can see, that is with the rule, it is more curved vertically. This end would have been more curved. So if I keep a 8 millimeter thing, this would be, because of the more curvature backward, this will be in blue. This is flatter area, that is going to be in clinically red. This is more like a saddle shape. Second thing, we have to look at the values here. If this is more than plus 11, we are looking at probably a case of keratoconus. Similarly, the value here, if you are looking at a value more than plus 16, you are again looking at a case of keratoconus. Coming to the Pachy map. Well, okay, Pachy map. So here you should be assessing the thickness of the cornea. You will be getting the thickness of the cornea. Definitely the values are depicted at the center. Usually a range of 520 to 540 is usually taken. Anything less than 500, you may be looking at a case of keratoconus. The thickness can go even higher, up to 600 is all, that's okay. You have to look at corneal edema or all those things when any other abnormalities in the cornea has to be correlated clinically. So that's about the thickness map. Now, maybe some patients will bring a second page to you. Maybe a second page will be there with the patient, wherein we will be saying something like this. Nothing to worry, relax, cool mind. This is talking about elevation. Is talking about the back elevation. The same thing that we have just seen. This one. This is the anterior elevation. This is the posterior elevation. So that is the anterior elevation, posterior elevation. The central 3 millimeters is then negated. It is just deleted. That is this map. What we have to be looking at is that the last two down, one for the anterior, the other one for the posterior. The anterior value should not be more than +5. This should not be more than +12. But you don't have to remember the number. Just look down. There is a green, yellow and red tags that is giving you the numbers as such. If it is in yellow, that is indicated, that is in the middle range. If it is anything depicted in red, that means you are looking at a case of keratoconus. Then another thing that you will be seeing in that map is this. This is just telling you how is the thickness varying from the center, then 2 millimeter circle, then 4 millimeter circle, and as it goes to the periphery. So accordingly, you know that from the center to the periphery, the thickness of the cornea increases. So for this patient, that red line is telling you where is that thickness standing from the center to the periphery. It is supposed to go with this line. Anything between the standard deviation, up and down, is taken normal. But if you feel that this red line is going somewhere way down, you may be looking at a case of keratoconus. Also down, you can see a lot of D's. This is the differential score for the front, back, pachy, thinnest, and the axis, as well as that is the total D. Now this is going to be the second page of a keratoconus patient. As you can see, everything is in red. The last thing, as you can see a big red there like a thali, and this is on the higher range. And this is the pachy map. This is the graph. As you can see, the down one, it's gone way below the graph. And when you see down that red lines, everything is in the red area. That is telling you, you may be looking at a case of keratoconus. This is the bad score. Okay, now we are going for the live wire. Can I have a patient on stage? Thank you, Faris.
Hello. Hello.
Close. Balakam. How do you start? You just select a patient. Okay, going to scan the patient, new patient. Okay. Oh, laptop on screen. So you enter the name of the patient. This is the pentacam. This is what the optometrist see on screen. Now we are going to take the scan. Of it's connected to the pentacam. Pentacam is ready. Tamanna, Tamanna, time, time. 20. Okay, so we are aiming at the patient's eye. Okay, a click has been done. Scan is generated. You can show the display, quad maps off. Yeah. So this is what we were. Now this patient's having is a normal green zone in the curvature map. Anterior elevation is less than plus 11, less than plus 16. Pachy is on the higher side, 594. That's normal for him. And the demography, the curvature, anterior, back, pachy, all that is telling you this is not a keratoconic patient, but unfortunately he's not having any refractive error. So we won't be taking him for it. Thank you. Okay, so now we will go to a few cases. Thank you, Linda. Thank you, Faris. Okay. Mouse barrier. That you just removed, no? No, that's fine. This is of a mouse, right? Mouse or the mouse in there? The mouse in there? No. Are they in there? You know. Okay, sorry. So now we will go to okay. So now we will discuss case number 1. He is Ijaz. His right eye vision is 6 in the right eye and left eye is 6/60. That is 612 in the right eye, 660 in the left eye. The power -1 in the right eye, -5, 160. So definitely the cylinder is on a higher end, 160 plus 10, yes, summing up to 170 taken. So where do you think you can place this patient? Anyone from the delegates? We'll show you the Ijaz. No communication with pentacam, display format. Yeah, load, yeah. Load the left eye of the patient. display going for 4-map refractive. This is the patient's pentacam. Anybody want to give a try? Start with this, this. Be taken from here, taken well. K1 is 45. There is a difference of 5 here. Could be a case of corneal astigmatism, and that is all in favor. Looking down, Pachy is how much? Less. So
500 and
51, 53, 446. So what do you think? Keratoconus, I said it has to be a difference of 20 microns. Here, it's 20 microns? No. Anterior elevation map, posterior elevation maps. How much is the value? Plus 11, more than plus 11. On the top, more than plus 16 down? No. Thin cornea, high astigmatism, keratoconus? No. See the display of Berlin Ambrosio. Again, anterior elevation, posterior elevation, any red tali marks there? No. How was that line going? It's all maybe a little on the other side, right? It's not going down. So, what are we looking at? Any takers? It's a physiologically thin cornea. So, there is an entity wherein the thickness of the cornea is less. Astigmatism, it is 160/10, as you can see here. That is telling you this may not be at keratoconus. So, take case 1, thin cornea. It could present as keratoconus. All thin corneas are not keratoconus. Case number 2. Case number 2 for son, right eye 6/6, left eye 6/12, not improving with any refraction. Okay, I have to close this, then go to, yeah. For son is second case. Okay, we have to load, examination load. We will take the left eye load. Okay, going to display 4-map refractive. Any takers from the delegate? K1 42, K2 45. The K-max 55, but Pachy is 524, 515, 507. You look at the curvature map, what do you see? It's not a symmetrical bow tie you are looking at for sure. Some steepness in the inferior part, value there, plus 18 is there, or plus 27 is here. It's supposed to be plus 11. More than plus 16, this is plus 46. So, what are we looking at? With a normal thickness cornea, 515. What are we looking at? Has to be a case of keratoconus. So, a thin cornea is not the criteria to diagnose keratoconus. First case, you saw a thin cornea, but it was not keratoconus. Second case, you are seeing a normal thickness cornea, but it happens to be keratoconus. This is the BAD score. You can see it's the tali is here, the red thing is there. That line you see, it's gone below. So, case of keratoconus. I have to close this. Next case. Case number 3, Kunji Mohammed. Right eye is -5. Left eye is minus 4.50. It's in 90 anyway. So, from the refractive error point, you don't feel anything of much significance. Now, if you Yeah. So 6 cases. I'll anyway upload the entire presentation on WhatsApp. See the
Thank you, Dr. Shaji, for that wonderful presentation. Now we move on to the final talk in our first cornea session. The next speaker is Dr. Professor Srinivas K. Rao, sir. Dr. S.K.R. sir did his graduation from Madras Medical College, where he was adjudged the best outgoing student. He's had his ophthalmology training from Shankar Netralaya. The gold medal saga continued in 2002, where he was awarded one by the Royal College of Surgeons, Edinburgh. He's been a consultant in various eye hospitals, including Shankar Netralaya. At present, he is the director of Darshan Eye Care and is a visiting professor with Sri Ramchandra Medical University, Chennai, Chinese University of Hong Kong, Shanzhou Medical University, China. He has more than 25 years of experience in the management of corneal and refractive diseases and is a pioneer in corneal and refractive surgeries in India. He was the president of the Cornea Society of India. He has been a faculty in numerous conferences, CMEs and workshops and has multiple publications to his credit. Sir, we are absolutely delighted and thrilled to have you here with us, inviting you to tell us whether to tame or treat the cone.
Thank you very much for those kind words. Good morning, everybody. I'd like to thank Abet Al Salama for the invitation to be here, and also Shaji for making all the arrangements and the hospitality. I'd like to take a moment also to say how proud I am of Shaji and the good work that he's doing. He was a fellow with me a very, very long time ago, but even then I was very impressed with his sincerity, his hard work, and his deep and abiding faith in the Almighty, and my best wishes to you, Shaji. Chosen a topic that is quite hot at the current moment, which is keratoconus, and he wanted me to share some perspective about it on these two aspects of it. This was a paper that was published earlier this year, and from this it seems that the current hotbeds of keratoconus prevalence are the Middle East and India. If you look at the top, like Russia, the incidence is about 0.2 per lakh of people, but in these two places it can go as high as 4,790 per lakh. And therefore, if you look at some of the earlier textbooks where keratoconus is described as an ectatic disease of rare occurrence, that definition is now called into contention because with these numbers, I don't think you can call it rare anymore. Keratoconus was first described in 1854 by Nottingham, and it's surprising that as of this month, 168 years later, we still don't have a clear understanding of the etiology of this fairly complex disease. It's generally believed that genetics and environment play an important part in its causation, but the relative contributions are not clear. There are various modes of inheritance, but they generally seem to be of incomplete penetrance, and this can also change depending on the ethnicity that you're looking at. Like I showed you, Russia, the Middle East, and India are all very different, and there is as yet no single definite locus that has been identified. We are very aware of the strong associations of keratoconus with allergy, atopy, eye rubbing, and with a pre-existing family history. But if you look carefully, there are also other anecdotal associations with a number of systemic conditions as well as other ocular conditions. The seat of the problem in keratoconus is also not clear, and we postulate that it could be the epithelium, it could be the stromal collagen, it could be the keratocytes, there could be an increase in the enzymes that cause a degradation of the corneal tissues, there could be changes in the corneal biomechanics, or currently it is also believed that this could be a pro-inflammatory state based on tear proteomic analysis. All this confusion, however, has done one good thing. There's been a lot of interest and research in this condition in the past 2 decades, and therefore we now have, as Shaji showed you, better methods for early diagnosis of this condition. This research and thinking has also resulted in a lot of treatment options for managing this problem. We still have our traditional methods, but we now have a lot of very nice specialty contact lenses with which it is possible to fit virtually every cone and get back good vision. We also attempt to preserve the shape of the cone at the time of presentation by doing a collagen cross-linking or by tissue augmentation like a Bowman's layer transplant. We attempt also to improve the shape of the existing cone. We can implant intrastromal devices either of plastic or corneal stroma itself, or we could do a very controlled excimer laser ablation to try and modify the shape. And finally, of course, if all else fails, we can do a corneal transplant. And we have also learned in the past decade or so about better eye drops management in this condition. So sometimes it becomes very confusing with all these options when a particular patient presents to us as to what can we do for him. The natural history of keratoconus is that it starts in the teens, although if you look at the literature, it's been described as early as 4 years or even as late as 50 years. And it generally tends to progress until the patient reaches about 35 plus years of age. So with this background, for me, if I see somebody with an early cone and good best spectacle corrected vision, if it is a young patient, all I want to do, if he is progressing, is a cross-linking. This will stabilize the disease. If the patient is of a slightly older age, say 30 plus, and the disease doesn't seem to be actively moving on, I would just continue to watch him very closely. If there is a moderate cone which results in a degradation of spectacle corrected visual acuity, in a young patient who is also progressing, I would cross-link, and then as I said, there are a wide range of contact lenses available, and you could get him to see well with one of these. With an older patient who doesn't seem to be progressing, I would just fit him with the lens and watch him closely, provided I can improve his vision. And if he fails a cone because if he fails the contact lens because he's a very advanced cone, then I would do one of these corneal transplant procedures. In the first instance, my focus is basically on trying to preserve the status quo because he already has good spectacle corrected vision, and cross-linking has been shown to be an accepted modality which can stabilize the cone in most of these patients. Of course, if you have to do a transplant, I would try to do my best to do a DALC because there are benefits to preserving the endothelium. But if I can't, and if I have to do a penetrating graft, it doesn't bother me because in keratoconus, penetrating keratoplasty also has very good 10-year outcomes. My approach is basically a very safe and conservative one. The first instance, I just want to keep him where he is. And here I have nothing better to offer, so I do a transplant. And this is usually my go-to methods. Occasionally, if I have a patient in the middle category where I can do a good contact lens, but if the patient doesn't tolerate the lens or if he doesn't want to wear a lens, then I can look at options like these where I can either try and improve the shape or try and do a tissue augmentation. But remember that neither of these procedures generally slow down the cone and you still have to cross-link him even if you're doing these. I keep these as the last because I still think in my hands I have issues with predictability, safety, and reversibility of these techniques. And in my particular practice, this segment is a very small percentage of people, those whom I can't satisfy with a contact lens. And therefore, in my practice, these generally are my 2 go-to methods for keratoconus still. And luckily, Shaji asked me to speak only about these 2. If you look at the structure of the cornea, it has the tropocollagen. We know it has the interpeptide hydrogen bonds. And the collagen fibers have a hexagonal lattice arrangement in the lamellae. And the lamellae themselves are stacked one on top of the other. And the intervening space is filled with glycosaminoglycans that are secreted by the keratinocytes. When something goes wrong in this architecture and results in poor corneal rigidity and it starts to lose its shape, we currently attempt to increase the intrahelical and the intermicrofibrillar bonds by doing cross-linking to restore the rigidity of the cornea so that it stops its shape worsening. This cross-linking can be done either by the type 1 mechanism which is an anaerobic mechanism and involves a lot of toxic radicals, or by the more preferred type 2 mechanism, which is more gentle and requires oxygen and is the aerobic phenomenon. One of the important elements in the cross-linking process is the vitamin B2 or riboflavin. We use it at 0.1% concentration with 20% dextran. We normally apply it every 2 minutes for about 10 times for about 20 minutes. And in this isotonic version is the preferred one if your pachymetry is more than 400 microns. If you have a thinner cornea between 350 and 400 microns, we tend to use the hypotonic riboflavin, which is essentially the same thing as the initial one, but without the dextran. And if you're one of those who likes to do the epi-on procedure, where you don't want to remove the epithelium, your riboflavin will contain BAK or some other toxin, which disturbs the tight junctions in the corneal epithelium so that the riboflavin can penetrate. The other important element in this process is 370 nanometer ultraviolet light. We deliver a total radiance of 5.4 joules per square centimeter during the process. And the original Dresden protocol, which started this whole adventure, basically used 3 milliwatts for 30 minutes. And today we have accelerated versions where you can invert that and do it for 3 minutes using 30 milliwatts per square centimeter. And this is one of the accelerated devices that you can see there. And on the bottom is the console, which allows you to play with the timing and the energy, but the machine will make sure that you deliver a total energy of 5.4. That device on the top is a dosimeter. It's a very important part of this instrument because for every case, you first need to make sure that the instrument is providing you with the ultraviolet radiation at the concentration and dose that you want. So before every procedure, you must make sure that the device is calibrated. I do the epithelial removal process. So for me, it's a sterile procedure, much like a cataract. We use topical anesthetic and a lot of antibiotics throughout the procedure. I tend to patch my patients until epithelialization, so I see them for the next 2 days. But you can also use a bandage contact lens, and some surgeons will do a bilateral procedure as well. Postoperatively, I use topical antibiotics for a week. We use ointment to stabilize the epithelium. We use tear substitutes to lubricate the surface, and a soft steroid starting at 4 times a day and tapering it down over 4 weeks. And what I think is very important is to minimize UV exposure. They wear some sun protective glasses for the next 3 months at least. I believe that this reduces the haze in the cornea. Many of these patients have associated allergies, and if you have somebody with a VKC and a keratoconus, you must make sure that the changes of VKC have been addressed properly before you touch the cornea for your cross-linking process. In about 10% of people, particularly the very young or the very severe cones, it can progress even after your cross-linking. And in the young people these days, I routinely tell them that they may need a touch-up procedure after 7 or 8 years because the bonds will tend to get reorganized or remodeled, and the cone will show up after some time. I'm talking about somebody who's 8 to 12 years at the time of the first procedure. If you don't calibrate your machine and if it's delivering too much energy, or if you don't maintain the 3 centimeter distance between the device and the cornea, you could overcook the cornea and then get corneal haze, corneal scar, and endothelial damage. Because we remove the epithelium and we also use postoperative steroids, infections can happen. And we have seen progressive thinning after the cross-linking even over the next 7 years. There is corneal destabilization of the collagen. Sometimes it gets extremely thin, and you may have to do a tectonic procedure like a DALC or a PK afterwards. So collagen cross-linking today is very popular, is very common, and it's very done extensively, but to me it's still very poorly understood. A lot of controversies. I told you about the epithelium off and the epithelium on. There are various ways in which you can remove the epithelium, but I think the general consensus today is that it's better to do it epithelium off, and it's more effective that way. For the thin corneas, I talked about the hypotonic riboflavin. You could use distilled water to swell the cornea. You could cheat by leaving a small island of epithelium over the cone to make it thicker there. But with the new sub-400 micron Hafezi protocol, we can now treat up to corneas of 200 micron thickness, provided you keep limiting the duration of UV exposure. Initially, the accelerated protocols talked about 3-minute exposures, but current evidence indicates that the sweet spot may be 9 minutes because you need to give time for the oxygen to regenerate in the cornea so that the type 2 mechanism becomes the predominant mechanism. And before this was understood, there were efforts to increase the oxygenation of the tissue by creating an oxygen enrichment when you're doing the cross-linking, or by using a pulsed UV delivery on-off kind of a system to allow the oxygen to reform. The Avedro introduced the customized protocol where you do a topography guided cross-linking, and in the recent September ESCRS, Hafesi has described what he calls the PACE, which is the PTK-assisted customized epi-on cross-linking, again attempting to target only the cone and treat it better. And there were other procedures which came in between, creating a femtosecond pocket in the cornea, filling it with riboflavin and cross-linking, or trying to do it in the LASIK bed for a few seconds, but I don't think these have really caught on, and these are of questionable efficacy. You can do cross-linking for these cousins of the keratoconus, which are the pellucid marginals, but here remember, because the thinning is quite inferior, you have to remove a large area of epithelium, and when you're treating the inferior part which is affected, protect your limbus and make sure that you put a sponge over the central normal cornea. If you just treat the entire area, you'll get excessive flattening of the normal central cornea as well. So these two precautions you must take. Moving on to surgery, because keratoconus affects the stroma and the shape, very early on it was recognized that it's advantageous to retain the patient's endothelium, but lamellar surgery never caught on because when you're working halfway in the thickness of the cornea, you get a lot of interface scarring. It's only when we understood that we could go right down to the decimes and replace the stroma that this procedure caught on. And today we understand that you can also do well if you retain only about 10% of the posterior stroma in a pre-decimetic DALK. In order to achieve this decime separation, we used an air bubble, and this was suggested, proposed, and popularized by Mohammed Anwar. And when we did achieve the air bubble, we believed that we were removing all of the stroma, leaving behind only the decimes and the endothelium, which was why this procedure did such a good job. In order to do this separation injecting air, you can use a humble 30-gauge needle, or you can use more specialized cannulas. These are blunt-tipped cannulas with an opening port at the bottom. So you force the air against the posterior surface. There are many people who describe this, and Dr. Rajesh Fogla was one of them as well. And these do work quite nicely. So when you inject air, basically if you get a bubble that starts from the center, which is circumscribed and dome-shaped and extends to about 8.5 millimeters and has a white border at the edge, we now call it the type 1 bubble. If you inject the air, and basically you find that the bubble starts at the periphery, it goes all the way out to the limbus at about 10.5 millimeters and has this kind of a glassy appearance. We now call it the type 2 bubble. All of us were seeing this right from the early 2000s when we started doing this air injection process, but it was this gentleman who explained why we see this phenomena, and he made us understand what is happening, because he described a 6th layer of the cornea. When I was doing my ophthalmology, cornea had only 5 layers. So he described this layer called the pre-decimes layer, which is eponymously also called as the Duas layer. And the importance of understanding its role in DALK is this. So this black thing here is the Duas layer in a cartoon. So it is relatively firmly attached to the underlying decimes membrane shown in red, and relatively loosely attached to the corneal stroma shown in gray on the top. It ends at about 8 to 8.5 millimeters within the posterior stroma. So when you inject air, if the air reaches the plane between the Duas layer and the stroma, this creates the type 1 bubble, and that is why it is circumscribed in about 8 to 8.5, because that is where the Duas layer gets firmly attached to the stroma, and you can't spread it beyond that. If, on the other hand, the air enters the plane between the Duas layer and the DM, the entire DM can split open, and that is why you get a 10.5 millimeter glassy bubble, which is called the type 2 bubble. The importance of recognizing the type 2 bubble is, if you try your traditional method of stromal removal in this bubble, with the DM underlying you, it will break most of the time because it's a very delicate structure. The type 3 bubble is basically a combination of the type 1 and a type 2 in the same eye. Now, this is a video from 2007. If you watch the upper right corner of the cornea, you'll see the type 2 bubble forming there. I didn't know of this concept then, so I'm using viscoelastic to expand the bubble. You can see it spreading open, and then I'm doing the traditional method of stromal removal, and you can see what happens here. Yep, that's the DM going away. I'll show it to you again. So basically, trying to remove the stroma and the DM breaks. So you can't do the stromal removal in this situation. This patient luckily had a cataract. We had discussed this with him before, so we just went ahead, did a cataract extraction and a PK as well, and he did well. Now, this is a patient from last week. So here, basically, we now understand this whole process a little better. So this is a type 1 bubble. So here you can go ahead and bravely remove the stroma because the Duas layer is a much stronger layer, will allow a lot of manipulation. The only problem with the Duas layer is it's only 8 to 8.5. So on the right extreme, you can see that the walls are quite vertical because I've gone right up to the edge of the Duas bubble. But here, you can find that the bubble has not gone all the way out to my trephination mark. So here, when I'm removing the stroma, I have to respect that. So I'm leaving a very thin sliver of stroma on the posterior surface. Because here the dua and the stroma have attached, you can't separate that stroma, and if you keep trying it, you will end up with a perforation. So you have to understand the mechanics of this when you're doing your DALC. So I've removed it, but this was a type 3 bubble, and you can see this oval area there on the upper part of the screen in the cornea. That is the type 2 bubble there. So all you have to do is to nick the Duas layer, let that air come out, the DM goes and opposes itself with the Duas layer, and then you can proceed. So this is how you deal with the type 2 bubble. You don't try and remove the stroma on top, you will always fail. In these kind of extreme cones, there's not enough stroma to give you the counter pressure to separate the DM. So no matter how many times you inject, sometimes you just cannot separate. Doesn't matter, you don't have to give up. All you have to do is to do a pre-decimetic DALC, which means you go into a manual dissection mode. So just go in layers, keep removing stromal layers until you can see no more bubbles in the bottom, which means that there is very little stroma there. And as long as you're in the 90% depth, you will often get good outcomes both in terms of interface haze and in terms of vision. And this is that patient 2 weeks later with an unaided vision of 612, and you can see the interface is quite clear. So if you can't get a big bubble to separate the Duas layer, all is not lost. You can still proceed with the DALC most of the time. So a DALC offers you many advantages, and in this kind of a situation, one eye has had a PK, the other eye has had a DALC, fellow eyes of a patient. Did this 8 years ago, I still can't tell them apart. I can only say this is the DALC on the bottom because it's a smaller 8.5 millimeter button, and that's the larger 9.5 millimeter button for the PK. But if you look very carefully at the graft-host junction under high magnification on the slit lamp, sometimes you can tell a PK and a DALC apart. Provided they've been done well, it's very hard to tell the difference. The DALC offers you the immunological advantage of avoiding an endothelial rejection, but it has most of the complications of a PK. You can get suture-related astigmatism, and you can get interface haze. This is a very old picture about 14 years ago. This is a 40-year-old gentleman who had a herpes simplex thick scar in his only eye, and I didn't want to do a PK for him. So we discussed it with him, did a manual dissection, removed 90% of the scar. So we ended up with a haze, but you can see the pupil. He's got 612 vision, and he's lasted 15 years now, and he's still going, and he's quite happy. So sometimes you can allow a little haze in the posterior surface. But because of the interface, you can get vessels sneaking in if you don't remove your sutures on time, and the vessels can leak lipid as well. You can get suture-related loosening and vascularization, and particularly in maculocorneal dystrophy in older patients, on day one, sometimes you may not see a layer attachment. The posterior layer may be separated. All you have to do is to go back and re-inject air, and often it will settle like this. Because you're injecting air, you can get pupillary blocks in the early postoperative period. You have to watch for that. You can get a Uret-Zavalia syndrome like you can get in a PK with this dilated kind of pupil. And you can get suture-related infections. So a DALC doesn't necessarily solve all your problems. It only solves your immunological endothelial rejection problem. A stromal rejection is not uncommon in a DALC. You can see the inferior haze and clouding in this DALC. But fortunately, it will resolve with topical steroids. This is the appearance 4 days later, and this is the appearance 3 weeks later. And most of these stromal rejections will go away with just topical steroids. Finally, coming to the cousin, the pellucid marginal, you can't do these standard things there. So basically, because there is inferior thinning, one option is to do a crescentic wedge resection of the inferior thin stroma. And as you can see here, this was about 11.5 against the rule. Following surgery, in the first few weeks, you will have a 50% overcorrection, which is what you want. But as the wound remodels and as you remove the suture over the next 6 to 9 months, it will settle down to a more decent astigmatism. And finally, if you have a combination of these cousins in the same eye with a keratoconus and a pellucid, then neither of these procedures will work. And the only thing you can do there is a large diameter DALC to help this patient. So once again, thank you very much for the invitation and the hospitality. I'm really enjoying this meeting, and I'm looking forward to the rest of it. Thank you very much.
Thank you, Dr. Srinivas, for that academically rich talk. Now, I request Dr. Shaji and Dr. Swadik to please come onto the stage. And audience, if you have any questions regarding keratoconus and its management, you can ask now. Any questions?
Audience mic.
I'm Dr. Sanjana from Chaitanya Hospital. It was a very nice talk by all three of you all. Actually, this question is for Srinivas sir. With regarding to HPMC versus dextran and isotonic riboflavin, is there any preference among these two, sir? Like of late they tell isotonic with HPMC is better than dextran. So what is your take?
I don't think it's better, but I think it's equivalent. The initial ones that we used to get came with dextran. Now we're getting a lot of Indian versions which are coming with HPMC as well. I find them equivalent. I use both. So I don't think one is better than the other, in my experience.
Thank you, sir.
Just like you tell the PGs, if there are no doubts, that means all your doubts have been answered by the speakers.
Okay, one more doubt. Srinivas
Thanks,
sir.
Sanjana.
Sir, with respect to DALC, compared to Big Bubble versus manual layer by layer technique, do you feel that manual layer by layer technique will give almost the similar post-op results compared to Big Bubble? Like for beginners, we tend to fail the Big Bubble technique while trying and then we end up converting into PKP. So do you think trying a manual layer by layer and giving a almost similar result is better, or attempting a Big Bubble is the ideal situation, sir?
It's technically more challenging to do the manual dissection. There are certain indications where it becomes your primary procedure. For instance, if you've had a hydrops and you've had a scar, but it's not in the visual axis, then I don't think it's wise to attempt a big bubble. So then you have to go ahead with this. If you ended up with a micro perf during your removal of stroma, then you have to convert to a manual dissection. And occasionally, like in the video, if the big bubble just does not form despite multiple attempts, then you convert to a manual. But if you had the option of doing a big bubble, I would definitely prefer that. So this is a default option. If that doesn't work, and if you do it well, you can get good outcomes. But to start off attempting that in a routine patient may not be the best, because I think the results with the big bubble will definitely be a little better than with this, but you can give good results even with this, if you can't do the big bubble.
Thank you.
I would like to ask one question. Many people say that in keratoconus, do a corneal wavefront guided removal of the higher order aberration, centralizing the cone, and then going for a refractive procedure, ICL or something like that. Does it really work, or just a...
I know a lot of people do it, but in like I said, my reading and my understanding of it, I think it's kind of an unpredictable hit or miss kind of thing. And to me, it seems not the ideal option, because most of these things will work only when you have adequate corneal stromal thickness. You can't put in a ring, you can't do these ablations if you have thin corneas. And in these moderate cones, with the current generation of contact lenses that we have today, almost all the time, we can get them back to perfect vision. With these techniques, the goal is to reduce the astigmatism, reduce the irregularity. So you're not saying that I do this and you have good vision. So in an occasional patient who cannot wear a contact lens, who refuses to wear a contact lens for whatever reason, then you're forced to try these things. But if in my hands, if I can get a good lens going, I tell them it's better to accept that and go on. Because these procedures also have a lot of problems. Basically, when you do an excimer procedure, you have to use some mitomycin to reduce the haze. So we're kind of working at cross purposes. We have an unhealthy cornea, we're killing the keratocytes, we're putting in mitomycin. So you can't titrate the scarring. So I sometimes think it's a hit or a miss. You do it, you may get a good result, you may not. And therefore, if you can have a procedure like a contact lens which can give them good vision, I think you should try that. As these procedures evolve, as our understanding improves, and as our ability to titrate them better and get better outcomes improves, then definitely, yes, we should be moving on to these. Because obviously, it's not good to have a patient wear a lens day in and day out for the rest of his life. But for me, until I can get the same degree of confidence in the outcome with these procedures, I would stay with the conservative approach.
My question is to Sadiq sir. Let's say you have a suspicious cone and the patient wants some refractive surgery in place. Would you go for a laser procedure or any other of your choice?
I'm an examiner and I don't like people asking me questions. I ask you questions. I'm a very much conservative. I was aggressive in my beginning professional days, but when I became the Royal College examiner, I am more I am to the UK style of practice, the NHS style of practice, and where it is highly conservative. I don't take up risky things. I asked this question to SKR sir just to convince Shaji. Because in the beginning of my ophthalmology practice, I used to listen to the speakers in the conference. Many people speak very high of many of the new or inventions. They may not be doing it in their operation theater, but they present it to just get some appreciation. And I used to take up these things and practice on my patients, and I had landed up in trouble in my earlier days. Later on, I realized that I take up only time-tested things. Now, I want to control him. He is doing a lot of dangerous things. I want to convince him with his own teacher, Dr. SKR. That is why I asked this question. So, to me, I won't do any, if there is a little bit of suspicion, I won't do any refractive procedure in that patient, whether it is PRK, LASIK, or even ICL, even if there is a slight doubt of keratoconus. That is my way of practice.
Sir, what's your take on the presbyope correction era? What do you think? Is there a future? What's your take on presbyope refractive corrections? Your own.
I don't do it. I don't understand it that well. I think I was talking with Khalil on the way we were coming in. I think we should have a clear concept as to what we are trying to do for the person. If you've understood the procedure very well, you're confident that you can do it well, and for the duration of the presbyopia at 45 to the next 20 years till 65, if the patient's going to have good vision, then yes, I think it's a good procedure, can offer it. But if it's just going to do something for 2 or 3 years, and then again everything is going to start because presbyopia is a moving target, then I personally wouldn't meddle with the cornea, because later on this patient's going to get a cataract, he's going to get other things. We're just increasing the complexity of those procedures, and today with the evolution of the multifocal lenses going on, maybe at some point a little later when he has a cataract, this may be a more elegant way of sorting out his presbyopia.
Thank you, sir. Sadiq sir wants to add something on.
Not regarding that question. I have a general advice to upcoming ophthalmologists. The patient's safety is the utmost important in our clinical practice, in our surgeries, and in our medical advices. Never take up anything risky, and some of you, I have examined some of you in the Glasgow Royal College examination, and also some of you are my candidates for the FRC exam. In both these examinations, one thing which is specifically tested is how safe you are to your patients. In a general Indian practice scenario, many doctors do practice many things which are highly risky to the patients, which are, in my opinion, in an NHS way of practice, it is not at all advisable. Be safe to the patients, do only time-tested thing, and that is my sincere advice to upcoming ophthalmologists.
Okay, so any more questions from the delegates? Yeah, Khalil sir. Mike.
Refractive procedure and the cross-linking together, LASIK extra in the borderline cases. Of course, sir has done not to take the risks at any.
I think there's not enough data, and the whole premise is questionable. I mean, if it was that much of a suspicion that the patient would have a LASIK problem, you shouldn't be doing LASIK at all. And if he doesn't have a potential for a cone based on the current screening methodology, then doing something like LASIK extra is a process of creating a controlled scarring. In LASIK, you want less healing and less scarring. So you're having two things at cross purposes. So I know it was introduced, I know they talked about it, but I don't see much in the literature now, and there is not real rationale or, I think, a need for doing something like that.
Thank you.
Okay, we are way beyond the time schedule, so I think we'll wind up the discussion, if not anymore, or we'll take up everything at the end. Thank you. Thanks a lot. Thank you, sir.
Thank you to your speakers for that wonderful discussion. We'll move on to the inauguration function now. After that, we'll have a much awaited session on cataract.
Dr. Srinivas K. Rao, cornea specialist and director of Darshan Eye Care. Dr. Rajesh P., MOS President and Medical Superintendent of Abate AS Al Salama Group, Pindalmanna. Dr. Shaji Hussain, MOS Treasurer and Senior Cornea Surgeon of Abate AS Al Salama Eye Hospital. Dr. Advocate A. Shamsuddin, Arikuril, MD of Abate AS Al Salama Group. Muhammad Kutti Arikuril, CM of Abate AS Al Salama Group. Dr. Muhammad Swadik, Medical Director and Cornea Department Head of Abate AS Al Salama. Dr. M.A. Safrullah, Medical Superintendent and Senior Phaco Surgeon of Abate AS Al Salama Group, Calicut.
Yeah. Most of the KSO's executive members were supposed to be here, but they couldn't make it because today happened to be the executive committee meeting of KSOs. So I wanted to invite Dr. Gobinath sir to represent KSOS for us. Gobinath sir. Okay. Dr. Ashoka Valsala madam. Okay. When they come, just ask them to be on the dais. Okay. So there is one person I wanted to invite on my own. During my fellowship, she had been a mother to me, and she is the strength behind SKR. I would like to introduce you all to Dr. Shobna. Madam, please on the dais. She is the silent person. She is the strength. It was a surprise. Thank you. Video. Videos on.
Now, let us watch some witches.
Monitor on the center. Monitor. Same display. Okay. Videos.
Now, let us watch some wishes from those who could not be present here.
Live session alla video play cheya fast. idalla ഈ വീഡിയോ ക്ലോസ് ചെയ്യ്. On the monitor also, front monitor. Play. Front monitor. ഇങ്ങനെ പ്ലേ ചെയ്തിട്ട് കാര്യമില്ല. Okay, you can close it. We'll play this video later. You can call upon the persons on the dais. President Moise.
Dr. Arup Chakravarti. Sorry.
Moise President. Dr.
I would like to welcome Dr. Rajesh, MOIS President and Medical Superintendent of Abetes Salama Group, to deliver a few words.
Good morning, everyone. The Chief Guest of the day, Dr. Muthaiya sir. The main speaker of the day, Dr. Srinivas K. Rao. All other speakers and the delegates. It has been quite a while that we have had a proper meeting, academic meeting under the Malappuram Ophthalmic Society. So Shaji has been doing a wonderful work for the last 1 to 2 weeks. He was busy organizing an eye donation camp. And now this has been followed by this meeting, that is a Cor-Kram. Anyway, I also came to know about the meaning of this word Cor-Kram only today. But then I feel that the whole, the theme of the meeting, at least the posture of the meeting is based on the posture of the big hit of this year, Vikram. So I feel that, I hope that this meeting is just going to be a big hit, just like Vikram. And we have got a very star-studded meeting. We've got very good speakers from different parts of the country. I hope that all those people who are attending this meeting will benefit from this meeting. I don't want to extend my speech because we are already running much behind the schedule. I hope that this is going to be a very wonderful experience for all the speakers as well as the delegates who are attending this meeting. Thank you.
Thank you, sir. Now I'd like to welcome Dr. Srinivas K. Rao, sir, Senior Cornea Specialist and Director of Darshan Eye Care.
Thank you very much, and dignitaries on the dais, good morning. I think our Lokesh Kanagaraj is doing a good job. Like he directed Vikram, Shaji is busy directing Cor-Kram. So it's been a wonderful experience so far. The travel here was nice and the place is very pleasant. This is my first visit to this part of India. And whatever I've seen of the hospital is very, very, very impressive. And I was just hearing about Dr. Swadik's travel schedule for the week, and it's amazing that he's able to manage so much of work and also travel so much. So like Dr. Rajesh said, I think we're already running late, so I'm just going to stop here and just give my best wishes to Shaji and the team for the rest of the meeting, and really enjoying myself. Thank you.
Thank you, sir. Now I would like to welcome Shobana ma'am to deliver a few words.
Good morning to all. I'm a non-ophthalmologist here. I'm basically a microbiologist. Shaji was there for a year with us, and we generally treat all our fellows as family because our residence is very close by. So we usually have a very good relationship with all his fellow doctors who come and train under him. And Shaji was very comfortable right from the beginning with the patients also. We had a very pleasant experience, and he has made sure that he has taken good care of us during this trip, and it is a very nice place, and we wish Shaji and his team all the best.
Thank you, ma'am. I would like to welcome Dr. Muttaya to deliver a few words.
Hello, welcome to all and greetings. Respected Chairman, Mr. Mohammad Gutti, Advocates, Dr. Shamsuddin, MD, Elevate Group of Companies, Professor Srinivasa Rao, eminent personalities in the corneal diseases, Dr. Sadiq, Medical Director of Abate Group of Companies, Dr. Rajesh, Medical Superintendent, Abate Group of Companies, Dr. Safarullah, Medical Superintendent, Abate Calicut Branch, Dr. Valsala, Dr. Shobana on the stage, and distinguished speakers of the day, Dr. Ahmed Khalil, Dr. Bashir from Madras. Welcome to you all once again for this meeting. I am glad to be here today for this meeting, but since due to my ill health, I cannot be here for the full day. I wish you all the best of luck, and I thank Dr. Rajesh and Dr. Shadi for their kind gesture to give an opportunity to be amongst you on this day. Please play the video. Yes.
Thank you, sir.
Thank you, sir. Thank you, sir. Side screen and the colleagues are okay. So I would go ahead with the next session. Like whenever I called most of my friends, they had a query. Shaji, are you no longer working at Al Salama? Why the name Abate? So I thought I will include our management team also in the inauguration function just to clear up those doubts. So for that, I call our beloved Managing Director, MD, Dr. Advocate Shamsuddin, to clear those doubts of my friends.
Good morning. Thank you very much, Shaji, for giving an opportunity. എനിക്ക് തോന്നുന്നത് കുറേ ആളുകൾ രാവിലെ മുതലേ ഇരിക്കുകയാണ്, ഡോക്ടർമാരുമാണ്. അപ്പോൾ വലിയ പ്രയാസമില്ലാത്ത ആൾക്കാർക്കൊന്ന് എണീറ്റ് നമുക്ക് ചെറിയൊരു എക്സസൈസ് ചെയ്തിട്ടാണ് തുടങ്ങാം. ഓക്കെ, ഒന്ന് എണീറ്റ് നിൽക്കാൻ പറ്റുമോ? ഓക്കെ, അപ്പോൾ ചെറിയൊരു എക്സസൈസ് ഞാൻ പറയുന്നത് പോലെ ചെയ്യാം. ഓക്കെ, എല്ലാവരും കൈ ഒന്ന് മേപ്പെട്ട് വെക്കുക, ഒന്ന് തലയിൽ തൊടുക, നെറ്റി തൊടുക, താടി പിടിക്കുക. പല ആൾക്കാരും താടി എവിടെയാണ്? ഇവിടെയാണ്. ഞാൻ പറയണത് പോലെ ചെയ്യാനാണ് നിങ്ങളോട് പറഞ്ഞത്, ഞാൻ ചെയ്യണത് പോലെ ചെയ്യാനല്ല. ഓക്കെ, അപ്പോൾ ഒഫ്തൽമോളജിസ്റ്റ് ആകുമ്പോൾ കണ്ണിനാണ് കൂടുതൽ പവർ, വായക്കല്ല എന്നുള്ളതാണ് ആദ്യമായിട്ട് നിങ്ങളോട് പറയാനുള്ളത്. ഓക്കെ, ഇനി ഡോക്ടർ ഷാജി വലിയൊരു കാര്യമാണ് പറഞ്ഞത്, എന്തുകൊണ്ട് അൽസലാമ അബെയ്റ്റായി. അപ്പോൾ അതിനു മുമ്പ് ഒരു ചോദ്യം ഞാൻ ചോദിക്കാൻ വീണ്ടും. ഡിമാറ്റ് അക്കൗണ്ട് എന്ന് പറഞ്ഞ സാധനമുണ്ട്, അതിലുള്ള കണ്ണ് ഡോക്ടർമാർക്ക് ഒന്ന് കൈവെക്കുമോ? ഡിമാറ്റ് അക്കൗണ്ട് ഓക്കെ, കുറേ ആൾക്കാരും കേട്ടിട്ട് പോലുമില്ല. ഓക്കെ, വെരി ഗുഡ്. ഡിമാറ്റ് അക്കൗണ്ട് എന്ന് പറയുന്നത് സ്റ്റോക്ക് എക്സ്ചേഞ്ചിൽ സ്റ്റോക്ക് വാങ്ങുന്ന ഒരു അക്കൗണ്ടാണ്. ഓക്കെ, ഇനി BSc എസ്റ്റാബ്ലിഷ് ചെയ്തത് 1875 ഫ്രം ദ നോർത്ത് കേരള. ദാറ്റ് മീൻസ് മലപ്പുറം, കാലിക്കറ്റ്, കണ്ണൂർ, കോഴിക്കോട്, കാസർഗോഡ്, വയനാട്. How many listed companies in BSc? Anybody? Any idea? No listed company in BSc. Last 147 years. അപ്പോൾ ഈ ഹിസ്റ്ററി ഒന്ന് ചേഞ്ച് ചെയ്ത് വി ആർ ദ ഫസ്റ്റ് North Kerala based company in the history of BSc. അതിന് 6 ഡയറക്ടേഴ്സാണ് ഉള്ളത്. ഒന്ന് ഞാൻ തന്നെയാണ്, ഒന്ന് മുഹമ്മദ് കുട്ടി, ഡോക്ടർ സാദിഖ്, ഡോക്ടർ സഫറുള്ള, ഡോക്ടർ രാജേഷ്, and one more director is there, Jamal. He is a CEO of Cosmo Travels, a subsidiary of Air Arabia. അപ്പോൾ ഞങ്ങളെ സംബന്ധിച്ചിടത്തോളം ഈ അബൈറ്റ് AS എന്ന പേര് മാറ്റത്തിലൂടെ ഒരു ഗ്ലോബൽ കാഴ്ചപ്പാടിലൂടെ ഞങ്ങൾ വരികയാണ്. വരുന്ന ഒരു 10 വർഷം കൊണ്ട് വി ആർ പ്ലാനിങ് ടു സ്റ്റാർട്ട് 44 ഐ ഹോസ്പിറ്റൽസ് ഓൾ ഓവർ ദ വേൾഡ്. അപ്പോൾ അതിൻ്റെ ഒരു പ്രോസസ്സ് എന്ന് പറയുന്നത് ഇറ്റ്സ് എ വെരി ലോങ് പ്രോസസ്. ഫസ്റ്റ് ഓഫ് ഓൾ I appreciate all the doctors here, because why you are coming here today? To improve your knowledge, right? So I know that very well. You know ophthalmology well. But if you consider your skills in the surgery, it may be 5% or 10%. Still you have to improve 90%. Right or wrong? Before starting this eye hospital, what I understand, ophthalmology is only one. ഇപ്പോൾ എനിക്കറിയാം ഡോക്ടർ സാദിഖ് മാനേജ് ചെയ്യുന്നതല്ല ഡോക്ടർ സഫറുള്ള മാനേജ് ചെയ്യുന്നത്, ഡോക്ടർ സഫറുള്ള മാനേജ് ചെയ്യുന്നതല്ല ഡോക്ടർ രാജേഷ് മാനേജ് ചെയ്യുന്നത് എനിക്ക് നന്നായിട്ട് അറിയാം. പക്ഷേ ആളുകൾക്ക് വേറുള്ളൊരു ഡൗട്ട് എന്താ അറിയോ? ഒരു ബിസിനസ് ചെയ്യണമെന്നുണ്ടെങ്കിൽ എന്ത് നോളജാണ് വേണ്ടത്? വാട്ട് നോളജ് റിക്വയർഡ് ടു start a business? Finance. What else? ഇതാണ് നമ്മുടെ മിസ്അണ്ടർസ്റ്റാൻഡിങ്. ബിസിനസ് തുടങ്ങണമെന്നുണ്ടെങ്കിൽ മാനേജ്മെൻറ്റ് എക്സ്പേർട്ട് ആയിരിക്കണം. അതിനെന്തൊക്കെ വേണം? ഫിനാൻസ് ഒരു പാർട്ട് മാത്രമാണ്. ഓപ്പറേഷൻ വേണം. നിങ്ങൾ പറയണ ഓപ്പറേഷൻ അല്ല കേട്ടോ, ഓപ്പറേഷൻ മാനേജ്മെൻറ്റ്. ഓക്കെ, ഫിനാൻസ് മാനേജ്മെൻറ്റ് വേണം, HR മാനേജ്മെൻറ്റ് വേണം, പിന്നെ മാർക്കറ്റിംഗ് മാനേജ്മെൻറ്റ് വേണം, IT വേണം. ഇതിനൊരു ടീം വേണം, ഇതിനൊരു ലീഡർ വേണം. അവർ എവറി ഡേ ബിസിനസ് വേൾഡ് ഈസ് ചേഞ്ചിങ്. ഇപ്പോൾ നിങ്ങൾക്കറിയാം, നമ്മൾക്ക് മൊബൈൽ ഉപയോഗിക്കുമ്പോൾ ഏത് മൊബൈലായിരുന്നു എല്ലാവരും ഉപയോഗിച്ചിരുന്നത്? മൊബൈൽ സ്റ്റാർട്ടിങ്ങിൽ ഏത് മൊബൈലായിരുന്നു? നോക്കിയ. ഇപ്പം നോക്കിയ ആണോ ഉപയോഗിക്കണത്? ആ കാലഘട്ടത്തിൽ നോക്കിയ ഉപയോഗിച്ചതിൻ്റെ ഓരോ നമ്പർ പോലും നമുക്കൊക്കെ അറിയാം. വാട്ട് ഹാപ്പൻ നോക്കിയ? കാലഘട്ടത്തിനനുസരിച്ചിട്ടുള്ള ചേഞ്ച് വന്നില്ല അല്ലേ? ആപ്പിൾ വന്നു. ആപ്പിൾ വന്നപ്പോൾ തന്നെ ഉടനെ തന്നെ സാംസങ് അത് ഒപ്പിച്ച് ഗൂഗിളിനായിട്ട് ഇതാക്കി സംഗതി കൊണ്ടുവന്നു. അപ്പോൾ ബിസിനസ് എന്ന് പറയുന്നത് നല്ലവണ്ണം റിസർച്ച് ചെയ്യേണ്ട ഒരു സാധനമാണ്. അത് സൈഡിലൂടെ പോകണൊരു പണിയല്ല. അപ്പോൾ പല ആൾക്കാരും വിചാരിക്കുന്നത് എഡ്യൂക്കേഷൻ അല്ലെങ്കിൽ ബിസിനസ് തുടങ്ങാൻ ഒരു എഡ്യൂക്കേഷൻ വേണ്ടെന്നാണ്. അപ്പോൾ ഇതിന് എന്ത് വേണം? കണ്ടിന്യൂസ് എഡ്യൂക്കേഷൻ വേണം, കണ്ടിന്യൂസ് റിസർച്ച് വേണം. അപ്പോൾ ഞങ്ങൾ പറഞ്ഞു വരുന്നൊരു പോയിൻ്റ്, ഞങ്ങളുടെ ഇപ്പോൾ പുതിയ ഷെയർ ഞങ്ങൾ എടുക്കുന്നുണ്ട്. ഇതിൻ്റെ ഫേസ് വാല്യൂ എന്ന് പറയുന്നത് 10 രൂപയാണ്. വരുന്ന 10 വർഷം കൊണ്ട് 10 രൂപയുടെ ഷെയർ 500 രൂപയിൽ എത്തിക്കുക എന്നുള്ളതാണ് ഞങ്ങളുടെ പ്ലാൻ. അതെങ്ങനെ എത്തിക്കുക എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ അതിന് വ്യക്തമായിട്ടുള്ളൊരു പ്ലാൻ ഉണ്ട്. എത്ര ബ്രാഞ്ച് തുടങ്ങണം, ആ ബ്രാഞ്ച് തുടങ്ങുമ്പോൾ എത്ര ടേൺ ഓവർ ഉണ്ടാവണം, ടേൺ ഓവർ കൂടുമ്പോൾ എത്ര പ്രോഫിറ്റ് ഉണ്ടാവണം, പ്രോഫിറ്റ് കൂടുമ്പോൾ എത്ര ഡോക്ടർമാരുണ്ടാവണം, എത്ര സ്റ്റാഫ് ഉണ്ടാവണം, എല്ലാത്തിനും വ്യക്തമായിട്ടുള്ളൊരു പ്ലാനോട് കൂടിയാണ് ഞങ്ങൾ മുന്നോട്ട് പോകുന്നത്. അപ്പോൾ അതുകൊണ്ട് ഞാൻ എൻ്റെ സംസാരം ചുരുക്കുകയാണ്. എന്തുകൊണ്ട് അൽസലാമ അബേറ്റ എന്ന് പറഞ്ഞു കഴിഞ്ഞാൽ ഗ്ലോബലൈസേഷന് വേണ്ടിയിട്ടാണ് അൽസലാമ അബേറ്റ് ആയിട്ടുള്ളത്. BSc ഇപ്പോൾ നിങ്ങൾക്ക് നോക്കിയാൽ അബേറ്റ് AS എന്ന് ഗൂഗിൾ ചെയ്ത് കഴിഞ്ഞാൽ ഞങ്ങളുടെ ഫുൾ ഡീറ്റെയിൽസ് കിട്ടും. അപ്പോൾ അബേറ്റിൻ്റെ കൂടുതൽ കാര്യങ്ങൾ അറിയുന്നതിന് വേണ്ടി ഡോക്ടർ ഷാജിനെയോ ഡോക്ടർ സഫറുല്ലാനെയോ സാദിഖിനെയോ രാജേഷിനെയോ ഒക്കെ ബന്ധപ്പെട്ടാൽ മതി. നിങ്ങൾക്ക് കൂടുതൽ ഡീറ്റെയിൽസ് അവർ പറഞ്ഞു തരും. താങ്ക് യു വെരി മച്ച്.
Thank you, sir. Next, we will move into the momentum distribution. Now I invite Dr. Advocate Shamsuddin Arikuril to hand over the momentum to Dr. Muttaya. Thank you, sir. Now I invite Muhammad Kutti Arikuril to hand over the momentum to Dr. Srinivas Kerao. Now the inaugural session is over. Then we will move to the...
We'll move to the next session. Thank you. Thank you, everyone. Thanks for making it. We'll start the next session, cataract. I invite Dr. Tamanna, Dr. Preeta.
കണ്ണുകൾക്ക് കൂടുതൽ നിറമുള്ള കാഴ്ചകളേകാൻ പുതുമയുള്ളൊരു പേര്. ഷോൺ ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ അബേറ്റ് AS ഒപ്റ്റിക്കൽസ്. ലേറ്റസ്റ്റ് ഡിസൈനുകളോട് കൂടിയ പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺഗ്ലാസുകളും അഫോർഡബിൾ പ്രൈസിൽ സ്വന്തമാക്കാം. ഇനി കണ്ണു തുറക്കാം പുതുമയുടെ പുതിയ ലോകത്തേക്ക്. അബേറ്റ് AS ഒപ്റ്റിക്കൽസ്. ഒറിജിനൽ, സ്റ്റൈലിഷ്, അഫോർഡബിൾ.
It gives me great
കണ്ണുകൾക്ക്
pleasure to
കൂടുതൽ
invite
നിറമുള്ള
a very
കാഴ്ചകളേകാൻ
dynamic surgeon to start our second session, Dr. Shreyas Ramamurthy. He is consultant, cornea, cataract and refractive services at the Eye Foundation, Coimbatore. He completed his MS from Aravind Eye Hospital and completed his fellowship in cornea and anterior segment from LV Prasad Eye Institute. He has received many awards. He has received a gold medal for MS ophthalmology from Aravind Eye Hospital. He has also received a gold medal in his contribution in subspecialty at IIRSI. He has also received a gold medal at the NIO meet in Pune. He has an amazing academic feat right from his school days. Coming to his publications, he has numerous publications. I have actually a whole list. He has 22 major publications in peer-reviewed journals. So we are really happy to have you here, sir.
I think the technology which Dr. Shaji has brought in this meeting is a little beyond what I'm used to. So, at the outset, I would like to thank everyone at Abate AS as I know it, and also Dr. Shaji for this wonderful invite, and really looking forward to interacting with all of you, and thank you for the opportunity once again. I would have loved to be a part of that keratoconus session. So it's my core area of specialty, and as a lot of different viewpoints which I had a lot, and maybe of what. But anyway, so moving on to the cataract session, and primarily here to represent Alcon and a variety of their equipments and IOLs. So I'm going to be talking to you all first on Centurion and subsequently about Panoptics. And unfortunately, Dr. Bala could not be here today because of sudden health. So I'll briefly be talking about the Vivity IOL as well. So starting off with the Centurion vision system and active fluidics. I mean, as you all know, over the last decade, this phaco machine has really revolutionized the way we are approaching cataract surgery today, the ease with which we are able to approach cataract surgery, as well as deal with a variety of complicated situations which were initially being thought as cases where you cannot perform phaco, where you would want to either do an ECC or an SICS. Now almost there is no case today where phaco emulsification cannot be done. It's not just about our improved technical skill, but it's also to do with our understanding of the equipment and the better control that the modern day phaco machines are able to give us. So quickly running through the phaco machine itself, the Centurion system is a very good looking machine, as you can see here. Has a very interactive display, very ergonomically designed, and one of the things which you'd fall in love with is the wireless foot switch, which really makes it extremely comfortable, ergonomically designed, especially if you have a long list. But what really is setting this machine apart from the competition is the fact that it has what we call a loading bay, where you're actually able to which is the core of the active fluidics component of this machine. So we have always been conventionally used to gravity-based systems where the bottle height and the flow really determined how the stability of the phaco chamber was. But with this active fluidics, essentially, it is a dynamic responsive system. So it has two pressure plates in which a special BSS bag is placed, and the responsiveness of the pressure plate is controlled by the variety of sensors, the aspiration irrigation sensors, which are give a continuous feedback system. And this helps you to maintain a specific target IOP and maintain the stability of the chamber. So we'll talk a little bit more about it as we go on. The other advancements which the Centurion has brought in is the high performance peristaltic pump. So you have, instead of the previous Infinity which had 4 pressure plates, this has 7 of them, and these 7 rotors of the peristaltic pump is what increases the efficiency of the peristaltic pump itself. So the pinch effect is increased, and it has what we also call a dual segment pump. I'll allude to it in a subsequent slide as well. And these 7 loaded rollers are what are continuously working on both the upper aspect as well as the inferior aspect of the tubing and giving you a continuous peristaltic energy. It also has optical sensors. This optical sensor is on the machine and has corresponding sensors on the FMS as well, on the cassette as well. And this gives feedback to the machine every 5 milliseconds. And this continuous feedback is what helps in controlling the target IOP and maintaining the chamber stability right through the procedure. So this is the dual segment pump which I was talking about. Traditionally, the peristaltic machines had the pinching along one side, and on the other side, the tubing would just pass through without having any pinch effect. But here, because of the 7 rollers which are available, there is a peristaltic effect which happens both on the upper as well as on the inferior aspect, and this dual segment pump increases the efficiency of the peristaltic pump. Like I mentioned, on the cassette you have the corresponding aspiration sensor and irrigation sensor which provides the continuous feedback. Now you also have the active sentry which has come in, wherein there is a continuous feedback from the handpiece as well, which again increases the efficiency of the entire system. So how does this really help? Now, in a general phaco system which we've been used to all these days, when you're going in for a complete occlusion, the IOP actually increases because the outflow has been reduced, and when you reach full occlusion, the IOP then stabilizes. But then when your piece is either emulsified or the piece is removed from the phaco tip, there is an occlusion break. And this occlusion break is what causes the drop in IOP, and this because of the sudden evacuation of the fluid, and that is what causes the surge. And this reduces the stability. Now we have had multiple traditional mechanisms like venting and the bore sizes, the tubing compliance and other things which have helped in reducing it. But we have never really addressed the core problem, which is the IOP fluctuation itself. And this is where the Centurion is making a difference, wherein what it does is when you're reaching a partial or full occlusion, it is sensing that the IOP will go up, and it is automatically controlled by the action of the feedback system and on the pressure plates. So the IOP actually does not increase, and your chamber neither deepens during your phaco procedure when you're fully occluded, nor is there any increase in the tension inside the eye. As a result of which, even when the occlusion breaks, there is hardly any fall in the IOP, and therefore the stability is better. There is no surge that you sense with this system. So this is really the main difference that the active fluidics brings in, and as you can see here, in comparison to volume displacement to vacuum, the Centurion definitely performs much better as compared to the previous Infinity system. So I'll take you all through a few cases to not make it too boring and too theoretical. So this is a fairly hard cataract with a iris coloboma, and usually these colobomatous eyes don't dilate uniformly, so you may require iris hooks, or it's difficult to put in. Oh, sorry, video is not running. hope the earlier slides were visible. Was still. Coming on this screen. It's visible on that. I think the HDMI cable is fine. It's the projector which is not. So I hope some of it is visible for the people at the back. So essentially what I'm trying to show in these videos is what I'm trying to show in these videos is the efficiency that the machine is able to give us in relatively difficult cases. Usually colobomatosis eyes are associated with hard cataracts, and there can be a mild zonular weakness if there is associated lens coloboma in that region. So generally you want a sufficiently sized rhexis to allow for a good safe phacoemulsification. So here in these hard cataracts, the chopping technique is very important. I do prefer a direct chop, but in these harder cataracts, I go in for a slightly core burying into the, doing a small trench in the center so that I can bury deeper, and then doing a multi-level chopping where you're first initially separating at a superior level, and as it separates you will find that there are some fibers, leathery fibers posteriorly attached. So you may have to go in a little deeper a second time and then separate it, hold a little deeper and separate it so that it breaks all the way right up to the center. Subsequent to the chopping technique, you will notice even in these relatively hard cataracts, it goes in with such ease and efficiency. This video has not been speeded up. This is actually the efficiency with which the cataract is being emulsified. And you would notice that the CD rarely ever crosses 28, 29, even in very hard cataracts, brown to black cataracts. So that is a distinct advantage which this system gives us. And also it helps us to deliver quality lenses. Like this patient had a significant astigmatism. This is a customized toric lens correcting about 7 diopters of astigmatism for this patient. And these are things which you can do with ease now because of the quality and efficiency which the machine gives us. This is just a brief video to show that you can also work on lower vacuum. Initially, we started off by working on the regular 60, 55 vacuum, but even now at a vacuum of 30, you would notice that the chamber is extremely stable, and even when the last pieces are being evacuated, you're working at a vacuum of 550, 600 with an IOP of 30. Even then, the chamber is very, very stable, and the patient is also extremely comfortable right through the procedure. Again, in cataracts which is a traumatic cataract which I had about 4 to 5 clockers of zonular dialysis, I'm initiating the rhexis with a needle, but then I switch over to the microforceps because you won't have enough countertraction to complete. You need a moderate sized rhexis. Obviously, you initiate away from the area of zonular weakness and then complete it towards it. The capsule hooks are my favorite in these techniques to initially stabilize and do a safe phacoemulsification. Now here where the machine helps is ensuring chamber stability again is very, very important in these cases because the capsule is weak, it tends to billow up. You can always add capsule hooks if you feel in that area of zonular dialysis where the bag was tending to billow upwards. And then once a couple of pieces have been evacuated, it becomes easier to put in the capsular tension ring. Now the capsular tension ring and capsular hooks work in tandem with each other. I like to use both of them together because the capsule hooks ensure that there is no progressive zonular dialysis during your phaco maneuvers, during your chopping maneuvers. And at the same time, you'll notice even in this case with a weak bag, the chamber remains stable right through the procedure, enabling us to do a very safe phacoemulsification, putting in a CTR. Traumatic zonular dialysis, usually a CTR is sufficient when it is not exceeding 4 or 5 clock hours, but when it is more, then we can use a CTS segment as well. This is some last cortex being removed from the area where the capsule hooks were, which cannot be removed prior to the removal of capsule hooks. So once the CTR is in place, IOL is in the bag is stable, you can remove the cortex without any injury to the bag in the dialyzed area. This is another case with an intumescent cataract with a small pupil again. So in these cases, again, visibility is very, very important because there is a high chance of rhexis runoff. You will have intumescent cataract either because of milky fluid or a very hydrated cortex. It's the hydrated cortex where the risk of runoff is even more because in the milky cortex, once you make a nick, most of it comes down, the intralenticular pressure reduces. So in these cases, this is my go-to technique. I make a small rhexis, debulk, either you can use a IA or you could just do a little bit of hydro maneuver, and then you could enlarge your rhexis subsequently and then go ahead with phacoemulsification. Again here, sometimes you might end up with a smaller rhexis, and having good chopping techniques with a stable chamber becomes very, very important. And that is where again the Centurion really helps, and you could emulsify these cases with these cataracts with ease, and it's quite comfortable right through the procedure, not having to change any technique, your settings in any way for any of these cataracts. Whether it is a moderate cataract or a hard cataract, I do it with the same settings and they continue to work quite well, and that is the kind of comfort which the machine gives us. There's also certain other parameters. Apart from the target IOP, you have the patient eye level, so that can also be monitored based on how your operating position is, the height at which you place your table. There's something called a irrigation factor and IOP ramp, which can also be modified to the speed at which you achieve the preset IOP, and all this can be used for surgeon control and can be modified, and the system responsiveness is also good. This is just a brief video to show where the bag becomes completely empty, and even then there is no fluctuation in the chamber. Now there's only the 10 indicates that there is only 10 ml left in the bag, and now even when it becomes 0, Only after I hear the voice saying that the bag is now empty, do I realize that the bag is empty and I remove my phaco probe. There's hardly any, you don't see any wrinkling, no collapse in the chamber as you would normally see. These are again one other difficult situation. It's an eye syndrome with a decompensated cornea. The epithelium has already been removed. And the cornea's early phases of decompensation, that's why it's hazy but not completely edematous. It's a fairly dense cataract. The other challenges with eye syndrome is the presence of peripheral anterior synechiae, especially in essential iris atrophy. It can be quite challenging. Chandler syndrome is less so, but in essential iris atrophy, this can be quite a challenge, not just during the phacoemulsification, but as well subsequently during the DSEC. In this kind of cases, it's very important that the iris is not manipulated at all because it can become very floppy. So having a stable chamber and doing in the bag phaco with your probe right in the center is extremely important. Subsequently, I know the talk about DSEC is beyond the scope of this talk, so I won't go into the details, but air management and bubble management becomes quite challenging in these cases as the bubble tends to go posteriorly behind the iris as the iris is kind of tenting forwards because of the already existing peripheral anterior synechiae. So in these cases, after doing, this is just the decimus stripping which is being done, but after the visco wash, you'll, once the lenticule is inserted, you'll find that the bubble does not tend to remain in the anterior chamber and it tends to keep going behind. So one of the things to do in these cases is to ensure you have a tight fill, even if there is a combination of air and fluid needs to be given to ensure you have a tight fill. Leave the patient with a tight fill for about half an hour and then you can go ahead and decompress and the iris falls back and you can still have a completely attached lenticule. I would avoid DMEC in these cases because it becomes a little more difficult to unfold in these situations. Again, this is just yet another hard cataract which where the chamber stability and the ease of phaco becomes much easier because of these advances. Just again alluding to the multi-level chopping to ensure that it breaks right up to the center. You may have to even hold one more time and then go a little deeper, bury a little deeper and then separate it in these hard cataracts. And this is essentially where this machine really makes a difference. In the regular cases, even in your normal machines, you would be quite comfortable. And like I alluded to earlier, this is quite consistent and it is not just in one case that even in these hard cataracts, your CD rarely exceeds 25 to 30. And that is something which the amount of energy consumption is also reduced by the improved fluidics. The emulsification is easy, the chamber is stable, and the overall surgical comfort with these cases is extremely good. It allows you to handle each and every case, any kind of case, challenging case with phaco itself, and makes the entire procedure much more easy. There's so many things which you can play with. You can have a combination of longitudinal and torsional phacos. You can have preset vacuums reaching a particular peak and then falling after it reaches a certain peak. You can alter the aspiration flow while it is going up the ramp to the peak and then stabilizing. There are a variety of settings that you can play around with and it's a fairly enjoyable experience. You can change the IOP ramp speed, the time it takes to reach the preset IOP. The flow compensation is also something very, very important for any egress of fluid which is happening through a possibly leaky side port or a main wound. That flow compensation is also carried on. It's just some of the improvements of the Centurion over the Infinity system where it has active fluidics, it has monitors the patient eye level, there is a leakage compensation which is available. The irrigation pressure can be controlled. You can select the speed at which the IOP has to go in. The dual segment peristaltic pump is something which really has increased the efficiency and some of the speed of emulsification which you see in the videos is also because of that. And subsequently, the fluidics can be monitored right through the surgery. The interpret balance tip is another advancement. This balance tip essentially, as you can see here, has this particular bend towards the tip. So it increases the torsional tip movement and it increases your stroke length for a similar tip size. So the traditional tips which you're using with the Infinity, the Kelman tips, for which gave us a stroke length of about 140 to 150, this gives you about 190 for the same kind of tip. And that is essentially because of the movement of the balance tip. There is greater movement towards the tip and lesser movement towards the incision, and this also reduces the incidence of wound burn and other problems. The vitrectomy system is also very, very useful. You have a high cut rate of 4,000, which gives you a very controlled vitrectomy, anterior vitrectomy when it needs to be done. And of course, if you have the Varion system and the Lensix platform with the Luxar microscope, it really gives you an entirely complete refractive suite, which gives you seamless transfer of information. There's nothing you need to enter, right from the IOL power to the settings to everything can be transferred from one system to the other. Thank you so much for your attention. Dr. Shaji, should I move on to the panoptics talk? So this is about switching gears from phaco machine to IOLs. We'll be talking about a quick overview of presbyopia correcting IOLs, though I'll be, sorry. So I'll give a quick overview of some of the presbyopia correcting IOLs that we are using with an emphasis on panoptics. So definitely the demands of the modern day patient are not very similar, although these are photographs of Caucasian patients provided by the company. This is not unfamiliar scenario even in India right now. And definitely, even if they are not skiing, there are activities which they want to do for distance very comfortably, even at the age of 60, 70. And definitely there is the usage of computers, laptops, screens has definitely increased. My 96-year-old grandfather spends an enormous amount of time on Facebook every day. And of course, he wants to read the newspaper when he gets up in the morning. So these are not uncommon demands of a modern day patient, and the IOL industry has to keep up with the demands of the modern day patient. We have various options now. We have multifocals, which are essentially started off as bifocal. I'm no longer even talking about refractive IOLs because I think they were used in an era even before I became an ophthalmologist 15 years ago. So it's really not refractive IOLs are totally gone, and it's only a bifocal or a trifocal diffractive, and of course the newer age EDOF lenses that we are talking about. In this particular talk, when I talk about EDOF, I'm only going to be referring to Symphony, though we have a lot of extended EDOFs, monofocal EDOFs which are available, which I'll probably cover during when we speak a little bit about Vivity. So in the diffractive bifocal, we traditionally had the Restore IOL or the Technis multifocal IOLs. There are a variety of wonderful Indian companies which make very good Indian multifocal IOLs. And this has really helped us extend the reach, the benefit to a large sector of patients. And I think there is excellent value for money that a good number of Indian multifocals give us. And it helps us to give the opportunity for a patient who's not willing to pay a large amount to also have and enjoy the multifocality. So it's just a line to encourage the use of those lenses as well. Blended vision was being tried a lot when we were talking about intermediate vision. We had low ad and high ad IOLs, where essentially we put in the high ad in the non-dominant eye for giving very good near vision, but the low ad IOLs were being used in the dominant eye, which gave you a little better intermediate vision apart from having good distance vision. Then you had the EDOF lenses, which gave excellent distance and intermediate. However, the near was a little unsatisfactory, and therefore we had to resort to doing a micromonovision, where you leave behind a little bit of the myopia in the non-dominant eye, 0.5 to 0.75, and this helped in bridging the gap between the near to the intermediate to the distance. Essentially, the claim with the EDOF lenses was that you may have lower photic phenomena, and this is something which I address in the later half of the presentation. So what they were trying to say was the EDOF would try to go closer to that of a monofocal lens and give you a similar contrast and MTF scores as you would see. So then came the fact that because we are, by using an EDOF, having to do this micromonovision 0.5, 0.75, without which the patient would not have near vision, came the mix and match concept of putting in a symphony in the dominant eye and a high ad power in the non-dominant eye. This also helped, like in some of the patients where you can see this particular post-op, where the patient has a very, very small requirement for reading N6. In these patients, they would be quite happy to go ahead with just a little bit of micromonovision, and then they do extremely well. But you could have another set of patient who's not very happy, requires a higher ad, a +1 or 1.25, where even doing a 0.5 or 0.75 micromonovision will not be good. And anything more than a 0.5 or 0.75 micromonovision is also not good, because a significant defocus will also increase the amount of photic phenomena which the patient has. So it's not good to have a large amount of defocus with a multifocal IOL. So in these cases, it's better to go in for a higher ad multifocal. Possibly the patient may have a shorter working distance, wants to read at a closer distance, and these high ad multifocals do well. So this mix and match, which we were using in occasional patients, there was a proper study which was done on it, where you could see by using a low ad multifocal and a high ad multifocal, which is what we were doing earlier, gave good distance and near vision, but the intermediate vision was a little suboptimal. Whereas by using a EDOF in one eye and a high ad multifocal in the other eye, the intermediate vision was, the quality of the intermediate vision was better, and a greater percentage of patients achieved 20, 25, 62 versus 97% in this study. Then came the trifocal era, and predominantly we are very much in the midst of it, and using the Panoptics, which is a hydrophobic, and Zeiss 80 Lisa Tri, which was another hydrophilic plate haptic which is available. Now the initial concern was, would bifocal, where we had a lot of photic phenomena issues on and off, which was a concern, would trifocals increase the amount of photic phenomena? So we thought more foci, more rings, you will have more photic phenomena. But that was not really the case, and I will talk about why that's not really the case. And actually the photic phenomena is comparable or slightly lesser than the bifocal multifocals. So the monofocal IOL, you have a single base curve, single power, which helps you see for distance. In the bifocal, you have a single diffractive ring which goes over the base curve, and based on the number of rings and the add power, you had a working distance of 25, 30 or 40 centimeter, and you could choose it according to that. Now conventionally, what happens with a trifocal is, your near, the way the lens is designed, the near target becomes half of the intermediate target. That's how the diffractive ring gets adjusted, the space between the diffractive rings. So because of which, we were initially getting a 40 and 80 centimeter with the traditional trifocals. Now this 80 centimeter was a little farther away for an average human being, because you would have to be quite tall, well beyond 6 feet, to have an intermediate working distance of 80 centimeters. So you needed it to be a little closer, and that's where the Panoptics, they started off with what was a quadrifocal technology. Essentially, you had an extended intermediate at 120, which was cut down to half of 60, and then you had the near at 40. So essentially this quadrifocal enabled you to bring down the intermediate, or having a preferred intermediate, from an 80 to a 60 centimeter, which is more appropriate for an arm length for a person of average height. So the other thing which they did, I understand very little of this so-called enhanced light energy technology, but essentially what was done was, this 120 centimeters, so where you had a quadrifocal, that was truncated and the light energy was transferred for distance. So essentially, your entire, that 120 did not exist, and that was just used for the design of the lens. But the light energy distribution, there is no light energy going for the 120 sweet spot, is just being used for distance, and the remaining light energy is only being utilized for the 60 and 40. The reason this light energy utilization becomes very, very important in multifocal IOLs is greater the light energy utilization, lesser the stray light, lesser the amount of out of focus images which produce the photic phenomena like glare and halos. So greater light energy utilization was brought about by this enhanced technology, wherein, or the enlightened technology as they called it, where essentially the quadrifocal of 120, the light energy was truncated and being shifted for distance, and only the near and intermediate remained. Also, the rings last 4.5 millimeter of diffractive zone, as opposed to a slightly larger than what was there in the earlier restored. This gave a little greater sweet spot of pupil independence. So essentially, even if the person has a slightly a larger mesopic pupil, these patients tend to do quite well. The light energy utilization, which I was referring to, 88% of the light energy gets utilized in the panoptics. It's 100% in monofocal, or close to 100% in monofocal. But in the multifocal, because it gets split between the different foci, there is a certain amount of light energy which does not get utilized. And this stray light is what causes the out of focus images, glare and halos and photic phenomena. So this is again just the defocus curve showing the trifocal lens, giving you a peek at intermediate. It's just a quick video of the panoptics lens being implanted. It's very simple, very similar to the IQ lens, and really no difficulty in loading as well as implanting. It's just a version of the panoptics toric. Again, all you need to ensure is that you have a uniform overlap of the rexes, as you can see in this case, and a well-centered IOL with the Purkinje images on the center of the IOL. So I'll quickly run through what really were the options prior to the now extended mono EDOF, that is, let's say, Vivity and its other competitors. But we either had to choose between using a bilateral trifocal IOL or using a bilateral EDOF with micromonovision. So essentially, what we were trying to analyze through this study was to see whether a bilateral trifocal where you didn't have to do any micromonovision made the patient happier, or whether the patient with the micromonovision, because of the EDOF, were they having better contrast, better MTF scores, lesser photic phenomena, which is what we thought would be the case when we started this study. So we tried to compare the near and intermediate, and we also looked at the objective quality of scores through MTF scores, HOA and contrast sensitivity, and also had a subjective questionnaire. So this was a quick study done over 2 months of 64 eyes of trifocal and EDOF with micromonovision, and the micromonovision was targeted at 0.5. Now, uncorrected near visual acuity was better in the trifocal group or the panoptics group, which was expected because we did feel having a bilateral panoptics aimed at emetropia, these patients were doing very, very well with uncorrected near vision, a little better than the EDOF group, whereas the distance and intermediate was similar between both the groups. But what we did not expect was when it came to the objective quality of scores, looking at higher order aberrations, looking at MTF scores, these were very, very similar between both the groups. We expected MTF scores, we expected contrast sensitivity to be better in the EDOF group, but that was not the case. And spatial frequency both at 3 mm and 5 mm pupil was similar between both the groups. The contrast sensitivity both in scotopic and mesopic conditions were similar between both the groups. So in essence, we really did not find any difference in the quality of vision between the groups. The trifocal did just as well as the EDOF lens of diffractive technology. And the only advantage which the trifocal gave was as the defocus curve from the 0 to -2, it was quite similar between both the groups. But as you went to 2.5, 3 and 3.5, that is where the trifocals did much better, and the uncorrected near visual acuity was also better. The subjective questionnaires with photic phenomena were also quite similar between both the groups. So really what helped was, explaining to a patient about the concept of micromonovision and telling them not to compare by closing one eye with the other and asking them to view binocularly was a slightly more difficult concept for them to understand. Definitely took a little more chair time. But whereas with the trifocals, it's bilateral similar surgery, and with the, although we don't practice simultaneous bilateral cataract surgery, but there is a large body of surgeons who do it worldwide. And they feel with the advent of newer IOL power formulae, you are able to do simultaneous bilateral cataract surgery with trifocals and give them uncorrected 6.6 and 6/20/20 the next day. We've all switched over predominantly to the Barrett Universal 2. One point which I wanted to highlight before I close is that it's very, very important to address astigmatism when it comes to using multifocal IOLs, because astigmatism, any residual astigmatism greater than 0.5, 0.75 degrades multifocality, and the patient would be quite dissatisfied. So sometimes a very small astigmatism like this, you feel that it doesn't need to be addressed and you could go ahead with a spherical power, but the patient is not as happy and definitely requires a certain, you can see that the uncorrected visual acuity is only 618. So when you run these patients through the online calculator, or if you have devices like IOL Master 700, which gives you, it has the built-in toric IOL calculations, wherein you will notice that every patient, you run them through this, because of the higher the incidence of posterior corneal astigmatism, you will find that even patients with 0.8, 0.75, 0.9 may require a T3 or a T4 model. So it's important that we look into these aspects before you choose the appropriate IOL for the patient. And this is especially important when you have against the rule astigmatism. Whereas if you see a patient with a similar level, you saw 0.8 in that eye, but 0.75 with the rule astigmatism, the calculator does not suggest any toric model, because essentially the amount of, some amount of posterior corneal astigmatism will compensate for the withdrawal astigmatism on the anterior surface of the cornea, and therefore the patient will have hardly any residual astigmatism. So trifocals really are the way forward to meet the modern day visual demands of the patient. Addressing astigmatism and having a tailor-made approach according to the needs of the patient and their working distance becomes very important. Thank you so much.
Yeah, we have the wet lab session going on the other hall. So those of you who wants to have a hand on the phaco machine, please do go and give your phone mobile numbers. They'll call you when the slots are free. It need not matter if you are a phaco surgeon or not. See, this is just like marketing with a BMW. They make you ride the car, then give you the feel to buy it. So it doesn't matter if you are not a phaco surgeon, you haven't even done a single case. This is just a hands-on experience of how or what the phaco surgeons feel when they do it. Maybe with that, you will start a dream to become a phaco surgeon sometime. Okay? So you can go give your mobile numbers. They'll call you when their slots are free. Thank you. Sorry, guys. Okay. Next speaker.
Vivity, or should we come back?
Vivity, if we can split up. Okay, thanks.
Okay. Thank you so much.
Yeah, Ramesh.
Optical visual access, when it went to bifocal diffraction, the talk was on the angle alpha, angle kappa. What about?
So I didn't delve into the depth of, angle kappa less important in multifocal IOL itself, because it becomes more important when we are correcting refractive errors, because essentially we want the treatment to be on the pupil center, so the gap between the pupil center and the visual axis becomes important. Here we expect the IOL to center within the bag, and that is the center of the white to white, which would be the optical axis, and the gap between the optical axis and your visual axis becomes the angle alpha, and that becomes more important. Now, the newer lenses have a slightly larger central zone, so about 1.2 millimeter,
So half of that, maybe 0.5, 0.6 of angle alpha becomes something which is tolerable. The only problem is, even with the modern day equipments with iTrace, IL Master 700, various other equipments which can measure IL Master 700, there's a good visuometrics device as well. All of these, there is still a significant variability in the measurement from device to device, and we really don't know how accurate the science is as far as measurement of angle alpha is. That is one. And that is possibly why, when we looked at comparing patients with higher angle alpha and lower angle alpha, where we have implanted, and looked at their symptomatology, subjective acceptance, photic phenomena, we really couldn't make a difference. Yes, fortunately, the incidence of angle alpha is not very high in our population, but even when we managed to get a subset of patients between 0.5 and 0.75 and versus less than 0.5, we couldn't make any difference.
In your comparative study, you were comparing the Panoptics with the EDOC. Which was your EDOC? Was it Vivity or something?
No, sir. That time it was the Symphony, sir. Symphony with micromonovision.
Thank you, Dr. Shreyas, for those wonderful two talks, very informative. Next, it is my pleasure to invite Dr. Bindu S. Ajit for the next talk. Bindu ma'am is from Namada, Kozhikode. She's done her MBBS from Calicut Medical College and her ophthalmology training as well from there. She's done a fellowship in glaucoma from Arvind Eye Hospital, Coimbatore. She's been working with Comtrust Eye Hospital since 2002 and was instrumental in setting up their glaucoma department in 2007. She's an extremely high volume surgeon. She's trained in MIGS and she's been training multiple fellows in phacoemulsification for the past several years. Ma'am is presently also the Secretary of the Kozhikode Ophthalmic Society. She's attended and conducted various glaucoma as well as phaco workshops. Over to you, ma'am. Ma'am will be speaking to us on astigmatism management in cataract surgery.
Thank you. Thank you for the welcome. And thank you for making me share the stage with great icons. A really proud moment for me. Now we'll go to the topic, where within 15 minutes, any phaco surgeon can dream of or become a reality, become a cataract refractive surgery. So through this talk, I'll just mention why we are into toric, how we get equipped to do a toric, and what are the alterations we are doing in the procedure, and some of the errors we can come across. So like we had the previous speakers mentioning, we keep on increasing our surgical skill, and there is also the machine technology and the fluidics are also improving in a skyrocketing way. And the IOL designs in the platter is just increasing day by day. And as the previous speaker showed you, the high expectations of the patient. And we try to meet both and to give our best to the patient, and for us also, we need to develop from the phaco surgeon to become a phaco refractive surgeon. So the spherical part has been dealt with. Now I'll just deal with the astigmatism and the toricity part alone. Now we all are aware of the astigmatism with the rule, against the rule, but what the fact we are not aware of is that the magnitude of astigmatism that is present in our cataract population. We have around 30 to 47% of our routine cataract patients who are having astigmatism of more than 1 diopter, which we tend to miss. This is the same scenario both in the Indian population too, and we also did an audit at our hospital, and we had a 30% population with pre-op astigmatism. So this just gives you an amplitude or the magnitude we have to deal with when we have to shift to do a toric IOL. And we also know how toricity affects the quality of the vision too. There are multiple ways of correcting this toricity or the astigmatism, but my topic today will be with the toric IOL and how this stands apart with the other. It can be done as a component of the routine cataract surgery, and astigmatism management is more predictable and there is no regression here and it can be easily reversed also. So once we have decided to do the toric IOL, now we need to know how much to correct and in whom to correct. Now what is the ideal patient? It's very imperative that we select the ideal case so that we end up with both happy patient and happy surgeon. The ideal candidate should have the word regular astigmatism is the word to be underlined. We should select patients with regular astigmatism with no major ocular comorbidities and patients who are interested to reduce the wear of glasses. Now, during the surgical procedure, what are the requirements is you need to have an intact capsular bag and a continuous capsulotomy which prevents the rotation of the IOL once you have placed it in the axis. Now, when you come to difficult cases, which we saw the video, it is if you're not getting a rhexis, it might be, you might end up in trouble if you are doing a toric. So it's better to counsel the patient. We will try to do a toric, but if you're not able to do the rhexis properly because of this cataract or a difficult case, or if in case of posterior polar cataract, we expect a PCR, you can counsel the patient, be ready with both the lenses, and we can go in for a toric lenses. Now, how much to correct? It is, again, like our previous speaker clearly explained, against the rule, it is about 0.8, and with the rule, it's 1. But if you're going for a multifocal, even a minimal amount of 0.5 to 0.75 needs to be corrected. Otherwise, we end up with both compromised distance and near vision. Now, we have a wide range of toric power available. And even you can even customize it to the higher powers. Now we have decided to do a toric lens. Now what are the way you prepare yourself and prepare the patient? We have to measure the anterior and the posterior corneal astigmatism, the magnitude and the axis. We have to look the corneal surfaces for any irregularities, the keratoconus or any prior LASIK or the PRK surgeries. Definitely we have to exclude dry eye, especially this causes problem when you are measuring the keratometry reading. And you have to calculate your SIA and the centroid method. And then you have your online platforms to calculate your toric IOL. And then comes the reference marking. We'll go to it one by one. Now, just to understand what the storicity is, we have two elements. We have the pre-op corneal cylinder of the patient, and the next ingredient is the surgically induced astigmatism, which you are inducing during the surgery. So both has to be taken into consideration, and not to mention the amount of time you spend for biometry is the most important, and it has to be accurate. The axis length, even a small millimeter can give you spherical surprises. And the most important step in the toric lens is the keratometry, and it is important both for the axis and the power of the IOL. So how different is it when you do a keratometry in a patient whom you have selected for a normal IOL and for a toric IOL? You need to have multiple readings to enhance the accuracy, and you use the two devices with the two different principles if possible, and check if the steep meridian is same on both the keratometers. And if there is any variation, you should always see if there is patient is having a dry eye component, use a lubricant and then repeat it. Now, we also heard mentioning about the posterior corneal astigmatism, which is not a part of toric calculation the previous years. Now, this has become a very important topic because the posterior cornea acts as a concave lens and it affects the astigmatism correction. So, we can calculate it with the devices which we have. In the morning, we saw how he was explaining it with a pentacam, but it's not to worry if you don't have a pentacam. We have a normograms which you can use to calculate the posterior corneal astigmatism, and the Barrett toric calculator has an inbuilt automatic calculator which calculates both the magnitude and orientation of the posterior corneal astigmatism. Now, the next factor is the surgically induced astigmatism. Initially, we were using only the SIA. The ideal way is to calculate your own SIA with the online calculators, or you use the general guideline of 0.5 or 0.75 according to your incision size. But now we move on to the era of centroid values, where the SIA is calculated in both dimensions with magnitude and orientation. Again, you can use online calculators, or for a beginner, you can use it with a centroid value of 0.1. Now, I'll just simplify it for you with some figures. If your K1 reading is 46 and K2 is 42, what we learned is the astigmatism now is 2 at 85 degree. Like if it is with the rule astigmatism, we can subtract the posterior astigmatism and it comes to around 1.5. This is what we got the net astigmatism as. And then with that, we have to add upon the surgically induced astigmatism, and totally you get the projected post-op corneal astigmatism. That is what we get for the correction. But it is not, we cannot stop with that, because we are correcting the astigmatism at the plane of the intraocular lens. So initially we used to add just a factor of refractive factor, but now with the advancement, we have the estimated lens position where it can change between a myopic eye or a small eye. So we have calculators which include all this also. To sum up, we have to measure the anterior and the posterior astigmatism and also take care of the refraction factor. So this is all to just understand when you're given a sheet of paper with a toric IL calculator, because all this is already done, but to understand it better, you better have a knowledge of all what I've been told before. So with good prediction, you get it in Barrett-Torrent calculator with a minimal least post-corneal astigmatism, and you get the predicted IOL and where you have to place it. I'll just show you how you calculate. So we have two keratometric reading, compare with the two, and then you enter the K1, K2 steep axis and the flat axis, and you enter the axial length, the anterior chamber depth, and it is not necessary that you have to keep on changing your incision side. You can start with where you are comfortable doing it, and then you will get the power lens, and also the axis to be placed will be given to you. The main factor is you have to match it with the patient, but you cannot do it when the patient is lying down, because there is a factor of cyclotorsion where the eye gets rotated. So it's imperative to mark the horizontal axis in the sitting position. There are various ways of doing it. I'll just demonstrate this is the bubble marker. I'm not playing. Shall I take the video from the other one?
I think this is good.
No, I'll just folder land.
ഡ്യൂപ്ലിക്കേറ്റ് ചെയ്തിട്ടുണ്ടോ അത്?
എന്തെങ്കിലും ഞങ്ങൾക്കറിയില്ല.
Okay. So you just, with a marker pen, you mark the So I'm just taking it out individually. So, I'll just see. PowerPoint.
Anyway. Submit the PowerPoint. Other rows here. Hide presenter view. Then we will go to the next. Now ഇത് ഇവിടെ play
Yeah.
ചെയ്യാം.
Okay, fine. Yeah. So here you can see the A bubble, which has to be horizontal and in the center when you're marking. So now you see you're placing it so that you see the mark at the center, and then when it is center, you touch the cornea and you get the marking. So the other method is the slit lamp marking, which I commonly do. Just makes patients sit in the slit lamp with the horizontal beam at the, and then mark the 3 and 9 o'clock. When you mark it with only a marker pen, by the time you take it to the theater, there are chances that it will fade off. So you can always use a 23 gauge needle, bend, and then you do a nick on the cornea. You also have the image guided system where you need to do all this. Now we come to the surgery procedure as such, where you have to take some consideration when you're doing a toric. So this is the pre-op marking with the Mendes ray. You just have to compare with the sheet and make sure you kept the sheet in alignment with the patient so that the axis is not changed. You can also use, I generally use now a dialer to mark it. You can also mark your incision site also, but make sure when you're placing your IOL, you don't get confused between the two. Now the next important step is the section. You have to take care of the section because that definitely influences the astigmatism part. And the next important thing which you have to take care is the rhexis. You have to make sure the rim of the IOL is well covered and it is centered so that after your surgery also there is no rotation of the IOL, which is very important. Now we have done a phaco, now comes the intraocular lens implantation, where you have to align it in a particular direction, which is different from what we have been doing before. So it's just that you don't keep it aligned at the axis which you have marked, just to make sure that it doesn't rotate when you're doing the wash, because the visco has to be thoroughly washed unless. So just a video showing the intraocular lens implantation, like how differently we do in a routine, and this is, you don't put the IOL completely in the bag because you have difficulty in rotating it after once it is fully in the bag. So the leading haptic goes into the bag, and then you rotate the trailing haptic so that it is just 10 degrees away from your marked region. Sorry. So just, you see the 3 dots on the lens and then align it. The next important part is the visco wash. You have to wash it thoroughly, otherwise you will have surprises post-op. So you go under the lens. The point we have to note here is when you're going under the lens, your second hand has to guide the lens, otherwise it will have too much of movement, and then you slightly nudge it and bring it to the axis which you have marked. And the next important step where you can go wrong is your hydration of the wound. If you overhydrate it and overdistend the bag, there is a chance of rotation of your lenses which you have placed. So be gentle with your hydration. There's just another case of where you can just see the marks more clearly. Just rotate it, that's all. That is the only difference what you do from a normal phaco to a toric phaco. So it's just simple for everyone who's doing phaco to start a toric lens. And the next additional step is of course the wash of the visco under the lens. And take care the lens doesn't rotate too much when you're washing the visco underneath. Always you support with the other hand instrument so that it doesn't rotate too much. So like what previous speaker also showed a toric case and a colobomatous case, initially you select all safe cases, and once you are into it, you can also do it in difficult cases. This is one of my case who had undergone retinal surgery with silicone oil, and he developed secondary glaucoma, valve done. Actually he did a trap first and then a valve done, and then he had a toric element, and if the vision is getting corrected to 6-12, yes, you can go ahead with toric in these patients also, because it is a much forgiving lens, an adaptive lens. It doesn't have much issues like the multifocal lenses. So if the marking is not clear, you can also use peroperatively, you can just check your axis also. You can just check whether you have aligned it correctly in the predetermined axis. That also can be done after you're placing IOL, and then you can rotate it accordingly also. Like I told previously, even if you have a PCR and a posteropolar cataract, if it is central, well, and you know the IOL is going to be stable, you can go ahead with your toric lenses. Now what next after surgery? You just have, not like the routine case, what different you do is you check the placement of the IOL. You can tilt the slit lamp beam and see and match it with your marking in the sheet given to you. But you needn't go for the point by point, because even slight rotation, it doesn't give much surprises for you. When you get surprises is when it is tilted too much or rotated too much. So if your rotation is around 15 degrees from your desired axis, you lose 50% of its efficiency. Like for example, if your toric lens is of 2, you get a 1 cylinder correction if it is 15 rotated. And if it goes to 30 degree, then the whole cylinder remains as such. You have no correction of the cylinder. And if it is more than 30 degree rotation from the desired placement, you induce an astigmatism the other axis. So what happens if your IOL is not in the desired plane? You don't go and rotate it to the previous plane, but we have an online astigmaticfix.com website available where you have to enter the current placement and the current refraction, and then you get a new axis where you have to rotate it, and then you can take up the case for rotation, redialing, and rotate it according to the new marking. It has to be done before the 2 weeks, because after 2 weeks generally you have this fibrosis which will prevent you from realigning it. So the common errors which we encounter during the calculations is that here you see the toric calculation being done, but when you do a topo C, you see an irregular cornea, and it was a case with multiple corneal opacity. If you don't do it or examine the cornea clearly, you are going to end up doing a toric lens and end up in post-op surprises and an unhappy patient and an unhappy doctor too. So this was a case where one eye didn't show toricity, the other eye showed a toricity. Okay, again, go recheck. And then it was a pterygium with a cataract. So you have to go with the pterygium excision first and then calculate the K reading before you go in for the lenses. So like even you have intraoperative challenges, you can do the toric lenses with, because you have, like I told you, the acceptability, adaptability is much more with toric lenses than the multifocal lenses. So I welcome all your phacosurgeons to this group of cataract refractive surgery by just simple procedure of taking care of your measurement and realigning your IOL placement, which is just a simple step. Thank you.
Thank you, ma'am. It was a pleasure listening to you. Next, we have Dr. Ramesh Hariharan. Dr. Ramesh did his PG in ophthalmology under the aegis of National Board of Examination, New Delhi, and followed it up with a clinical clericalship in cornea and external disease under the mentorship of Professor Dr. Srinivas K. Rao. He has received numerous awards and recognition. He is a travel grant awardee at the International Symposium of Ophthalmology in the year 2013. His posters were among the top 10 in AAOS conference in the years 2013 and 15. He is currently the consultant ophthalmic surgeon at R Vision Eye Hospital, Iriti. I welcome you, sir.
Thank you for that humble introduction. I'm just a student of ophthalmology in front of my professor and distinguished luminaries here. I'm here to speak about something that I hold close to my heart and cherish, that is disruptions in cataract technology. And I'll be speaking a few words on Alcon's Clarion and autonomy system. I have no financial interest or disclosures to make for this presentation. Now, the question comes as, why an intraocular lens of all? The intraocular lens implantation is now the standard of care for aphakia management post-lenticular extraction. And the choice of an intraocular lens is weighted upon by factors such as the material, the design, the biocompatibility, and the patient's expectations. The Acrosoft from the Alcon stable has a proven track record of more than 100 million implants worldwide. But we are here to speak about the new kid on the block, the Clarion. Why to change when you have something that is going on stable for quite so long and has been tried and tested in numerous eyes? Now, innovative disruptions are always the constant in healthcare delivery. And as far as cataract surgery is concerned, the IOL material and the design has the potential to introduce new modalities of visual rehabilitation post-cataract surgery. And the trio of material, the optics, and the mechanics of the intraocular lens inside the eye, once it has been placed, has always been the game changer for any intraocular lens to be adapted in the post-market scenario. But with the newer options as discussed by my predecessors here of trifocals and EDOF lenses, why a monofocal IOL of all? The Acrosoft platform, those truly speaking as a monofocal IOL, has an aspheric design and has a broad landing zone. Now this defocus curve is essentially from the FDA data of Alcon's Acrosoft IQ, which has a good distance vision and a functional intermediate vision of close to 80 centimeters, that would be around 2.5 feet. Patients would be able to read N10 at that aspect. As far as Clarion is concerned, it's a whole new material as compared to Alcon's Acrosoft IQ. Then conventionally, hydrophobic IOLs have been, by definition, having a water content of less than 4%. The IQ has a water content of 0.4%. It has few unpronounceable names as its polymers. The Clarion has incorporated something called as hydroxyethyl methacrylate, which we all know as a hydrophilic material. It is essentially not. It helps to uniformly distribute the water through the copolymer matrix. And this enables to have a thinner optic with a 6 mm usable zone and is fully implantable through micro-insertion delivery systems. Here's where Alcon's commitment towards the manufacturing advances as far as the Clarion came into play. All that seems similar is yet so different. One is the enhancement in the optical clarity of the IOL, a smoother IOL surface, and the precision etch design, which I'll speak about later. The Clarion has been adopted from the Acrosoft design platform itself, which has a proven track record. Both of the lenses are similar. One is the Clarion and one is the IQ. Both have 13 mm chord length, a 6 mm fully usable optic zone. The only difference is with respect to the asphericity distribution. The Clarion has an anterior aspheric surface. The IQ also has a modified posterior aspheric surface. Now, what does the fully usable 6 mm optic mean for a cataract surgeon when we do a 5 to 5.5 millimeter capsulorhexis, a full complete overlap on the optic? But what this also does is reduce the edge artifacts or the positive dysphotopsias, which can occur with the truncated optic edge IOLs. And this has a better visual performance in mesopic or large pupil scenarios. The lens comes with a refractive index of 1.55 with a higher Abbe number close to 55, which would essentially mean lesser chromatic aberrations inside, and a precision etch design, which is proprietary to Alcon as of now, which is known to reduce the lens edge glare. Now, this still retains the Alcon's proprietary blue filtering chromophore, which is thought to mimic the natural crystalline lens by filtering out blue light between the range of 400 to 475 nanometers, as evidenced by a study by Botner and Walter way back in 1962. Now, I'll come to this design. What exactly is this lens edge design? What is so different about the Clarion, rather from as compared to the other IOLs that are in market currently? Now, the Clarion has a lower radius of curvature for the posterior optic edge, which would essentially somewhere be here, close to down on that lens edge surface. Now, the IQ has a posterior optic curvature of 8.5 microns, while Clarion has it at 7.9 microns, which would mean a sharper posterior optic edge in contact with the posterior capsule. This also helps to reduce the thickness at the edge, which is, as you can see, it is almost close to 30 microns of thickness, which is lost. And there is a small curvature which is incorporated into the posterior optic edge. It is not exactly cut at 90 microns, but at an acute angle. So what this does is has a sharper curvature, as I said, better contact with the posterior capsule, which I'll tell you what the need is for. And this also reduces the reflected light onto the IOL, thereby reducing the edge glare or the negative dysphotopsias that we can see with these lenses. Now, asphericity, cornea has an asphericity of plus 0.27 microns, while this lens retains a negative asphericity of minus 0.2. Thereby, a residual minimal positive spherical aberration is still maintained, and this is known to have a better depth of focus at refractive emetropia by a Royal Navy pilot study. The stable force haptics, which are also trademarked by Alcon, these are something which at the haptic design, this ensures a better centration and avoids tilt with varying degrees of capsular contracture, subject from 9 millimeters to 13 millimeters of the back size. And this also prevents the axial IOL shift. When you try to compress the capsular bag, the IOL can have a tendency to move back and forth, which can cause refractive errors in the post-operative period. So the design now enables something which has a refractive and a rotational stability, which would possibly mean possible migration of future designs onto the Clarion platform. Now, the Clarion capsular interactions. I'm sorry. So, thank you. Thank you. I'm sorry, technology still lets me down sometimes. Now, the capsular interaction with the Clarion intraocular lens. Now, posterior capsular opacification remains the unholy devil of modern day cataract surgery still. And we depend on certain preventive strategies for the same. The first is the IOL material. Hydrophobic IOLs have known to have lesser PCO effects than hydrophilic ones. The capsule shrink wrap effect, which is essentially surgeon dependent. You need to have a good 5 to 5.5 mm capsular excess, completely overlapping the optic. And the IOL interactions with the posterior capsule can be a game changer in certain scenarios. Now, what we consider is once we place the intraocular lens inside the capsular bag, there are certain biomolecules which are secreted as a part of the normal inflammatory process, few of which have come from the fibronectin family, which is essentially known to cause fibrosis. With the Clarion, and the biomarker study as evidence from the US FDA was fibronectin and F-actin to be immediately seen within 72 hours of implantation. And also, as I said, the lens such design, which has a better capsular or a sharper capsular contact with the posterior capsule. Now, one thing which was noticed by me, and I still do not know its clinical implications, is with the FDA declaration that there was one point with regards to cytotoxicity studies. There was a cell growth inhibition assay, which was done in vitro for the Clarion lens, and it was found to be positive as compared to the other lenses which were also had the same declaration. This could be indicative of PCO reducing characteristics of the material, but I frankly tell I do not know its clinical implications as of now. Now, as far as the surface characteristics are concerned, subsurface glistenings and haze were also known to be the bane of IQ for quite some time. Recent manufacturing advances have brought them down. But still, surface haze is a nano-sized rough texture seen on the slit lamp examination and is known to be a defect in the manufacturing process. Subsurface nanoglistenings and glistenins are fluid-filled vacuoles in the IOL optic zone, which are known to occur with hydration-related phase separation seen with hydrophobic IOLs only. Essentially, as the name suggests, these lenses do not like water. The position, subsurface nanoglistenings are more towards the surface within 120 microns, and glistenings are more seen towards the central part of the lens. These do not have any impact on the vision as experienced by the patient, but as ophthalmologists, when you do a clean surgery and you see these things inside the eye, we tend to get disheartened. Now, Clarion, by numerous studies as evidenced by these articles, have shown no evidence of surface haze, subsurface nanoglistenings, or optical surface irregularities. This was done on a modified Miata scale, which is currently the norm for deciding the surface irregularities by electron microscopic analysis, and Clarion was found to be equivalent or to be better than the currently glistening-free IOLs as evidenced by that study. I'll come to something on the IOL delivery system, autonomy. Now, autonomy is essentially, by my limited understanding, enhancement on the AutoCert and the UltraCert delivery systems that Alcon currently have in place. It's a single-use device, length of 16.5 1 centimeters, and it has an IOL delivery speed of 3 millimeters per second. Now, what essentially we need to look out for is, one is the proprietary depth guard. This is something similar to the UltraCert. It is compatible with 2.2 millimeter incisions. It has a depth guard, that means you can, nozzle will hit the outer valve of the incision and you can just hold your cartridge steady. It has a 3 mm nozzle, which means for a 1.5 to 2 millimeter chord length of the incision, your nozzle or the tip will be inside the anterior chamber for a better IOL delivery. And an innovative CO2 powered mechanism, which means once you prime the IOL, there will be a click sound, and that is the CO2 released from the canister at the back part. And the moment you press on the lever, the release of gas pushes the plunger and helps to advance the IOL. Now, this comes preloaded with the Clarion as of now. Now, what does this depth guard do? Why is it so important? Now, as far as incisions are concerned, as ma'am said, surgically induced astigmatism is not just dependent on how you create an incision, it's also dependent on how you manipulate that incision intraoperatively. Now, there should not be any change in the incisional architecture. There should not be any wound distortion for you to have a predictable postoperative surgically induced astigmatism. For a 2.2 millimeter incision, if we go by simple mathematics, a circumference of the circle that we can expand the incision is close to 7 mm. So 2.2 is not as simple as we think. Now, the IOL delivery within a capsular bag in a predictable manner in a micro-incision system can be achieved with this. And also the lens material helps in certain part, because once we increase the water content, the pliability of the IOL changes. As compared to the shootout phenomena which we as surgeons might have experienced prior, Clarion does not have that issue as of now. But yes, it comes with its own things. We need to prime the system before we can actually implant the lens, wherein you have to fill it with a qualified viscoelastic. Alcon still promotes chondroitin sulfate. I use HPMC, disclaimer. And you have to remove the lockout assembly, and you have to advance the plunger by releasing CO2 from the canister. One click, you will hear a click sound, and after that second time, you have to press the lever for the plunger to advance, and the IOL comes into the loading position. Now, at the tip of the nozzle, there is a small mark. You have to bring the lens up to this position, and the optics and the haptics will come folded together, as with any intraocular lens delivery system. Now, these are certain photographs for various IOL loading positions that we can encounter. The first two are very safe. The next three require some rotation in your hands to have a safe IOL delivery system. Otherwise, the haptic can touch the endothelium, or you can have some mishaps occurring inside. The last one, I personally do not like that configuration, and I tend to deliver the IOL outside and reinsert it again using a different D cartridge. Now, these are all regards to configurations with the leading haptic. The trailing haptic, which is in contact with the plunger, you also need to keep a lookout for. And in case you see any kinking or any straightening of the trailing haptic, it's a no-no. You have to stop injecting at that point of time. These are certain indications where there is no data available for evaluation as per Alcon. And these are essentially indications there where we as surgeons will explain a guarded visual prognosis for cataract surgery preoperatively itself to the patient. Now, one thing which one can notice is extremely shallow chamber, not due to a swollen cataract. And as ma'am said, the modern day emmetropia calculations are based on the estimated lens position rather than the keratometry and the axial length, which were quite in vogue when I was studying ophthalmology. That is the one thing that you need to look on for. Variations in the anterior chamber depth can still give you a postoperative refractive surprise. Now, to summarize, Clarion has a unique biomaterial. As I said, it incorporates HEMA, better distribution of water throughout the copolymer matrix, making it pliable and easy for insertion. It is based on a proven IOL design from the Acrosoft platform. It has a proprietary lens edge design, which reduces edge artifacts, positive dysphotopsias, and also a better posterior capsule interaction for reduction of posterior capsular opacification. And optical surface characteristics, which as on today, according to literature available, is amongst the top lenses available in the market. Proprietary stable force haptic, which helps you to ensure refractive emmetropia or whatever intended target refraction you need to achieve in the postoperative period for quite some amount of time, irrespective of varied degrees of capsular contracture, which we might can see with varied ocular pathologies. A novel IOL delivery system. But still, one question that comes to it, it's still a new kid on the block, but there are studies ranging from 1 to 3 years, which has its clinical efficacy with respect to visual rehabilitation, rotational stability, and capsular interactions. So thus completing the trio of material, optics, and mechanics of an intraocular lens inside the eye. So Clarion has undeniable qualities that are not just meant to be beautiful, but offer to improve patients' functional vision, which is a common goal for us all clinicians, the scientists, and I also understand the industry as well. But then it's still a never-ending sojourn towards the holy grail of cataract surgery or refractive emmetropia across all distances with 100% light utilization. Thank you very much.
Thank you, sir. Next, I request Dr. Shreyas to come to the stage. He will be speaking to us on VBT.
Good afternoon once again. As I alluded to earlier, unfortunately, Dr. K.C. Bala could not be here because he to kill yesterday, and so it's a kind of a last-minute filler. So it's completely a slide deck given to me by Alcon this morning. So I will try my best to explain what little I know about Vivity and how it works, and maybe we could have more discussion on it later. So essentially, in the previous talk, we spoke about different IOL options for correcting presbyopia. But if you notice, all of them had rings. All of them were either refractive technology or diffractive technology. Even the EDOF lenses have rings. So the problem was that when you have these diffractive technology or refractive technology, you will continue to have photic phenomena. So the ideal IOL is something which can give you vision at different distances without giving you any photic phenomena. Such an IOL till date does not exist, and it is an attempt by Alcon to try and approach towards that perfection. So I'll quickly take you all through what is Vivity, how Vivity works, and what is the technology behind it, the so-called X-wave technology as well as the wavefront shaping. So now we kept speaking about refractive, diffractive, but this is completely a step away from that entire thing, where they call it the wavefront shaping technology, and I'll talk about it in the subsequent slides. So essentially, when we are looking at refractive multifocal IOLs or diffractive multifocal IOLs, the light is being split between different foci. So now in refractive IOLs, there are multiple, depending on the refractive power of each ring, there are multiple foci where it comes in, and therefore the amount of glare, photic phenomena, everything was a little higher. The diffractive IOLs, because the interference fringe patterns, gave you two separate foci. So one for distance and one just anterior to it, which gave you near. But despite that, because of the gratings and the rings, you still continued to have photic phenomena, though to a lesser extent than refractive IOLs, but it continued to be there in diffractive IOLs also. So with the wavefront technology, basically I'll keep using two words right through the presentation. One is shifting, the other is stretching. So essentially what it is trying to do is stretch a particular focal point over a distance, and then just shifting it just anterior to the retinal point of convergence where the image is going to fall, thereby giving you a continuous range of vision over a particular distance, that is from your distance near, that is from early intermediate towards distance, where there is no break, there is no peak in the IOL powers, whereas in your defocus curves, in your multifocal, trifocal IOLs, you will have a peak and a trough, where the power is for a particular distance for 40 centimeter, 60 centimeter, 80 centimeter, you will have a peak and a trough. In between that, there will be an area where the visual acuity tends to come down. But that does not happen with this technology, where there is a smooth transition element, because there is only a single focal point, there is no specific add power to the lens, and it is this single focal point that is stretched to give you, through the wavefront shaping technology, to give you a continuous focus. So essentially where it stands practically for us is, now with the monofocal you have good distance, minimal to no intermediate, maybe whatever intermediate is there is possibly due to the fortunate myotic pupils of older patients. Bifocal, where you have distance and near, less intermediate, so there is a break in between. With trifocal, it tries to bridge that gap by giving good near vision, reasonable intermediate vision, but there can be a small gap. And also, like I said, it's not just in the continuous focus alone, but also the photic phenomena associated with the rings. The EDOF tried to reduce the photic phenomena, but then while it gave excellent intermediate and distance, there was lesser near vision. With the Vivity, it is trying to address that with a smooth transition, where the quality of vision remains like that of a monofocal IOL, where you have a standardized vision for distance, which can be also brought in for intermediate and near for the continuous focus. So essentially, there are two elements which you need to understand. One, there is a small elevation on the Vivity IOL at the edge, which is about a 1 micron elevation, and then a smooth curvatural change in the central 2.2 millimeter of the lens. That is the only difference from the Vivity to that of a normal monocular Acrosoft lens. So essentially, the stretch in the wavefront and shifting the wavefront just anterior to the retinal focal point are the two things which happen. This stretch gives you a extended focal range, which enables you to see from intermediate to distance. The near is still not achieved with this lens. There is still glasses required for reading, especially fine print. Maybe something like a computer distance or a cell phone if kept at an arm's length away to distance visual acuity is very good. And the surface transition element and the smooth curvature is what gives it the shift, and that gives the continuous extended focal range. So it's just a video. It has an audio as well, but I think it's probably not connected. So they call this the X-wave technology because of the extended focal and the stretching of the focal point. So a couple of things to remember here is it utilizes all the light energy like that of a monofocal lens. So therefore there is no scattering, no stray light, and lesser, obviously no photic phenomena. And in the central zone 2.2 millimeter, you have these two transition elements. So one, like I said, which is the elevation, which is about a micron higher, which will come to focus soon. So it's a slightly elevated smooth plateau that is 1 micron higher than the rest of the lens. And then a smooth curvature, slight curvature change throughout the entire 2.2, which gives that little additional power. So that's what happens when your focal light is going into it. There is a point of focus just anterior and behind the retina in a normal lens. And then what the Vivity is trying to do is stretch that focus area which is there from in front and behind the retina. And the shift caused by the small curvatural change gives you the focal point from and over an extended period, which enables you to see from intermediate to distance. So again, X-wave is just, like I said, a fancy terminology for the extended range of vision, and obviously exceptional visual disturbance profile, which is going to be comparable to that of a normal monofocal lens. So essentially what they are trying to say is bridging this gap of full range of vision without any visual disturbance. So now you have a trifocal, like I said, the perfect IOL, which gives you full range of vision and very little to no visual disturbance, still does not exist. You have the trifocal lens, which gives you full range of vision, but definitely there are visual disturbances. EDOF, which may have slightly lesser visual disturbances query, but definitely the visual range of vision is lesser than that of a trifocal lens, like we discussed in the earlier presentation. But the Vivity gives you a better range of vision, definitely, than a monofocal lens without any photic phenomena. So that's where it is an advantage. So patients who are essentially still doing a lot of nighttime driving, are worried about the glare and halos, these are patients who are ideal candidates for Vivity. The only thing is we need to tell them that they may still, for fine reading, for newspaper reading, they will require a small reading glass. So the way I see it, this is possibly the lens for our generation or my generation, wherein when we develop cataracts, it's been quite some time since I read anything on a piece of paper. So it's always either a cell phone or a laptop or a computer screen or on a television, or of course distance vision. So that's how our lifestyle is changing, and we are losing that need or requirement for reading without a backlight at 33 centimeters. The amount of time spent reading books and newspaper is lesser. So I would rather have something which gives me excellent distance near, intermediate and extended intermediate vision without any photic phenomena than have something which gives me perfect near vision at 33 centimeters but gives me a lot of photic phenomena. So this is essentially the crux of the presentation, just a video to show that we do implant these lenses once in a while, and is a Vivity toric that is going into the eye, and yeah, just being checked into position. Is a Varian overlay which has unfortunately not come in this video. So essentially, as of now, currently the only lens which is talking about wavefront shaping technology, and it will give you a comparable visual profile to that of a best-in-class monofocal IOL with excellent distance, intermediate, and functional near vision. This is something we must remember, not commit to giving N6 at 33 for these patients. Thank you so much.
Thank you, Dr. Shreyas, for that talk on the new kid on the block, Vivity. So it's my pleasure now to invite our next speaker, Dr. Safrullah M.A. Safrullah sir is our medical director at Abate AS Hospital at our Kozhikode branch. Now, how do you introduce somebody who has explicitly told you beforehand itself, so I thought I'll thoroughly embarrass her with an anecdote. That is vintage Safrullah sir. So we had this patient, a relative of one of our fellow doctors, quite demanding, and they wanted a micro incision, cataract surgery through a 2.2 millimeter incision. And sir decided, yes, he'll go with it. I mean, it was a usual routine case, and coincidentally, the electricity sort of, decided to play hooky and went off. We have a generator backup. That day, the generator also was in a moody, state, and decided that, okay, I'm only going to give you a little bit of power, so you can hold the lens at times when it feels like, the rest of the times you can't. So this guy wants a 2.2 millimeter incision cataract surgery. Sir has already done already started just the first chop has been done. Now, he's in a dilemma. So I later on asked our OT sister, sir, what did he do? So she said, sir, no, madam. He simply sat there and did a manual 2 millimeter cataract surgery, which went on for more than the usual time. Now he comes out of the OT, and the attendants and everybody are like, all worked up, this and that and everything. And for 5 minutes, he hears, after that nerve-wracking surgery, he hears their entire rant for 5 minutes, and then just pats them gently and tells them, "Korponulya." And then he goes off. And 3 days later, the patient comes and has a 6/6 vision. So that is vintage Safrullah sir for you. So I'm handing over the mic to sir. He'll be speaking to us on his experience with the latest technology IOLs.
Thank you, Preeta. That is too much. I would like to share my experience with the latest technology IOLs. I'm not going to the details of the techniques or the exhaustive data and all. I will explain few of my cases, 2-3 cases. And even after doing a good surgery with a reasonably good visual outcome, patients were unhappy. So I just want to put that few cases here. Generally, I'm very happy with most of the patients are very happy after putting multifocal IOLs, especially after this new IOLs like trifocals and EDOF came into play. This is, as other speakers already explained, why we use multifocal IOLs is just to correct the presbyopia. That is the only available option now, and it gives very good results. And for those who don't want to use, those who hate spectacles, this is the only choice available. And I will share some few cases here. Actually, the surgeries went uneventful, but the patient was very unhappy. So I am putting this just to share my experience, for these newcomers who are stepping into this new IOLs, these premium IOLs, just not to get disheartened by the patient's behavior. This can happen because of the situation. So this is a female patient, an OT nurse by profession. She came with a history of blurring of vision for 3-4 months. She had a history of mild uveitis 1 year back with mild redness and pain, for which she had taken treatment. Which when she came for my office, she was perfectly normal, no symptoms, nothing was there. This is the visual, the vision. It was 612, improving to 6.9 in the right eye. Left eye was perfectly normal. NCT and other fundus, everything is normal. Sritam showed mild PSC. AC, anterior segment, everything is quiet. AC, there is no cells or flare. No signs of any inflammation. Everything is quiet, and patient was symptom-free for last 1 year. Biometry showed 1.5 cylindrical cylinder in 100 degree. Phaco IOL with panoptic storic was done. Actually, I explained beforehand that because especially the young patient, they will have very high expectation about the result. They will expect that it will be as normal as her previous eye. The vision will improve to the 100%. But I explained, but still after the surgery, the vision improved to 6 parts and 6. And other eye is perfectly normal. So she used to come like this to my office. Close one eye, I'm seeing, but I'm not able to see clearly like the other eye. Every day, every 2 weeks, she visit my office. And finally, she got a job in New Delhi and went. So when I look into that, the problem here is the left eye is perfectly normal. So she is able to compare the vision of the left eye with the right eye. So that's the basic problem. And her vision, the baseline vision was 6.9 before surgery. And being an OT nurse, she need very fine to see fine needles and such that is not able to focus with both eyes. Actually, she has got a good near vision with the left eye, but she is comparing the both eyes, so she is not very happy. This is a second case. A student, she also came with a blurred vision for 4 months. She had a trauma 2 years back. Our Dr. Rajesh did a fine vitrectomy for her, and the vision improved. She was having vitreous hemorrhage and retinal tear, which was treated very well, and the vision improved from counting finger to 6.9. And last few months, she developed a blurring of vision, and she had the vision like 624, improving to 612 parts. Here also, the left eye is perfectly normal. She is having posterior capsular cataract, and being I have an experience with the other patient. She came maybe after 2 months with the first insert. So I was very hesitant, and I explained to several times. The surgery, the biometry was showing almost 1.5 astigmatism. So this time I put a VVT toric, so that I thought the photic phenomena, everything will be solved. So she will be much happier than putting a panoptic toric. But similar result. She is also complaining like this. I am not seeing. Right eye I can see well. Left eye I can see well. Right eye I am not able to see properly. She is only 2 weeks back only I did the surgery. Maybe she will come back with the same complaint. This is another. Here also this is the problem. Left eye is perfectly normal, and young patient with mild cataract, patient will never be happy. They will have the same complaint that they will expect more. That's the reason for this. This is a case, international means she came from Middle East. He's a surgeon, he do a lot of microsurgeries. He came after somewhere he did a surgery and put a multifocal IOL. A plate haptic, it's not the normal lens which we are using here. He wanted to remove that IOLs and want a monofocal IOLs. when we see the refraction status, he is very surprisingly, he is having 6/6 and 6 vision in both eyes. I tried to explain him that no need to remove the lens. We will be happy after neuroadaptation and all. You will improve, just give some time. But he is reluctant. He wanted to remove that lens from the eye. So this is the picture, very well done surgery, well-centered IOL. But he is insisting, so we removed the IOL and put a monofocal IOL in both eyes. The vision was like this, accepting plus 2.5 for near vision. But he is very happy. He said he was having a lot of headache, fatigue symptoms and all. So he is much relieved of that, and hopefully he will be able to restart his surgery soon. So these are few cases. You may also land up in such patients. Don't get disheartened. This is because you have to talk with the patient while counseling. That is the most important thing, especially when you see young patient, unilateral cataract, mild or cataract with very good baseline vision, and those who require very high quality vision, and some myopic patients are also usually not happy with the near vision they get from the multifocals. So try to bring their expectation to a realistic level, and especially for those patients, very young patients with unilateral cataract, and also those with mild cataract, talk several times, and even on the day of surgery also you talk to them. The limitations of our technology. Maybe in future we will have a very good IOLs which can give high quality near, intermediate and distant vision. Until that time you may have to take little extra effort to counsel these patients. Thank you.
Thank you, Safrullah sir. Next we have Dr. Khalil Ahmad. Dr. Khalil did his MS ophthalmology from MMC Chennai. He also did his training in oculoplasty from AIMS Delhi. He received his fellowship from the Royal College of Surgeons from Glasgow and has also done his refractive surgery training from Mumbai. He is a founder and managing trustee of Annur Welfare Trust, a welfare organization catering to the needs to eradicate blindness, controlling diabetes mellitus and retinal ailments. He has over 25 years of experience in ophthalmology. He is currently the director of Annur Eye Hospital at Egmore and Piriamath. Welcome, sir.
A very good afternoon. I think you are more hungry for knowledge than for lunch, yeah? And it's a great pleasure being back in Salama. It's all a nostalgic feeling. And now I'm sandwiched between my guru, Dr. Sadiq, who has taught me FECO, and my student, I'm proud to say Dr. Shaji is my student who was doing his fellowship when I was here. And I would like to talk about the IOLs. In Tamil, there is a saying, late vandalum, latest vandirugare. Though come late in the session, I've come with the latest technology here. We are all saying about the perfect lens. Today, they are near perfect. Yeah, the technology has taken us so far, thanks to the people who have been involved in the laying the foundation, who have done all the research for hundreds of years. Yeah, we are enjoying the fruits of it. Even our professors didn't have so much of technology and techniques. They envy this generation for doing so many advanced things. And this generation is so blessed to get the benefit. The patients are so blessed to get the benefit of all this. So we are come for the history from couching. Yeah, they used to, with a needle just push the total cataract into the vitreous, and that was the treatment that time. And I was surprised to know when we are talking about all this technology and techniques and flying high, even today, I was very surprised to know that in certain parts of the world, they are still doing this. Would you believe it? Yeah? They are not having access to any kind of modern ophthalmology. And the age of ICCE, yeah, where we took out the whole bag together, and the ECCE, SICS. SICS is a wonderful surgery. Many surgeons don't have the exposure to SICS. We had the opportunity to go through, I have seen an ICCE also, my professors have been doing, and the ECCE, SICS, all these. SICS is also a wonderful technique. Then we got the phacoemulsification, and we had the rigid lenses, and now we have the foldable lenses. And in the foldable lenses, we have got a long way with the spheric and blue blocking lenses, the yellow lenses. And now the previous speaker has wonderfully told about the glistening-free lenses. In the normal lenses, the micro vacuoles across the years, the micro vacuoles appear under the surface of the lenses and causes a haze. So these things are prevented with the glistening-free lenses. And recently I saw a patient of mine with an opaque IOL. Yeah, then I was wondering what to tell him. We have to totally do a recataract. We got to remove the IOL and replace it. But the other eye had cataract. I just advised for now the other eye. Then we have this multifocal, EDOF, trifocals, which we have been elaborating since morning. And these multifocal lenses give a vision of distance near. So the intermediate vision is absent. So again, the patients sometimes have to adjust the distance to see better. And the EDOF lenses are there. Then the trifocal lenses give a distance, intermediate, and near. But still there is a gap between the distance, intermediate. Still there's a gap between the intermediate and near. And these lenses had a shortcoming that we couldn't give it for the astigmatic patients. But now that is also covered with the toric multifocal and toric trifocal, and now we saw the toric Vivinex and things. And there are so many lenses which have now something called sulcoflex lenses, which we can, supposing one eye is already having a monofocal, and we tell, and he now he has heard about the multifocal, and he wants a multifocal in the other eye. So we couldn't have an option to tell him, no, one eye is having monofocal and you cannot get the other eye into multifocal. So, but now we have that option. When we put a multifocal in the other eye, and in the first eye, you tell him that we'll put an add-on lens, yeah, a piggyback lens. This sulcoflex lens is a wonderful lens, which we can make a monofocal. We can add on a multifocal lens onto it. We can add on a toric onto it. We can add on a toric multifocal onto it. You know, the options are getting so wide. And of course, we have the refractive lens exchange. Even the presbyopic patients, like Dr. Shaji is doing presbyon and things like that. And there's an option of refractive lens exchange. Recently, last month, a 45-year-old lady, she came and she had -3 in both eyes, and she said, I want to be spectacle free. And the refractive surgeon said that we will do a LASIK, but you have to have reading glasses. So I offered her a trifocal lens, and she had no astigmatism, a trifocal lens, and she's very happy now with both eyes trifocal size lens I had implanted. Then we have now, as we have seen, the demand is so much. The people's expectations are so much. One patient came, I operated on him with a good monofocal imported lens. And then he came back after a couple of weeks later with a big bazooka. He wanted to shoot me. Yeah, I said, what happened? Refraction was 6.6 N6, like what Dr. Safrullah had experienced. And I said, what's wrong? He said, why did you make me wear glasses? I can't see distance so well. I can't see reading so well without the glasses. So I had to, really talk and get him out of it. So here we see this, you have to see the watch also clearly, the time, the dashboard, the road, everything has to be clear. And this is the demands of today's patients. So there are a lot of companies helping us to bring near natural, spectacle-free vision. Yeah, you have the IO-Care, even as Dr. Shreyas was explaining about the Indian lenses are not bad at all. They are really innovative. Of course, the imported ones have an edge, but these lenses are not bad at all. IO-Care company, they could make a lens at 45 diopters. Yeah, a person with hypermetropic, with such a huge myopic power. Usually we had to put a piggyback lens, but now if we tell them, they can make lenses, customized lenses, and they have made lenses up to 45 diopters, IOL up to 45 diopters. I think, as far as I know, it must be a world record. And even cylinders, if you tell them, they make customized lenses to very high powers. And biotech, Apasami, of course, our old Apasami, and biotech lenses, and so many other Indian companies are doing really good. And the Alcon lenses, Johnson & Johnson, the AMO company had been taken over by Abbott had been taken over by Johnson & Johnson now, and they make the time-tested Technis lenses, Technis platform. And Hoya, Zeiss, there's so many lenses, and even the Zeiss has a huge range of powers you can order for. But this is, we have to give hats off, we have to give the credit to the R&D department, yeah, of all these. Yeah, they are putting in a lot of their mind. We are just implanting the lenses and getting the credit, and but all the thanks comes to us. But behind the scene, there's a huge efforts with the scientists. And I would give a tribute to the father of optics. We are talking about so much about optics from morning, so much of physics in that. But the father of optics, he is Hassan ibn Haytham, Latinized as Al-Hazen. Al-Hazen was his popular name, and he was from Egypt in the 10th century. Yeah? Even in the Duke Elder book, in the topic of optics, his name and thing is there. He is Al-Hazen. So hats off to he's the father of modern optics, and all the people who have been involved. We really, they are collaborating with us. Yeah, they are not. So we have to really appreciate their efforts. And now the Clarion was beautifully explained. The glistening-free lenses, even the Hoya has glistening-free lenses. The Vivinex and the EDOF lenses of the VBT from Alcon and Eyehance from Johnson & Johnson. The Eyehance also gives distance and intermediate without the rings and without the glare and halos. It's a real advancement. And even the Indian IOCare has the magnificent lens in the same technology. Trifocal lenses, of course, we have seen about the synergy, which I'm going to tell about now. And we have the Panoptics. And in the Zeiss platform also, we have this trifocal lenses. And now I would really like, we are really excited today to speak about Synergy IOLs. Synergy is from the Technis platform, the Johnson & Johnson platform company. And this is a combination of trifocal and EDOF. So I was telling about the problem of, the gap between the distance and near, gap between the distance and intermediate and near. There are some places where it is blurred. But this gives a continuous range of vision, something like EDOF. It is a combination of EDOF and a trifocal. Technis multifocal and a Technis Symphony. Yeah, the Symphony had a problem with it. It wasn't good for near. But they have combined both the technologies and got out with this exciting, wonderful lens, which we can tell to some extent it is a perfect lens, perfect IOL, a futuristic IOL. And the best part of it, we have the problem of glare and halos. Whenever we talk about multifocal lenses, we say about glare and halos, we are scared about it. And this lens reduces the the spherical aberration, it has technology to reduce the spherical aberration and also the chromatic aberration. It has something called chromaline technology, and it reduces the chromatic aberration also, and it gives less glare and halos. And it has something called violet blocking technology, filtration, which reduces the glare like the opposite from the headlights which come from the opposite vehicles. So I think this is a really futuristic lens, and the patients whom I have implanted are really happy. And of course, there are rings on this. Yeah, it is not the ring-free lens like the VBT or the ring-free lens like the iHands, but it has rings. So there can be some amount of, though it very minimal, they can be, we have to give a little bit of caution to the patients that you can have this glare and halos, but definitely it is a great advancement and the glare and halos are going to be much less. So I think this is an ultimate lens which we have in our basket now, and the patients so far are doing really well. We can, like patients who are housewives, or people who don't drive, even the men who don't drive, who have drivers and who don't drive, we can, and who are very particular about near vision also. Like in VVT, you need the near ad, about 1 or 1.5 ad you have to for near reading, but here you have the whole range with the minimum glare, it's something wonderful. So just the comparison between the PanOptics and VVT synergy, the distance, intermediate, near come for all, but the intermediate is for all, and near in VVT the little bit of minus point is you have to have a little bit of add for near. Up to functional near, as Dr. Shreyas was mentioning, they'll be able to see. Glare and halos, yes, PanOptics does have, and though to quite some extent. And VVT, the advantage is has no glare and halos, no rings at all. So it's going to be a wonderful thing. And Synergy has very less. And rings, of course, this has PanOptics has a lot of rings, and also the Synergy also has rings, but less number of rings. And here we have, as I told, we have continuous range of vision in the. You have continuous, range of vision for the VVT, and there's a video here of implanting the Synergy lens. The few tips for the postgraduates. The side port entries which I make is just sufficient, or on the right side for the for the viscoelastic cannula to get in, and on the left side it is much less. I just give a partial entry so that it is not too big and there is no fluid leakage and the chamber stability is good. And of course we need a good rhexis which envelops the optic. And technology has taken us. Even we got so good viscoelastics, with chondroitin and hyaluronate, which can protect the cornea endothelium much better, even in hard cataracts, and with such good machines as Dr. Shreyas was explaining about the Centurion. Now, don't worry about the cost of Centurion, because most of except for Shreyas, not many people will be affordable, or Al Salama, they'll be affordable for Centurion. There is a little brother of Centurion, the Legion here, which is half the price, and it works quite as good, except for the active fluidics is not there. You have a pole for the fluid, but almost all other features are there in a much more compact system. And that is also for Malcon. So what I am using now with this machine is the Earthly combined machine. So basically, it is the same phaco techniques. I have a very wonderful chopper. It is called a side chopper. Yeah, we usually have a blunt chopper that we are familiar with, and a normal chopper which cuts inside. But this chopper cuts sideways, because the angle between the phaco tip and your side port is about 90 degrees. So if you want to cut towards the phaco tip, you need a side chopper. Now this, I have changed it now to a normal blunt chopper, and I keep the blunt chopper behind near the PC when eating the last piece so that the surge doesn't interfere. And this synergy lens is like a cup. It is like a bowl. And when we insert it, finally, it touches the PC. It sticks onto the posterior capsule, snugly. And soon they are coming out with, of course, abroad the toric version has come, and in India also the toric version is on the way. At the moment, we have to implant it in only the people who do not have the much cylinder. This is the lens. It does have those rings, and it's like a bowl there. You have to manually load. There are many lenses. The Clarion, as we saw, and the Hoya, whole range of Hoya lenses are all preloaded now. This we do have to load. I insert the lenses under saline itself. I don't put the visco, so avoiding the one step of taking out the visco, and if you leave some visco behind, then the IOP spikes and all those things. So I put it under the saline itself. The irrigation is on from the left hand, and I put the lens under saline itself. So wonderful experience, and thanks Dr. Shaji and all the organizers to invite me here. It's a real pleasure and honor to be here. And as I told Dr. Sadiq, my mentor, and my student, Dr. Shaji, I'm sandwiched between both of them. Yeah, and thank you so much.
Now we can open up the floor for questions and discussions. I'd like to invite the panel back on stage. Dr. Shreyas, Dr. Bindu ma'am, Khalil sir, Safrullah sir, Dr. SKR sir, you as well. Dr. Ramesh. And we have Dr. Shaji as well on stage. So please feel free to ask your questions.
Yeah, so the session is open for discussion. Any doubts from the delegates? Okay, I'll start with the doubt. We indeed had a debate in Abate ASL Salama recently with regard to the add power we give for VVT and eye hands. What is your take on the add power that is given to the patient after implanting a VVT, after implanting eye hands? I'll start with Shreyas.
Near vision add, and at what distance to all of the panelists? This was something we had a lot of discussion about.
I think, unfortunately, by practice or this thing, our optometrists are all, I think most of you can hear me. So, optometrists are all used to giving a standard 2.5 ad or 2.75 ad for everybody. But unfortunately, that's not the case, and even in patients with a normal monofocal lens, they actually have a varying requirement based on their pupil sizes and their working distance. So I think it's important to measure individually for all these patients. By and large, as an average, I think between 1.25 to 1.5 is the requirement, and which is for if they have a working requirement of 33.
For which lens? For both?
Frankly, I mean, nearly for both, but I would say with Vivity, maybe it's a little lesser. Even with a diopter, we're able to get away. With eye hands, about 1.5 is necessary.
For VVT would be 1. That means probably
Closer to 1.5. Though I've had a couple of patients. The problem is when you give them an add power and make them read our Snellen near visual acuity chart, they require an add of 1. But as such, when you ask the patient whether they require the add in their day-to-day life, a vast majority of them are able to get away without requiring the add. So I think there is a certain defocus which it gives for the near, or at least extended near as I like to call it, where they are quite comfortable. And I think our case selection is also such that we choose those patients who are not very particular about newspaper reading in the morning. So it's not the elderly patient. Elderly patients, we blindly go in for the multifocals. They are not going to be driving at night. They want to read well, and they have always used to reading a newspaper or a book, or even a Quran or a Bible. But then if it's a younger patient, I feel they are a better candidate for Vivity.
Okay. Khalil sir, your experience?
Yeah, as Dr.
So Madam asked if it is 33 or 40. So again, like I said, we do it for the working distance of that particular patient, even for a normal monofocal lens. So depending, I mean, Srinivas sir may not be keeping anything below 40 centimeters. His arm length is such. So whereas somebody who's shorter might require a closer reading distance. But generally, our dictum is that we start at 33 and then take it towards 40 and ask them what they are comfortable with and give the reading distance.
Khalil sir?
Yeah, I think the optometrist should be
much more.
It should flash that this lens has been put. Yeah. Otherwise, standard 2.5 goes inside.
We in fact have on the file. We stick it. If it's a high hands patient, Synergy or VVT. So it comes on the file. So the optometrists know, okay, this is a patient in whom a premium lens has been. Otherwise, as you said, it's dictum plus 3. You make them read.
This thing totally subjective. Totally subjective depending on what the patient is comfortable with. I had a patient with VVT, but fortunately, unfortunately, he had a minus 0.5. And he was happy with all the distance. He didn't require the glass.
Yeah, great. So your take?
Pretty much what they said. I think also sometimes they have a half a diopter cylinder. Sometimes they have a preoperative bigger eye or a smaller eye. The lens position changes a bit. So the same 24 diopter lens, if it's a shallow AC or a deep AC, performs slightly differently. Then there's a synergy when you have it in both eyes. You're testing monocularly, but when they are using both eyes, there's an additive phenomenon as well. But ideally, for these fussy patients, I tell them to bring whatever they want, their laptop. So they sit with the laptop, we forget the book, we don't use that. So we give them the laptop, and then the ad is chosen based on what that particular, because he has it at this angle, something. These are for the fussy ones. But for the other ones,
one more question for you, sir. Just to take on I have taken the advice from MS and you for not being so dynamic with the surgeries. But I had a patient recently he's from the Middle East. He did his LASIK surgery maybe 20 years back. And he has landed up now with probably a regression, and he's having a minus 3. So his vision was counting fingers 2 meters for distance. And he is come to me, he's around 48 now. So I gave him all the options, and he took up, in fact, he had discussed with somebody else, and he had come to me with the idea of implanting a VVT, clear lens extraction, and he said the lens has to be VVT. So I went ahead, I did VVT for both the eyes. The patient was not happy, especially for his near vision. He was, if I'm not wrong, N12. Then the concept of higher order aberration jumped in. There was so many discussion about the higher order aberration. I did a topo guided, I lifted the flap, ablated him. Now he is happy and he is an 8. And for distance, he was an amblyopic, so he is at 612. Was I wrong, or that concept of higher order aberration with VVT, what are your takes on that? Like any experience, similar experiences?
I've not done anything like that at all. Maybe Shreyas?
Shreyas, anything take on that? Was I wrong?
No, I wouldn't, consider that preoperatively. I think the evaluation has to be done where we look at the topography, the amount of higher order aberrations, especially coma in the patient, and as well as if you have access to an eye trace, we can do it as well. This gives us a realistic picture of what the current corneal status is. And frankly, in well done ablations, well centered ablations, the patient is comfortable with the quality of vision. There are quite a number of post-refractive surgery patients where we have implanted multifocal IOLs and the patients are doing quite well. The only concern comes to contrast sensitivity. I mean, where there is a drop in contrast sensitivity from the LASIK procedure to drop after the multifocal IOL as well. But when counseled and when told that these patients, while there might be a minor drop in contrast, for that particular patient, their comparison is the other eye. And they're usually very, very happy. I mean, so I don't think the dictum that if refractive surgery has been done, totally stay away from multifocal IOL does not hold true anymore. If the previous ablation has been done well, well-centered, the aberrations are higher order aberrations as well as the deep focus are not high, then yes, they would do quite well.
Okay, you mean the EDOF is preferred over multifocal, or what do you think on that? Or
I mean, I think, frankly, all the EDOFs nowadays, what we have currently, don't really give near vision. So if the patient is okay with not having functional near vision and just having good quality of intermediate and distance, then yes, maybe EDOF. But if the patient really wants unaided near vision, then I think as of now we don't have anything. But one thing in that particular patient, the other choice that we should keep in mind is using a presbyopic phakic IOL. And we've been using it for the last 3-4 years now. And I think it's an excellent go-to option for a number of these presbyopic patients. We've started using that more than, let's say, procedures like Presby Max or Presbeyond, which are altering the quality of vision significantly. Because it's a reversible procedure. Two, you can choose different ad powers. There are 5 different ad powers which are available with the presbyopic phakic IOL. You can put a slightly lower ad power in the dominant eye, slightly higher ad power, so that this helps the patient for the next 10 years. Let's say if they are getting it done at 42, 43, you might only put a effective spectacle plane ad of 1.25 in one eye, but you could choose a 2 in the non-dominant eye. And they do extremely well. So far, all the patients have been very happy. And because of the relative lesser number of rings, the relative anterior position where it's quite close to the pupil, the photic phenomena are also not very high. So they hardly complain of any photic phenomena, and even with a direct questionnaire, they are quite happy with it.
so that power you decide with presbyopic ICL will be based on the age, or is
so
it
the ad power, there are 5 different ad powers which are available.
Depending upon the
so
age.
you can use a similar ad power in both eyes for an older patient, or for a relatively younger patient, you could do a mix and match and put a slightly lower in one eye and a higher in the other, so that it continues to serve them for the next decade or so.
Great, thank you.
So far, we haven't had patients who've required that, sir. But then, just like how we do monovision in LASIK, a number of these patients, we just do a 1.5 diopter monovision, and they continue to do well even at 52, 53. Although traditionally in glasses, we would have given them a 2.5 by then. So I think it's just that the patient also gets adapted to that working distance and is able to maintain that. But with a +2 effective spectacle plane ad, I think most of them hopefully should do well. Though as of now, we've not had to do that exchange.
Also, one last question from my side about the formulas. Let's say you have a refractive patient post-LASIK. We have a variety of formulas now to calculate the IOL power. which formula would you be preferring? Or starting with sir, any my experiences, I am more comfortable. I feel Haggis has given me good results. Rather than comparing the powers given by Barrett's universal formulas, I don't know if I am doing something wrong here, I'm not sure.
For me, for my post-refractive patient, the first thing is the topography. If the topography doesn't show a nice uniform zone, which like I said is there in most of the newer generation LASIKs, but some of the earlier generation ones done with the large beam lasers which are still coming back, you can often see some variation in the corneal topography. Then, in my opinion, it doesn't matter which formula you use, it's not going to work.
Yeah.
So the best thing there is to do the cataract, and then either you do an intraoperative refraction, and then you 1.9 times that you can put in a lens, or if you want to be even more accurate, you can send the patient away FA kick, do a refraction in the clinic, a subjective 3 days later, and then put in the lens after that, because then you know which point in that multifocal cornea he prefers to see out of, and that can change it. Otherwise, you're just doing overall, averaging. But for somebody who has a decent topography after the LASIK, then our protocol is to basically, I use the Sirius machine. It's a dual shame plug.
Yeah.
And in that it has Gaussian stuff which gives you the corneal effective refractive power. So we use that, and we use it. Most of these people have a larger axial length.
Yes.
So we use the Bangkok modification for the axial length and the holiday. And in our experience, that's been the most accurate. We also have the ASCRS calculator done, which also has the Barrett.
Yeah.
But I tend to fudge between the two, and
then decide.
in my hands, the Sirius corneal equivalent power works well.
Barrett 2K.
Barrett 2K.
Predominantly only Barrett 2K.
Okay.
Previously, we used to, like sir said, use that and the ASCRS formula.
Yeah.
But then now we've more or less
Barrett
switched over to Barrett 2K.
The Haggis L formula
Haggis,
is pretty good.
Okay.
Of course, we compare it with the Barrett also.
Yeah. Bindu Madam, Safarullah sir, Ramesh, any
Just
input?
one point to add, like
Yes, ma'am.
I'm dealing more with glaucoma patients.
Yeah.
So for them, better than multifocal, I think the extend focal does better acceptance for them.
Edo-
That is what
which-
I've used more of Technos eye hands in those
Yeah,
patients.
eye hands, yeah,
Better
exactly.
acceptability I've seen in those patients.
Yes. Safarullah sir, Ramesh, anything from your side? Yeah.
In post-refractive surgery, what would be the target refraction that you would like to intend or expect? What would be your target refraction?
Overcorrection? Or
We
is it
usually say myopic, but how much?
minus 0.5 or?
Between the various formulae that you're getting, if you're getting them pretty much the same, then I think these days they're quite accurate. So about 1/2 to 1 is, I think, adequate. More than that, maybe a little overkill.
They should never be on plus, then it will be a big half a second.
Target hemetropia.
Yeah, okay. Sorry, any doubts on the delicate side?
Operating ophthalmologists do need a very good near vision. And if an operating surgeon, he comes to you for a cataract surgery, would you advise the present day multifocals or a monofocal? Which would be your?
It of VVT probably. Sometimes we operate without the microscope. We got to see the eye.
No. I'm not asking about the plasty, but microscope-based surgeries.
Pardon?
No. I am not asking for the ocular plastic surgeries without microscope, just through the microscope.
I think VVT would be a safe option.
What's your opinion, sir?
Multifocals I never choose for the patient. We have a long discussion and I tell them that there is no perfect lens. So I will tell you what each lens can and can't do. And you have to choose, and whatever you choose, you compromise. So you will never get the perfect solution with any multifocal, in my opinion, today. I only know of one colleague of mine who had it done. So he went in for an Acrisoft monofocal with a mild monovision. He said he didn't want a multifocal. Only ophthalmologist I know who's had cataract surgery done. So he didn't want a multifocal. It was his personal choice. So I think particularly for an ophthalmologist, I would never dare to choose the lens for him.
I think as sir said, they are obviously educated enough to choose their own lens, so we could do that. But then
lived with compromised near vision for some time now. So even with the monofocal, they will still be able to operate because they would have already had a plus 2.5 at that age. But having said that, in recent times, there are a couple of ophthalmologists who've undergone surgery, not my father yet, but others, where a multifocal lens, and they are quite happy with it. Obviously, they are not having to drive a lot, and they just wanted a better ease of vision, so they are comfortable. But like Sir said, they opted for it, and they wanted to use it.
I have a small scar on my cornea, central cornea, which I got it treated, and its scar is much less now, post-viral keratitis. So if for myself, I would like in that eye, with the scar, I would prefer a VVT, and the other eye synergy.
Shaji, write it down. Right eye VVT, left eye synergy.
The VVT is basically a monofocal lens, so it's more forgiving. Slight things up and down in the cornea or retina, it will forgive. Whereas the multifocal, true multifocals, trifocals will not forgive.
Sir, I'm Rosemary. I work in a neighboring hospital, Ahilya. I wanted to ask one question to Dr. Shreyas. Now, correct me if I'm wrong. In the study mentioned, you were mentioning that the photic phenomenon between panoptics and EDOFs were almost similar. When driver patients come to me, I usually discern them from panoptics because from what I remember from my PG days, they all have rings. Night vision is going to be a problem. Personally, again, I'm not very sure, but I always advise Technis eye-hands lenses, one eye, micromonovision, the other eye, and they are usually happy spectacle-free. So am I wrong in disordering these patients from panoptics?
Let me clarify. The EDOF in that study was symphony. So eye-hands, because we are genuinely looking at multifocal vision there. Eye-hands VVT at this point of time don't really give multifocal vision. They are giving distance vision with some intermediate vision, which a lot of patients get in monofocal also if you actually care to measure them. The DFU given on the direction for use by eye-hands is only a half a diopter more than for intermediate than the Technis monofocal lens. True. So that's all the intermediate ad that even the company's recommendation direction for use is saying that it's only a half a diopter. So if you're genuinely looking at multifocals, we are not really, either eye-hands or VVT are not there yet. So that study was to compare the EDOF diffractive symphony versus panoptics to see whether there was any excess glare or halos. Obviously there's glare and halos in both. It's not more in the trifocal is what I was trying to say. So if you said a driver who's having a lot of nighttime driving and is bothered about the glare and halos, they are not candidates for both trifocal as well as symphony or synergy. And because all of them will have some amount of glare and halos. Granted, they are better than the older generation multifocals, but still there is glare and halos. So in those cases, like you said, going in for eye-hands or even at regular IQ or Technis, they will do quite, they should be fine.
And Ramesh sir, you were asking a question about angle alpha. Now with Appasamy and all coming with economical packages with in-focus IOLs, now we have more and more patients opting for such packages. 10, 12 patients go fine, but one patient comes up with photic phenomena, halos, mesopic vision complaints. So do you do a pre-op alpha, angle alpha assessment for all patients? And what is the cutoff you take for these lenses?
The cutoff for all these angles are based on how the eye is. For a normal anatomical predisposition, it will not make much of a difference, but you have high myopia, high hypermetropia or something like that, then these optical axes, the visual axes do take a bit of a hit.
So do you do an angle alpha assessment in all cases pre-op?
It is usually, the skewing factors are usually showed up on an optical biometer, which by default is now becoming the norm for preoperative assessment for cataract surgery. Very difficult to measure it clinically, but yes, we can shine a torchlight and ask them to look straight. If there is any skew deviation, yes, these are not good candidates. The second is the optical zone which is available on the IOL. That differs for each many types of IOLs that are available. The sweet spot, the central optical zone, the ring-free zone, it varies for Indian multifocals, the diffractive multifocals to the trifocals. So all those also do take a stand on deciding whether this patient would benefit or whether he'll have some distortions in the vision post-implantation of an IOL.
Now I have this lady, I've already operated in focus. As Safrullah sir said, she comes every 3 weeks and keeps telling me she has halos. Outdoors she's fine. Good light conditions she's fine, but in the kitchen, in the bathroom, she has these difficulties with halos. I even offered IOL explantation, but she's not willing for that also. She's like, no, 6/6 and 6, that is all fine. But this is her only complaint. Now she needs cataract surgery in the other eye. So what should I advise now?
So usually in the trifocals, multifocals, the contrast goes down in the dim light.
Yeah.
This one has good in the day and at night.
For the other eye, what should I advise her now?
Synergy.
She's not going to go for that package.
You have to convince.
No, I was thinking whether I should go for a plain monofocal now.
Yeah, that's an option. And but if you convince them, you know, it's all about your marketing strategy, how you speak, how you convince. You know, it's one-time investment. You know, for the lifelong vision. You can't be explanting and implanting lenses.
On that aspect, sir, one more question, last question. Now, I had a 32, 33-year-old patient who came last year. I have not used Divinity yet, no. So he came, he told me, you tell me which is the best lens to put, I will do that. So at that point of time, this patient has not had any near vision problem.
I would bet on synergy. Yeah?
This patient has never had a near-eye problem. My neighbor patient also, IT professional, driving patient. So I told him, I'm not sure, I told him, put a Clarion. We did Clarion both eye. I counseled him well that you will need glasses for reading, but surprisingly, he is spectacle free. He's an IT professional. He has absolutely no difficulty in doing his system work. So now I'm wondering, I've seen all those presentations on Vivinity. Should we really push patients for Vivinity when Clarion bilaterally may give almost same results for these patients?
No, so the question here is, are Eyehance or Vivity really adding value over a monofocal lens? That my question in mind, all of us have at the back of our minds. We are not very sure how much value it adds. But if it's a bilateral, this patient may be, I mean, IT professional, you said, working distance might be there, I mean, might be a little further away, some pseudo accommodation might be there. But then again, if it's a unilateral cataract, young patient, I always prefer a monofocal lens because they have enough accommodation in the other eye to read comfortably, and it's importantly for them, it's the quality of vision that they want bilaterally, and I feel a monofocal is the best choice, and I would stay away from all multifocals for a young patient with a unilateral cataract. Bilateral cataracts, however, like the steroid-induced PSC cataracts and other things, they do well with multifocal also. And I'm sure we'll all have anecdotal experiences with patients who have been happy and not happy. That does vary a little bit. But I think predominantly, I would say, as of today, if it's especially an older patient, you have to think about what is the contraindication for multifocal IOL. I think every patient is an indication for multifocal IOL. If there are some contraindications, those ones are the only ones you'd stay away from.
Whatever multifocal, whatever things, you know, you just have to tell them this is the best lens, according to my knowledge. Of course, we have to discuss about the sometimes VVT, we may require reading glasses and all that. But generally, you must say it's all about counseling. Yeah, it's all about counseling. You just tell them that this is the best lens available in the world today. Most of the time, you will be spectacle free. And you may have some glare. These 2 points, you just put it on and put everybody here. So, you know, if they are ready for that, mentally, if they are ready for that, you know, they bring down the expectations. And you say, this is the best trade-off, this is the best in the world, best technology so far. So, you know, most of them agree.
I had one patient. She underwent multifocal in one eye, and she came to my OP with a +3 lens for reading. So I advised her, anyway you are using +3 lens, so better we'll do monofocal in the other eye. Why to put multifocal in the other eye? So he agreed for that, and I put a monofocal in the other eye. After the surgery, she said for reading, okay, I'm comfortable with +3 in both eye, but for functional vision, near vision and all, he's much happy with the multifocal. That is the situation. So I think if one eye is multifocal, better to put a multifocal in the other eye also. And if they want to use a reading glass, we can advise reading glass for them.
Sir, one question. I've had a patient who was basically from Gulf only. This is for the entire panel. And I did a VVT in both eyes. His complaint was, after the surgery, he has right eye 6.6 and 1.25 N6 in there. And in the other eye, he has got a +0.5 cylinder at around 130 degrees and N6 again with +1.25. Now his complaint is he has problems in night driving. I had counseled him that night driving VVT is comfortable and he has the same issues. So is it that astigmatism which is causing the problem, or what else could I have done better?
Any defocus does increase the photic phenomena, and if you give him a pair of glasses and that goes away, that itself tells you that might be it. Maybe you could even do a bioptics touch-up laser and correct that power if that makes it go away. Otherwise, I don't see, at least till date, I've not had a patient with eye hands or VVT complaining of excessive photic phenomena. Of course, there are monofocal patients also who complain of glare. Maybe to that extent we could get, but nothing beyond that.
I would really, because the people we require distance, intermediate and near. Right? So as far as possible, even I'm bored about these glasses. Sometimes I do miss my glasses somewhere. I'm half blind. I cannot read because I'm presbyopic. So this is like you're dependent on this, and the way to go forward. Who can we can fix in multifocality. It is a boon today. We have the technology, we have the lenses and things. So I think this should be the way forward.
Okay.
Pardon? Depending on their pocket. Other very good Indian
did Johnson
counterparts also there.
Did Johnson & Johnson sponsor your tickets?
Actually, Alcon did, I think.
No, it's Dr. Shaji. Okay. So I'm not sure if I'm the only one who's hungry. Really sorry to be stopping your discussion. I think we'll just proceed on. The lunch is served in the 5th floor. Before that, we'll just distribute the certificates for the speakers, and you guys can all hurry up to the lunch hall. I call upon Dr. Gobinath sir to give the certificate to Dr. Shreyas Ramamurthy for his wonderful presentation. And thank you, Shreyas, for taking up the talk of Dr. Balasubramanian. It was indeed a... I call upon Dr. Ashwaka Valsala madam to give the certificate to Dr. Bintu. Central go. I call Dr. Bharati madam to give the certificate to Dr. Ramesh. I call upon Dr. Lucy Tobin madam to give the certificate to Dr. Khalil Ahmed. Gauri madam. Madam, no. And I would like to give the certificate to SKR myself. I call upon Dr. Divya to give the certificate to Dr. Safrullah, sir. Okay, so thank you. Okay, I call upon Dr. Rajesh, sir, to give the certificate to Dr. Mohammed Sadiq. Okay, thank you all. We are winding up for lunch. We have 1 hour. The time now is 2:24. We'll assemble back at 3:30. Okay.
മാറുന്ന ലോകത്തിൽ മാറ്റമില്ലാതെ തുടരുന്ന വിശ്വാസത്തിന് ഇനി പുതിയ പേര്. അൽ സലാമ ഐ ഹോസ്പിറ്റൽ ഇനി മുതൽ അബേറ്റ് AS. അൽ സലാമ ഐ ഹോസ്പിറ്റൽ. നിങ്ങളുടെ വിശ്വാസം ഊട്ടിയുറപ്പിച്ച അതേ ടീം, അതേ മാനേജ്മെന്റ്, അതേ ഡോക്ടർമാർ. മാറുന്നത് പേര് മാത്രം. ആരോഗ്യ മേഖലയിലെ നൂതനമായ ടെക്നോളജിയെ ധാർമ്മികമായി നിങ്ങളിലേക്ക് എത്തിക്കാൻ അബേറ്റ് AS. അബേറ്റ് AS. അൽ സലാമ ഐ ഹോസ്പിറ്റൽ. അഡ്വാൻസ്ഡ് ആൻഡ് എത്തിക്കൽ. മാറുന്ന ലോകത്തിൽ മാറ്റമില്ലാതെ തുടരുന്ന വിശ്വാസത്തിന് ഇനി പുതിയ പേര്. അൽ സലാമ ഐ ഹോസ്പിറ്റൽ ഇനി മുതൽ അബേറ്റ് AS. അൽ സലാമ ഐ ഹോസ്പിറ്റൽ. നിങ്ങളുടെ വിശ്വാസം ഊട്ടിയുറപ്പിച്ച അതേ ടീം, അതേ മാനേജ്മെന്റ്, അതേ ഡോക്ടർമാർ. മാറുന്നത് പേര് മാത്രം. ആരോഗ്യ മേഖലയിലെ നൂതനമായ ടെക്നോളജിയെ ധാർമ്മികമായി നിങ്ങളിലേക്ക് എത്തിക്കാൻ അബേറ്റ് AS. അബേറ്റ് AS. അൽ സലാമ ഐ ഹോസ്പിറ്റൽ. അഡ്വാൻസ്ഡ് ആൻഡ് എത്തിക്കൽ. മാറുന്ന ലോകത്തിൽ മാറ്റമില്ലാതെ തുടരുന്ന വിശ്വാസത്തിന് ഇനി പുതിയ പേര്. അൽ സലാമ ഐ ഹോസ്പിറ്റൽ ഇനി മുതൽ അബേറ്റ് AS. അൽ സലാമ ഐ ഹോസ്പിറ്റൽ. നിങ്ങളുടെ വിശ്വാസം ഊട്ടിയുറപ്പിച്ച അതേ ടീം, അതേ മാനേജ്മെന്റ്, അതേ ഡോക്ടർമാർ. മാറുന്നത് പേര് മാത്രം. ആരോഗ്യ മേഖലയിലെ നൂതനമായ ടെക്നോളജിയെ ധാർമ്മികമായി നിങ്ങളിലേക്ക് എത്തിക്കാൻ അബേറ്റ് AS. അബേറ്റ് AS. അൽ സലാമ ഐ ഹോസ്പിറ്റൽ. അഡ്വാൻസ്ഡ്
Abate AS, formerly known as Al Salama, is reaching new heights in the realm of eye care and education sectors in India and is the first BSE-listed company headquartered in northern Kerala. Al Salama was established in Perindalmanna in 2004 and has tremendously grown both within and outside of Kerala. Abate AS Hospitals and Opticals are renowned for providing top-notch services that earned trust and loyalty from many walks of life. The group also operates optometry, architecture,
business management,
interior designing and fashion designing colleges. Abate AS is opening a new world of opportunities with an ambition to open a network of 44 plus eye hospitals, optical centers and educational facilities across India, Europe and the GCC. The group is ready to venture into real estate, jewelry and other fast-growing sectors, enabling sustaining investment and revenue prospects. Under the leadership of Dr. Advocate Shamsuddin Arikurian, Chairman of Abate AS Group of Companies, the dynamic and forward-thinking team, Abate AS is moving into new horizons. Abate AS, Group of Companies. Grow together. Abate AS, formerly known as Al Salama, is reaching new heights in the realm of eye care and education sectors in India and is the first BSE-listed company headquartered in northern Kerala. Al Salama was established in Perindalmanna in 2004 and has tremendously grown both within and outside of Kerala. Abate AS Hospitals and Opticals are renowned for providing top-notch services that earn trust and loyalty
Sean
from many
Opticals ഇനി
walks
മുതൽ
of life.
Abate
The group
AS
also
Opticals
operates
ലേറ്റസ്റ്റ്
optometry,
ഡിസൈനുകളോട് കൂടിയ
architecture,
പ്രിസ്ക്രൈബ്ഡ്
business
ഗ്ലാസുകളും
management,
സൺഗ്ലാസുകളും
interior designing
അഫോർഡബിൾ
and
പ്രൈസിൽ
fashion
സ്വന്തമാക്കാം.
designing colleges.
ഇനി കണ്ണു തുറക്കാം
Abate AS is
പുതുമയുടെ
opening
പുതിയ
a new
ലോകത്തേക്ക്.
world of opportunities
Abate AS
with an ambition
Opticals.
to open a
Original,
network of
stylish,
44 plus eye
affordable.
hospitals, optical centers and educational
കണ്ണുകൾക്ക്
facilities
കൂടുതൽ
across
നിറമുള്ള
India,
കാഴ്ചകളേകാൻ
Europe
പുതുമയുള്ള
and the
പേര്.
GCC.
ഷോൺ
The group
Opticals
is ready
ഇനി
to
മുതൽ
venture
Abate
into real
AS
estate,
Opticals
jewelry
ലേറ്റസ്റ്റ്
and other
ഡിസൈനുകളോട് കൂടിയ
fast-growing sectors,
പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും
enabling sustaining
സൺഗ്ലാസുകളും
investment and
അഫോർഡബിൾ
revenue
പ്രൈസിൽ
prospects.
സ്വന്തമാക്കാം.
Under
ഇനി
the
കണ്ണു
leadership
തുറക്കാം
of
പുതുമയുടെ
Dr.
പുതിയ
Advocate
ലോകത്തേക്ക്.
Shamsuddin
Abate
Ali
AS
Kurian,
Opticals
chairman of
ഒറിജിനൽ
Abate AS
സ്റ്റൈലിഷ്
companies,
അഫോർഡബിൾ.
the dynamic and forward-thinking team.
കണ്ണുകൾക്ക്
Abate AS
കൂടുതൽ
is
നിറമുള്ള
moving
കാഴ്ചകളേകാൻ
into new
പുതുമയുള്ളൊരു
horizons.
പേര്.
Abate
ഷോൺ
AS,
Opticals ഇനി മുതൽ
group of
Abate
companies.
AS Opticals
Grow
ലേറ്റസ്റ്റ്
together.
ഡിസൈനുകളോട് കൂടിയ പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺഗ്ലാസുകളും അഫോർഡബിൾ
Abate
പ്രൈസിൽ
AS,
സ്വന്തമാക്കാം. ഇനി
formerly
കണ്ണു
known
തുറക്കാം
as
പുതുമയുടെ
Salama,
പുതിയ
is reaching
ലോകത്തേക്ക്.
new heights in the
Abate
realm
AS
of eye
Opticals
care and education
ഒറിജിനൽ
sectors in India
stylish
and is the first
affordable.
BSc-listed company headquartered
കണ്ണുകൾക്ക്
in
കൂടുതൽ
northern
നിറമുള്ള
Kerala.
കാഴ്ചകളേകാൻ
Al-Salama
പുതുമയുള്ളൊരു
was
പേര്.
established in Perindalmana
ഷോൺ
in
Opticals ഇനി മുതൽ
2004 and has
Abate AS
tremendously
Opticals
grown both
ലേറ്റസ്റ്റ്
within
ഡിസൈനുകളോട്
and
കൂടിയ
outside of Kerala.
പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും
Abate AS
സൺഗ്ലാസുകളും
hospitals and opticals
അഫോർഡബിൾ പ്രൈസിൽ
are renowned
സ്വന്തമാക്കാം.
for providing
ഇനി കണ്ണു
top-notch
തുറക്കാം
services
പുതുമയുടെ
that earn
പുതിയ
trust
ലോകത്തേക്ക്.
and loyalty
Abate AS
from many
Opticals
walks of life.
ഒറിജിനൽ
The group also
stylish
operates
affordable.
optometry, architecture, business
കണ്ണുകൾക്ക്
management,
കൂടുതൽ
interior
നിറമുള്ള
designing and
കാഴ്ചകളേകാൻ
fashion
പുതുമയുള്ളൊരു
designing
പേര്.
colleges. Abate
ഷോൺ
AS
Opticals
is
ഇനി
opening
മുതൽ
a new world
Abate
of
AS
opportunities
Opticals
with an ambition
ലേറ്റസ്റ്റ്
to open a
ഡിസൈനുകളോട് കൂടിയ
network of
പ്രിസ്ക്രൈബ്ഡ്
44 plus
ഗ്ലാസുകളും
eye hospitals,
സൺഗ്ലാസുകളും
optical
അഫോർഡബിൾ
centers
പ്രൈസിൽ
and
സ്വന്തമാക്കാം.
educational facilities
ഇനി കണ്ണു
across
തുറക്കാം
India,
പുതുമയുടെ
Europe
പുതിയ
and the
ലോകത്തേക്ക്.
GCC.
Abate AS
The group
Opticals
is ready to
ഒറിജിനൽ
venture into real
stylish
estate, jewelry
affordable.
and other fast-growing sectors,
കണ്ണുകൾക്ക്
enabling
കൂടുതൽ
sustaining
നിറമുള്ള
investment
കാഴ്ചകളേകാൻ
and revenue
പുതുമയുള്ളൊരു പേര്.
prospects. Under the
ഷോൺ
leadership
Opticals
of
ഇനി മുതൽ
Dr.
Abate
Advocate
AS
Shamsuddin
Opticals
Ali Kurian,
ലേറ്റസ്റ്റ്
chairman
ഡിസൈനുകളോട്
of
കൂടിയ
Abate
പ്രിസ്ക്രൈബ്ഡ്
AS
ഗ്ലാസുകളും
companies,
സൺഗ്ലാസുകളും
the dynamic and
അഫോർഡബിൾ പ്രൈസിൽ
forward-thinking
സ്വന്തമാക്കാം.
team, Abate
ഇനി
AS
കണ്ണു
is
തുറക്കാം
moving
പുതുമയുടെ
into new
പുതിയ
horizons.
ലോകത്തേക്ക്. Abate
Abate
AS Opticals
AS,
ഒറിജിനൽ
group of companies.
stylish affordable.
Grow together.
കണ്ണുകൾക്ക് കൂടുതൽ നിറമുള്ള കാഴ്ചകളേകാൻ
Abate
പുതുമയുള്ളൊരു
AS,
പേര്.
formerly
ഷോൺ
known as
Opticals ഇനി
Salama,
മുതൽ
is
Abate
reaching
AS
new heights in
Opticals
the realm of
ലേറ്റസ്റ്റ്
eye care and
ഡിസൈനുകളോട്
education
കൂടിയ
sectors in
പ്രിസ്ക്രൈബ്ഡ്
India
ഗ്ലാസുകളും
and is the first
സൺഗ്ലാസുകളും
BSc-listed
അഫോർഡബിൾ പ്രൈസിൽ
company
സ്വന്തമാക്കാം.
headquartered
ഇനി
in
കണ്ണു
northern
തുറക്കാം
Kerala.
പുതുമയുടെ
Al-Salama
പുതിയ
was
ലോകത്തേക്ക്.
established in
Abate
Perindalmana
AS
in
Opticals
2004
ഒറിജിനൽ
and has
stylish
tremendously grown
affordable.
both within and outside of Kerala.
കണ്ണുകൾക്ക്
Abate AS
കൂടുതൽ നിറമുള്ള
hospitals and
കാഴ്ചകളേകാൻ
opticals are
പുതുമയുള്ളൊരു
renowned
പേര്.
for providing
ഷോൺ
top-notch
Opticals
services
ഇനി മുതൽ
that earn
Abate
trust
AS
and
Opticals
loyalty from
ലേറ്റസ്റ്റ്
many walks of
ഡിസൈനുകളോട്
life.
കൂടിയ
The group
പ്രിസ്ക്രൈബ്ഡ്
also
ഗ്ലാസുകളും
operates
സൺഗ്ലാസുകളും
optometry,
അഫോർഡബിൾ
architecture,
പ്രൈസിൽ
business
സ്വന്തമാക്കാം.
management,
ഇനി കണ്ണു
interior
തുറക്കാം
designing and
പുതുമയുടെ
fashion
പുതിയ
designing
ലോകത്തേക്ക്.
colleges.
Abate
Abate
AS
AS
Opticals
is opening a new
ഒറിജിനൽ
world of
stylish
opportunities with an ambition
affordable.
to open a network of 44 plus
കണ്ണുകൾക്ക്
eye
കൂടുതൽ
hospitals,
നിറമുള്ള
optical
കാഴ്ചകളേകാൻ
centers and
പുതുമയുള്ളൊരു പേര്.
educational facilities
ഷോൺ
across
Opticals
India,
ഇനി മുതൽ
Europe and
Abate
the
AS
GCC.
Opticals
The
ലേറ്റസ്റ്റ്
group is ready
ഡിസൈനുകളോട്
to
കൂടിയ
venture into
പ്രിസ്ക്രൈബ്ഡ്
real estate,
ഗ്ലാസുകളും
jewelry
സൺഗ്ലാസുകളും
and other
അഫോർഡബിൾ
fast-growing
പ്രൈസിൽ
sectors,
സ്വന്തമാക്കാം.
enabling
ഇനി കണ്ണു
sustaining
തുറക്കാം
investment
പുതുമയുടെ
and revenue
പുതിയ ലോകത്തേക്ക്.
prospects. Under
Abate
the
AS
leadership
Opticals
of Dr.
ഒറിജിനൽ
Advocate
stylish
Shamsuddin Ali
affordable.
Kurian, chairman of Abate AS group of
കണ്ണുകൾക്ക്
companies,
കൂടുതൽ
the
നിറമുള്ള
dynamic
കാഴ്ചകളേകാൻ
and
പുതുമയുള്ളൊരു
forward-thinking
പേര്.
team, Abate AS
ഷോൺ
is
Opticals
moving
ഇനി
into
മുതൽ
new
Abate
horizons.
AS Opticals
Abate
ലേറ്റസ്റ്റ്
AS,
ഡിസൈനുകളോട് കൂടിയ
group of
പ്രിസ്ക്രൈബ്ഡ്
companies.
ഗ്ലാസുകളും സൺഗ്ലാസുകളും
together.
അഫോർഡബിൾ പ്രൈസിൽ സ്വന്തമാക്കാം. ഇനി കണ്ണു തുറക്കാം പുതുമയുടെ
Abate
പുതിയ
AS,
ലോകത്തേക്ക്. Abate
formerly known
AS
as
Opticals
Al-Salama,
ഒറിജിനൽ
is reaching new
stylish
heights in the realm of
affordable.
eye care and education sectors in India
കണ്ണുകൾക്ക്
and is the
കൂടുതൽ
first
നിറമുള്ള കാഴ്ചകളേകാൻ
BSc-listed
പുതുമയുള്ളൊരു
company
പേര്.
headquartered in
ഷോൺ
northern Golden
Opticals
Kettle.
ഇനി
Al
മുതൽ
Salama
Abate
was established
AS
in
Opticals
Perindalmanna
ലേറ്റസ്റ്റ്
in 2004.
ഡിസൈനുകളോട് കൂടിയ
It has
പ്രിസ്ക്രൈബ്ഡ്
tremendously
ഗ്ലാസുകളും
grown,
സൺഗ്ലാസുകളും
both within and
അഫോർഡബിൾ
outside
പ്രൈസിൽ
of Kerala.
സ്വന്തമാക്കാം.
Abate
ഇനി കണ്ണു
AS
തുറക്കാം
Hospitals and
പുതുമയുടെ
Opticals
പുതിയ
are renowned
ലോകത്തേക്ക്.
for providing
Abate AS
top-notch
Opticals.
services that
Original,
earn trust and
stylish,
loyalty from
affordable.
many walks of life. The group also operates optometry, architecture, business management, interior designing and fashion designing colleges. Abate
latest
AS is
ഡിസൈനുകളോട്
opening a
കൂടിയ
new world of
പ്രിസ്ക്രൈബ്ഡ്
opportunities
ക്ലാസുകളും
with an
സൺ
ambition
ഗ്ലാസുകളും
to open a
അഫോർഡബിൾ
network
പ്രൈസിൽ
of
സ്വന്തമാക്കാം
44+
ഇനി
eye
കണ്ണു
hospitals,
തുറക്കാം
optical
പുതുമയുടെ
centers
പുതിയ
and
ലോകത്തേക്ക്
educational facilities
അബേറ്റ് AS
across
Opticals
India, Europe
ഒറിജിനൽ
and the GCC.
stylish affordable
The group is ready to venture into real estate,
കണ്ണുകൾക്ക് കൂടുതൽ
jewelry,
നിറമുള്ള
and other
കാഴ്ചകളേകാൻ
fast-growing
പുതുമയുള്ളൊരു പേര്
sectors, enabling
ഷോൺ
sustaining
ഒപ്റ്റിക്കൽസ്
investment
ഇനി മുതൽ
and revenue
അബേറ്റ്
prospects.
AS Opticals
Under the leadership
ലേറ്റസ്റ്റ്
of
ഡിസൈനുകളോട്
Dr.
കൂടിയ
Advocate
പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും
Shamsuddin
സൺ
Ali
ഗ്ലാസുകളും
Chairman
അഫോർഡബിൾ
of
പ്രൈസിൽ
Abate
സ്വന്തമാക്കാം
AS Group of
ഇനി
Companies.
കണ്ണു
The
തുറക്കാം
dynamic
പുതുമയുടെ
and forward-thinking
പുതിയ
team,
ലോകത്തേക്ക്
Abate
അബേറ്റ്
AS
AS
is
Opticals
moving into new
ഒറിജിനൽ
horizons.
സ്റ്റൈലിഷ്
Abate
affordable
AS Group of Companies.
കണ്ണുകൾക്ക് കൂടുതൽ നിറമുള്ള കാഴ്ചകളേകാൻ പുതുമയുള്ളൊരു പേര് ഷോൺ ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ അബേറ്റ് AS Opticals
formerly known as
ലേറ്റസ്റ്റ്
Al
ഡിസൈനുകളോട്
Salama,
കൂടിയ
is reaching
പ്രിസ്ക്രൈബ്ഡ്
new
ഗ്ലാസുകളും
heights in the realm
സൺ
of
ഗ്ലാസുകളും
eye care and
അഫോർഡബിൾ
education
പ്രൈസിൽ
sectors in
സ്വന്തമാക്കാം
India, and
ഇനി
is the
കണ്ണു
first
തുറക്കാം
BSc
പുതുമയുടെ
listed
പുതിയ
company
ലോകത്തേക്ക്
headquartered
അബേറ്റ്
in
AS
Northern
Opticals
Kerala. Al Salama
ഒറിജിനൽ
was established
stylish
in Perindalmana
affordable
in 2004 and has tremendously
കണ്ണുകൾക്ക്
grown
കൂടുതൽ
both
നിറമുള്ള
within
കാഴ്ചകളേകാൻ
and outside of
പുതുമയുള്ളൊരു പേര്
Kerala. Abate AS
ഷോൺ
Hospitals
ഒപ്റ്റിക്കൽസ്
and
ഇനി മുതൽ
Opticals are
അബേറ്റ്
renowned
AS
for providing
Opticals
top-notch
ലേറ്റസ്റ്റ്
services
ഡിസൈനുകളോട്
that
കൂടിയ
earn trust
പ്രിസ്ക്രൈബ്ഡ്
and
ഗ്ലാസുകളും
loyalty
സൺ
from
ഗ്ലാസുകളും
many walks of
അഫോർഡബിൾ
life.
പ്രൈസിൽ
The group
സ്വന്തമാക്കാം
also
ഇനി
operates
കണ്ണു തുറക്കാം
optometry,
പുതുമയുടെ
architecture,
പുതിയ ലോകത്തേക്ക്
business management,
അബേറ്റ് AS
interior
Opticals
designing and fashion
ഒറിജിനൽ
designing
stylish
colleges. Abate AS is opening a new world of
കണ്ണുകൾക്ക്
opportunities with an
കൂടുതൽ
ambition
നിറമുള്ള
to open a
കാഴ്ചകളേകാൻ
network of
പുതുമയുള്ളൊരു പേര്
44+ eye
ഷോൺ
hospitals,
ഒപ്റ്റിക്കൽസ്
optical
ഇനി മുതൽ
centers and
അബേറ്റ് AS
educational
Opticals
facilities across
ലേറ്റസ്റ്റ്
India,
ഡിസൈനുകളോട്
Europe
കൂടിയ
and the
പ്രിസ്ക്രൈബ്ഡ്
GCC.
ഗ്ലാസുകളും സൺ ഗ്ലാസുകളും
The group is ready to
അഫോർഡബിൾ
venture
പ്രൈസിൽ
into
സ്വന്തമാക്കാം
real estate,
ഇനി കണ്ണു
jewelry,
തുറക്കാം
and other
പുതുമയുടെ
fast-growing
പുതിയ
sectors,
ലോകത്തേക്ക്
enabling
അബേറ്റ് AS
sustaining
Opticals
investment and
ഒറിജിനൽ
revenue prospects.
stylish
Under the
affordable
leadership of Dr. Advocate
കണ്ണുകൾക്ക്
Shamsuddin
കൂടുതൽ
Ali
നിറമുള്ള കാഴ്ചകളേകാൻ
Chairman of
പുതുമയുള്ളൊരു
Abate
പേര്
AS Group of Companies.
ഷോൺ
The
ഒപ്റ്റിക്കൽസ്
dynamic
ഇനി
and
മുതൽ
forward-thinking
അബേറ്റ്
team,
AS Opticals
Abate AS,
ലേറ്റസ്റ്റ്
is moving
ഡിസൈനുകളോട്
into new
കൂടിയ
horizons.
പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺ
Abate
ഗ്ലാസുകളും
AS,
അഫോർഡബിൾ
group
പ്രൈസിൽ
of
സ്വന്തമാക്കാം
companies.
ഇനി കണ്ണു തുറക്കാം
Grow
പുതുമയുടെ
together.
പുതിയ ലോകത്തേക്ക് അബേറ്റ് AS Opticals ഒറിജിനൽ
Abate AS,
stylish
formerly known
affordable
as Al Salama, is reaching new
കണ്ണുകൾക്ക്
heights in the
കൂടുതൽ
realm of
നിറമുള്ള
eye care and
കാഴ്ചകളേകാൻ
education
പുതുമയുള്ളൊരു
sectors in
പേര്
India, and is the
ഷോൺ
first
ഒപ്റ്റിക്കൽസ്
BSc
ഇനി മുതൽ
listed company
അബേറ്റ് AS
headquartered
Opticals
in Northern
ലേറ്റസ്റ്റ്
Kerala.
ഡിസൈനുകളോട്
Al Salama
കൂടിയ
was
പ്രിസ്ക്രൈബ്ഡ്
established in
ഗ്ലാസുകളും
Perindalmana
സൺ
in
ഗ്ലാസുകളും
2004
അഫോർഡബിൾ പ്രൈസിൽ
and has
സ്വന്തമാക്കാം
tremendously
ഇനി
grown
കണ്ണു
both
തുറക്കാം
within
പുതുമയുടെ
and outside
പുതിയ
of Kerala.
ലോകത്തേക്ക്
Abate
അബേറ്റ്
AS
AS
Hospitals
Opticals
and Opticals
ഒറിജിനൽ
are renowned for
stylish
providing
affordable
top-notch services that earned trust and
കണ്ണുകൾക്ക്
loyalty
കൂടുതൽ
from many
നിറമുള്ള
walks of
കാഴ്ചകളേകാൻ
life. The
പുതുമയുള്ളൊരു
group
പേര്
also operates
ഷോൺ
optometry,
ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ
architecture,
അബേറ്റ്
business
AS
management,
Opticals
interior
ലേറ്റസ്റ്റ്
designing and
ഡിസൈനുകളോട്
fashion
കൂടിയ
designing
പ്രിസ്ക്രൈബ്ഡ്
colleges.
ഗ്ലാസുകളും
Abate
സൺ
AS
ഗ്ലാസുകളും
is opening
അഫോർഡബിൾ
a new
പ്രൈസിൽ
world of
സ്വന്തമാക്കാം
opportunities
ഇനി
with
കണ്ണു
an
തുറക്കാം
ambition to open a
പുതുമയുടെ
network
പുതിയ
of
ലോകത്തേക്ക്
44+
അബേറ്റ്
eye
AS
hospitals,
Opticals
optical centers
ഒറിജിനൽ
and educational
stylish
facilities
affordable
across India, Europe and the GCC.
കണ്ണുകൾക്ക് കൂടുതൽ
The
നിറമുള്ള
group is
കാഴ്ചകളേകാൻ
ready to venture
പുതുമയുള്ള
into
പേര്
real estate,
ഷോൺ
jewelry, and
ഒപ്റ്റിക്കൽസ്
other
ഇനി മുതൽ
fast-growing
അബേറ്റ്
sectors,
AS
enabling
Opticals
sustaining
ലേറ്റസ്റ്റ്
investment
ഡിസൈനുകളോട്
and
കൂടിയ
revenue
പ്രിസ്ക്രൈബ്ഡ്
prospects.
ഗ്ലാസുകളും
Under the
സൺ
leadership
ഗ്ലാസുകളും
of
അഫോർഡബിൾ
Dr.
പ്രൈസിൽ
Advocate
സ്വന്തമാക്കാം
Shamsuddin
ഇനി കണ്ണു
Ali
തുറക്കാം
Chairman
പുതുമയുടെ
of
പുതിയ
Abate
ലോകത്തേക്ക്
AS Group of
അബേറ്റ്
Companies.
AS
The
Opticals
dynamic and
ഒറിജിനൽ
forward-thinking team,
stylish
Abate AS,
affordable
is moving into new horizons.
കണ്ണുകൾക്ക് കൂടുതൽ
Abate
നിറമുള്ള
AS,
കാഴ്ചകളേകാൻ
group
പുതുമയുള്ളൊരു
of
പേര്
companies.
ഷോൺ
Grow
ഒപ്റ്റിക്കൽസ് ഇനി
together.
മുതൽ അബേറ്റ് AS Opticals ലേറ്റസ്റ്റ് ഡിസൈനുകളോട് കൂടിയ
Abate AS,
പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും
formerly
സൺ
known as
ഗ്ലാസുകളും
Al Salama,
അഫോർഡബിൾ പ്രൈസിൽ
is
സ്വന്തമാക്കാം
reaching new heights
ഇനി
in the
കണ്ണു
realm of
തുറക്കാം
eye care and
പുതുമയുടെ
education
പുതിയ
sectors in
ലോകത്തേക്ക്
India, and is
അബേറ്റ്
the
AS
first
Opticals
BSc listed
ഒറിജിനൽ
company
stylish
headquartered in
affordable
Northern Kerala. Al Salama was established in
കണ്ണുകൾക്ക് കൂടുതൽ
Perindalmana
നിറമുള്ള
in
കാഴ്ചകളേകാൻ
2004 and
പുതുമയുള്ളൊരു
has
പേര്
tremendously grown
ഷോൺ
both
ഒപ്റ്റിക്കൽസ്
within
ഇനി
and
മുതൽ
outside of
അബേറ്റ്
Kerala.
AS Opticals
Abate AS
ലേറ്റസ്റ്റ്
hospitals and
ഡിസൈനുകളോട്
opticals
കൂടിയ
are renowned
പ്രിസ്ക്രൈബ്ഡ്
for
ഗ്ലാസുകളും
providing
സൺ
top-notch
ഗ്ലാസുകളും
services
അഫോർഡബിൾ
that earn
പ്രൈസിൽ
trust
സ്വന്തമാക്കാം.
and loyalty
ഇനി കണ്ണു
from
തുറക്കാം
many walks of
പുതുമയുടെ
life.
പുതിയ
The group
ലോകത്തേക്ക്.
also
Abate
operates
AS
optometry,
Opticals.
architecture,
Original
business
stylish,
management,
affordable.
interior designing, and fashion designing colleges.
കണ്ണുകൾക്ക് കൂടുതൽ
Abate
നിറമുള്ള
AS is
കാഴ്ചകളേകാൻ
opening a new
പുതുമയുള്ളൊരു
world of
പേര്.
opportunities with an
ഷോൺ
ambition to
Opticals
open
ഇനി
a
മുതൽ
network of
Abate AS
44 plus
Opticals
eye hospitals,
ലേറ്റസ്റ്റ്
optical
ഡിസൈനുകളോട്
centers,
കൂടിയ
and
പ്രിസ്ക്രൈബ്ഡ്
educational
ഗ്ലാസുകളും
facilities
സൺ
across
ഗ്ലാസുകളും
India,
അഫോർഡബിൾ
Europe,
പ്രൈസിൽ
and the
സ്വന്തമാക്കാം.
GCC.
ഇനി കണ്ണു തുറക്കാം
The group is ready
പുതുമയുടെ
to venture
പുതിയ
into
ലോകത്തേക്ക്.
real estate,
Abate AS
jewelry,
Opticals
and other
ഒറിജിനൽ,
fast-growing sectors,
stylish,
enabling
affordable.
sustaining investment and revenue prospects.
കണ്ണുകൾക്ക്
Under the
കൂടുതൽ
leadership
നിറമുള്ള
of
കാഴ്ചകളേകാൻ
Dr.
പുതുമയുള്ളൊരു
Advocate
പേര്.
Shamsuddin
ഷോൺ
Ali Kurian,
ഒപ്റ്റിക്കൽസ്
chairman
ഇനി മുതൽ
of
Abate AS
Group of
Opticals
companies.
ലേറ്റസ്റ്റ്
Dynamic
ഡിസൈനുകളോട്
and
കൂടിയ
forward-thinking
പ്രിസ്ക്രൈബ്ഡ്
team,
ഗ്ലാസുകളും
Abate AS
സൺ
is
ഗ്ലാസുകളും
moving into
അഫോർഡബിൾ
new
പ്രൈസിൽ
horizons.
സ്വന്തമാക്കാം. ഇനി കണ്ണു
Abate
തുറക്കാം
AS,
പുതുമയുടെ
group
പുതിയ
of
ലോകത്തേക്ക്.
companies.
Abate AS
Grow
Opticals
together.
ഒറിജിനൽ, stylish, affordable.
Abate AS,
കണ്ണുകൾക്ക്
formerly
കൂടുതൽ
known as
നിറമുള്ള കാഴ്ചകളേകാൻ
Salama, is
പുതുമയുള്ളൊരു പേര്.
reaching new heights in the
ഷോൺ
realm of eye
ഒപ്റ്റിക്കൽസ്
care
ഇനി
and
മുതൽ
education
Abate
sectors in
AS
India, and
Opticals
is the first
ലേറ്റസ്റ്റ്
BSc
ഡിസൈനുകളോട്
listed
കൂടിയ
company
പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും
headquartered in
സൺ
Northern
ഗ്ലാസുകളും
Kerala.
അഫോർഡബിൾ
Salama
പ്രൈസിൽ
was
സ്വന്തമാക്കാം.
established in
ഇനി കണ്ണു
Perindalmannu
തുറക്കാം
in 2004
പുതുമയുടെ പുതിയ
and has
ലോകത്തേക്ക്.
tremendously
Abate
grown
AS
both
Opticals
within and
ഒറിജിനൽ,
outside of Kerala.
stylish,
Abate AS
affordable.
Hospitals and Opticals are renowned for
കണ്ണുകൾക്ക്
providing
കൂടുതൽ
top-notch
നിറമുള്ള
services
കാഴ്ചകളേകാൻ
that earn
പുതുമയുള്ളൊരു
trust
പേര്.
and loyalty
ഷോൺ
from many
ഒപ്റ്റിക്കൽസ്
walks
ഇനി
of
മുതൽ
life. The
Abate
group
AS
also
Opticals
operates
ലേറ്റസ്റ്റ്
optometry,
ഡിസൈനുകളോട് കൂടിയ
architecture,
പ്രിസ്ക്രൈബ്ഡ്
business
ഗ്ലാസുകളും
management,
സൺ
interior
ഗ്ലാസുകളും
designing, and
അഫോർഡബിൾ
fashion
പ്രൈസിൽ
designing
സ്വന്തമാക്കാം.
colleges.
ഇനി കണ്ണു
Abate
തുറക്കാം
AS is
പുതുമയുടെ
opening a
പുതിയ
new world of
ലോകത്തേക്ക്.
opportunities
Abate
with an
AS
ambition to
Opticals
open a
ഒറിജിനൽ,
network of 44
stylish,
plus eye
affordable.
hospitals, optical centers, and educational
കണ്ണുകൾക്ക്
facilities
കൂടുതൽ
across
നിറമുള്ള
India,
കാഴ്ചകളേകാൻ
Europe,
പുതുമയുള്ളൊരു
and the
പേര്.
GCC.
ഷോൺ
The group
ഒപ്റ്റിക്കൽസ്
is
ഇനി
ready
മുതൽ
to venture
Abate
into
AS
real estate,
Opticals
jewelry,
ലേറ്റസ്റ്റ്
and other
ഡിസൈനുകളോട് കൂടിയ
fast-growing
പ്രിസ്ക്രൈബ്ഡ്
sectors,
ഗ്ലാസുകളും
enabling
സൺ
sustaining
ഗ്ലാസുകളും
investment
അഫോർഡബിൾ
and
പ്രൈസിൽ
revenue
സ്വന്തമാക്കാം.
prospects.
ഇനി
Under
കണ്ണു
the
തുറക്കാം
leadership of
പുതുമയുടെ
Dr.
പുതിയ
Advocate
ലോകത്തേക്ക്.
Shamsuddin
Abate
Ali
AS
Kurian,
Opticals
chairman of
ഒറിജിനൽ,
Abate AS
stylish,
Group of companies.
affordable.
The dynamic and forward-thinking team,
കണ്ണുകൾക്ക്
Abate AS,
കൂടുതൽ
is
നിറമുള്ള
moving
കാഴ്ചകളേകാൻ
into new
പുതുമയുള്ളൊരു പേര്.
horizons.
ഷോൺ
Abate
ഒപ്റ്റിക്കൽസ്
AS,
ഇനി മുതൽ
group
Abate
of companies.
AS Opticals
Grow
ലേറ്റസ്റ്റ് ഡിസൈനുകളോട്
together.
കൂടിയ പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺ ഗ്ലാസുകളും അഫോർഡബിൾ പ്രൈസിൽ
Abate
സ്വന്തമാക്കാം.
AS,
ഇനി
formerly
കണ്ണു
known
തുറക്കാം
as
പുതുമയുടെ
Salama,
പുതിയ
is
ലോകത്തേക്ക്.
reaching new heights in
Abate
the realm
AS
of eye
Opticals
care and education
ഒറിജിനൽ,
sectors in
stylish,
India, and is the
affordable.
first BSc listed company
കണ്ണുകൾക്ക്
headquartered in
കൂടുതൽ
Northern
നിറമുള്ള
Kerala.
കാഴ്ചകളേകാൻ
Salama
പുതുമയുള്ളൊരു
was
പേര്.
established in Perindalmannu
ഷോൺ
in
ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ
2004 and
Abate
has
AS
tremendously
Opticals
grown both
ലേറ്റസ്റ്റ്
within
ഡിസൈനുകളോട്
and
കൂടിയ
outside of
പ്രിസ്ക്രൈബ്ഡ്
Kerala.
ഗ്ലാസുകളും
Abate AS
സൺ ഗ്ലാസുകളും
hospitals and
അഫോർഡബിൾ
opticals
പ്രൈസിൽ
are renowned
സ്വന്തമാക്കാം.
for providing
ഇനി കണ്ണു തുറക്കാം
top-notch services
പുതുമയുടെ
that
പുതിയ
earn
ലോകത്തേക്ക്.
trust and
Abate
loyalty
AS
from many
Opticals
walks of life.
ഒറിജിനൽ,
The group
stylish,
also operates
affordable.
optometry, architecture, business
കണ്ണുകൾക്ക്
management,
കൂടുതൽ
interior
നിറമുള്ള
designing,
കാഴ്ചകളേകാൻ
and fashion
പുതുമയുള്ളൊരു
designing
പേര്.
colleges.
ഷോൺ
Abate
ഒപ്റ്റിക്കൽസ്
AS is
ഇനി മുതൽ
opening a new
Abate
world of
AS
opportunities
Opticals
with an ambition
ലേറ്റസ്റ്റ്
to open
ഡിസൈനുകളോട്
a
കൂടിയ
network of
പ്രിസ്ക്രൈബ്ഡ്
44
ഗ്ലാസുകളും
plus eye
സൺ
hospitals,
ഗ്ലാസുകളും
optical
അഫോർഡബിൾ
centers,
പ്രൈസിൽ
and
സ്വന്തമാക്കാം.
educational facilities
ഇനി കണ്ണു തുറക്കാം
across India,
പുതുമയുടെ
Europe,
പുതിയ
and the
ലോകത്തേക്ക്.
GCC.
Abate AS Opticals
is ready to
ഒറിജിനൽ,
venture into real
stylish,
estate,
affordable.
jewelry, and other fast-growing sectors,
കണ്ണുകൾക്ക്
enabling
കൂടുതൽ
sustaining
നിറമുള്ള
investment
കാഴ്ചകളേകാൻ
and revenue
പുതുമയുള്ളൊരു പേര്.
prospects. Under the
ഷോൺ
leadership
ഒപ്റ്റിക്കൽസ്
of
ഇനി മുതൽ
Dr.
Abate
Advocate
AS Opticals
Shamsuddin Ali
ലേറ്റസ്റ്റ്
Kurian,
ഡിസൈനുകളോട്
chairman of
കൂടിയ
Abate
പ്രിസ്ക്രൈബ്ഡ്
AS
ഗ്ലാസുകളും
companies.
സൺ
The
ഗ്ലാസുകളും
dynamic and
അഫോർഡബിൾ പ്രൈസിൽ
forward-thinking
സ്വന്തമാക്കാം.
team, Abate
ഇനി കണ്ണു
AS
തുറക്കാം
is moving
പുതുമയുടെ
into new
പുതിയ
horizons.
ലോകത്തേക്ക്. Abate AS
Abate
Opticals
AS,
ഒറിജിനൽ,
group of companies.
stylish, affordable.
Grow together.
കണ്ണുകൾക്ക് കൂടുതൽ നിറമുള്ള കാഴ്ചകളേകാൻ പുതുമയുള്ളൊരു
Abate
പേര്.
AS, formerly
ഷോൺ
known as
ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ
Salama,
Abate
is reaching
AS
new
Opticals
heights in the realm of
ലേറ്റസ്റ്റ്
eye care and
ഡിസൈനുകളോട് കൂടിയ
education sectors in
പ്രിസ്ക്രൈബ്ഡ്
India,
ഗ്ലാസുകളും
and is the
സൺ
first
ഗ്ലാസുകളും
BSc
അഫോർഡബിൾ
listed
പ്രൈസിൽ
company
സ്വന്തമാക്കാം.
headquartered
ഇനി കണ്ണു
in
തുറക്കാം
Northern Kerala.
പുതുമയുടെ
Salama
പുതിയ
was
ലോകത്തേക്ക്.
established in
Abate AS
Perindalmannu
Opticals
in 2004
ഒറിജിനൽ,
and has
stylish,
tremendously grown
affordable.
both within and outside of Kerala.
കണ്ണുകൾക്ക്
Abate
കൂടുതൽ
AS
നിറമുള്ള
Hospitals and
കാഴ്ചകളേകാൻ
Opticals
പുതുമയുള്ളൊരു
are
പേര്.
renowned for providing
ഷോൺ
top-notch
ഓപ്റ്റിക്കൽസ് ഇനി
services
മുതൽ
that earn
അബേറ്റ്
trust
AS
and
ഓപ്റ്റിക്കൽസ്
loyalty from
ലേറ്റസ്റ്റ്
many walks of
ഡിസൈനുകളോട്
life.
കൂടിയ
The group
പ്രിസ്ക്രൈബ്ഡ്
also
ഗ്ലാസുകളും
operates
സൺഗ്ലാസുകളും
optometry,
അഫോർഡബിൾ
architecture,
പ്രൈസിൽ സ്വന്തമാക്കാം.
business management,
ഇനി കണ്ണു
interior
തുറക്കാം
designing
പുതുമയുടെ
and fashion
പുതിയ
designing
ലോകത്തേക്ക്.
colleges.
അബേറ്റ് AS
Abate
ഓപ്റ്റിക്കൽസ്
AS is opening a
ഒറിജിനൽ,
new world of
stylish,
opportunities with an
affordable.
ambition to open a network of 44
കണ്ണുകൾക്ക്
plus eye
കൂടുതൽ
hospitals,
നിറമുള്ള കാഴ്ചകളേകാൻ
optical centers,
പുതുമയുള്ളൊരു
and
പേര്.
educational facilities
ഷോൺ
across
ഓപ്റ്റിക്കൽസ്
India,
ഇനി മുതൽ
Europe,
അബേറ്റ്
and the
AS
GCC.
ഓപ്റ്റിക്കൽസ് ലേറ്റസ്റ്റ് ഡിസൈനുകളോട് കൂടിയ പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺഗ്ലാസുകളും അഫോർഡബിൾ പ്രൈസിൽ സ്വന്തമാക്കാം. ഇനി കണ്ണു തുറക്കാം പുതുമയുടെ പുതിയ ലോകത്തേക്ക്. അബൈറ്റ് AS Opticals. Original, stylish, affordable.
Chairman of Abaid AS
കണ്ണുകൾക്ക് കൂടുതൽ നിറമുള്ള കാഴ്ചകളേകാൻ പുതുമയുള്ളൊരു പേര്. ഷോൺ ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ അബൈറ്റ് AS Opticals. ലേറ്റസ്റ്റ് ഡിസൈനുകളോട് കൂടിയ പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺഗ്ലാസുകളും അഫോർഡബിൾ പ്രൈസിൽ സ്വന്തമാക്കാം. ഇനി കണ്ണു തുറക്കാം പുതുമയുടെ പുതിയ ലോകത്തേക്ക്. Abaid AS Opticals. Original, stylish, affordable.
eye care and education sectors in India
കണ്ണുകൾക്ക്
and is the
കൂടുതൽ
first
നിറമുള്ള കാഴ്ചകളേകാൻ
BSc-listed
പുതുമയുള്ളൊരു
company
പേര്.
headquartered in
ഷോൺ
Northern
ഒപ്റ്റിക്കൽസ്
Kerala.
ഇനി മുതൽ
Salama
അബൈറ്റ്
was
AS
established in
Opticals.
Perindalmada
ലേറ്റസ്റ്റ്
in
ഡിസൈനുകളോട്
2004
കൂടിയ
and has
പ്രിസ്ക്രൈബ്ഡ്
tremendously
ഗ്ലാസുകളും
grown
സൺഗ്ലാസുകളും
within
അഫോർഡബിൾ
and
പ്രൈസിൽ
outside of
സ്വന്തമാക്കാം.
Abaid
ഇനി കണ്ണു
AS
തുറക്കാം
Hospitals and
പുതുമയുടെ
Opticals,
പുതിയ ലോകത്തേക്ക്.
renowned for providing
Abaid AS
top-notch
Opticals.
services that
Original,
earned trust
stylish,
and loyalty
affordable.
from many walks of life. The group also
കണ്ണുകൾക്ക്
operates
കൂടുതൽ നിറമുള്ള
optometry,
കാഴ്ചകളേകാൻ
architecture,
പുതുമയുള്ളൊരു പേര്.
business management,
ഷോൺ
interior
ഒപ്റ്റിക്കൽസ്
designing
ഇനി
and
മുതൽ
fashion
അബൈറ്റ്
designing
AS
colleges.
Opticals.
Abaid
ലേറ്റസ്റ്റ്
AS
ഡിസൈനുകളോട്
is opening
കൂടിയ
a new world
പ്രിസ്ക്രൈബ്ഡ്
of
ഗ്ലാസുകളും
opportunities
സൺഗ്ലാസുകളും
with an ambition to open
അഫോർഡബിൾ
a
പ്രൈസിൽ
network of
സ്വന്തമാക്കാം.
44+
ഇനി
eye
കണ്ണു തുറക്കാം
hospitals,
പുതുമയുടെ
optical centers,
പുതിയ
and
ലോകത്തേക്ക്.
educational
അബൈറ്റ്
facilities
AS
across
Opticals.
India,
Original,
and the
stylish,
GCC.
affordable.
The group is ready to venture into real
കണ്ണുകൾക്ക്
estate,
കൂടുതൽ
jewelry,
നിറമുള്ള
and other
കാഴ്ചകളേകാൻ
fast-growing
പുതുമയുള്ളൊരു പേര്.
sectors, enabling
ഷോൺ
sustaining
ഒപ്റ്റിക്കൽസ് ഇനി
investment
മുതൽ
and revenue
അബൈറ്റ്
prospects.
AS Opticals.
Under the leadership
ലേറ്റസ്റ്റ്
of
ഡിസൈനുകളോട്
Dr.
കൂടിയ
Advocate
പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും
Shamsuddin
സൺഗ്ലാസുകളും
Adikurian, chairman
അഫോർഡബിൾ
of
പ്രൈസിൽ
Abaid
സ്വന്തമാക്കാം.
AS Group of
ഇനി കണ്ണു
companies.
തുറക്കാം
The dynamic
പുതുമയുടെ
and
പുതിയ
forward-thinking
ലോകത്തേക്ക്.
team, Abaid
അബൈറ്റ്
AS,
AS Opticals.
is moving into
Original,
new horizons.
stylish, affordable.
Abaid AS Group of companies.
കണ്ണുകൾക്ക് കൂടുതൽ നിറമുള്ള
Grow
കാഴ്ചകളേകാൻ
together.
പുതുമയുള്ളൊരു പേര്. ഷോൺ ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ
Abaid
അബൈറ്റ്
AS,
AS Opticals.
formerly known
ലേറ്റസ്റ്റ്
as
ഡിസൈനുകളോട്
Salama,
കൂടിയ
is
പ്രിസ്ക്രൈബ്ഡ്
reaching new
ഗ്ലാസുകളും
heights in the
സൺഗ്ലാസുകളും
relevant eye care and
അഫോർഡബിൾ
education
പ്രൈസിൽ
sectors in
സ്വന്തമാക്കാം.
India
ഇനി
and is
കണ്ണു
the
തുറക്കാം
first BSc
പുതുമയുടെ
listed
പുതിയ
company
ലോകത്തേക്ക്.
headquartered
അബൈറ്റ്
in
AS
Northern
Opticals.
Kerala.
Original,
Salama was
stylish,
established in Perindalmada
affordable.
in 2004 and has
കണ്ണുകൾക്ക്
tremendously grown
കൂടുതൽ
both
നിറമുള്ള
within
കാഴ്ചകളേകാൻ
and outside of
പുതുമയുള്ളൊരു പേര്.
Kerala. Abaid AS
ഷോൺ
Hospitals
ഒപ്റ്റിക്കൽസ്
and
ഇനി മുതൽ
Opticals are
അബൈറ്റ്
renowned
AS
for
Opticals.
providing top-notch
ലേറ്റസ്റ്റ്
services
ഡിസൈനുകളോട്
that
കൂടിയ
earned trust
പ്രിസ്ക്രൈബ്ഡ്
and
ഗ്ലാസുകളും
loyalty
സൺഗ്ലാസുകളും
from many walks of
അഫോർഡബിൾ
life.
പ്രൈസിൽ
The group
സ്വന്തമാക്കാം.
also
ഇനി
operates
കണ്ണു തുറക്കാം
optometry,
പുതുമയുടെ
architecture,
പുതിയ ലോകത്തേക്ക്.
business management,
അബൈറ്റ് AS
interior
Opticals.
designing and
Original,
fashion designing
stylish,
colleges. Abaid
affordable.
AS is opening a new world of
കണ്ണുകൾക്ക്
opportunities with
കൂടുതൽ
an
നിറമുള്ള
ambition to open
കാഴ്ചകളേകാൻ
a network
പുതുമയുള്ളൊരു
of
പേര്.
44+ eye
ഷോൺ
hospitals,
ഒപ്റ്റിക്കൽസ് ഇനി
optical
മുതൽ
centers,
അബൈറ്റ്
and
AS
educational
Opticals.
facilities across
ലേറ്റസ്റ്റ്
India,
ഡിസൈനുകളോട്
Europe,
കൂടിയ
and the
പ്രിസ്ക്രൈബ്ഡ്
GCC.
ഗ്ലാസുകളും സൺഗ്ലാസുകളും
The group is ready
അഫോർഡബിൾ
to
പ്രൈസിൽ
venture
സ്വന്തമാക്കാം.
into real estate,
ഇനി കണ്ണു
jewelry,
തുറക്കാം
and other
പുതുമയുടെ
fast-growing
പുതിയ ലോകത്തേക്ക്.
sectors,
അബൈറ്റ്
enabling
AS
sustaining
Opticals.
investment and
Original,
revenue prospects.
stylish,
Under the
affordable.
leadership of Dr. Advocate
കണ്ണുകൾക്ക്
Shamsuddin
കൂടുതൽ നിറമുള്ള
Adikurian,
കാഴ്ചകളേകാൻ
chairman of
പുതുമയുള്ളൊരു
Abaid
പേര്.
AS Group of companies.
ഷോൺ
The
ഒപ്റ്റിക്കൽസ്
dynamic
ഇനി മുതൽ
and
അബൈറ്റ്
forward-thinking
AS
team,
Opticals.
Abaid AS,
ലേറ്റസ്റ്റ്
is moving
ഡിസൈനുകളോട്
into
കൂടിയ
new horizons.
പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺഗ്ലാസുകളും
AS,
അഫോർഡബിൾ പ്രൈസിൽ
group of
സ്വന്തമാക്കാം.
companies.
ഇനി കണ്ണു തുറക്കാം
Grow
പുതുമയുടെ
together.
പുതിയ ലോകത്തേക്ക്. അബൈറ്റ് AS Opticals. Original,
Abaid AS,
stylish,
formerly known
affordable.
as Salama, is reaching new
കണ്ണുകൾക്ക്
heights in the
കൂടുതൽ
realm of
നിറമുള്ള
eye care
കാഴ്ചകളേകാൻ
and education
പുതുമയുള്ളൊരു
sectors
പേര്.
in India and is the
ഷോൺ
first
ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ
BSc-listed
അബൈറ്റ്
company
AS
headquartered
Opticals.
in Northern
ലേറ്റസ്റ്റ്
Kerala.
ഡിസൈനുകളോട് കൂടിയ
Salama was
പ്രിസ്ക്രൈബ്ഡ്
established
ഗ്ലാസുകളും
in Perindalmada
സൺഗ്ലാസുകളും
in 2004
അഫോർഡബിൾ പ്രൈസിൽ
and has
സ്വന്തമാക്കാം.
tremendously
ഇനി
grown
കണ്ണു തുറക്കാം
both within
പുതുമയുടെ
and outside
പുതിയ
of
ലോകത്തേക്ക്.
Kerala.
അബൈറ്റ്
Abaid
AS
AS
Opticals.
Hospitals and Opticals
Original,
are renowned for
stylish,
providing
affordable.
top-notch services that earned trust and
കണ്ണുകൾക്ക്
loyalty
കൂടുതൽ
from
നിറമുള്ള
many walks
കാഴ്ചകളേകാൻ
of life.
പുതുമയുള്ളൊരു
The group
പേര്.
also operates
ഷോൺ
optometry,
ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ
architecture,
അബൈറ്റ് AS
business
Opticals.
management, interior
ലേറ്റസ്റ്റ്
designing
ഡിസൈനുകളോട്
and
കൂടിയ
fashion designing
പ്രിസ്ക്രൈബ്ഡ്
colleges.
ഗ്ലാസുകളും
Abaid
സൺഗ്ലാസുകളും
AS is
അഫോർഡബിൾ
opening a
പ്രൈസിൽ
new world of
സ്വന്തമാക്കാം.
opportunities
ഇനി കണ്ണു
with an
തുറക്കാം
ambition to
പുതുമയുടെ
open a
പുതിയ
network of
ലോകത്തേക്ക്.
44+
അബൈറ്റ്
eye
AS
hospitals,
Opticals.
optical
Original,
centers, and educational
stylish,
facilities
affordable.
across India, Europe, and the GCC.
കണ്ണുകൾക്ക് കൂടുതൽ
The
നിറമുള്ള
group is
കാഴ്ചകളേകാൻ
ready to venture
പുതുമയുള്ളൊരു പേര്.
into real estate,
ഷോൺ
jewelry,
ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ അബേറ്റ് എയർസ് ഓപ്റ്റിക്കൽസ് ലേറ്റസ്റ്റ് ഡിസൈനുകളോട് കൂടിയ പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺഗ്ലാസുകളും അഫോർഡബിൾ പ്രൈസിൽ സ്വന്തമാക്കാം. ഇനി കണ്ണു തുറക്കാം പുതുമയുടെ പുതിയ ലോകത്തേക്ക്. അബേറ്റ് എയർസ് ഓപ്റ്റിക്കൽസ്, ഒറിജിനൽ, സ്റ്റൈലിഷ്, അഫോർഡബിൾ. കണ്ണുകൾക്ക് കൂടുതൽ നിറമുള്ള കാഴ്ചകളേകാൻ പുതുമയുള്ള ഒരു പേര്. ഷോൺ ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ അബേറ്റ് AS ഒപ്റ്റിക്കൽസ് ലേറ്റസ്റ്റ് ഡിസൈനുകളോട് കൂടിയ പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺ ഗ്ലാസുകളും അഫോർഡബിൾ പ്രൈസിൽ സ്വന്തമാക്കാം. ഇനി കണ്ണു തുറക്കാം പുതുമയുടെ പുതിയ ലോകത്തേക്ക്. അബേറ്റ് AS ഒപ്റ്റിക്കൽസ്, ഒറിജിനൽ, സ്റ്റൈലിഷ്, അഫോർഡബിൾ.
Al Salama was established in
കൂടുതൽ നിറമുള്ള
in
കാഴ്ചകളേകാൻ
2004
പുതുമയുള്ളൊരു
and has
പേര്.
tremendously grown.
ഷോൺ ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ അബേറ്റ് AS ഒപ്റ്റിക്കൽസ് ലേറ്റസ്റ്റ് ഡിസൈനുകളോട് കൂടിയ പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺ ഗ്ലാസുകളും അഫോർഡബിൾ പ്രൈസിൽ സ്വന്തമാക്കാം. ഇനി കണ്ണു തുറക്കാം പുതുമയുടെ പുതിയ ലോകത്തേക്ക്. അബേറ്റ് AS ഒപ്റ്റിക്കൽസ്, ഒറിജിനൽ, stylish, affordable.
Interior designing and fashion designing colleges.
കൂടുതൽ
Abate
നിറമുള്ള
AS is
കാഴ്ചകളേകാൻ
opening a new
പുതുമയുള്ളൊരു
world
പേര്.
of opportunities with
ഷോൺ
an ambition to
ഒപ്റ്റിക്കൽസ്
open
ഇനി മുതൽ
a network
അബേറ്റ്
of
AS
44 plus
ഒപ്റ്റിക്കൽസ്
eye hospitals,
ലേറ്റസ്റ്റ്
optical
ഡിസൈനുകളോട് കൂടിയ
centers and
പ്രിസ്ക്രൈബ്ഡ്
educational
ഗ്ലാസുകളും
facilities
സൺ
across
ഗ്ലാസുകളും
India,
അഫോർഡബിൾ
Europe,
പ്രൈസിൽ
and the
സ്വന്തമാക്കാം.
GCC.
ഇനി കണ്ണു തുറക്കാം
The group is
പുതുമയുടെ
ready to
പുതിയ
venture
ലോകത്തേക്ക്.
into real estate,
അബേറ്റ് AS
jewelry,
ഒപ്റ്റിക്കൽസ്,
and other
ഒറിജിനൽ,
fast-growing sectors,
stylish,
enabling
affordable.
sustaining investment and revenue prospects.
കണ്ണുകൾക്ക്
Under the
കൂടുതൽ
leadership
നിറമുള്ള
of
കാഴ്ചകളേകാൻ
Dr.
പുതുമയുള്ളൊരു പേര്.
Advocate Shamsuddin
ഷോൺ
Ali Kuri,
ഒപ്റ്റിക്കൽസ് ഇനി
chairman
മുതൽ
of
അബേറ്റ്
Abate
AS
Group of
ഒപ്റ്റിക്കൽസ്
companies.
ലേറ്റസ്റ്റ്
The dynamic
ഡിസൈനുകളോട്
and
കൂടിയ
forward-thinking
പ്രിസ്ക്രൈബ്ഡ്
team,
ഗ്ലാസുകളും
Abate AS,
സൺ
is
ഗ്ലാസുകളും
moving
അഫോർഡബിൾ
into
പ്രൈസിൽ
new
സ്വന്തമാക്കാം.
horizons.
ഇനി കണ്ണു തുറക്കാം
Abate AS,
പുതുമയുടെ പുതിയ
group of
ലോകത്തേക്ക്.
companies.
അബേറ്റ് AS ഒപ്റ്റിക്കൽസ്,
together.
ഒറിജിനൽ, സ്റ്റൈലിഷ്, അഫോർഡബിൾ.
Abate AS,
കണ്ണുകൾക്ക് കൂടുതൽ
formerly known
നിറമുള്ള
as
കാഴ്ചകളേകാൻ
Al Salama,
പുതുമയുള്ളൊരു
is
പേര്.
reaching new heights in the
ഷോൺ
realm of eye
ഒപ്റ്റിക്കൽസ്
care
ഇനി
and
മുതൽ
education
അബേറ്റ്
sectors in
AS
India
ഒപ്റ്റിക്കൽസ്
and is the first
ലേറ്റസ്റ്റ് ഡിസൈനുകളോട്
BSE
കൂടിയ
listed
പ്രിസ്ക്രൈബ്ഡ്
company
ഗ്ലാസുകളും
headquartered
സൺ
in
ഗ്ലാസുകളും
Kerala.
അഫോർഡബിൾ
Al
പ്രൈസിൽ
Salama was
സ്വന്തമാക്കാം.
established in
ഇനി കണ്ണു
Perindimana
തുറക്കാം
in
പുതുമയുടെ
2004
പുതിയ
and has
ലോകത്തേക്ക്.
tremendously
അബേറ്റ്
grown
AS
both
ഒപ്റ്റിക്കൽസ്,
within and
ഒറിജിനൽ,
outside of Kerala.
stylish,
Abate AS
affordable.
hospitals and opticals are renowned for
കണ്ണുകൾക്ക്
providing
കൂടുതൽ നിറമുള്ള
top-notch
കാഴ്ചകളേകാൻ
services that earn
പുതുമയുള്ളൊരു പേര്.
trust and loyalty
ഷോൺ
from many
ഒപ്റ്റിക്കൽസ് ഇനി
walks of
മുതൽ
life.
അബേറ്റ്
The group
AS
also
ഒപ്റ്റിക്കൽസ്
operates
ലേറ്റസ്റ്റ്
optometry,
ഡിസൈനുകളോട് കൂടിയ
architecture,
പ്രിസ്ക്രൈബ്ഡ്
business
ഗ്ലാസുകളും
management,
സൺ
interior
ഗ്ലാസുകളും
designing, and
അഫോർഡബിൾ
fashion
പ്രൈസിൽ
designing
സ്വന്തമാക്കാം.
colleges.
ഇനി കണ്ണു
Abate
തുറക്കാം
AS is
പുതുമയുടെ
opening a
പുതിയ
new world
ലോകത്തേക്ക്.
of opportunities
അബേറ്റ്
with
AS
an ambition
ഒപ്റ്റിക്കൽസ്,
to open a
ഒറിജിനൽ,
network of 44
stylish,
plus eye
affordable.
hospitals, optical centers, and educational
കണ്ണുകൾക്ക്
facilities
കൂടുതൽ
across
നിറമുള്ള
India,
കാഴ്ചകളേകാൻ
Europe,
പുതുമയുള്ളൊരു
and
പേര്.
the GCC.
ഷോൺ ഒപ്റ്റിക്കൽസ്
is
ഇനി മുതൽ
ready to venture
അബേറ്റ്
into
AS
real
ഒപ്റ്റിക്കൽസ്
estate, jewelry,
ലേറ്റസ്റ്റ്
and
ഡിസൈനുകളോട്
other
കൂടിയ
fast-growing
പ്രിസ്ക്രൈബ്ഡ്
sectors,
ഗ്ലാസുകളും
enabling
സൺ
sustaining
ഗ്ലാസുകളും
investment
അഫോർഡബിൾ
and
പ്രൈസിൽ
revenue
സ്വന്തമാക്കാം.
prospects.
ഇനി
Under
കണ്ണു
the
തുറക്കാം
leadership of
പുതുമയുടെ
Dr.
പുതിയ
Advocate
ലോകത്തേക്ക്. അബേറ്റ്
Shamsuddin
AS
Ali Kuri,
ഒപ്റ്റിക്കൽസ്,
chairman of
ഒറിജിനൽ,
Abate AS
stylish,
Group of companies.
affordable.
The dynamic and forward-thinking team,
കണ്ണുകൾക്ക്
Abate
കൂടുതൽ
AS,
നിറമുള്ള
is
കാഴ്ചകളേകാൻ
moving into new
പുതുമയുള്ളൊരു പേര്.
horizons.
ഷോൺ
Abate
ഒപ്റ്റിക്കൽസ്
AS,
ഇനി മുതൽ
group
അബേറ്റ്
of
AS
companies.
ഒപ്റ്റിക്കൽസ് ലേറ്റസ്റ്റ്
Grow
ഡിസൈനുകളോട്
together.
കൂടിയ പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺ ഗ്ലാസുകളും അഫോർഡബിൾ പ്രൈസിൽ
Abate
സ്വന്തമാക്കാം.
AS,
ഇനി കണ്ണു
formerly
തുറക്കാം
known as
പുതുമയുടെ
Al Salama,
പുതിയ
is
ലോകത്തേക്ക്.
reaching new heights
അബേറ്റ്
in the
AS
realm of eye
ഒപ്റ്റിക്കൽസ്,
care and
ഒറിജിനൽ,
education sectors in
stylish,
India and is the
affordable.
first BSE listed company
കണ്ണുകൾക്ക്
headquartered
കൂടുതൽ
in
നിറമുള്ള
northern Kerala.
കാഴ്ചകളേകാൻ
Al Salama
പുതുമയുള്ളൊരു
was
പേര്.
established in
ഷോൺ
Perindimana in
ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ
2004 and
അബേറ്റ്
has
AS
tremendously
ഒപ്റ്റിക്കൽസ്
grown
ലേറ്റസ്റ്റ്
both within
ഡിസൈനുകളോട്
and
കൂടിയ
outside of
പ്രിസ്ക്രൈബ്ഡ്
Kerala.
ഗ്ലാസുകളും
Abate
സൺ
AS
ഗ്ലാസുകളും
hospitals and
അഫോർഡബിൾ
opticals
പ്രൈസിൽ
are
സ്വന്തമാക്കാം.
renowned for
ഇനി
providing
കണ്ണു തുറക്കാം
top-notch services
പുതുമയുടെ
that
പുതിയ
earn
ലോകത്തേക്ക്.
trust and
അബേറ്റ്
loyalty
AS
from
ഒപ്റ്റിക്കൽസ്,
many walks of life.
ഒറിജിനൽ,
The group
stylish,
also operates
affordable.
optometry, architecture, business
കണ്ണുകൾക്ക്
management,
കൂടുതൽ
interior
നിറമുള്ള
designing,
കാഴ്ചകളേകാൻ
and fashion
പുതുമയുള്ളൊരു
designing
പേര്.
colleges.
ഷോൺ
Abate
ഒപ്റ്റിക്കൽസ്
AS
ഇനി
is
മുതൽ
opening a new
അബേറ്റ്
world
AS
of opportunities
ഒപ്റ്റിക്കൽസ്
with an
ലേറ്റസ്റ്റ്
ambition to
ഡിസൈനുകളോട്
open a
കൂടിയ
network of
പ്രിസ്ക്രൈബ്ഡ്
44
ഗ്ലാസുകളും
plus eye
സൺ
hospitals,
ഗ്ലാസുകളും
optical
അഫോർഡബിൾ
centers,
പ്രൈസിൽ
and
സ്വന്തമാക്കാം.
educational
ഇനി
facilities
കണ്ണു തുറക്കാം
across India,
പുതുമയുടെ
Europe,
പുതിയ
and
ലോകത്തേക്ക്.
the GCC.
അബേറ്റ് AS
The
ഒപ്റ്റിക്കൽസ്,
group is ready to
ഒറിജിനൽ,
venture into real
stylish,
estate,
affordable.
jewelry, and other fast-growing sectors,
കണ്ണുകൾക്ക്
enabling
കൂടുതൽ
sustaining
നിറമുള്ള
investment
കാഴ്ചകളേകാൻ
and
പുതുമയുള്ളൊരു
revenue
പേര്.
prospects. Under the
ഷോൺ
leadership
ഒപ്റ്റിക്കൽസ്
of
ഇനി മുതൽ
Dr.
അബേറ്റ്
Advocate
AS ഒപ്റ്റിക്കൽസ്
Shamsuddin Ali
ലേറ്റസ്റ്റ്
Kuri,
ഡിസൈനുകളോട് കൂടിയ
chairman of Abate
പ്രിസ്ക്രൈബ്ഡ്
AS
ഗ്ലാസുകളും
Group of companies.
സൺ
The
ഗ്ലാസുകളും
dynamic
അഫോർഡബിൾ
and
പ്രൈസിൽ
forward-thinking
സ്വന്തമാക്കാം.
team, Abate
ഇനി കണ്ണു
AS
തുറക്കാം
is moving
പുതുമയുടെ
into
പുതിയ
new
ലോകത്തേക്ക്.
horizons.
അബേറ്റ് AS
Abate
ഒപ്റ്റിക്കൽസ്,
AS,
ഒറിജിനൽ,
group of
stylish,
companies.
affordable.
Grow together.
കണ്ണുകൾക്ക് കൂടുതൽ നിറമുള്ള കാഴ്ചകളേകാൻ പുതുമയുള്ളൊരു
Abate
പേര്.
AS. formerly
ഷോൺ
known as
ഒപ്റ്റിക്കൽസ്
Al
ഇനി മുതൽ
Salama,
അബേറ്റ്
is
AS
reaching new
ഒപ്റ്റിക്കൽസ്
heights in the realm of
ലേറ്റസ്റ്റ്
eye care
ഡിസൈനുകളോട്
and
കൂടിയ
education sectors
പ്രിസ്ക്രൈബ്ഡ്
in India,
ഗ്ലാസുകളും
and is the
സൺഗ്ലാസുകളും
first BSc
അഫോർഡബിൾ
listed
പ്രൈസിൽ
company
സ്വന്തമാക്കാം.
headquartered
ഇനി കണ്ണു
in
തുറക്കാം
Northern Kerala.
പുതുമയുടെ
Al Salama
പുതിയ
was
ലോകത്തേക്ക്.
established in
അബേറ്റ് AS
Perunthimala in
ഒപ്റ്റിക്കൽസ്
2004
ഒറിജിനൽ
and has
സ്റ്റൈലിഷ്
tremendously grown
അഫോർഡബിൾ.
both within and outside of Kerala.
കണ്ണുകൾക്ക്
Abate
കൂടുതൽ
AS
നിറമുള്ള
Hospitals and
കാഴ്ചകളേകാൻ
Opticals
പുതുമയുള്ളൊരു
are
പേര്.
renowned for providing
ഷോൺ
top-notch
ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ
services that earn
അബേറ്റ്
trust
AS
and
ഒപ്റ്റിക്കൽസ്
loyalty
ലേറ്റസ്റ്റ്
from many
ഡിസൈനുകളോട്
walks of
കൂടിയ
life. The
പ്രിസ്ക്രൈബ്ഡ്
group also
ഗ്ലാസുകളും
operates
സൺഗ്ലാസുകളും
optometry,
അഫോർഡബിൾ
architecture,
പ്രൈസിൽ സ്വന്തമാക്കാം.
business management,
ഇനി കണ്ണു തുറക്കാം
interior designing
പുതുമയുടെ
and fashion
പുതിയ
designing
ലോകത്തേക്ക്.
colleges.
അബേറ്റ് AS
Abate
ഒപ്റ്റിക്കൽസ്
AS is opening
ഒറിജിനൽ
a new world of
സ്റ്റൈലിഷ്
opportunities with an
അഫോർഡബിൾ.
ambition to open a network of 44
കണ്ണുകൾക്ക്
plus eye
കൂടുതൽ നിറമുള്ള
hospitals,
കാഴ്ചകളേകാൻ
optical centers,
പുതുമയുള്ളൊരു
and
പേര്.
educational facilities
ഷോൺ
across
ഒപ്റ്റിക്കൽസ്
India,
ഇനി മുതൽ
Europe,
അബേറ്റ്
and the
AS
GCC.
ഒപ്റ്റിക്കൽസ്
The
ലേറ്റസ്റ്റ്
group is
ഡിസൈനുകളോട്
ready to
കൂടിയ
venture
പ്രിസ്ക്രൈബ്ഡ്
into real
ഗ്ലാസുകളും
estate,
സൺഗ്ലാസുകളും
jewelry, and other
അഫോർഡബിൾ പ്രൈസിൽ
fast-growing
സ്വന്തമാക്കാം.
sectors,
ഇനി
enabling
കണ്ണു തുറക്കാം
sustaining investment
പുതുമയുടെ
and
പുതിയ
revenue
ലോകത്തേക്ക്.
prospects.
അബേറ്റ്
Under the
AS
leadership
ഒപ്റ്റിക്കൽസ്
of Dr.
ഒറിജിനൽ
Advocate
സ്റ്റൈലിഷ്
Shamsuddin
അഫോർഡബിൾ.
Adikurian, Chairman of Abate AS Group
കണ്ണുകൾക്ക്
of
കൂടുതൽ
Companies, the
നിറമുള്ള
dynamic
കാഴ്ചകളേകാൻ
and
പുതുമയുള്ളൊരു
forward-thinking
പേര്.
team, Abate
ഷോൺ
AS, is
ഒപ്റ്റിക്കൽസ്
moving
ഇനി മുതൽ
into new
അബേറ്റ്
horizons.
AS ഒപ്റ്റിക്കൽസ്
Abate
ലേറ്റസ്റ്റ്
AS,
ഡിസൈനുകളോട് കൂടിയ
group of
പ്രിസ്ക്രൈബ്ഡ്
companies,
ഗ്ലാസുകളും സൺഗ്ലാസുകളും
grow
അഫോർഡബിൾ
together.
പ്രൈസിൽ സ്വന്തമാക്കാം. ഇനി കണ്ണു തുറക്കാം പുതുമയുടെ പുതിയ
Abate
ലോകത്തേക്ക്.
AS,
അബേറ്റ്
formerly
AS
known
ഒപ്റ്റിക്കൽസ്
as Al Salama,
ഒറിജിനൽ
is reaching
സ്റ്റൈലിഷ്
new heights in the
അഫോർഡബിൾ.
realm of eye care and education sectors in India,
കണ്ണുകൾക്ക്
and is
കൂടുതൽ
the first
നിറമുള്ള കാഴ്ചകളേകാൻ
BSc-listed
പുതുമയുള്ളൊരു
company
പേര്.
headquartered
ഷോൺ
in Northern
ഒപ്റ്റിക്കൽസ്
Kerala.
ഇനി മുതൽ
Al Salama
അബേറ്റ്
was
AS
established in
ഒപ്റ്റിക്കൽസ്
Perunthimala
ലേറ്റസ്റ്റ്
in
ഡിസൈനുകളോട്
2004
കൂടിയ
and has
പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും
tremendously grown
സൺഗ്ലാസുകളും
both within
അഫോർഡബിൾ
and
പ്രൈസിൽ
outside of
സ്വന്തമാക്കാം.
Kerala.
ഇനി
Abate
കണ്ണു
AS
തുറക്കാം
Hospitals and
പുതുമയുടെ
Opticals
പുതിയ
are
ലോകത്തേക്ക്.
renowned for
അബേറ്റ്
providing
AS
top-notch
ഒപ്റ്റിക്കൽസ്
services that
ഒറിജിനൽ
earned trust
സ്റ്റൈലിഷ്
and loyalty
അഫോർഡബിൾ.
from many walks of life. The group also
കണ്ണുകൾക്ക്
operates
കൂടുതൽ നിറമുള്ള
optometry,
കാഴ്ചകളേകാൻ
architecture,
പുതുമയുള്ളൊരു പേര്.
business management,
ഷോൺ
interior
ഒപ്റ്റിക്കൽസ്
designing,
ഇനി മുതൽ
and fashion
അബേറ്റ്
designing
AS
colleges.
ഒപ്റ്റിക്കൽസ്
Abate
ലേറ്റസ്റ്റ്
AS
ഡിസൈനുകളോട്
is opening
കൂടിയ
a new world
പ്രിസ്ക്രൈബ്ഡ്
of
ഗ്ലാസുകളും
opportunities with an
സൺഗ്ലാസുകളും
ambition to open
അഫോർഡബിൾ
a
പ്രൈസിൽ
network of
സ്വന്തമാക്കാം.
44
ഇനി
plus
കണ്ണു
eye
തുറക്കാം
hospitals,
പുതുമയുടെ
optical centers,
പുതിയ
and
ലോകത്തേക്ക്.
educational
അബേറ്റ്
facilities
AS
across
ഒപ്റ്റിക്കൽസ്
India,
ഒറിജിനൽ
Europe, and the
സ്റ്റൈലിഷ്
GCC.
അഫോർഡബിൾ.
The group is ready to venture into real
കണ്ണുകൾക്ക്
estate,
കൂടുതൽ
jewelry,
നിറമുള്ള
and
കാഴ്ചകളേകാൻ
other
പുതുമയുള്ളൊരു
fast-growing
പേര്.
sectors, enabling
ഷോൺ
sustaining
ഒപ്റ്റിക്കൽസ് ഇനി
investment
മുതൽ
and
അബേറ്റ്
revenue
AS
prospects.
ഒപ്റ്റിക്കൽസ്
Under the
ലേറ്റസ്റ്റ്
leadership
ഡിസൈനുകളോട്
of
കൂടിയ
Dr.
പ്രിസ്ക്രൈബ്ഡ്
Advocate
ഗ്ലാസുകളും
Shamsuddin
സൺഗ്ലാസുകളും
Adikurian, Chairman
അഫോർഡബിൾ
of
പ്രൈസിൽ
Abate
സ്വന്തമാക്കാം.
AS Group of
ഇനി കണ്ണു
Companies,
തുറക്കാം
the dynamic
പുതുമയുടെ
and
പുതിയ
forward-thinking
ലോകത്തേക്ക്.
team,
അബേറ്റ്
Abate
AS
AS
ഒപ്റ്റിക്കൽസ്
is moving into
ഒറിജിനൽ
new horizons.
സ്റ്റൈലിഷ് അഫോർഡബിൾ.
Abate AS, group of
കണ്ണുകൾക്ക്
companies,
കൂടുതൽ നിറമുള്ള
grow
കാഴ്ചകളേകാൻ
together.
പുതുമയുള്ളൊരു പേര്. ഷോൺ ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ അബേറ്റ് AS ഒപ്റ്റിക്കൽസ്
formerly known
ലേറ്റസ്റ്റ്
as
ഡിസൈനുകളോട്
Al Salama,
കൂടിയ
is
പ്രിസ്ക്രൈബ്ഡ്
reaching new
ഗ്ലാസുകളും
heights in the
സൺഗ്ലാസുകളും
realm of eye care
അഫോർഡബിൾ
and
പ്രൈസിൽ
education
സ്വന്തമാക്കാം.
sectors in India,
ഇനി
and is
കണ്ണു
the
തുറക്കാം
first
പുതുമയുടെ
BSc-listed
പുതിയ
company
ലോകത്തേക്ക്.
headquartered
അബേറ്റ്
in
AS
Northern
ഒപ്റ്റിക്കൽസ്
Kerala. Al
ഒറിജിനൽ
Salama was
സ്റ്റൈലിഷ്
established in
അഫോർഡബിൾ.
Perunthimala in 2004 and has
കണ്ണുകൾക്ക്
tremendously grown
കൂടുതൽ നിറമുള്ള
both
കാഴ്ചകളേകാൻ
within and outside
പുതുമയുള്ളൊരു
of
പേര്.
Kerala. Abate
ഷോൺ
AS
ഒപ്റ്റിക്കൽസ്
hospitals
ഇനി
and
മുതൽ
opticals
അബേറ്റ്
are
AS
renowned for
ഒപ്റ്റിക്കൽസ്
providing top-notch
ലേറ്റസ്റ്റ്
services
ഡിസൈനുകളോട് കൂടിയ
that earn
പ്രിസ്ക്രൈബ്ഡ്
trust and
ഗ്ലാസുകളും
loyalty
സൺഗ്ലാസുകളും
from many walks of
അഫോർഡബിൾ
life.
പ്രൈസിൽ
The
സ്വന്തമാക്കാം.
group also
ഇനി കണ്ണു
operates
തുറക്കാം
optometry,
പുതുമയുടെ
architecture,
പുതിയ ലോകത്തേക്ക്.
business
അബേറ്റ്
management,
AS
interior
ഒപ്റ്റിക്കൽസ്
designing, and
ഒറിജിനൽ
fashion designing
സ്റ്റൈലിഷ്
colleges.
അഫോർഡബിൾ.
Abate AS is opening a new world of
കണ്ണുകൾക്ക്
opportunities
കൂടുതൽ
with an
നിറമുള്ള
ambition to
കാഴ്ചകളേകാൻ
open a
പുതുമയുള്ളൊരു
network of
പേര്.
44 plus eye
ഷോൺ
hospitals,
ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ
optical centers,
അബേറ്റ്
and
AS
educational
ഒപ്റ്റിക്കൽസ്
facilities
ലേറ്റസ്റ്റ്
across
ഡിസൈനുകളോട്
India,
കൂടിയ
Europe, and
പ്രിസ്ക്രൈബ്ഡ്
the
ഗ്ലാസുകളും
GCC.
സൺഗ്ലാസുകളും
The group is
അഫോർഡബിൾ
ready to
പ്രൈസിൽ
venture
സ്വന്തമാക്കാം.
into real estate,
ഇനി കണ്ണു തുറക്കാം
jewelry, and
പുതുമയുടെ
other fast
പുതിയ
growing
ലോകത്തേക്ക്.
sectors,
അബേറ്റ്
enabling
AS
sustaining
ഒപ്റ്റിക്കൽസ്
investment
ഒറിജിനൽ
and revenue
സ്റ്റൈലിഷ്
prospects under the
അഫോർഡബിൾ.
leadership of Dr. Advocate
കണ്ണുകൾക്ക്
Shamsuddin
കൂടുതൽ നിറമുള്ള
Adikurian,
കാഴ്ചകളേകാൻ കണ്ണുകൾക്കേകാൻ പുതുമയുള്ളൊരു പേര്. ഷോൺ ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ അബേറ്റ് AS ഒപ്റ്റിക്കൽസ്. ലേറ്റസ്റ്റ് ഡിസൈനുകളോട് കൂടിയ പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺഗ്ലാസുകളും അഫോർഡബിൾ പ്രൈസിൽ സ്വന്തമാക്കാം. ഇനി കണ്ണു തുറക്കാം പുതുമയുടെ പുതിയ ലോകത്തേക്ക്. അബേറ്റ് AS ഒപ്റ്റിക്കൽസ്. ഒറിജിനൽ, സ്റ്റൈലിഷ്,
formerly known as Salama, is reaching new heights in the realm of eye care and education sectors in India, and is
ഷോൺ
the first
ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ
ESC-listed
അബേറ്റ്
company
AS ഒപ്റ്റിക്കൽസ്.
headquartered in
ലേറ്റസ്റ്റ്
Northern Kerala.
ഡിസൈനുകളോട് കൂടിയ
Salama was
പ്രിസ്ക്രൈബ്ഡ്
established
ഗ്ലാസുകളും
in Perumal
സൺഗ്ലാസുകളും
in 2004
അഫോർഡബിൾ പ്രൈസിൽ
and has
സ്വന്തമാക്കാം.
tremendously
ഇനി കണ്ണു
grown
തുറക്കാം
both within
പുതുമയുടെ
and
പുതിയ
outside of
ലോകത്തേക്ക്.
Kerala.
Abate AS Opticals.
Hospitals and
Original,
Opticals are renowned
stylish,
for providing
affordable.
top-notch services that earned trust and
കണ്ണുകൾക്ക്
loyalty
കൂടുതൽ
from
നിറമുള്ള
many
കാഴ്ചകളേകാൻ
walks of life.
പുതുമയുള്ളൊരു
The
പേര്
group also operates
ഷോൺ
optometry,
ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ
architecture,
അബേറ്റ് AS
business
ഒപ്റ്റിക്കൽസ്
management,
ലേറ്റസ്റ്റ്
interior
ഡിസൈനുകളോട്
designing
കൂടിയ
and fashion
പ്രിസ്ക്രൈബ്ഡ്
designing
ഗ്ലാസുകളും
colleges.
സൺഗ്ലാസുകളും
AS is
അഫോർഡബിൾ
opening a
പ്രൈസിൽ
new
സ്വന്തമാക്കാം.
world of opportunities
ഇനി കണ്ണു
with an
തുറക്കാം
ambition to
പുതുമയുടെ
open a
പുതിയ
network of
ലോകത്തേക്ക്.
44
അബേറ്റ്
plus eye
AS
hospitals,
ഒപ്റ്റിക്കൽസ്
optical
ഒറിജിനൽ
centers and
stylish
educational facilities
affordable.
across India, Europe and the
കണ്ണുകൾക്ക്
GCC.
കൂടുതൽ നിറമുള്ള
The group is
കാഴ്ചകളേകാൻ
ready to
പുതുമയുള്ളൊരു
venture
പേര്
into real estate,
ഷോൺ
jewelry
ഒപ്റ്റിക്കൽസ്
and
ഇനി
other
മുതൽ
fast-growing
അബേറ്റ് AS
sectors,
ഒപ്റ്റിക്കൽസ്
enabling
ലേറ്റസ്റ്റ്
sustaining
ഡിസൈനുകളോട്
investment
കൂടിയ
and revenue
പ്രിസ്ക്രൈബ്ഡ്
prospects.
ഗ്ലാസുകളും
Under the
സൺഗ്ലാസുകളും
leadership of
അഫോർഡബിൾ
Dr.
പ്രൈസിൽ സ്വന്തമാക്കാം.
Advocate
ഇനി കണ്ണു
Shamsuddin
തുറക്കാം
Adikurian,
പുതുമയുടെ
chairman
പുതിയ
of Abate
ലോകത്തേക്ക്.
AS Group of
അബേറ്റ്
companies.
AS ഒപ്റ്റിക്കൽസ്
The dynamic and
ഒറിജിനൽ
forward-thinking
stylish
team Abate
affordable.
AS is moving into new horizons.
കണ്ണുകൾക്ക് കൂടുതൽ
Abate
നിറമുള്ള
AS,
കാഴ്ചകളേകാൻ പുതുമയുള്ളൊരു
group of
പേര്
companies.
ഷോൺ ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ
together.
അബേറ്റ് AS ഒപ്റ്റിക്കൽസ് ലേറ്റസ്റ്റ് ഡിസൈനുകളോട് കൂടിയ
Abate
പ്രിസ്ക്രൈബ്ഡ്
AS,
ഗ്ലാസുകളും
formerly
സൺഗ്ലാസുകളും
known as
അഫോർഡബിൾ
Salama,
പ്രൈസിൽ
is
സ്വന്തമാക്കാം.
reaching new
ഇനി
heights
കണ്ണു
in the realm
തുറക്കാം
of eye care
പുതുമയുടെ
and education
പുതിയ ലോകത്തേക്ക്.
sectors in India
അബേറ്റ്
and is the
AS
first
ഒപ്റ്റിക്കൽസ്
BSc
ഒറിജിനൽ
listed company
stylish
headquartered in
affordable.
northern Kerala. Al Salama was
കണ്ണുകൾക്ക്
established in
കൂടുതൽ നിറമുള്ള
Perundumanna in
കാഴ്ചകളേകാൻ
2004
പുതുമയുള്ളൊരു
and has
പേര്
tremendously grown
ഷോൺ
both
ഒപ്റ്റിക്കൽസ്
within
ഇനി മുതൽ
and outside
അബേറ്റ്
of Kerala.
AS ഒപ്റ്റിക്കൽസ്
Abate AS
ലേറ്റസ്റ്റ്
hospitals
ഡിസൈനുകളോട്
and
കൂടിയ
opticals are
പ്രിസ്ക്രൈബ്ഡ്
renowned for
ഗ്ലാസുകളും
providing
സൺഗ്ലാസുകളും
top-notch services
അഫോർഡബിൾ പ്രൈസിൽ
that earn
സ്വന്തമാക്കാം.
trust and
ഇനി
loyalty
കണ്ണു തുറക്കാം
from many
പുതുമയുടെ
walks of life.
പുതിയ
The
ലോകത്തേക്ക്.
group also
അബേറ്റ്
operates
AS ഒപ്റ്റിക്കൽസ്
optometry, architecture,
stylish
business management,
affordable.
interior designing and fashion designing
കണ്ണുകൾക്ക്
colleges.
കൂടുതൽ
Abate
നിറമുള്ള
AS
കാഴ്ചകളേകാൻ
is opening a new
പുതുമയുള്ളൊരു പേര്
world of opportunities
ഷോൺ
with an ambition
ഒപ്റ്റിക്കൽസ്
to
ഇനി
open
മുതൽ
a network
അബേറ്റ്
of
AS
44
ഒപ്റ്റിക്കൽസ്
plus eye
ലേറ്റസ്റ്റ്
hospitals,
ഡിസൈനുകളോട്
optical
കൂടിയ
centers and
പ്രിസ്ക്രൈബ്ഡ്
educational
ഗ്ലാസുകളും
facilities
സൺഗ്ലാസുകളും
across India,
അഫോർഡബിൾ
Europe
പ്രൈസിൽ
and the
സ്വന്തമാക്കാം.
GCC.
ഇനി കണ്ണു തുറക്കാം
The group is
പുതുമയുടെ
ready to
പുതിയ
venture
ലോകത്തേക്ക്.
into real estate,
അബേറ്റ് AS
jewelry
ഒപ്റ്റിക്കൽസ്
and other
ഒറിജിനൽ
fast-growing sectors,
stylish
enabling
affordable.
sustaining investment and revenue prospects.
കണ്ണുകൾക്ക്
Under
കൂടുതൽ
the
നിറമുള്ള
leadership of
കാഴ്ചകളേകാൻ
Dr.
പുതുമയുള്ളൊരു പേര്
Advocate Shamsuddin
ഷോൺ
Adikurian,
ഒപ്റ്റിക്കൽസ് ഇനി
chairman
മുതൽ
of
അബേറ്റ്
Abate
AS
AS Group of
ഒപ്റ്റിക്കൽസ്
companies.
ലേറ്റസ്റ്റ്
The dynamic
ഡിസൈനുകളോട്
and
കൂടിയ
forward-thinking
പ്രിസ്ക്രൈബ്ഡ്
team
ഗ്ലാസുകളും
Abate AS
സൺഗ്ലാസുകളും
is moving
അഫോർഡബിൾ
into
പ്രൈസിൽ
new
സ്വന്തമാക്കാം.
horizons.
ഇനി കണ്ണു തുറക്കാം
Abate AS,
പുതുമയുടെ പുതിയ
group
ലോകത്തേക്ക്.
of companies.
അബേറ്റ് AS ഒപ്റ്റിക്കൽസ്
together.
ഒറിജിനൽ stylish affordable.
Abate AS,
കണ്ണുകൾക്ക് കൂടുതൽ
formerly known
നിറമുള്ള
as
കാഴ്ചകളേകാൻ
Al Salama,
പുതുമയുള്ളൊരു
is
പേര്
reaching new heights in the
ഷോൺ
realm of
ഒപ്റ്റിക്കൽസ്
eye care
ഇനി മുതൽ
and education
അബേറ്റ്
sectors
AS
in India
ഒപ്റ്റിക്കൽസ്
and is the
ലേറ്റസ്റ്റ്
first
ഡിസൈനുകളോട്
BSc
കൂടിയ
listed company
പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും
headquartered
സൺഗ്ലാസുകളും
in northern Kerala.
അഫോർഡബിൾ
Al
പ്രൈസിൽ
Salama was
സ്വന്തമാക്കാം.
established
ഇനി
in
കണ്ണു
Perundumanna
തുറക്കാം
in
പുതുമയുടെ
2004
പുതിയ
and has
ലോകത്തേക്ക്.
tremendously
അബേറ്റ്
grown
AS
both
ഒപ്റ്റിക്കൽസ്
within and
ഒറിജിനൽ
outside of Kerala.
stylish
Abate
affordable.
AS hospitals and opticals are renowned for
കണ്ണുകൾക്ക്
providing
കൂടുതൽ നിറമുള്ള
top-notch
കാഴ്ചകളേകാൻ
services that earn
പുതുമയുള്ളൊരു പേര്
trust and loyalty
ഷോൺ
from
ഒപ്റ്റിക്കൽസ്
many
ഇനി
walks
മുതൽ
of life.
അബേറ്റ്
The group
AS
also
ഒപ്റ്റിക്കൽസ്
operates
ലേറ്റസ്റ്റ്
optometry,
ഡിസൈനുകളോട് കൂടിയ
architecture,
പ്രിസ്ക്രൈബ്ഡ്
business
ഗ്ലാസുകളും
management,
സൺഗ്ലാസുകളും
interior designing
അഫോർഡബിൾ
and
പ്രൈസിൽ
fashion
സ്വന്തമാക്കാം.
designing colleges.
ഇനി കണ്ണു തുറക്കാം
Abate AS
പുതുമയുടെ
is opening
പുതിയ
a new
ലോകത്തേക്ക്.
world of opportunities
അബേറ്റ് AS
with an ambition
ഒപ്റ്റിക്കൽസ്
to open a
ഒറിജിനൽ
network of
stylish
44 plus eye
affordable.
hospitals, optical centers and educational
കണ്ണുകൾക്ക്
facilities
കൂടുതൽ നിറമുള്ള
across India,
കാഴ്ചകളേകാൻ
Europe
പുതുമയുള്ളൊരു പേര്
and the GCC.
ഷോൺ ഒപ്റ്റിക്കൽസ്
The group
ഇനി
is
മുതൽ
ready to
അബേറ്റ്
venture
AS
into real
ഒപ്റ്റിക്കൽസ്
estate,
ലേറ്റസ്റ്റ്
jewelry,
ഡിസൈനുകളോട്
and other
കൂടിയ
fast-growing
പ്രിസ്ക്രൈബ്ഡ്
sectors,
ഗ്ലാസുകളും
enabling
സൺഗ്ലാസുകളും
sustaining investment
അഫോർഡബിൾ
and
പ്രൈസിൽ
revenue
സ്വന്തമാക്കാം.
prospects.
ഇനി
Under
കണ്ണു
the
തുറക്കാം
leadership of
പുതുമയുടെ
Dr.
പുതിയ ലോകത്തേക്ക്.
Advocate
അബേറ്റ്
Shamsuddin
AS ഒപ്റ്റിക്കൽസ്
Adikurian, chairman
ഒറിജിനൽ
of Abate
stylish
AS Group of companies.
affordable.
The dynamic and forward-thinking team
കണ്ണുകൾക്ക്
Abate
കൂടുതൽ
AS
നിറമുള്ള
is
കാഴ്ചകളേകാൻ
moving into new
പുതുമയുള്ളൊരു പേര്
horizons.
ഷോൺ
Abate
ഒപ്റ്റിക്കൽസ്
AS,
ഇനി മുതൽ അബേറ്റ്
group of
AS
companies.
ഒപ്റ്റിക്കൽസ് ലേറ്റസ്റ്റ്
Grow
ഡിസൈനുകളോട്
together.
കൂടിയ പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺഗ്ലാസുകളും അഫോർഡബിൾ പ്രൈസിൽ
Abate
സ്വന്തമാക്കാം.
AS,
ഇനി കണ്ണു
formerly
തുറക്കാം
known as
പുതുമയുടെ
Al Salama,
പുതിയ
is
ലോകത്തേക്ക്.
reaching new
അബേറ്റ്
heights in the
AS
realm of
ഒപ്റ്റിക്കൽസ്
eye care and
ഒറിജിനൽ
education sectors in
stylish
India and is the
affordable.
first BSc listed company
കണ്ണുകൾക്ക്
headquartered
കൂടുതൽ
in
നിറമുള്ള
northern
കാഴ്ചകളേകാൻ
Kerala. Al
പുതുമയുള്ളൊരു
Salama
പേര്
was established in
ഷോൺ
Perimala
ഒപ്റ്റിക്കൽസ്
in
ഇനി മുതൽ
2004
അബേറ്റ്
and has
എയർസ്
tremendously
ഒപ്റ്റിക്കൽസ്
grown
ലേറ്റസ്റ്റ്
both
ഡിസൈനുകളോട്
within
കൂടിയ
and outside of
പ്രിസ്ക്രൈബ്ഡ്
Kerala.
ഗ്ലാസുകളും
Abate
സൺ
AS
ഗ്ലാസുകളും
hospitals and
അഫോർഡബിൾ
opticals
പ്രൈസിൽ
are
സ്വന്തമാക്കാം.
renowned for
ഇനി കണ്ണു
providing
തുറക്കാം
top-notch
പുതുമയുടെ
services
പുതിയ
that earn
ലോകത്തേക്ക്.
trust and
അബേറ്റ്
loyalty
എയർസ്
from
ഒപ്റ്റിക്കൽസ്
many walks of
ഒറിജിനൽ
life. The group
stylish
also operates
affordable.
optometry, architecture,
കണ്ണുകൾക്ക് കൂടുതൽ നിറമുള്ള കാഴ്ചകളേകാൻ പുതുമയുള്ളൊരു പേര് ഷോൺ ഒപ്റ്റിക്കൽസ്. ഇനി മുതൽ അബേറ്റ് AS ഒപ്റ്റിക്കൽസ്. ലേറ്റസ്റ്റ് ഡിസൈനുകളോട് കൂടിയ പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺ ഗ്ലാസുകളും അഫോർഡബിൾ പ്രൈസിൽ സ്വന്തമാക്കാം. ഇനി കണ്ണു തുറക്കാം പുതുമയുടെ പുതിയ ലോകത്തേക്ക്. അബേറ്റ് AS ഒപ്റ്റിക്കൽസ്. ഒറിജിനൽ, സ്റ്റൈലിഷ്, അഫോർഡബിൾ.
And other fast-growing sectors,
കണ്ണുകൾക്ക്
enabling
കൂടുതൽ നിറമുള്ള
sustained
കാഴ്ചകളേകാൻ
investment and
പുതുമയുള്ളൊരു
revenue
പേര്
prospects. Under
ഷോൺ
the leadership
ഒപ്റ്റിക്കൽസ്. ഇനി
of
മുതൽ
Dr.
അബേറ്റ് AS
Advocate
ഒപ്റ്റിക്കൽസ്.
Shamsuddin
ലേറ്റസ്റ്റ്
Adikurian,
ഡിസൈനുകളോട്
chairman
കൂടിയ
of Abate
പ്രിസ്ക്രൈബ്ഡ്
AS
ഗ്ലാസുകളും
Group of companies,
സൺ ഗ്ലാസുകളും
the dynamic
അഫോർഡബിൾ
and
പ്രൈസിൽ
forward-thinking
സ്വന്തമാക്കാം.
team,
ഇനി
Abate
കണ്ണു
AS
തുറക്കാം
is
പുതുമയുടെ
moving into
പുതിയ
new
ലോകത്തേക്ക്.
horizons.
അബേറ്റ് AS
Abate
ഒപ്റ്റിക്കൽസ്.
AS,
ഒറിജിനൽ,
group of
സ്റ്റൈലിഷ്,
companies.
അഫോർഡബിൾ.
Grow together.
കണ്ണുകൾക്ക് കൂടുതൽ നിറമുള്ള കാഴ്ചകളേകാൻ പുതുമയുള്ളൊരു
Abate
പേര്
AS,
ഷോൺ
formerly known
ഒപ്റ്റിക്കൽസ്.
as
ഇനി
Al
മുതൽ
Salama,
അബേറ്റ്
is
AS
reaching new
ഒപ്റ്റിക്കൽസ്.
heights in the realm of
ലേറ്റസ്റ്റ്
eye care
ഡിസൈനുകളോട്
and
കൂടിയ
education
പ്രിസ്ക്രൈബ്ഡ്
sectors in
ഗ്ലാസുകളും
India, and is
സൺ
the
ഗ്ലാസുകളും
first BSc
അഫോർഡബിൾ
listed
പ്രൈസിൽ
company
സ്വന്തമാക്കാം.
headquartered
ഇനി കണ്ണു
in
തുറക്കാം
Northern Kerala.
പുതുമയുടെ
Al
പുതിയ
Salama
ലോകത്തേക്ക്.
was established in
അബേറ്റ് AS
Perindalmanna
ഒപ്റ്റിക്കൽസ്.
in 2004
ഒറിജിനൽ,
and has
സ്റ്റൈലിഷ്,
tremendously grown
അഫോർഡബിൾ.
both within and outside of Kerala.
കണ്ണുകൾക്ക്
Abate
കൂടുതൽ
AS
നിറമുള്ള
hospitals
കാഴ്ചകളേകാൻ
and opticals
പുതുമയുള്ളൊരു
are
പേര്
renowned for providing
ഷോൺ
top-notch
ഒപ്റ്റിക്കൽസ്. ഇനി മുതൽ
services that earn
അബേറ്റ് AS
trust and
ഒപ്റ്റിക്കൽസ്.
loyalty
ലേറ്റസ്റ്റ്
from many
ഡിസൈനുകളോട്
walks of
കൂടിയ
life.
പ്രിസ്ക്രൈബ്ഡ്
The group
ഗ്ലാസുകളും
also operates
സൺ ഗ്ലാസുകളും
optometry,
അഫോർഡബിൾ പ്രൈസിൽ
architecture,
സ്വന്തമാക്കാം.
business
ഇനി
management,
കണ്ണു തുറക്കാം
interior designing
പുതുമയുടെ
and
പുതിയ
fashion
ലോകത്തേക്ക്.
designing colleges.
അബേറ്റ് AS
Abate
ഒപ്റ്റിക്കൽസ്.
AS is opening
ഒറിജിനൽ,
a new world of
സ്റ്റൈലിഷ്,
opportunities with
അഫോർഡബിൾ.
an ambition to open a network of
കണ്ണുകൾക്ക്
44 plus
കൂടുതൽ
eye
നിറമുള്ള
hospitals,
കാഴ്ചകളേകാൻ
optical centers,
പുതുമയുള്ളൊരു
and
പേര്
educational facilities
ഷോൺ
across
ഒപ്റ്റിക്കൽസ്. ഇനി
India,
മുതൽ
Europe,
അബേറ്റ്
and
AS
the GCC.
ഒപ്റ്റിക്കൽസ്. ലേറ്റസ്റ്റ്
The group is
ഡിസൈനുകളോട്
ready
കൂടിയ
to venture
പ്രിസ്ക്രൈബ്ഡ്
into real
ഗ്ലാസുകളും
estate,
സൺ ഗ്ലാസുകളും
jewelry, and other
അഫോർഡബിൾ പ്രൈസിൽ
fast-growing
സ്വന്തമാക്കാം.
sectors,
ഇനി കണ്ണു
enabling
തുറക്കാം
sustaining
പുതുമയുടെ
investment
പുതിയ
and revenue
ലോകത്തേക്ക്.
prospects.
അബേറ്റ്
Under
AS
the
ഒപ്റ്റിക്കൽസ്.
leadership of
ഒറിജിനൽ,
Dr. Advocate
സ്റ്റൈലിഷ്,
Shamsuddin
അഫോർഡബിൾ.
Adikurian, chairman of Abate AS
കണ്ണുകൾക്ക്
Group of
കൂടുതൽ
companies.
നിറമുള്ള
The
കാഴ്ചകളേകാൻ
dynamic and
പുതുമയുള്ളൊരു പേര്
forward-thinking team, Abate
ഷോൺ
AS,
ഒപ്റ്റിക്കൽസ്.
is
ഇനി
moving
മുതൽ
into new
അബേറ്റ് AS
horizons.
ഒപ്റ്റിക്കൽസ്.
Abate
ലേറ്റസ്റ്റ്
AS,
ഡിസൈനുകളോട് കൂടിയ
group
പ്രിസ്ക്രൈബ്ഡ്
of
ഗ്ലാസുകളും
companies.
സൺ ഗ്ലാസുകളും
Grow
അഫോർഡബിൾ
together.
പ്രൈസിൽ സ്വന്തമാക്കാം. ഇനി കണ്ണു തുറക്കാം പുതുമയുടെ പുതിയ
Abate
ലോകത്തേക്ക്.
AS,
അബേറ്റ് AS
formerly known
ഒപ്റ്റിക്കൽസ്.
as Al
ഒറിജിനൽ,
Salama, is reaching
stylish,
new heights in the
affordable.
realm of eye care and education sectors in
കണ്ണുകൾക്ക്
India, and is
കൂടുതൽ
the
നിറമുള്ള
first
കാഴ്ചകളേകാൻ
BSc-listed
പുതുമയുള്ളൊരു
company
പേര്
headquartered
ഷോൺ
in Northern
ഒപ്റ്റിക്കൽസ്.
Kerala.
ഇനി മുതൽ
Al Salama
അബേറ്റ്
was
AS
established in
ഒപ്റ്റിക്കൽസ്.
Perindalmanna
ലേറ്റസ്റ്റ്
in
ഡിസൈനുകളോട് കൂടിയ
2004 and has
പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും
tremendously
സൺ
grown
ഗ്ലാസുകളും
both within
അഫോർഡബിൾ
and
പ്രൈസിൽ
outside of
സ്വന്തമാക്കാം.
Kerala.
ഇനി
Abate
കണ്ണു
AS
തുറക്കാം
hospitals
പുതുമയുടെ
and opticals
പുതിയ
are
ലോകത്തേക്ക്.
renowned for
അബേറ്റ്
providing
AS
top-notch
ഒപ്റ്റിക്കൽസ്.
services
ഒറിജിനൽ,
that earned trust
stylish,
and loyalty
affordable.
from many walks of life. The group
കണ്ണുകൾക്ക്
also
കൂടുതൽ
operates
നിറമുള്ള
optometry,
കാഴ്ചകളേകാൻ
architecture,
പുതുമയുള്ളൊരു പേര് ബിസിനസ് മാനേജ്മെന്റ് ഷോൺ
interior
ഒപ്റ്റിക്കൽസ്. ഇനി
designing
മുതൽ
and fashion
അബേറ്റ്
designing
AS ഒപ്റ്റിക്കൽസ്.
Abate
ലേറ്റസ്റ്റ്
AS
ഡിസൈനുകളോട്
is
കൂടിയ
opening a new
പ്രിസ്ക്രൈബ്ഡ്
world of
ഗ്ലാസുകളും
opportunities
സൺ
with an
ഗ്ലാസുകളും
ambition to open
അഫോർഡബിൾ
a
പ്രൈസിൽ
network of
സ്വന്തമാക്കാം.
44
ഇനി
plus
കണ്ണു
eye
തുറക്കാം
hospitals,
പുതുമയുടെ
optical
പുതിയ
centers,
ലോകത്തേക്ക്.
and educational
അബേറ്റ്
facilities
AS ഒപ്റ്റിക്കൽസ്.
across India,
ഒറിജിനൽ,
Europe, and the
stylish,
GCC.
affordable.
The group is ready to venture into real
കണ്ണുകൾക്ക്
estate,
കൂടുതൽ നിറമുള്ള
jewelry, and
കാഴ്ചകളേകാൻ
other
പുതുമയുള്ളൊരു
fast-growing
പേര്
sectors, enabling
ഷോൺ
sustaining
ഒപ്റ്റിക്കൽസ്. ഇനി മുതൽ
investment and
അബേറ്റ്
revenue
AS
prospects.
ഒപ്റ്റിക്കൽസ്.
Under the
ലേറ്റസ്റ്റ്
leadership
ഡിസൈനുകളോട്
of
കൂടിയ
Dr.
പ്രിസ്ക്രൈബ്ഡ്
Advocate
ഗ്ലാസുകളും
Shamsuddin
സൺ ഗ്ലാസുകളും
Adikurian,
അഫോർഡബിൾ
chairman
പ്രൈസിൽ
of
സ്വന്തമാക്കാം.
Abate AS Group
ഇനി
of
കണ്ണു
companies.
തുറക്കാം
The dynamic
പുതുമയുടെ
and
പുതിയ ലോകത്തേക്ക്.
forward-thinking team,
അബേറ്റ്
Abate
AS
AS,
ഒപ്റ്റിക്കൽസ്.
is moving
ഒറിജിനൽ,
into new horizons.
stylish, affordable.
Abate AS, group of
കണ്ണുകൾക്ക്
companies.
കൂടുതൽ നിറമുള്ള
Grow
കാഴ്ചകളേകാൻ
together.
പുതുമയുള്ളൊരു പേര് ഷോൺ ഒപ്റ്റിക്കൽസ്. ഇനി മുതൽ അബേറ്റ്
Abate
AS
AS,
ഒപ്റ്റിക്കൽസ്.
formerly
ലേറ്റസ്റ്റ്
known as
ഡിസൈനുകളോട്
Al
കൂടിയ
Salama,
പ്രിസ്ക്രൈബ്ഡ്
reaching
ഗ്ലാസുകളും
new heights
സൺ
in the realm
ഗ്ലാസുകളും
of eye care
അഫോർഡബിൾ
and
പ്രൈസിൽ
education
സ്വന്തമാക്കാം.
sectors in India,
ഇനി
and
കണ്ണു
is the
തുറക്കാം
first BSc-listed company headquartered in Northern Kerala. Al Salama was established in Perindalmanna in 2004 and has tremendously grown both within and outside of Kerala. Abate AS hospitals and opticals are renowned for providing top-notch services that earned trust and loyalty from many walks of life. The group also operates optometry, architecture,
business management,
interior designing and fashion designing colleges. Abate AS AS is opening a new world.
Okay. The tear meniscus height is the volume of the tear that you get just above the lid margin. So you have to look at that in a case of dry eye, and if the size is less than 1 millimeter, probably this patient may be having dryness. One thing to be taken care of here is the meibomian gland opening. The meibomian gland opening. Make sure when you squeeze at the lid margins closer to the lashes, you are getting a clear secretions from the openings of those meibomian glands. Third, never forget about blepharitis. That is also having a role here. Once you have assured yourself, okay, I have looked at all these three, because if it's meibomian gland dysfunction, your treatment protocol varies. Blepharitis is another mode of treatment. So these three things come the first shot for you. Next is Shermer's. I know most of you would be aware of doing Shermer's 1, 2, 3. We are already confused which is for with parakin, which is without parakin. That doesn't matter. Anyway, Shermer's value is not the final to assess this patient is having dry eye. It is just one among the other things that you have to look at while you assess a patient with dry eye. Second, this is tear breakup time. Okay. Next is the tear breakup time. Tear breakup time, just make sure. Okay, where are the disturbance? Okay, next is the tear breakup time. Tear breakup time, as you know, it has to be if the tear film breaks up. If the tear film breaks up within 10 seconds, you know that the tear breakup time is low. Now, how do I usually give? What do I give for a patient with dry eye? CMC, HPMC is the first in line. I no longer give the plain. I keep it for allergic and viral conjunctivitis patients nowadays, because here in viral conjunctivitis and allergic conjunctivitis, there is no point in giving the higher end CMC with erythritol, carnitine and glycerol, because you don't want those toxins that is being secreted in that disease to stick on back in the eye. You want all the toxins that is being produced to be washed off. So there, a plain CMC 2 hourly will do the job. Mostly I give the CMC with erythritol, L-carnitine and glycerol combinations, and we have a lot of brands available, Optiv and the Glytears. There are a lot of medicines with the erythritol, L-carnitine, glycerin available. When do I give a polyethylene glycol or propylene glycol is when the T-bud is relatively on the lower side. This tells me the evaporative part of the dry eye is on a higher side. So that is when I think about propylene glycol and polyethylene glycol. We have a lot of brands in the market, Cysteine Ultra, Moistain, Normotears. You can choose any of it when the T-bud is less than 10 seconds. Now let's say the screen time is on the higher side. Kids using tabs, laptops for a longer time. It's a software engineer. We may need a gel form, maybe Gentile, Ducera gel or any of those gel forms, IMIS gel, to help you to retain those tears for a longer time. I usually give it once in the morning and one at 8 o'clock in the evening. That helps the patients much better. Now the question is, when do I give steroids? Well, that is when you suspect there is an inflammatory element here. Now what do I mean by that? Usually why fluoromethanol and loteprednol is they are the surface acting milder steroids. IOP elevation chances are very less or nil, I would say, given in tapered dosage that can be tapered in 5 days. 3 times a day for 5 days, 2 times a day for 5 days and once a day for 5 days. Now this is what I mean by an inflammation. Like when you, maybe even when you were straight looking at it, you know this is already a congested eye. Dryness is one element, but it's already in the inflamed situation. And when you stain it, you can see there are a lot of staining SPKs on the surface of the cornea. So coming to the dry eye in detail, we usually have, now let's say if it's on the inflammatory side, if it's a plain dry eye, nothing on the surface, it's not usually stained up much. But let's say if we are on the inflammatory side, we do the fluorescent stain, tear breakup time, rose Bengal lissamine green, light Weber epitheliopathy assessment and Shermer's 2. Now what is lid viper epitheliopathy is after giving the lissamine green, if you see that this margin of the lid, after you fold it, the palpebral area, if it is taking up the lissamine green, we are looking at a case of severe dry eye, more on the immune side. Now this After staining the cornea with fluorescent, if you feel that the number of dots, we divide the cornea into 3 segments, one central and inferior. Depending upon the number of dots, don't go with that number, don't take it as a take-home message. It just means minimal dots, if it is 1, if it is more than a few dots, then it is 2. If it's a lot of dots taking up the stain, we are talking about 3 grades. So 1, 2, 3 is given according to the stage of SPKs on the cornea. Next is, this is 3 by 3. This is taking up the complete, lot of staining being taken up on the corneal surface. Rose Bengal goes the other way. We take it from the conjunctiva, the central cornea and the nasal part of the conjunctiva. So this is how you can grade the staining of Lissamine green or Rose Bengal. Now this is a case wherein it looks an absolutely normal eye. There is no inflammation at all, but Lissamine green showed me it is taking up a stain. Fluorescent staining has showed me. So yes, if the patient has come back to you after maybe once you gave the dry eye drops, patient has come back to you after 2 weeks saying, doctor, I'm not feeling much better, I think there is something more. So at that time you have to think, I have to do the Lissamine green or Rose Bengal and the fluorescent stain. If you are taking up those surfaces taking up the stain, that tells you, you will have to start this patient on anti-inflammatory drugs. And this was the Shermers of the patient. Now, so this is more about treating inflammation in dry eye. So the key mechanisms of dry eye disease is mainly inflammation is one major part among the cycle. And it is associated with a lot of things in the environment. What would that result in is tissue destruction and affecting the nerve sensations, which can again decrease the reflex secretion that is supposed to come from the lacrimal gland and decrease the corneal sensitivity. Again, there is decrease of tear production. So here, these are the things: adhesion molecule, T cell inhibition, cytokines and matrix metalloproteinases are the ones that is taking the things back into the cycle. That is called as the vicious cycle. So we need something to block that. This is about the immune modulators that help in the dry eye disease. It just aggravates. The dry eye disease eye just doesn't know when to control the immune modulators, whereas the other eye does. So these are, as I said, the order of diagnostic tests vary. As I have already given the table, a lot of things to be assessed before you look at the dry eye, and the values, it's all discussed. You will be knowing all that. And there is matrix metalloproteinases. You have a check easily. It can be checked about the role or the amount of matrix metalloproteinases. Lot of other additional procedures are available. So coming to the how do we manage a case of dry eye inflammation in dry eye? Cyclosporin A, corticosteroids, tetracyclines have doxycyclines is a very good drug to manage the lid part. Omega-3 fatty acids. The patients on autologous serum. Cytokine inhibitors, I usually don't use those two. Artificial tears, secretagogues is difficult, it's not much available in the market nowadays. Punctal occlusion, costlier thing, but can be done with catgut plugs. So the role of cyclosporin here is to cut this off so that the visual cycle doesn't happen much. Cyclosporin, this is for the PGs. So it is given twice a day, 1 drop per eye, and usually begins after 4 weeks of starting it. So until the 4th week, you will have to give the patient some surface acting steroid along with it. Adjunctive therapies can be given, and few case studies. A lady, 50-year-old, symptoms of dry eye, 5 years with dry mouth and nose. So this is the thing you have to keep in mind, and this is the surface of the cornea, very bad. This are positive. ANA is positive, SSA is positive, this is negative. So yes, we are looking at a case of primary Sjogren's syndrome. And here hydroxychloroquine comes in your prescription. Omega-3 fatty acid anti-inflammatory, Restasis anti-inflammatory for the initial 4 weeks, lotipred will help. and definitely a non-preserved, because the preservatives in the tear substitutes can further worsen the inflammation. Case number 2, here the patient is a rheumatoid arthritis patient, and the surface is bad, conjunctival staining is bad. So here we are looking at a case of secondary Sjogren's syndrome. Again, rheumatoid arthritis, methotrexate has to be given. All that is under the guidance of the rheumatologist. Omega-3 fatty acid is there, restasis is in, and here sodium hyaluronate has a role, and the other drugs are seen. The last case is again with rheumatoid arthritis, but the tear breakup time is less, fluorescent staining, Schirmer's is low. We are looking at a case of chronic aqueous deficiency. So here punctal plex for a longer time will help. Then again restasis, omega-3 fatty acids are in. This is something we can always try. With that, I conclude my talk on dry eye. Now I call upon Dr. SKR to have a discussion on corneal infections. Put a chair on the deck. Anything.
And has tremendously grown both within and outside of Kerala. Await AS Hospitals and Opticals are renowned for providing top-notch
Sound, cherry sound. In out vannilla. Laptop in out. Laptop in out vannilla. Okay, so this is more like a discussion. I know many of you would have treated a lot of corneal ulcers. Where are extra volume? Sound varununde.
Doctor Advocate
Extra sound varununde idile.
Chairman of Abate AS Group of Companies, the dynamic and forward-thinking team. Abate AS.
No, there is something playing in the background.
Horizons. Abate AS.
Okay, so many of you would have experience treating corneal infections, like to say bacterial, fungal, viral, acanthamoeba. But just now after lunch, one of my residents, he had discussed a case of cornea infections with me. So this is a discussion between sir and me about our experiences. We'll take it one by one, more in a discussion mode. Mic to sir. To start with, bacterial infections. So according to you, when do we scrape, or when do you mandatorily say a bacterial ulcer has to be scraped?
I think to some extent it depends upon your experience in handling corneal infections. If you've been doing this for a while, and if you're reasonably comfortable with the morphology of corneal bacterial infections and fungal infections, if the patient presents to you early in the disease, within the first 24 to 48 hours, when you can make reliable judgment calls or diagnostic calls based on the morphology, it is reasonable to treat without microbiology. If you're not very comfortable with this, and or the patient presents about 7 or 8 days to you later after the infection started, and he has already been put on medications, then the morphology on the cornea will change. It's sometimes difficult to judge based on the appearance. Then it might be better to scrape. So it's a yes and no kind of answer. I wouldn't suggest that you scrape every dot infiltrate that you see. But on the other hand, when it is required, if you don't, then you could be in trouble as well.
And when do you say this is not a fungal, this is more in terms of a bacterial infection? What are the clues?
Most bacterial infections tend to have a rapid spread, unlike fungi which start and spread very slowly, most of them. There are no rules. These are textbooks, the infections don't read the textbooks. But by and large, bacterial infections tend to spread faster. So if he comes to you 48 to 72 hours later, and you see an infection that's already spreading, and by spreading I mean that the edges will be convex outwards because the organism is growing out like that, so it will be spreading out. The patient will have significant symptoms of pain, redness, and if you look into the AC, you'll see a lot of AC flare and cells even in 2 to 3 days. In a fungus, in 2 to 3 days, this usually will not happen. It will be a very small, slow, low-grade infection that's starting. The typical hyphate pattern, the satellite lesion, the dry raised lesion, all this happens at a week to 10 days. We're talking about 3 days. So a smaller lesion which has not spread rapidly, patient comes saying, yeah, I have some irritation, 3 days. You look at it, eye is not very red, you got a small white lesion in the cornea, AC is not showing much reaction. That is slightly more in favor of a fungus.
So now let's say we have diagnosed, yes, this could be bacterial. We have sent the patient up for scraping, and the diagnosis came as, let's say, gram-positive cocci. What would be your line of management?
Basically, you're talking about a gram stain has shown you that, isn't
gram
it?
stain, sorry.
It depends then on how virulent you think the organism is. If you think the organism is not very virulent, it's got an infection but it's not very aggressive, then a 4th generation fluoroquinolone is good monotherapy because these things work against most gram-positive agents. The only bacterial agent where you have to be careful with a fluoroquinolone is if you have a pneumococcus. A pneumococcus does not respond to a 4th generation fluoroquinolone. The antibiotic that particular one is sensitive to is cefazolin. So you have to give fortified cefazolin 50 milligrams per mil. There you would go wrong if you gave a fluoroquinolone. The pneumococci are present in 2 specific situations. Obviously, we've been taught about the dacryocystitis-associated keratitis. To be honest, I haven't seen one in a very long time. What I see most often is suture-related infections. On the cornea, a suture-related infection in my mind is pneumococcus until proven otherwise. So if I see a suture-related infection, I will automatically gravitate to cefazolin. If you don't see such a virulent picture and you're willing to use a fluoroquinolone, I use today only gatifloxacin. I do not use moxifloxacin for corneal infections. The incidence of resistance to moxi, at least in Chennai, is extremely high. I think this comes from the constant use of this agent in cataract surgery over the last decade. It's been used like water inside the eye, on top of the eye, everywhere. So I think there's extensive resistance. The second thing is the GATI scores, because it has a 0.3% formulation and it has a 0.5% formulation. The Zymaxid is a double strength version. It contains BAK, benzalkonium chloride. One of the advantages in some ways of moxi is it's unpreserved, it's self-preserved. So therefore you can inject it into the eye. But if you have a BAK, to some extent it aids its penetration into the cornea, and therefore that may be one reason why the GATI is slightly better. So for corneal infections, if I choose a fluoroquinolone as monotherapy, it's always gatifloxacin. I don't use moxifloxacin.
And let's say you have started the patient on a gatifloxacin and he is not responding. What would be your first choice for a fortified drug, as you said?
If I'm convinced still at this point that it's a gram-positive agent and it's not responding to a fluoroquinolone and I've ruled out a pneumococcus, then I move on to a fortified cephalosporin. If I have a staphylococcus as my primary pathogen, then I would consider vancomycin. So when I'm upgrading my antibacterial therapy from a fluoroquinolone, the 2 fortified agents that I have as my choices are fortified cephalosporins and vancomycin.
Okay, so the patient has started healing now, but you feel there is some amount of inflammation still persisting in that patient. Would you be thinking on adding something more to that, maybe to fight those inflammation?
So when we talk about patients slowing down his response, you'll have to look at it from 2 aspects. Sometimes they come to you with a very angry eye, a lot of symptoms of burning and pain. So 2 ways to look at it. One is that the medicines that you're using are now starting to cause a toxicity, or 2, that the infection is now going out of control. For toxicity, the few signs will be that you will see extensive redness on the eye, which was not there until 2-3 days back when he was getting better. Second, when you stain, you will see a lot of corneal staining, but not as much conjunctival staining, because the toxicity affects the more gentle corneal epithelium first. The conjunctival epithelium is more robust. The third point would be, if you ask a patient, do any of the drops that you're using sting? He will often say yes, and he'll single out 1 out of the 4 drops that you're giving him. Every time he puts it in, it will be stinging. So that is a sign of toxicity. And if you're lucky, you may be able to look at the differential redness between the lower half and the upper half, because most people put their drops into the lower cul-de-sac. So that area will get preferentially more inflamed. And finally, when you look at the cornea, the defect will be getting better, the infiltrate will not be increasing, and the AC reaction will be quietening. So if these 3 are getting better, but the surface is getting worse, you're dealing with a toxicity. But if your defect is getting larger, if your infiltrate is slowly increasing, and your AC reaction is very high, then you have 2 possibilities, actually 3. One is that your organism is resistant to the antibiotic. More likely it's a multi-drug, multi-agent infection. So one organism is getting better with your drop, but the other one is now starting to expand. The third possibility is we've missed a fungus. We're treating it as bacterial. It's the fungus which is increasing. So depending on which of the signs are predominant, I will decide. If I think it's the toxicity, then I will actually step down on the medications, add some lubrication. If I'm convinced it's the infection, then I will biopsy. Because I've already done a scraping, I had something, I treated based on that, he's not getting better, then don't waste time, do a biopsy. Get the deeper infiltrate, send it to histopath and microbiology, look at what comes back, and then alter your treatment plan.
When would you think about starting steroids in a case of bacterial ulcer?
Steroids is not for the inflammation part. It's basically when I've had the patient on a bactericidal antibiotic for 4 to 7 days, I'm convinced that the infection is getting better. But if it is partly in the pupillary plane, then I may consider a loteprednol twice a day, beginning just to see if he's getting further better, as an effort to limit the scar. If the same infiltrate was outside the pupillary area, I won't bother with a steroid, because every time you use a steroid, you do have a small risk of it getting worse. So why take that chance if it's in the periphery? Let him have a scar, it's outside the pupil, it doesn't matter.
Now let's say he develops, everything's gone well, he's healed up well, and he's finally ended up with a scar at the center of the cornea. Would you like to give some medications for the patient to see if whether the scar is going, or would you later
normally once he ends up with the epithelialization complete and a little opacity, if it's in the pupillary area, like I said, I would have started him on a low dose of a steroid, maybe 4 times a day, and then taper it down to once over the course of the next 4 to 6 weeks. Do a lot of lubrication, because a lot of the corneal healing is epithelial remodeling. All the irregularities in the stroma, the epithelium will smooth out for you. So give him a lot of lubrication and give him some ointment at night, because when they wake up in the morning, you want a more gentle awakening. So I will do this for about 2 to 3 months, then see, and then by then the scar modulation would be reasonable, and then you can decide if it's time for you to do something further to help the patient.
So the time we wait is around at least 3 months.
2 to 3 months, yes.
8 months.
But I may not use the steroid for 2 to 3 months.
Yeah.
The steroid's 4 to 6 weeks tops.
Yeah.
But you wait for 3 months, let it remodulate, do a refraction, and then based on the patient's demands and your assessment, you can judge.
Yeah. We'll go to the next, that is the fungal. Now, you have already mentioned about the key features of fungal. Can you just elaborate on that once again, about the clinical findings we see in a fungal ulcer?
The fungal ulcer basically is a very slow growing infection in the beginning, although in the city we do see bad ones as well, but generally it takes off slowly, and once it starts, then it spreads very rapidly. If somebody has used a steroid in a corneal infiltrate and then sent him to you, your awareness must be much higher, because in that situation the fungus becomes very aggressive. The fungus has a normal growth pattern of growing horizontally in the cornea along the lamellae. If you use steroids, it turns vertical, it starts to go down, and the fungus is one thing that can go past an intact DM. So if you see a hypopion in a bacterial infection, 99.9%, it is basically sterile leukocyte accumulation. In a fungus, quite often, particularly if steroids have been used, the hypopion can contain the fungal organisms. 2 signs to tell you whether or not it could be infective hypopion. One is it will not be a fluid hypopion. The bacterial hypopions accumulate very rapidly, so they'll be very fluid. This will be thick, yellow, curdy precipitate. The second thing, in a fungal infection, if you are seeing roseolae on the iris, they are not actually rubeosis, but you'll see the iris vessels dilating at different points if you look very carefully. If you see that, it's often a sign that the fungus is in the AC, because the fungus produces a lot of angiogenic factors, and that causes these vessels to dilate. As long as it's only in the cornea, you will seldom see these changes inside the eye in the iris. So a slow-growing lesion with the hyphate pattern, the typical dry appearance and all, you don't go by, that's for the exam, you just mention it there and forget about it. In the clinic, you can see wet ulcers with fungi as well. But with fungi, the most important thing that you have to remember is the pythium. Today, the pythium is quite common. We know how to pick it up. So if you see it looks like a fungus, they say if it looks like a duck, walks like a duck, no, it's a duck. In the fungus, it's not so. It may look like a fungus, you have the hyphate pattern and all that, but it relentlessly spreads despite giving antifungals, then you must think of pythium. And in pythium, at least now, based on the LV Prasad group's work, we know that linezolid and azithromycin do work. So you can switch therapy and try and get them better. If it's not and your biopsy shows pythium, operate early, because the pythium is a very resistant drug and bug, and the only way to get rid of it is surgery. So don't forget pythium when you're talking about fungi.
And with regard to your mode of treatment for a case of fungal?
If it's very early, if it's only in the anterior 20% of the stroma, natamycin should be your go-to drug. It works very well. Most of them will respond if you catch them early. Once it's gone deeper than 30-40% in the stroma, natamycin is not effective because it has very poor penetration. The Arvind study has shown that voriconazole doesn't work, at least down south, where we see a lot of filamentous fungi. So we see fusarium a lot. So in fusarium, voriconazole does not work. Maybe the aspergillus, it may, we don't know, we don't have data, but aspergillus is seen in the north. Down south, it's almost always fusarium. So don't waste your time giving voriconazole. Don't waste your time giving fluconazole. Fluconazole is a pure candidal agent. It has no effect on a filamentous fungus, and 98+% of corneal infections, primary infections, are filamentous fungi. You only see candida in an immunocompromised or a post-Stevens-Johnson eye, that will look very different. So natamycin, if it is superficial, if it is deeper, the agent of choice for me is amphotericin B, 0.15%, but you have to reconstitute it. It doesn't come as a drop. You get the powder is 50 milligrams in the vial. You can divide it into 6 equal parts, add 5 ml of distilled water to each part. That will give you the 0.15% strength. And you have to prescribe it in a light protected bottle. Either you have a brown bottle or you put tape around the bottle and give it to them. It's very light sensitive. And tell the patient to keep it away from sunlight when he uses it. And this has to be reconstituted after 3 days. It does not last. It's a very unstable solution. So if I mix it on Monday, Tuesday, Wednesday, Thursday morning, he has to have the fresh next bottle. And don't mix all 6 bottles and give it to him and say, use this Monday, use that Thursday. It doesn't work. All of them will degenerate by Wednesday. So he has to come back to the clinic and then take the next one.
The last we will have a discussion is viral infections. So when do I suspect that this is not bacterial, not fungal? This could be a case of viral keratitis.
See, when I started doing this corneal stuff 30 years ago, if somebody had appeared in front of me and said, like the IOL choice, you have a choice of bacterial infection, choose one, I would have almost always chosen a viral infection. Because in those days, we had absolutely no antifungals. Even natamycin had to be imported from the US. We had things like itraconazole. We were powdering miconazole and ketoconazole into tablets and putting them in solutions and giving. So it was nystatin was there, very unfavorable fungi. We were petrified of fungus. Bacteria was so-so. But viruses used to heal like magic. They will come with a dendrite, I will give them acyclovir, and then within the next 3 days, it's all gone. So I would have put up my hand and said, give me a viral infection anytime. But today, I'm very scared of the virus. Because this chap called CMV has come into the picture, and he's creating horrible problems for the cornea. So he gets into the endothelium, it's very hard to get rid of them. So today, if you have a viral dendritic lesion, it's still okay. You can treat them. You can use ganciclovir, you can use acyclovir. Usually it will go away. But the stromal viral keratitis today is getting harder to treat, and the endothelial virus is a problem because it's very hard to recognize. Because of our lack of awareness, most of the time they come with some endothelial edema, corneal edema, endothelial changes, AC reaction. Then you generally treat them as disciform, this thing, that thing. And then it's CMV, they never get better. Cornea goes for a toss, you do surgery, it comes back in the graft, becomes a very bad situation. And the only way to diagnose it is to do an aqueous tap and do a PCR analysis. It's very hard to diagnose the CMV in the back of the cornea otherwise. But stromal keratitis is also not uncommon. So if you have what you think is a long-standing bacterial keratitis referred to you who's not getting better, do keep your virus in mind, particularly if your biopsy comes back negative. The histopath and the micropeople can't see the bacteria and the fungus, then it's either microsporidia or virus. So these are the two possibilities you have to keep in mind.
How would be the armamentarium in dendrites? Let's say the surface dendrite, there is a perfect pattern. What would be the drugs you would give for a dendrite? What would be the drugs for stromal viral keratitis?
For epithelial keratitis, all you need is a surface agent. The HEDS study showed that there's no need for an oral antiviral in dendrite. You can treat it quite well with a topical antiviral, which can either be acyclovir or ganciclovir. Use it 5 times a day. Usually within 5 to 7 days, it gets better. If it gets into the stroma, if it's causing some kind of a necrotizing reaction, then you need oral antivirals. You can either use valacyclovir 1000 milligrams twice or thrice a day, or you can use acyclovir 400 milligrams 5 times a day. You can take your choice. Both work equally well. These people will also need topical antivirals. They may need a little antibiotic protection because the stroma is so unhealthy that secondary infections can come in. And after 4 or 5 days, once you have this in place, if you see a lot of inflammation, you must add some steroids as well. But after you've started your antivirals.
So steroids may have to be given in a case of stromal
Necrotizing, yes, because a lot of the damage there is from the body's defense system getting into the cornea. So the virus is doing 50%, your body is doing 50%. So you need this steroid to rein your body's immune system in.
Okay, sir, then we'll stop the session. Thanks a lot, sir. Thank you for having me.
My pleasure.
Last time? 3:40. At 4 o'clock, we have a premiere of the movie Nino. Where is the director of the movie? Yeah, director, you're called on stage. You're called on stage. This is Srihari. He is our optometry student. He is also having a big talent into movies. He is taking care of our marketing area. I think he wants to talk a little his movie Nino. പറഞ്ഞോ അല്ലെങ്കിൽ എല്ലാവരും പോകും.
Actually, all the guys are here. I was working in a movie recently, so Shadi sir have called me and told me to take a movie with our beloved Ninu. She is here, and our artist and all guys are coming to watch the preview. Here we are presenting the first premiere. So I don't know what the things will happen. Let's.
What do you mean? You don't know for what?
Just watch the movie or watch the video, and after all, we can have a session with our team. All the guys are here, our DOP, scriptwriter, artist, and associate directors, and all the team have on the way. And
it's a request from Srihari's side. Please don't go.
Yes, please don't go, because
stay back.
These guys are coming just to see their preview, and you guys should be here, and you have to see what the things that we have done here.
How was your work?
How was the backstage? How easy was it to shoot the movie?
It is a long story. We can discuss further things after the movie,
Fine.
I think.
Okay.
First of
So-
all, you just. You
So
guys-
don't go away. Stay
Okay.
back. Okay. Thank you, Shreyas. Okay. So actually this session was purely intended for the PGs. I was expecting at least 40 PGs from Kerala. In fact, I had personally in touch with at least 160 PGs who are currently doing their post-graduation in Kerala as well as in Coimbatore. But I am seeing very few here. Otherwise, actually this was a very planned interactive session if I had at least 15 PGs in hand. So I changed to plan B. I had a discussion with few of the PGs. I got a few queries from their side. So I will be discussing that one by one. Actually, this was intended to be an hour session, but we have only 20 minutes. So I'll cut it short to 15 minutes. I don't want the Nino's movie to be delayed. So this session will just go on for 15 minutes. The rest of the session, I promise you, it will be available online. Okay, so case one is we have three patients here. One is Amar, 60-year-old, K142, K242, IOL power is 18 diopters, his post-op vision is 6/6. Amar, then Akbar, 60-year cataract, 42, 44, IOL power 18, post-op vision is 6/12. Biometry of Anthony, same, but the post-op vision is 6/12. Would any of the PGs like to take up and tell me why Amar got 6/6, Akbar 6/12, Anthony 6/12 parts? How many PGs here? Oh, surprisingly done. Any of you? Sorry, Salman? Yeah, exactly. Thank you. So see, Akbar has a corneal astigmatism. Probably he was not counseled for a toric lens. And he had gone in for a monovision, normal lens. And that was the reason probably why he did not get a 6/6 parts. And Amar, he didn't have a corneal astigmatism. Single lens was fine for him. For Anthony, probably if everything's gone well from the basic aspect, if his vision is poor, that would tell you, if everything has gone in well, that is just telling you he may be having something more, or it may be a retinal issue that you're looking at. Probably you would have missed it earlier. Next, among the options you have for IOL, again, Amar is a Mr. Irritation, Akbar is a software engineer, Anthony is a voracious reader and doesn't have any night driving. Post-op vision is 6/6 N18, 6/6 N8, 6/6 N6. Why? Sonal? Mike? Mike? Yeah. You can be. Agreed? Akbar? His vision is N8 for near. Any guess for which lens he must have tried? Probably an EDOF, that is probably VVT. This very less near vision remains. And about Anthony? He has gone in for a multifocal IOL, probably. And he is a good reader, he doesn't drive much. So multifocal lenses wouldn't give him a complaint. But he, being an irritating patient, he was not counseled for any of the higher end lenses. It's more safer to go with single vision. They are much happier there. Okay, so a small video about wound architecture. I have to thank Dr. Deepak Megur. I have borrowed his. I couldn't time to make my own. Sorry. Okay, a perfect incision has to be secure, self-sealing and astigmatically neutral, and it should heal appropriately sized. A well-designed entry for the phaco is 2 by 2 millimeters. And this is the most important thing. You have to go parallel to the iris, tilt a bit, and then go again parallel. It's not a one-way through. You just go first parallel, then tilt a bit, go along with the corneal configuration, then go straight parallel to the cornea. So the size is usually, it's usually a square of 2 by 2.2 by 2. Nearly 2 by 2 millimeters. And if you are going for a 2.8, that's also fine. So again, this is 2 by 2.2, that is the for a normal MICS. You may have to extend it a little bit for with a 2.8 incision this way, that's also fine. And as I said, the entry is little parallel to the iris. This is where the iris is. So it has to come vertically, go with the configuration of the cornea, then parallel to the iris, and then enter into the anterior chamber. It looks as if the surgeon is going straight, but it's not actually so. Now let's say we have a small pupil. That was the next question given. How do I manage? I try injecting adrenaline, then I try the Y hooks. I try to push away the iris to the sides. I missed there. I'm coming back with the Y hook, going off again. Now I am still not confident because I have a mature cataract behind and I don't know what to expect there. As such, this is a tough case. Now I need a bigger, I would be more confident if I have a bigger, more dilated pupil. So the option here would be to come in with a B-hex. I am very happy that this came in during this time because it has been a lifesaver for many of my cases. This is an Indian product. I am proud of that. Now we are using all the 3 ports to place the B-hex in well. Okay, that is an adequately confidently dilated. I will use the spatula to adjust it, to centralize it a little bit comfortably. Okay, now is the rhexis. Rhexis, we will try to go a little bit under the iris, but it's a mature cataract. We don't know when it will extend. We have a little in an apprehension as we proceed with the rhexis. But still I am trying, I need a bigger rhexis because I know I will be handling a bigger or a harder nucleus. As and when I feel it's running away from me, I inject visco, form the AC back again, and then move on and go on with the rhexis. Again, I feel I have given way, it's going a little to the periphery. I am stopping, injecting visco again, forming the AC, displacing the capsule way down and proceeding on with the rhexis. Srihari, meantime, make sure the movie, everything is set up well here. Okay, the rhexis is complete. Now I am going in with the phaco. This is 4 times faster from the normal. So usually I chop the nucleus, but here it's a mature cataract. I wouldn't chop. I start with sculpting. I make sure I have a good sculpt, trenched well. For a hard nucleus, it's advisable to go with sculpting rather than direct chop because we don't know how the zonules would be. We use the other instrument, the hook, to stabilize the nucleus as and when you sculpt. Now I am holding the segments. It's in a chop mode. I'm holding the segments with the phaco probe and separating the fragments. This is in chop mode, but the vacuum is high and it is separating the segments into 4 pieces. Make sure it is completely separated. Usually stays back at the central part. Make sure it's separated by the hook. Now I'm trying to eat it up. This is the next segment. Here power has to be on a higher side, so the vacuum. Whereas when you chop, the power is on a lower side initially to divide it. But to eat it up, you may have to increase the power also along with the vacuum. Once that's out, now we make sure the cortex is eaten up. We may have to go a bit blindly in after the cortex. The lens is being placed. Visco has not been used under irrigation, because as such we may anticipate IOP spikes. So minimal use of visco under irrigation. Try to dial in the lens, and we are not worried about the visco the very next day, just like Dr. Khalil had. And don't forget that you have placed a BX there that has to be removed. Now one question came in was, Rexus, is it usually done clockwise or anti-clockwise? It depends on whatever you are more oriented with. I usually go anti-clockwise. And let's say if it's run away, then I use the micro scissors or micro forceps that is presently available to save the day. Nucleus management, again, I think we will need a bigger session for this. I'll just run fast. This is something I want all of you to get an orientation, especially the OT staffs. This is a 3-piece lens. I would say the difficult lens to handle would be the 3-piece lens. But if the loading is done well, that is, you place in the leading haptic, make sure the trailing haptic is placed behind that stopper. This is B cartridge. B cartridge has a stopper there. It's called a nudge or something. It's a big cartridge, so we may have to extend the incision later on. And you just slide in the injector and it goes in easily. That's the B cartridge. And it goes in easily into the eye. Whereas if you talk about the C cartridge, this is the C cartridge. It doesn't have a peg, so just take the 3-piece lens, check visco. Usually it's very common, it usually happens after you do a very tough case. You are very happy that you have removed the nucleus out, but when it's usually the sisters who load the lenses for us. And if it's a 3-piece lens, usually we are a little anticipating how would the sister have loaded the 3-piece lens. 3-piece has a way of loading. This is how it should be done. Stretch the leading haptic a bit, push it in. Then the trailing haptic there is no stopper there. Then load it in. Now what do we do with the trailing haptic is just slide it, just after pushing it, slide that trailing haptic a little out and then push it in. This is usually what we use is the C cartridge. It's a smaller cartridge, works with the 2.2 incisions. And there is Usually the IOL has to be placed inverted S. What happens if it goes in a S mode? It depends. If you want to take it back, you can take it back. If you have I ever left it behind? Yes, I have, but it's not for the books. And side port, yes, it has to be hydrated well. That's a very important thing, and it should not become very white after you hydrate the side port and the main port. Just make sure it's adequately hydrated to get a good closure. Suture, I don't put sutures for my phaco main incisions, except if the entry, you call it as, there is a pattern to it, I'm not, I forgot the name. If you are getting that kind of an entry, a little with a apex towards the front, then chevron shape. If that's how you have entered, then there is a mandatory that you have to suture the tunnel. PCR is beyond the scope. Vision, we'll just go faster. Now, few about the LASIK doubts they had it. They wanted to see the procedure, how it's being done. You dry the surface. We place the keratome. Then the suction. The suction goes in, and once the suction is complete, we get the information that the vacuum is complete. The saline comes in and the keratome moves front and comes back. Now it's removed. Now, as you already know, there is a flap that is being formed. We just mop it dry. What's the time? 4. 5 more minutes. Srihari, your session is ready? Yeah. So we have a flap formed. I'm using spatula kind of a thing to lift up the flap. Shibil, move it. Okay, the flap is lifted. Now we are waiting for the laser. It's come in. The laser is happening. The laser is on now. That's it. It's removed, and I'm washing the surface just to wash away all the debris. Placing the flap back again. And the surface is dried. That's one eye. For both eye, usually the time taken is 15 minutes. Residual stromal thickness is the amount of stroma that remains after you ablate, and it has to be more than 300 microns. Optic zone is how much diameter of the area is being lasered by the laser machine. Usually it's 6. And we have a MEL 90 calculator here that is developed by, it's an in-house app. We have designed it for MEL 90, so it makes things easier. We enter the spherical power, we enter the cylinder, we enter the optic zone that we are planning, the CCT of the patient, the flap thickness. This is kept in hand by the person who was doing the evaluation for a LASIK patient, who were usually not good in maths. So we designed an app so that it's all done by the app itself. The sphere is entered, this is for the other eye. You can plan for PRK or LASIK. Cylinder -2, optic zone 6. CCT of the patient is 520. Flap thickness we are planning is usually 130, 42, 44. Just calibrate and it's given whether the patient is fit for LASIK according to the values. Otherwise, they had to enter it, take up it in a page, write it, calculate, bring a calculator and do all that. Now it's done in a second. So with the entry of Pentacam, the evaluation has multiplied or it's become very fast now. Now the difference between PRK, LASIK, femto and SMILE is PRK, we debride the surface epithelium, laser. LASIK, you have already seen, flap lifted, placed back. Femto, instead of using a microkeratome in LASIK, femto uses another laser to make a flap. That is the femto laser. And then excimer is used in both LASIK and femto to cause the flattening of the cornea. SMILE, we use a laser to make a lenticule within the cornea, make a small opening and remove the lenticule within the cornea. Complications, mostly very less. If you want to know what I have usually faced is maybe flap based, probably because the patients usually come rubbing. LASIK in KC, yes, it is something of discussion now. Now coming to ICL, this is the ICL procedure. So this is the first step. The plunger is kept in, it's wet, made wet. Then we inject a little bit of saline first into the injector, into the cartridge, sorry. Then a bit of visco. Movie setter. Time 4 o'clock. Start. Waiting. Delegates Show. Okay, this is the lens. It's taken. Sit. Okay, that is the lens, the loading of the lens onto the cartridge. Okay, the lens is placed in the cartridge. The orientation is very important. It has to be placed with that dot. There is a dot here. It's dialed in. Turned. We hold the lens from the other end. After holding the lens, we move the cartridge back. We don't, after holding the lens, it's the cartridge that is pushed back. It's not the lens that is that's moving front. It's the cartridge that is taken back. It's loaded into the injector now. Before that, the plunger has to be placed in. We have to make sure that the plunger gets locked within that system. It's locked in now. Now we are loading the cartridge. For ICL, more time is taken probably for loading the lens. Rather than the procedure per se is nothing. It's just go in and come out. It's locked now. You have to push it, make sure it's in hand. Everything's gone in. Now we just push it into the. It's locked. That's it. And it's placed back. Yeah. Injecting so that to see whether the lens is moving safely or not, then it's placed back. Now the patient part, speculum is placed. We are making incisions, 2 side ports. This is going to be the main port, minimal visco. After it's usually 2.8 that we make, then we extend it a little bit to 3. Now once that is done, I am trying to, without using visco, I am irrigating and trying to push in the ICL. So under irrigation, the ICL is going in. Because visco is always something you are a little scared about on day 1 up to day 3. So the more you get trained to do things without using a visco will help you much as you learn. So once the ICL is placed in the anterior chamber, the irrigation is still going on. Now I am trying to dial in all the foot plates inside. And it's finally placed after placing it in the anterior chamber, we are gradually dialing it into the posterior chamber and ensure the AC is formed. That's ICL. When do we do it? When the patient is not usually fit for LASIK. There are a lot of other criteria to be looked at. Complications, you have to think about intraocular pressure rise and cataract in a patient who has undergone ICL. With that, Volt is something we have to look at and learn and assess post-operatively. And with that, I thank you all for your patient listening. Thank you. So it's going to be the premiere show. Srihari and team, please be on stage. Bagger.
ഗുഡ് മോർണിംഗ് ഫ്രണ്ട്സ്. ഇന്നിപ്പോൾ നമ്മൾ മറ്റൊരു CMAയുടെ മുമ്പിലാണ് നിൽക്കുന്നത്. ഇത് തികച്ചും വ്യത്യസ്തമായ ഒരു CMA ആണ്. മലപ്പുറം ഓഫ്താൽമിക് സൊസൈറ്റിയെ പറ്റി മുമ്പ് നമ്മൾ അധികം കേട്ടിട്ടില്ല. ഇപ്പോൾ മലപ്പുറം ഓഫ്താൽമിക് സൊസൈറ്റി ഹാസ് കം ഔട്ട് വിത്ത് എ ബാങ്. ഐ ഡൊണേഷൻ ഫോർട്ട്നൈറ്റിനിടയിലാണ് മലപ്പുറം ഓഫ്താൽമിക് സൊസൈറ്റി വളരെ ആക്റ്റീവായി പല പ്രോഗ്രാംസ്, പ്രോബ്ലി ദേ ഹാവ് കണ്ടക്റ്റഡ് മോർ ദാൻ 30 പ്രോഗ്രാംസ്. അങ്ങനെ വന്നതിൻ്റെ പര്യവസാനമായാണ് ഈ Cor-Kram എന്ന CME, കാറ്ററാക്ട് ആൻഡ് റിഫ്രാക്റ്റീവ് സർജറിയിൽ ഡോക്ടർ ശ്രീനിവാസ് കെ റാവു, ഡോക്ടർ മുഹമ്മദ് സ്വാദിഖ്, ഡോക്ടർ ഷാജി ഹുസൈൻ ഇവരെല്ലാവരും കൂടി ഒന്നിച്ച് നടത്തുന്ന വളരെ മനോഹരമായ ഈ CMEക്ക് എല്ലാ ഭാവുകങ്ങളും നേരുന്നു.
Hi all, I'm Dr. Biju John, Treasurer KSOS. I wanted to be a part of this CME, but as you all know, the KSOS is having an important ECM today. So I take this opportunity to wish the CME all the very best. I'm sure it will be a grand success, judging by the way it has been organized under the efficient leadership of Dr. Muhammad Swadik and Dr. Shaji Hussain and the organizing club, that is the Malappuram Ophthalmic Society. So once again, I wish the CME all the very best.
Hi friends, greetings from the Scientific Committee of Kerala Society of Ophthalmic Surgeons. I'm very happy to see this program, Cor-Kram, being organized by my friends Dr. Shaji Hussain, Dr. Rajesh P. And others from Salama Hospital and Malappuram Ophthalmic Society. It's a very well crafted program and has very eminent faculty and the best teachers like Dr. Srinivas Rao. I'll go anywhere to listen to talks by Dr. Srinivas Rao. And I'm sure that everyone who is attending this program will have a real good scientific feast. I wish all the best for this program.
Dear friends, a very good morning to all of you. I'm Dr. Sai Kumar. I'm the President-elect of the KSOS. I congratulate the Malappuram Ophthalmic Society for this wonderful meeting on cornea and refractive surgery. I congratulate Dr. Shaji and the entire team for organizing such a good meeting. Unfortunately, I could not be present physically for today's meeting. I wish this meeting all the very best, and I'm sure the delegates will benefit immensely with this meeting. Thank you.
Hello, I'm Dr. Manoj Venugopal, Additional Professor of Ophthalmology, Government TD Medical College, Alappuzha. I was eagerly waiting to attend this cataract refractive session by Shaji Hussain and his team from Salama, Perindalmanna, which is on 9th of October. Unfortunately, I'm not able to make it because I will have to attend the KSOS Executive Committee meeting at Kochi. I wish this function all the very best, and I am very sure that this team is going to come up with an exciting conference. Thank you so much.
Hi, I'm Dr. Soni George, Head of the Department of Ophthalmology Medical Trust Hospital, Cochin. I'm indeed very happy and pleased to be informed that the Salama Eye Hospital is conducting a one-day conference, the Cor-Kram, I hope I have pronounced it right, on cornea, cataract and refractive surgery. At a time when cataract surgery is almost becoming a refractive surgery, I find a lot of relevance in all the topics, and having a look at the list of topics and the speakers, I'm very sure this will be a wonderful conference with a lot of useful discussions. I congratulate Dr. Shaji Hussain, the organizing secretary, and Dr. Swadik, the organizing chairman, for conducting this conference, and I wish both of them and all the team involved in organizing this conference all the very best. I hope this conference will be attended very well by delegates, and all of them have a wonderful day of learning and discussion. All the best for the conference once again. Thank you very much.
Salama Group of Hospitals is organizing a CME of cataract and refractive surgery on 9th October. This is led by none other than Dr. Srinivas K. Rao, SKR as we call him. He is a brilliant academician, excellent surgeon and a great human being. I am sure that each attendee will benefit from the CME and enjoy the meeting. Best wishes from us.
Cor-Kram, with its unique name, and I hope I'm saying it correctly, intrigued me. But Shaji said it was based on the movie Vikram, which explains the unique brochure. With its unique name, I'm sure this will prove to be a very unique CME. The topics chosen are excellent and pertinent. The faculty are all masters in their own fields. The organizing secretary is bound to have more than a few tricks up his sleeve that will make the CME not just informative but entertaining as well. On behalf of the Kozhikode Ophthalmic Society and on my own behalf, I wish the CME all success.
Hi friends. Let me congratulate Salama Eye Hospital for organizing Cor-Kram under the aegis of KSOS and of course the Malappuram Ophthalmic Society. They have a superb selection of topics and excellent speakers. I'm sure Dr. Shaji Hussain and Dr. Mohammad Sadiq have worked hard to make this physical meeting a grand success. All my best wishes to the Salama team. Thank you.
ഈവനിങ് ഓൾ. ഈ ഡൊണേഷൻ്റെ ഭാഗമായിട്ട് അബൈറ്റ് എസ് അൽസലാമ പ്രസൻറ്റ് ചെയ്യുന്ന ഒരു അവയർനെസ് വീഡിയോ ആണ് ഇവിടെ പ്രസൻറ്റ് ചെയ്യാൻ പോകുന്നത്. അതിലെ മെയിൻ ക്യാരക്ടർ എന്ന് പറയുന്ന തൻ്റെ ഏറെ നാളത്തെ ആഗ്രഹം സഫലീകരിച്ച് സന്തോഷത്തോടെ ഈ വേദിയിലിരിക്കുന്ന ഒരു കൊച്ചുമിടുക്കിയാണ്. കഴിഞ്ഞ വർഷത്തെ സംസ്ഥാന സർക്കാരിൻ്റെ ഉജ്ജ്വല ബാല്യ പുരസ്കാരം കരസ്ഥമാക്കിയ നമ്മുടെ സ്വന്തം നീനു എന്ന അൽവീന. വള്ളിക്കാപ്പറ്റ ബ്ലൈൻഡ് സ്കൂളിൽ പഠനം തുടരുന്ന നമ്മുടെ നീനുവിന് പ്രായത്തിൽ കവിഞ്ഞ ഒരുപാട് കഴിവുകളുണ്ട്. 6ഓളം ഇൻ്റർനാഷണൽ ലാംഗ്വേജസ് അറിയുന്ന നീനുവിന് പിയാനോയിലും ഏറെ കഴിവ് തെളിയിച്ച ഒരു കുട്ടിയാണ്. അതുപോലെ തന്നെ കലണ്ടറിലെ സ്പെഷ്യൽ ഡേറ്റുകളുടെ ആഴ്ചകൾ ഏതാണെന്ന് കൃത്യമായി നീനു കാണാതെ അറിയാം. പ്രവാചിത ഫൗണ്ടേഷൻ എന്ന മ്യൂസിക് കമ്മ്യൂണിറ്റിയുടെ ആൾ ഇന്ത്യ വിന്നറാണ് നീനു. താങ്ക് യു.
കടല് കാണിച്ചു തരും.
കാണിക്കാലോ.
പപ്പ,
ഈ കടൽ എങ്ങനെ കാണാൻ?
കടലോ? കടല് നമുക്കൊരു ദിവസം കാണാൻ പോവാലോ?
അത് ഞാൻ ചെല്ലട്ടെ, ഞാൻ അയക്കാം. അത് ഇന്ന് തന്നെ ചെയ്യാം കേട്ടോ. ഒന്ന് ഹോൾഡ് ചെയ്യേ. ഇത് എത്ര പ്രാവശ്യം പറയണം അമ്മേ? ഡോക്ടർ ഓൾറെഡി പറഞ്ഞതല്ലേ ഇതൊന്നും കഴിക്കരുതെന്ന്. പറ.
മോളെ പപ്പ പോയിട്ട് വരാവേ. മോളകത്ത് കയറിയിരിക്കും. ചേച്ചി പോരുവേ. എങ്ങും പോവല്ലേ.
പപ്പന്റെ പേരെന്താ?
ബെല്ലി.
ഇവനെന്തിനെങ്ങനെ കളിക്കണേ?
അവനിവിടൊക്കെ ഇങ്ങനെ ഓടിച്ചാടി നടക്കാൻ.
ബെല്ലിന്റെ വാലെങ്ങനെയാ?
നോക്ക്, തൊട്ട് നോക്കണോ? ഇത് ഞങ്ങളുടെ കല്യാണ ഫോട്ടോ. കല്യാണം കഴിഞ്ഞ് പുള്ളി എന്നെ ആദ്യം പുറത്ത് കൊണ്ടുപോകുന്നത് കടൽ കാണിക്കാനാണ്. അന്നാണ് ഞാനും ആദ്യമായിട്ട് കടൽ കാണുന്നത്.
അമ്മേ, നമുക്കും കടൽ കാണാൻ പോയാലോ?
നമുക്കോ?
രാവിൽ നിലാവ് പോലെ നീരാടി നാം മഴയായി പൊഴിയും. മെല്ലെ തണുത്ത കാറ്റായി പാരാകെ നാം കുളിരായി പടരും. ആകാശമായി കുട പോലെ നിന്റെ മേലെയാ നീർത്തി നിൻ കുഞ്ഞു കണ്ണിലാ നീലാമ്പൽ പേലി നീർത്തിടും.
കഴിക്കണ്ട. ഇതൊക്കെ കഴിച്ചാൽ നമുക്ക് വെള്ളം പറ്റിയ ആരെങ്കിലും കടലൊക്കെ കാണിച്ചു തരാ?
ഞങ്ങളുടെ കാഴ്ചകൾ നിങ്ങളിൽ അവസാനിക്കുന്നില്ല. കാഴ്ചയുടെയും സ്നേഹത്തിന്റെയും കരുതൽ ഉറപ്പാക്കാം നേത്രദാനത്തിലൂടെ. മരണശേഷം ദാതാവിന്റെ നേത്രപടലം മാത്രമാണ് എടുക്കുന്നത്. അതുകൊണ്ട് തന്നെ നേത്രദാനം ദാതാവിന്റെ മൃതദേഹത്തെയോ കണ്ണുകളെയോ ഒരു തരത്തിലും വികൃതമാക്കുന്നില്ല. നിങ്ങളുടെ കണ്ണുകൾ നിങ്ങളുടെ മരണശേഷം 2 മനുഷ്യർക്കുള്ള കാഴ്ചയാണ്, ജീവിതമാണ്. Donate your eyes for a better world. Abait AS Al Salama Eye Hospital.
Thank you. I would like to invite Ninu and the team to the stage. Srihari, Shafi Puvathingal, Dop Shyam, Geedu, Shibu Perisheri, Muhammad Bilal, SK Mini and Nino, Anandan Raju, Ahmad Rabin, Matthews, Abiram Salman Dinil, Olid.
I met Sri Hari the other day at my place in Chennai when he had come with Shaji for the invitation. And he did tell me he was dabbling in photography and stuff, and I'd never realized it was of this magnitude. So I think I found the whole thing very nice, very professionally done, very touching, and I think it conveys the message that it's meant to very, very well. So congratulations to everybody involved in the making of this project. Hearty congratulations.
ശ്രീഹരി, എനിക്ക് പറയാൻ വാക്കുകളില്ല. അത് നിൻ്റെ ഒരു സ്വപ്നം ഒരു സാക്ഷാത്കരിച്ചൊരു ദിവസമാണ്. എൻ്റെ എന്നല്ല, ഒരു പക്ഷേ ഈ ടീമിൽ നിൽക്കുന്ന എല്ലാവരുടെയും ഒരു ആകെ ഒരു 10 മിനിറ്റിൻ്റെ അടുത്തുള്ളൊരു ചെറിയ ഷോർട്ട് ഫിലിം ആണെങ്കിലും അതിൻ്റെ പിന്നിൽ ഇത്രയും വലിയൊരു ടീമുണ്ട്. എത്ര മനോഹരമായിട്ടാണ് നിങ്ങളെല്ലാം ഇത് ചെയ്തിരിക്കുന്നത്. സത്യം പറഞ്ഞാൽ വാക്കുകളോട് പോലും നമുക്ക് പറഞ്ഞു തീർക്കാൻ പറ്റില്ല. അത്ര നന്നായിട്ടുണ്ട് ആ കുട്ടിയുടെ എല്ലാവരുടെയും അഭിനയം. എവറി ഫ്രെയിം ഒരു പ്രൊഫഷണലായിട്ട് ഒരു നല്ല ഒരു സ്റ്റാൻഡേർഡ് സിനിമ കാണുന്ന പോലെയാണ്. സത്യം പറഞ്ഞാൽ ഞാൻ ഭയങ്കര ഇമോഷണൽ ആവുകയാണ്. എനിക്ക് ഭയങ്കര ഇഷ്ടപ്പെട്ടു. എല്ലാവർക്കും ഇഷ്ടപ്പെട്ടിട്ടുണ്ടാവും.
ഞാൻ പറയാതിരിക്കുന്നത് ശരിയല്ല. തുടക്കം സത്യം പറഞ്ഞാൽ ഒരു തോട്ടായിരുന്നു. വൈ നോട്ട് ഒരു മൂവി, ഒരു ഷോർട്ട് ഫിലിം. ഡോക്ടർ ശ്രീനി സാറ് വിളിച്ചിട്ട് മലപ്പുറത്തെ ഐ ഡൊണേഷൻ എന്തെങ്കിലും ചെയ്യണം എന്ന് പറയുമ്പോൾ ഒരു ചെറിയ എന്തെങ്കിലും വയ്യാതിരിക്കുന്ന ഒരു ടൈമാണ്. ഭയങ്കര തിരക്കാണ്, OP എല്ലാം. അതിൻ്റെ ഇടയിൽ കൂടി ഇനി ഒരു ഐ ഡൊണേഷൻ ഒന്നും ചെയ്യാൻ വയ്യ എന്നിരിക്കുന്ന സമയത്ത് ശ്രീനി സാറ് വിളിക്കുന്നത്. സാറ് വിളിച്ചു, പക്ഷേ അപ്പം എന്തോ ഒരു എനർജി കയറി. അങ്ങനെ മോബ്സ് കിറ്റ് കാര്യങ്ങൾ, നമ്മൾ ഇൻറ്റേൺസ് എല്ലാവരും എൻ്റെ കൂടെ ഉണ്ടായിരുന്നു. അത് ഭയങ്കര ആക്റ്റീവായിട്ട് പോയി. പക്ഷേ എവിടെയോ എൻ്റെ മുന്നിലൊരു തോട്ട് പ്രോസസ്സ് വന്നു. വൈ നോട്ട് എ ഷോർട്ട് ഫിലിം? അതിൻ്റെ തോട്ട് പ്രോസസ്സ് കയറി വന്നു. പിന്നെ അത് നടത്തണമെന്ന് ഞാൻ തീരുമാനിച്ചു. എന്തെങ്കിലും ഉണ്ടാവണം. അപ്പോഴാണ് പിന്നെ നിന്നെ വിളിക്കുന്നത്, ഓരോ കോൺസെപ്റ്റ് ഡിസ്കസ് ചെയ്യുന്നത്. സത്യമായിട്ടും ദൈവം അല്ലെങ്കിൽ പഠിച്ചവനാണ് നീനുവിനെ എൻ്റെ ഒരു പേഷ്യൻ്റായിട്ട് ആക്ച്വലി നീനു അന്ന് എന്നെ കണ്ടു പോയിട്ടുണ്ട്. നീനുവിന് എന്തോ ഒരു പ്രോഗ്രാം ഉണ്ട്, ഭയങ്കര പെയിനാണെന്ന് പറഞ്ഞ് പെട്ടെന്ന് എൻ്റെ അടുത്ത് വന്നു, ഞാൻ ട്രീറ്റ് ചെയ്തു, പോയി. പക്ഷേ നീനു എന്ന ക്യാരക്ടർ ഞാൻ പിന്നെ ആലോചിച്ചിട്ടില്ല. ബട്ട് ഞാൻ ഒരു കുട്ടിനെ വേണം ഷോർട്ട് ഫിലിം ഉണ്ടാക്കാൻ എന്ന തോട്ട് പ്രോസസ്സിൽ ഇരിക്കുന്ന സമയത്താണ് നീനു ഫോളോ അപ്പിന് വരുന്നത്. വളരെ താങ്ക്ഫുള്ളായിട്ട് പാരൻസും അവരൊക്കെ സന്തോഷത്തോടെ പറഞ്ഞപ്പോൾ ഞാൻ അന്വേഷിക്കുന്ന കുട്ടി നീനു ആണ് എന്നുള്ളത് അപ്പോൾ പഠിച്ചവൻ്റെ മുന്നിൽ കാണിച്ചതായിരിക്കാം. പിന്നെയാണ് നിന്നെ വിളിക്കുന്നതും എല്ലാം സെറ്റാണ് ചെയ്യണം എന്ന് പറയുന്നതൊക്കെ. പക്ഷേ ശരിക്കും ഇറ്റ് വാസ് അമേസിങ്. ഓരോ ഫ്രെയിമും ഇനി നിങ്ങൾക്ക് പറയാം നിങ്ങളുടെ കഷ്ടപ്പാടുകൾ. ഞാൻ സത്യത്തിൽ ഞാൻ പ്രിവ്യൂ കണ്ടിട്ടില്ല. ഞാൻ നീനുവിൻ്റെ ഉമ്മാനെ നോക്കിയിരിക്കുകയായിരുന്നു സത്യം പറഞ്ഞാൽ. ഞാനിത് ശിവേട്ടനറിയാം. ശിവേട്ടൻ ഞങ്ങളുടെ എഡിറ്ററാണ്. ഞാൻ എല്ലാം പ്രൈവറ്റ് ഡിസ്കഷനും സിനിമയുടെ എന്ത് തോട്ട് വന്നാലും ശിവേട്ടനായിട്ടാണ് ഡിസ്കസ് ചെയ്യൽ. അബൈൻ്റെ പല പരിപാടികളും ശിവേട്ടൻ ചെയ്യാറുണ്ട്. ശിവേട്ടന് ഇപ്പോഴും ഇവിടെ പല ആൾക്കാർക്ക് അറിയാൻ തോന്നുന്നുണ്ട്. ഇപ്പോൾ പല ആൾക്കാർക്കും ശിവേട്ടനായിട്ട് കണക്ഷൻ ഉണ്ട്. ഈവൻ സ്റ്റുഡൻസിനടക്കം ശിവേട്ടൻ ഇവിടെ എൻ്റെ ഒപ്പം വന്നിട്ട്. അപ്പോൾ ശിവേട്ടനോട് ഞാൻ ഫസ്റ്റ് ഈ തോട്ട് പറഞ്ഞ അവസാനം എത്തുമ്പോഴും എൻ്റെ മനസ്സിൽ ഞാൻ ലാസ്റ്റ് പറഞ്ഞപ്പോഴും ഞാൻ വിചാരിച്ചിരുന്ന ഒരു സാധനം, ഇതെനിക്ക് നീനുവിൻ്റെ പാരൻസിന് വേണ്ടിയിട്ടുള്ളൊരു ഇതായിരിക്കണം. എനിക്ക് നീനു ആണ് ഇതിൽ സ്റ്റാറായിട്ട് നിൽക്കേണ്ടത് എന്നുള്ളൊരു സാധനം ഞാൻ ആദ്യം തൊട്ടേ അത് എഴുതുന്ന സംഭവം തൊട്ടേ ഞാൻ ആലോചിച്ചിരുന്നൊരു സംഗതിയാണ്. പക്ഷേ ഉമ്മ കരയണുണ്ടപ്പോൾ സത്യമായിട്ട് ഞാൻ ജീവിതത്തിലേക്ക് ഒരു മൊമെന്റ് ഞാൻ വിചാരിച്ചിട്ടില്ല. ഞാൻ പറയുമ്പോൾ ഭയങ്കര ഇമോഷണലായി പോകും. കാരണം എന്ന് വെച്ച് കഴിഞ്ഞാൽ സത്യം പറഞ്ഞാൽ ഞാനൊരു ലോങ് ബ്രേക്കിന് ശേഷം ഒരു സെറ്റിൽ വർക്ക് ചെയ്യണത്. ഞാൻ ലാസ്റ്റ് ശേഷം എന്ന് പറഞ്ഞൊരു സാധനമാണ് ചെയ്തത്. അത് ലോക്ക്ഡൗൺ സമയത്ത് നമ്മൾ ചെയ്തൊരു പരിപാടിയാണ്. അത് സെറ്റ് പരിപാടി ഒന്നും ആയിരുന്നില്ല, നമ്മൾ തന്നെ ക്ലോസ്ഡ് സ്പേസിൽ ചെയ്തൊരു സംഗതിയായിരുന്നു. അതിന് മുൻപ് ഞാൻ ചെയ്തൊരു വർക്ക് എന്ന് പറയുന്നത് ഭൂതാണ്. എനിക്ക് തോന്നുന്നു ഞാൻ ഡിഗ്രി തേർഡ് ഇയർ പഠിക്കുന്ന തേർഡ് ഇയർ സമയത്താണ്. ഓൾമോസ്റ്റ് തേർഡ് ഇയർ കഴിഞ്ഞു, എൻ്റെ PG കഴിഞ്ഞു. അത് കഴിഞ്ഞിട്ട് ഞാൻ 2 വർഷം വർക്ക് ചെയ്തു. അതായത് ഒരു 5-6 വർഷം ഞാൻ ബ്രേക്ക് എടുത്തിട്ടുണ്ട്. ആ ബ്രേക്കിന് ശേഷം ഞാൻ ഒരു സെറ്റിൽ വർക്ക് ചെയ്യാണ്. അതും ഞാൻ കൊച്ചിയിലാണ് പോയിട്ട് ഷൂട്ട് ചെയ്യുന്നത്. എന്നെ കൊച്ചിയിൽ ഒരുപാട് കാര്യത്തിന് ഒരുപാട് ആൾക്കാർ ഹെൽപ്പ് ചെയ്തിട്ടുണ്ട്. ഇപ്പോൾ ഇതിൽ പറയുകയാണെങ്കിൽ ഒരുപാട് ആൾക്കാരുടെ കാര്യങ്ങൾ പറയേണ്ടി വരും. ഇപ്പോൾ എസ്പെഷ്യലി രാജേഷ് സാറ് പറഞ്ഞ പോലെ ഇതിൻ്റെ ഓരോ ഫ്രെയിമും ബ്യൂട്ടിഫുൾ ആവാൻ കാരണം ശ്യാമേട്ടനാണ് ഇതിൻ്റെ ശ്യാമേട്ടനാണ് ഇതിൻ്റെ സിനിമാറ്റോഗ്രാഫർ. ശ്യാമേട്ടൻ എങ്ങനെയാണെന്ന് വെച്ചാൽ ഞാൻ ഭയങ്കര ടെൻഷനായിരിക്കും, ശ്യാമേട്ടൻ ഭയങ്കര കൂളാണ്. ഈവൻ ദ ലാസ്റ്റ് മൊമെന്റ് ഞങ്ങൾക്ക് DIയിൽ ഈ വിഷ്വലി കിട്ടണ വരെ ശ്യാമേട്ടൻ അത് കുഴപ്പമില്ല, സാധനം കിട്ടും, നമ്മൾ ഇതിലും വലുതൊക്കെ ഫേസ് ചെയ്തിട്ടുണ്ടെന്നൊക്കെ പറഞ്ഞിട്ട് ശ്യാമേട്ടൻ നമ്മളെ ഭയങ്കരമായിട്ട് മോട്ടിവേറ്റ് ചെയ്തിട്ടുണ്ട്. പിന്നെ അതേപോലെ തന്നെ എൻ്റെ ഡയറക്ഷൻ ടീം പറയാണ്ടിരിക്കാൻ പറ്റില്ല. ഞാൻ കുറേ ചീത്തയൊക്കെ വിളിച്ചിട്ടുണ്ടാവും. അതൊക്കെ ഞാൻ ഫ്രസ്ട്രേഷൻ്റെ പുറത്ത് പലതും പറഞ്ഞിട്ടുണ്ടാവും. കാരണം വെച്ചാൽ ഇതിൻ്റെ ഷൂട്ട് എന്ന് പറയുന്നത് അത് കഴിഞ്ഞ് ഞങ്ങളൊരു മേക്കിംഗ് വീഡിയോ ചെയ്തിട്ടുണ്ട്. അതും കൂടി നിങ്ങൾ ജസ്റ്റ് ഒന്ന് സഹിക്കണം, അതും കൂടി ഒന്ന് കാണിച്ചു തരാം. ഞങ്ങൾ 3 ദിവസം കൊണ്ടാണ് ഇത് മൊത്തം ഷൂട്ട് ചെയ്തത്. എൻറ്റയർ സാധനം ഞങ്ങൾക്ക് 3 ദിവസം കൊണ്ട് ഷൂട്ട് ചെയ്യണമായിരുന്നു. അതേപോലെ തന്നെ നിങ്ങൾ മറന്നു പോകാത്ത അല്ലെങ്കിൽ നിങ്ങൾ നോട്ടീസ് ചെയ്യേണ്ട ഒരാളുണ്ട്, എൻ്റെ ചെക്കൻ ബെൻലിയെ ഹാൻഡിൽ ചെയ്യിക്കണം. അതേപോലെ തന്നെ നീനുവിനെ ഹാൻഡിൽ ചെയ്യണം. ബെൻലി തൃശ്ശൂരിൽ നിന്ന് എറണാകുളത്ത് വരികയാണ്. ബെൻലിക്ക് അവിടെ സ്റ്റേ വേണം. ഇവർ 2 പേരും സിങ്ക് ആവണം. മാത്രമല്ല എനിക്ക് ഈ ഷെഡ്യൂൾ 3 ദിവസം കൊണ്ട് തീർക്കണം. 3 ദിവസം കൊണ്ട് തീർത്തില്ല എന്നുണ്ടെങ്കിൽ ബഡ്ജറ്റ് കയ്യിൽ പോകും. അപ്പോൾ ഞങ്ങൾ ഒരുമിച്ച് ഒറ്റക്കെട്ടായിട്ട് പല ക്രൈസിസിലും ഒരേപോലെ നിന്നിട്ടുണ്ട്. അതിപ്പോൾ പ്രൊഡക്ഷൻ ടീമാണെങ്കിൽ ഇപ്പോൾ മാത്തൻ, അതേപോലെ തന്നെ എല്ലാ ടീമും. എനിക്കങ്ങനെ പെട്ടെന്ന് ഞാൻ കൈവിട്ട് പോയി ആരെങ്കിലുമൊക്കെ പറയുകയാണെങ്കിൽ ഞാൻ ചിലപ്പോൾ വിട്ടുപോകും. പിന്നെ ആണ് ഫൈനലി മ്യൂസിക്കിൽ കയറുന്നത്. നിങ്ങളൊരു പാട്ട് കേട്ടിട്ടുണ്ടായിരുന്നു. അപ്പോൾ ഞാൻ മ്യൂസിക്കിൻ്റെ ഒരു സെഷൻ ചെയ്തിട്ട് എൻ്റെ വീടിൻ്റെ അടുത്ത് തന്നെയാണ് വിഷ്ണുവിൻ്റെ വീട്. വിഷ്ണുവിൻ്റെ സുഹൃത്താണ്, അവൻ മ്യൂസിക് ചെയ്യുന്ന ആളാണ്. വിഷ്ണു എബിനും കൂടിയിട്ടാണ് മ്യൂസിക് ചെയ്തത്.
ഞാൻ ഈ സെഷൻ ചെയ്തിട്ട് നേരെ വീട്ടിൽ പോയി. ഞങ്ങളൊക്കെ ഉറക്കമൊന്നുമില്ല, അതായത് ടെൻഷനാണ്, ഇത് വർക്കാവോ. ഞാൻ ലിറ്ററലി 3 ആഴ്ചയായിട്ട് ഞങ്ങൾ ഉറക്കില്ല. അപ്പോൾ വിഷ്ണു ഇങ്ങനെ വിളിക്കും, എന്നിട്ട് ഇങ്ങനെ ഓരോ സാധനങ്ങൾ ഇങ്ങനെ കേൾപ്പിക്കും, ചിലത് വർക്കാവും. അവൻ ഇതിൻ്റെ മേലെ തന്നെയാണ് വിഷ്ണു. എന്നിട്ട് ഒരു ദിവസമല്ല, മിനിഞ്ഞാന്ന് പറ്റിയാണ് എൻ്റെ അടുത്ത് വന്നിട്ട് പറയണം, നമുക്കൊരു പാട്ട് ചെയ്താലോ. അപ്പം ഞാൻ പറഞ്ഞ അളിയാ അത് കുറച്ച് ഓവറാവൂലേ. അപ്പം ഞാൻ പറഞ്ഞില്ല, വർക്കാവും. ഞാൻ പറയുന്നു വർക്കാവും. എന്നിട്ട് എബിനും വിഷ്ണുവും കൂടിയിട്ട് ഇവന്മാര് മ്യൂസിക് കമ്പോസ് ചെയ്യുക. ആ സ്റ്റുഡിയോയിൽ ഇരുന്നിട്ട് ഇവന്മാര് പാടിയിട്ട് കമ്പോസ് ചെയ്യാൻ, ലൈക്ക് ഒരു പൂ ചോദിച്ചിട്ട് പൂക്കാലം തരാന്നൊക്കെ പറയില്ലേ, അങ്ങനെ അത്രയും ഇൻവോൾവ് ആയിട്ട് എൻ്റെ ഒപ്പം നിന്ന ഒരു എൻറ്റയർ ക്രൂ ആണിത്. അതിൽ എപ്പോഴും മുന്നിൽ നിന്നിട്ടുള്ളത് നീനു ആണ്. നീനു അത്രയും അധികം ഞാനും നീനുമായിട്ട് സിങ്കായിപ്പോയി. അതേപോലെ തന്നെ ബെൻലി ആയിട്ട് സിങ്കായിപ്പോയി. സത്യത്തിൽ ഈ ഒരു ടീം ഇവിടുന്ന് പിരിയുമ്പോൾ സത്യത്തിൽ എനിക്ക് ദുഃഖമുണ്ട്. കാരണം എന്താ വെച്ച് കഴിഞ്ഞാൽ എൻറ്റയർ പ്രോസസ്സ് അത്രയും അടിപൊളിയായിരുന്നു. ഞങ്ങൾ ഫോർട്ട് കൊച്ചി പോകുന്നു, പോലീസ് പിടിക്കുന്നു, ശിവചേട്ടനൊക്കെ പോലീസ് പിടിച്ചിട്ടുണ്ട് എൻ്റെ ഇടയിൽ. അങ്ങനെ ഭയങ്കര രസകരമായിട്ടുള്ളതും ഭയങ്കര പ്രശ്നത്തിൽ ഈ വീട് ഷൂട്ട് ചെയ്ത സമയത്ത് ഒരുപാട് പ്രശ്നങ്ങൾ ഉണ്ടായിട്ടുണ്ട്. ആ ചേച്ചിയെ കുറെ ബുദ്ധിമുട്ടിച്ചിട്ടുണ്ട്. അപ്പോൾ ഫ്രം ദ പേപ്പർ ടു ദ സ്ക്രീൻ ഒരുപാട് ആൾക്കാർ ഇതിൻ്റെ പിന്നിൽ പ്രവർത്തിച്ചിട്ടുണ്ടെങ്കിലും എനിക്ക് ഇതിന് പ്രൈമറി തോട്ട് തന്നത് ഷായ് സാറാണ്. ഇങ്ങനത്തെ ഒരു സാധനം ചെയ്യണമെന്ന് ബേസിക്കായിട്ട് പറഞ്ഞ ഷായ് സാർ ഇത് പറഞ്ഞിട്ടില്ല എന്നുണ്ടെങ്കിൽ ഞാൻ നീനുവിനെ പരിചയപ്പെടില്ല, ഇങ്ങനത്തെ ഒരു പരിപാടി ഇവിടെ ഉണ്ടാവില്ല. അതേപോലെ തന്നെ ഈ ഒരു വേദി ഒരുക്കി തന്നതിലും ഭയങ്കര സന്തോഷമുണ്ട്. ഐ ആം വെരി ഹാപ്പി. ഞാൻ ഒരു ഒപ്റ്റോമെട്രിസ്റ്റ് ആയിട്ട് ഈ ഒരു വേദിയൊക്കെ ഞാൻ അഡ്രസ്സ് ചെയ്തിട്ടുള്ളൂ. ഞാനൊരു ഡയറക്ടറായിട്ട് പ്രത്യേകിച്ച് ഉള്ള നല്ല ജോലി കളഞ്ഞിട്ട് തേരാപ്പാര കീറപ്പാൻറ് ഇട്ട് പേരാപ്പാര നടക്കാന്ന് ഒരുപാട് ആൾക്കാർ പറഞ്ഞ സ്പേസിൽ തന്നെ എനിക്ക് വന്നിട്ട് ഇത്തരത്തിലൊരു സാധനം കൺവേ ചെയ്യാൻ പറ്റിയതിൽ വളരെയധികം സന്തോഷമുണ്ട്. ഫ്രം മൈ ബോട്ടം ഹാർട്ട് താങ്ക് യു സോ മച്ച്.
നീനുവിന് എന്തെങ്കിലും പറയണ്ടോ? എന്തെങ്കിലും നീനുവിന്റെ സിനിമനെ കുറിച്ച്?
സിനിമയില് നീനു, അമ്മ, പപ്പ, പിന്നെ
ബെൻലി,
പ്രധാനപ്പെട്ടതാണ് ബെൻലി.
ഇല്ല, ആരെ ഏറ്റവും കൂടുതൽ ഇഷ്ടം നീനുവിന്? അമ്മനെയാണോ, ബെൻലിനെയാണോ, പപ്പനെയാണോ? ബെൻലി. ഓ ഓക്കെ. നീനുവിന്റെ പാരൻസ്? നീനു ഓക്കെ. നീനുവിന്റെ പാരൻസ്? ഉപ്പ?
ഈ ഒരു ഷോർട്ട് ഫിലിമിൽ മോളെ കാസ്റ്റ് ചെയ്തതിനും ഇങ്ങനൊരു വേദി തന്നതിനും വളരെ താങ്ക്സ്. ഇങ്ങനെ മോളിപ്പോൾ ഇങ്ങനെ ഒക്കെ തന്നെയാണ് എല്ലാം ഇങ്ങനെ അറിഞ്ഞു വരിക. അപ്പോൾ അതിനൊരു
നിങ്ങൾ 3 ദിവസം എറണാകുളത്ത് എങ്ങനെ ഉണ്ടായിരുന്നു? നിങ്ങൾക്ക് വല്ല ബുദ്ധിമുട്ടുകൾ ഉണ്ടായിരുന്നു?
ഒരു
കംഫർട്ടബിൾ ആയിരുന്നു?
അല്ല, ഹാപ്പി ആയിരുന്നു.
നീനൊന്ന് ഫിറ്റ്സ് ഉണ്ടായിന്ന് കേട്ടു ഒരു ദിവസം.
അവിടുന്ന് കുറച്ച് ബുദ്ധിമുട്ടാവും വിചാരിച്ചു. പക്ഷെ അത് ഇവരെല്ലാരും കൂടിയിട്ട് ഒരു ചേട്ടന്മാരെ പോലെ, ചേട്ടന്മാരെന്നെ, അവൾക്ക് എല്ലാരെയും എല്ലാരെയും അറിയാം. പേര് ശ്രീഹരിയൊക്കെ എപ്പോഴും ഓരോന്ന് പറഞ്ഞിട്ട് അവളങ്ങനെ, അപ്പൊ അവള് ചാടി ഇങ്ങോട്ട് നീക്കും. അവളെന്നെ പറയും ടേക്ക് കട്ട് എല്ലാം അവളെന്നെ പറയും. എല്ലാം പഠിച്ചു അവളിപ്പോൾ. വീഡിയോ അവള് കീബോർഡ് വായിക്കുന്ന സമയത്തും കൂടി ശ്രീഹരി ചേട്ടൻ പറയുന്നത് അവൾ ആദ്യം പറഞ്ഞതിന് ശേഷമാണ് അവള് കീബോർഡ് വായിക്കുള്ളൂ. ഇന്നും കൂടെ ഇപ്പൊ അങ്ങനെ വായിച്ചിട്ടാ വന്നത്. പക്ഷെ മോർണിംഗിൽ ചെറുതായിട്ട് അവൾക്കൊരു ചെറിയൊരു ഇഷ്യൂ ഉണ്ടായി. പക്ഷെ ഓക്കെ ആയി. ഇങ്ങോട്ട് വരികയാണെന്ന് പറഞ്ഞപ്പോൾ കുറേയൊക്കെ ഓക്കെ ആയി. അതാണ് ആ ക്ഷീണം. ഇപ്പോൾ കുഴപ്പമില്ല. എന്നാലും ഭയങ്കര സന്തോഷമുണ്ട്. കാരണം മോള് ഞങ്ങൾ ഓരോ കാര്യത്തിലും നമ്മൾ തന്നെ മോളെ കൂടെ എല്ലാത്തിനും സപ്പോർട്ട് ചെയ്ത് എല്ലാ കാര്യത്തിനും മുന്നോട്ട് പോകും. പക്ഷെ അവളെ ഉള്ളിലൊരു ഭയങ്കര പവറാണ് അവളെ ഉള്ളിൽ എല്ലാ കാര്യത്തിനും. ഞാൻ ഇങ്ങനെ അല്ല എന്ന് അവളെപ്പോഴും തെളിയിച്ചു തരാണ് നമുക്ക് എല്ലാ കാര്യത്തിലും. അതിനിങ്ങനെ ഇതേപോലത്തെ ആൾക്കാരെ നമുക്ക് എപ്പോഴും നമ്മൾ മനസ്സുകൊണ്ട് താങ്ക്സ് ആണ്. കാരണം ഇങ്ങനെയുള്ള എല്ലാ കാര്യം നമ്മൾ ഡോക്ടേഴ്സിൻ്റെ അടുത്ത് പോയാലോ എവിടെ പോയാലോ അവരോട് അടുത്തായിട്ട് സിങ്ക് ആവും. അങ്ങനെയാണ് അവളൊരു ക്യാരക്ടർ. അങ്ങനെയാണ് എല്ലാവരുടെ അടുത്തും അങ്ങനെ തന്നെ. അപ്പോൾ ആ ഒരു ഇതിലാണ് അവൾ ഉയർന്നു പോണതും. ഭയങ്കര എന്താ പറയുക, എനിക്ക് ഫസ്റ്റ് ടൈം അത് കണ്ട ഉടനെ തന്നെ എൻ്റെ മോൾ ഓരോ ഡയലോഗ്സ് പറയണ സമയത്തും നമ്മൾ ഉൾക്കൊള്ളുകയാണ്. അവൾക്ക് ലാസ്റ്റ് ആ ഒരു രീതിയിൽ തന്നെ ആവട്ടെ ഇനിയും അത് മാത്രമേ നമ്മളെ മനസ്സിലുള്ളൂ. പക്ഷേ സന്തോഷം കൊണ്ടുള്ളൊരു കരച്ചിൽ വന്നതാണ്. ശരിക്കും പറഞ്ഞാൽ എല്ലാവരും എൻ്റെ ടീം എല്ലാവരും കഷ്ടപ്പെട്ടിട്ടുണ്ട്. നമ്മൾ കണ്ടിട്ടേ ഉള്ളൂ. ഒരു മൂവി കാണുമ്പോൾ 2 മണിക്കൂർ കഴിഞ്ഞ് നമ്മൾ ഇറങ്ങുമ്പോൾ നമ്മൾ അതിനെ റിവ്യൂ പറയുമ്പോൾ ഹാപ്പിയാണോ, അതിന് ബെനിഫിറ്റ്സ്, അതുപോലെ തന്നെ എന്താണ് അതിൻ്റെ ബാക്ക്വേർഡ്സ് എല്ലാം പറയുമ്പോൾ നമുക്ക് ഇതിന് ഇത്രയും കഷ്ടപ്പാടുണ്ടെന്ന് നമ്മൾ അറിയണില്ല. സത്യം പറഞ്ഞാൽ 10 മിനിറ്റിൻ്റെ മൂവി എന്ന് പറഞ്ഞു കഴിഞ്ഞാലും അത് എടുക്കാനുള്ള ഒരു എഫേർട്ട് ഓരോരുത്തരും, ആരും എടുത്തു പറയാനില്ല, ഓരോരുത്തരും കഷ്ടപ്പെട്ടിട്ടാണ്. അത് നമ്മളും കൂടെ നിന്നു എന്ന് മാത്രം. പാരൻസ് എന്നുള്ള നിലയ്ക്ക് സന്തോഷമുള്ള, ഞങ്ങൾ ഹാപ്പിയാണ്.
അവിടെ തോണി കയറ്റിയൊരു സീന് നിങ്ങൾക്ക് ഏറ്റവും വിഷമമുള്ള സീനായിരുന്നു എന്നറിയാം.
അതെ അതെ. പക്ഷേ അത് ഇവരിങ്ങനെ അവിടുന്ന് വിളിച്ച് പറയുമ്പോൾ അവള് പറയും ഓക്കെ ഓക്കെ അമ്മ ഉണ്ട് കൂടെ. എന്നെ ഓട്ടോന്ന് ഇറക്കി വിട്ടു അവള്. ഞാൻ ഇരിക്കുന്ന സമയത്ത് ശ്രീഹരി പറഞ്ഞു കംഫർട്ട് ആയിക്കോട്ടെ അമ്മ കൂടെ ഇരുന്നോന്ന് പറഞ്ഞു. അപ്പോൾ എന്നോട് ചോദിക്കുക എൻ്റെ അമ്മ ഇതല്ലല്ലോ, അമ്മ ഇറങ്ങിക്കോ, അമ്മ വന്നാ മതി. അതാണ് അവളതാണ് അതിലങ്ങോട്ട് മുഴുകി പോവാണ് അവള് ആ ഒരു കഥയില്.
ആ ഓട്ടോയില് സീറ്റിന്റെ പിന്നിൽ ആരും ഉണ്ടായിരുന്നു എന്ന് കേട്ടോ? അല്ല, നിങ്ങളെ ഡയറക്റ്റ് ചെയ്യാൻ വേണ്ടിട്ട് ആ സീറ്റിന്റെ പിന്നിലാരോ ഓട്ടോന്റെ പിന്നിലാരോ ഇരുന്നിരുന്നു എന്ന് കേട്ടു. ഡയറക്ടർ ഉണ്ടായിരുന്നു തോന്നുന്നു.
ശ്രീഹരി തന്നെയാണ് എല്ലാം. അവന്റെ പിന്നാലെ എല്ലാരും. അത് ഒരു വിഷമം വരുമ്പോഴും ഓരോരുത്തരും സപ്പോർട്ട് ചെയ്യണ കാണുമ്പോൾ നമുക്ക് ഭയങ്കര സന്തോഷമാണ്. അതെന്ന് വെച്ചാൽ ഒരു മൂവി കഴിഞ്ഞ് അങ്ങ് പോവുകയല്ല ചെയ്യണത്. എല്ലാവരും അത് കഴിഞ്ഞതിന് ശേഷം ഞങ്ങളൊരു നാഷണൽ ആന്തമൊക്കെ കഴിഞ്ഞിട്ടേ അവിടെ നിന്ന് പോവാറുള്ളൂ സത്യം പറഞ്ഞാൽ. അത് ഇവള് നാഷണൽ ആന്തം ചൊല്ലിയിട്ട് എല്ലാവരും സ്റ്റഡി ആയിട്ട് നിൽക്കണം. അതൊക്കെ എന്താ പറയുക, എല്ലാം ആ 3 ദിവസം കൊണ്ട് എല്ലാം കംപ്ലീറ്റ് ചെയ്ത് ഭയങ്കര സന്തോഷം. എവിടെയും നമ്മൾ കുറച്ച് ബുദ്ധിമുട്ടിയാലും അതിൻ്റെ അപ്പുറത്തേക്ക് വലുതായിട്ട് നമുക്ക് ഓരോ കാര്യങ്ങൾ അവിടെ നിന്ന് തന്നെ നേടി കിട്ടുന്നുണ്ട്. സത്യം പറഞ്ഞ സന്തോഷം.
ബെന്റ്ലി ഓണർ മാഡത്തിന് പിന്നെ കൺക്ലൂഡ് ചെയ്യാം.
ബെന്റ്ലി ഇപ്പം കുറച്ച് കാം മൈൻഡഡ് ആണ്, ബാക്കിയുള്ള ഡോഗ്സിന്റെ പോലെ അഗ്രസീവ് അല്ല. ഇവൻ ഇത്ര അറ്റ്മോസ്ഫിയറിന്റെ ഉള്ളിൽ ഇതുവരെ ആക്ടിങ്ങിനൊന്നും പോയിട്ടില്ല. അപ്പോൾ ചെറിയ ടെൻഷൻ ഉണ്ടായിരുന്നു. അപ്പോൾ ഇവൻ ഷോക്കൊക്കെ ഇറങ്ങുന്ന ഡോഗാണ്. അപ്പോൾ ശ്രീഹരിച്ചേട്ടൻ വിളിച്ചു പറഞ്ഞു കുഴപ്പമൊന്നും ഉണ്ടാവില്ല, എല്ലാ കാര്യങ്ങളും ചെയ്തു തരാന്ന് പറഞ്ഞപ്പോൾ നമുക്ക് കിട്ടാവുന്ന ഏറ്റവും ബെസ്റ്റ് ഫെസിലിറ്റീസ് ആണ് ചേട്ടൻ ഇറക്കിയത്. ഇവൻ കുറെ നേരം ഒന്നും ഇവന് അധികം ആക്റ്റീവായിട്ട് ഇരിക്കാൻ പറ്റില്ല. അതിനുള്ള എല്ലാ പ്രൊസീജിയേഴ്സും എല്ലാ ഫെസിലിറ്റീസും ആളൊരുക്കി. പിന്നെ ഇവൻ എല്ലാവരുമായിട്ട് സിങ്കായി. പിന്നെ ഇവന്റെ ഒരു നേച്ചറിനനുസരിച്ചുള്ള മൂഡ് ഉള്ള സിനിമ കാരണം കുറച്ചുകൂടി ബെനിഫിഷ്യലായി.
AC നിർബന്ധം തോന്നുന്നു അല്ലെ? കാറിലൊക്കെ AC ഇട്ടിട്ട് ഇരുന്നിരുന്നൊക്കെ പറഞ്ഞു. VIP
24 hours AC-ലിരിക്കണ.
തോണി കയറ്റിയപ്പോ എന്ത് തോന്നി?
തോണി കയറ്റിയപ്പോ വളരെയധികം വിഷമം തോന്നി. കാരണം ഇവനെ നീന്തിക്കാൻ കൊണ്ടുപോകാറുണ്ട്. പക്ഷെ ആ ഒരു കുളം എന്ന് പറഞ്ഞാൽ നീന്തി കഴിഞ്ഞ് കഴിഞ്ഞാൽ പിന്നെ ഷോ എന്ന് പറയുന്ന സാധനത്തിന്റെ അടുത്തേക്ക് പോകണ്ട, അങ്ങനത്തെ ഒരു പ്രശ്നമായിരുന്നു. പക്ഷെ ആള് ഫുൾ ധൈര്യം തന്നു. അപ്പൊ ഞങ്ങടെ ഞാന് വീണ് കഴിഞ്ഞാൽ ചാടാനുള്ള രീതിയിലാണ് നീനുവിന്റെ ഫാദറും ഞാനും ഒരുമിച്ചൊക്കെ
ഉണ്ടായിരുന്നത്.
ഇവൻ അവിടെ എത്തിയിട്ട് പബ്ലിക്കില് ഒരു കുര പോലും കുറച്ചിട്ടില്ല. കുറയ്ക്കാനായിട്ടുള്ള ഒരു സീൻ ഉണ്ടായിരുന്നു, അത് കട്ട് ചെയ്യേണ്ടി. പക്ഷെ അങ്ങനെ പബ്ലിക്കിൽ പോയ ആള് വെൽ ബിഹേവ്ഡ് ആണ്, കുറയ്ക്കില്ല. അങ്ങനെയാണ്.
മാഡം ശരിക്കൊരു സീനിയർ ആർട്ടിസ്റ്റ് ആണ്. മാഡം തൊണ്ടി മുതലും ദൃക്സാക്ഷിയും എന്ന് പറയുന്ന സിനിമയിൽ നിമിഷ സജയന്റെ അമ്മയായിട്ട് അഭിനയിച്ചിട്ടുണ്ട്. അതേപോലെ തന്നെ അർച്ചന 31 നോട്ട് ഔട്ട് എന്ന് പറയുന്ന സിനിമയിൽ ഐശ്വര്യ ലക്ഷ്മിയുടെ അമ്മയായിട്ട് അഭിനയിച്ചിട്ടുണ്ട്. ഞങ്ങളുടെ ഇങ്ങനെ ഒരു കുട്ടി സ്റ്റാർട്ടേഴ്സിന്റെ ഒരു ക്രൂവിൽ ശരിക്കും ഒരു സീനിയർ ആർട്ടിസ്റ്റ് ആയിരുന്നു മാഡം. അപ്പോൾ മാഡത്തിന്റെ ഒരു
വളരെ അപ്രതീക്ഷിതമായിട്ടാണ് എനിക്ക് ശ്രീഹരിയുടെ കോള് കിട്ടുന്നത്. ഞാൻ അപ്പോൾ കൊച്ചിയിലുണ്ടായിരുന്നു ഒരു വർക്ക്ഷോപ്പ് അറ്റൻഡ് ചെയ്യാൻ വേണ്ടിയിട്ട്. അപ്പോൾ വിഷയമൊക്കെ പറഞ്ഞപ്പോൾ എനിക്ക് താല്പര്യമായി. ഒരു വലിയ സന്ദേശത്തിൻ്റെ ഭാഗമാകാൻ കഴിഞ്ഞതിൻ്റെ വലിയ സന്തോഷമുണ്ട് എനിക്ക്. വന്നപ്പോൾ കുഞ്ഞിനെ കണ്ടു. എനിക്ക് ചെറിയൊരു ആക്ടർ എന്നുള്ള നിലയ്ക്ക് ചെറിയ വറിയുണ്ടായിരുന്നു. എങ്ങനെയാണ് മോളുമായിട്ട് കോപ്പറേറ്റ് ചെയ്ത് പോകാൻ പറ്റുമോ, നമുക്ക് മോളെ അഡ്ജസ്റ്റബിൾ നമുക്ക് എളുപ്പത്തിൽ വഴങ്ങുമോ, അല്ലെങ്കിൽ ഒരുമിച്ച് പോകാൻ ബുദ്ധിമുട്ടാകുമോ എന്നൊക്കെ വിഷമിച്ചിരുന്നു. പക്ഷെ കണ്ടു കഴിഞ്ഞപ്പോൾ അതൊന്നും ഉണ്ടായില്ല, വളരെ പെട്ടെന്ന് സിങ്കായി. പിന്നെ ഞാൻ ഈ സ്കൂളിൽ പഠിക്കുന്ന കാലത്ത് തന്നെ അന്ധവിദ്യാർത്ഥിനികൾ എൻ്റെ ക്ലാസ്സിലുണ്ടായിരുന്നു. അപ്പോൾ മറ്റാർക്കും തോന്നാത്ത ഒരു അടുപ്പം എനിക്ക് ആ കുട്ടികളോട് എന്നും ഉണ്ടായിരുന്നു. നോട്ട്സ് പറഞ്ഞു കൊടുക്കാൻ സ്കൂളിൽ മൊത്തത്തിലുള്ള അന്തർവിദ്യാർത്ഥിനികൾ എൻ്റെ അടുക്കിലേക്ക് വരും ഇൻ്റർവെൽ ടൈമിന് പഠിപ്പിക്കാനും നോട്ട്സ് കൊടുക്കാനും. അത് കോളേജിൽ വന്നപ്പോഴും തുടർന്നു. പക്ഷെ അത് ജീവിതത്തിൽ പിന്നെ ഒരു അധ്യായം ഇതുപോലെ വരും എന്നുള്ളത് അത് എവിടേക്കോ എന്തൊക്കെയോ എഴുതി വെക്കപ്പെട്ടിട്ടുണ്ട് എന്ന് ഞാൻ അപ്പോൾ മനസ്സിലാക്കി. അപ്പോൾ മോളുമായിട്ട് അഭിനയിച്ചത് വലിയൊരു എക്സ്പീരിയൻസ് ആയിരുന്നു. ഈ തോണി കയറുന്നൊക്കെ വളരെ ലാഘവത്തോടെ പറഞ്ഞെങ്കിലും എന്നോട് ശ്രീഹരി പറഞ്ഞ മാഡത്തിൻ്റെ ഉത്തരവാദിത്തമാണ് ബെർലിയെയും മോളെയും നോക്കുക എന്നുള്ളത് എന്ന് പറഞ്ഞു. അപ്പോൾ വാസ്തവത്തിൽ അത് ഉലയുന്ന വള്ളമാണ്. ഒരു ഇദ്ദേഹം ഇരിക്കുമോ എന്നുള്ള ഒരു ഇത് ഉറപ്പും എനിക്കില്ല. മോളെ കുഴപ്പമില്ല, ഞാൻ എങ്ങനെയെങ്കിലും ബാലൻസ് ചെയ്ത് പിടിച്ചിരുത്താം, അവളെ എൻ്റെ കൂടെ ഇരുന്നോളൂ എന്നുള്ളത്. മറ്റേ ആളിനെ ശരിക്കും പേടിച്ച് തന്നെയാണ് ഞാൻ ഉള്ളിൽ, പക്ഷെ പുറത്തതൊന്നും വന്നില്ല. എന്തായാലും വളരെ 3 ദിവസത്തെ ശ്രമം. ഓരോരുത്തരുടെയും പേരെടുത്ത് പറയണം. അത്യധികമായ ടാലൻ്റുള്ള കുട്ടികളുമാണ്. അവരുടെ അധ്വാനം, പരിശ്രമം, അവരെ നമ്മളെ ആർട്ടിസ്റ്റ് എന്നുള്ള നിലയിൽ നമ്മളോട് ഇടപെടുന്ന രീതി, നമ്മളെ കൺവിൻസ് ചെയ്യുന്ന രീതി എല്ലാം വലിയ ഒരു സംവിധായകനെ ഞാൻ ശ്രീഹരിയിൽ കാണുകയാണ്. ശ്രീഹരി ഇവിടെ കൊണ്ട് നിൽക്കത്തില്ല, വളരെ നല്ല ഭാവിയുള്ള ഒരു മികച്ച സംവിധാനമായി മാറട്ടെ എന്ന് ഞാൻ ആശംസിക്കുകയും ചെയ്യുന്നു. പിന്നെ ഇതിനകത്ത് ഇന്ന് എൻ്റെ ഹസ്ബൻഡ് ഡോക്ടർ സന്തോഷ് ഇവിടെ ഉണ്ട്. ഇതിൽ അഭിനയിക്കുമ്പോൾ തന്നെ ഇതിന് മുമ്പേ എനിക്ക് ഉള്ള ഒരാഗ്രഹവുമാണ്. നേത്രദാനം എന്ന് പറയുന്നത് വളരെ എന്താ പറയണ്ടേ, വളരെ ഉദാത്തമായ ഒരു കൃത്യമാണെന്ന് ഞാൻ മനസ്സിലാക്കുന്നു. എൻ്റെ കണ്ണുകൾ എൻ്റെ മരണശേഷം ഉപയോഗയോഗ്യമെങ്കിൽ ദാനം ചെയ്യപ്പെടണം എന്നാണ് ഞാൻ ആഗ്രഹിക്കുന്നത്. കാരണം കാഴ്ചകൾ കണ്ട് മതിവരാത്ത കണ്ണുകളാണ് എൻ്റേത്. എനിക്ക് ഒരുപാട് കാഴ്ചകൾ ഉൾക്കണ്ണ് എന്ന പോലെ തന്നെ ഈ പുറമേ കാണുന്ന കണ്ണുകൾ കൊണ്ട് ഒരുപാട് കാഴ്ചകൾ കാണണമെന്ന് ആഗ്രഹിക്കുന്ന ഒരാളാണ് ഞാൻ. അപ്പോൾ എൻ്റെ മരണശേഷം ആ കണ്ണുകൾ കൂടുതൽ കാഴ്ചകൾ കാണാനിടയാകുമെങ്കിൽ അതെനിക്ക് ഏറ്റവും സന്തോഷമാണ്. അപ്പോൾ എൻ്റെ ഹസ്ബൻഡിൻ്റെ സാന്നിധ്യത്തിൽ ഞാനത് ആവശ്യപ്പെടുകയാണ്, അദ്ദേഹത്തിനോടും കൂടി പറയുന്നത്. അതാണ് ഇപ്പോൾ ഈ സിനിമ എനിക്ക് നൽകിയ ഒരു എന്താ പറയണ്ടേ ആത്മവിശ്വാസം. എനിക്ക് നൽകാൻ കഴിയുന്ന ഏറ്റവും വലിയ കാര്യമായിട്ട് ഞാൻ അതിനെ കാണുന്നു. ഈ സിനിമ എന്നെ ഒരുപാട് മാറ്റിമറിക്കുകയും ചെയ്തിട്ടുണ്ട്. താങ്ക് യു ശ്രീഹരി.
ഇനി ശ്രീഹരി ആൻഡ് ടീം, നിങ്ങൾക്ക് എന്തെങ്കിലും പറയാനുള്ള ആർക്കും പറയാം. വേദിയാണ്, നിങ്ങളുടെ വേദിയാണ്. ക്യാമറാമാൻ വളരെ ഡൗൺ ടു എർത്ത് ആയിട്ടുള്ള ഒരാളാണ്. സിനിമാറ്റോഗ്രാഫർ
ഇതിൻ്റെ ഭാഗമാവാൻ സാധിച്ചതിൽ തന്നെ വളരെ സന്തോഷം. പിന്നെ ഇതിന് തുടക്കം കുറിച്ച ഷായ് സാറ്, പിന്നെ അബേറ്റായ സൽസലാമ, ഇത് രണ്ടും അല്ലേ വളരെയധികം ഈ ശ്രീഹരിയനെ ഇങ്ങനെ സപ്പോർട്ട് ചെയ്യണത് കാണുമ്പോൾ തന്നെ വളരെയധികം സന്തോഷമാണ്. പിന്നെന്താ, ഇതിൻ്റെ പുറകിൽ ഒരുപാട് കഥകൾ പറയുകയാണെന്ന് വെച്ചാൽ 3 ദിവസമേ നമ്മൾ ഷൂട്ട് ഉണ്ടായുള്ളെങ്കിലും ഒരു 30-45 ദിവസം ഒരു ഫിലിം ഷൂട്ട് ചെയ്ത അത്രയും കഥകൾ പോലെ ഞങ്ങൾക്ക് അത്രയും കഷ്ടപ്പാടുകളൊക്കെ ഇതിനകത്ത് ഉണ്ടായിട്ടുണ്ട്. അത്രയും.
സിനിമാറ്റോഗ്രാഫർ പറയാം, നിങ്ങൾ വളരെ ഡൗൺ ടു എർത്ത് ആണെന്നറിയാം. അവള് വെള്ളം. നിങ്ങളെ പേരെങ്കിലും ഒന്ന് പറഞ്ഞു തന്നോ?
ശ്യാം.
ശ്യാം. എവിടെ പഠിച്ചേ?
ഞാൻ തൃശ്ശൂരാണ്.
എത്ര ഈ ഫീൽഡില്?
ഞാൻ ഒരു 8 വർഷം മംഗ്ലീഷ് എന്ന് പറഞ്ഞ സിനിമ ഫസ്റ്റ് വർക്ക് ചെയ്തു. പിന്നെ അവിടെ തൊട്ട് ഇങ്ങോട്ട് പാപ്പൻ എന്ന് പറഞ്ഞൊരു സുരേഷ് ഗോപിയുടെ സിനിമ.
നിങ്ങളുടെ
മമ്മൂട്ടി ഇടയ്ക്കിടയ്ക്ക് സെറ്റ് പോകുമ്പോ
തല പിടിക്കും. ആ, നിങ്ങളുടെ അസിസ്റ്റന്റിനെ എവിടുന്ന കണ്ടുമുട്ടിയേ?
ഞങ്ങൾ അടുത്തടുത്തായിരുന്നു വീട്.
ഓ, ഓക്കെ. സെയിം ഫീൽഡിലാണ് രണ്ടുപേരും.
കല്യാണം കഴിഞ്ഞ പിന്നെ വർക്ക് ചെയ്യാൻ തുടങ്ങിയത് കൂടെ.
ഓക്കെ, ഓൾ ദി ബെസ്റ്റ്.
താങ്ക് യു.
പ്രൊഡ്യൂസർ ഒന്നും പറഞ്ഞില്ല. ബിലാൽ, എങ്ങനെയായിരുന്നു ചീത്തയൊക്കെ ശ്രീഹരിയുടെ?
ഭയങ്കര എക്സ്പീരിയൻസ് ആയിരുന്നു. ഫസ്റ്റ് ടൈമാണ് ഞാൻ ഇങ്ങനെ ഒരു സെറ്റിൽ വർക്ക് ചെയ്യണത്.
ഇനി കുറെ ഉണ്ടാവും. ശ്രീഹരിനെ പിടിച്ചാൽ കിട്ടൂല, നീ പിന്നാലെ കൂടിക്കോ.
അങ്ങനെ കുറേ കാര്യങ്ങൾ പഠിക്കാൻ പറ്റി. അതന്നെ മെയിനായിട്ട് കിട്ടിയൊരു സംഭവം. ഷാമേട്ടൻ കുറേ കാര്യങ്ങൾ പറഞ്ഞു തന്നിരുന്നു ക്യാമറനെ പറ്റിയിട്ട്. അങ്ങനെ പിന്നെ ലൈറ്റും ക്യാമറൻ്റെയും വേറെ ആൾക്കാരൊക്കെ ഉണ്ടായിരുന്നു. അവരും തന്നെ നല്ല ഹെൽപ്പ് ചെയ്തിരുന്നു, ഓരോ കാര്യങ്ങൾ പറഞ്ഞു തന്നിട്ട്. മെയിൻ കുറേ കാര്യങ്ങൾ പഠിക്കാൻ പറ്റി, അതാണ് മെയിനായിട്ട്.
എന്നാൽ ഇനി നീനുവിൻ്റെ പ്രോഗ്രാമിലേക്ക് കിടന്നാലോ? ഓക്കെ, ഷിബിലി.
Drishti, I told him we'll meet at Drishti. He's coming. Kozhikode, yeah.
പിയാനോ കാര്യങ്ങളൊക്കെ ഒരു വണ്ടിയിൽ നിന്ന് കൊണ്ടുവരുന്നുണ്ട്. അതിൻ്റെ മുമ്പ് ഈ ഓൾക്ക് അറിയുന്ന ലാംഗ്വേജസും അതൊക്കെ ചോദിച്ചു, അതൊക്കെ ചെയ്യും. പിന്നെ മെമ്മറി ടെസ്റ്റും കാര്യങ്ങളൊക്കെ. പക്ഷേ ഓള് കുറച്ച് അറിയിട്ടാണ് ഇപ്പോൾ സംസാരിക്കുന്നത്. വേണമെന്നുണ്ടെങ്കിൽ നമുക്ക് ഓളുടെ കയ്യിൽ മൈ കൊടുത്താണ്ട് ഉമ്മ കുറച്ച് ചോദിച്ചോട്ടെ. ബുദ്ധിമുട്ടിക്കണ്ട. അവള് എന്താണ് അവളെ കംഫർട്ട്?
ഓക്കെ, കുഴപ്പമില്ല. കീബോർഡ് കൊണ്ടുപോട്ടെ. കീബോർഡ് ചെയ്തതിന് ശേഷം അങ്ങനെ കണ്ടിന്യൂസ് ആയിട്ട് പോകുമ്പോൾ ഒരു പെട്ടെന്ന് ചോദിക്കുമ്പോൾ
അതന്നെ ഈ എനർജിയിൽ സെയിം എനർജി.
സ്വപ്നങ്ങൾ ചായം കൊട്ടിയ വനികമേൽ ഒരു മായിക പടമെഴുതാൻ നിഴലുകൾ ഒളിയുമായി ഇഴചേർത്തൊരു കഥയുമായി കാലത്തിൻ കൈകൾ മെല്ലെ മിഴി മറയും തിരശീലകൾ ഞൊറിയുകയായി പുലരികൾ അണയുമോ നവചാരുത പകരുവാൻ തിരി പകുതിയുമണയുമാ കതിരവൻ ഒരു ഞൊടിയിട തിരികെ ഒന്നുയരുമോ തമ്മിൽ മനസ്സൊരുക്കാൻ ഇരവൊരു പകലാകുവാ ഇനിയൊരു ചലനം 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 കണി കാണും മിഴികൾ നാളെ പുതിയൊരു ചലനം 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 ഇനി വെള്ളിത്തിരയിലാകെ കനിപൊളിയുടെ തളിരിളം വിരലിനാൽ കരളിതളുകൾ മൃദുലമായി തഴുകുവാൻ ഇനി ഉദിച്ചുയരാം ഒരു പുതിയ പൂത്താരകം. ഓ ഇനിയൊരു ചലനം 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 കണി കാണും മിഴികൾ നാളെ പുതിയൊരു ചലനം 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 ഇനി വെള്ളിത്തിരയിലാകെ ഇനിയൊരു ചലനം 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 കണി കാണും മിഴികൾ നാളെ പുതിയൊരു ചലനം 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 ഇനി വെള്ളിത്തിരയിലാകെ ചലനം 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 ചലനം
നമ്മൾ ഡാൻസിനുള്ള കുട്ടികളെവിടെയാ? കം ഓൺ സ്റ്റേജ്. അത് നോക്കാം, ടൈം ഒന്ന് ഇതാക്കാനാ. നീ എവിടെയെങ്കിലും ഇരുന്നു, അത് അവിടെ ഇരുന്ന സ്റ്റൂൾ മതിയോ? ചെയർ വേണോ? ആരെ ആര് വെൽക്കം ചെയ്യും? ക്ലാസിക് ഡാൻസ് അത് കൊണ്ട് വിളിക്കാം. ടൈം ചെറിയ. നമ്മൾ കുട്ടികളെവിടെയാ? ഒന്ന് വരൂ, ഓൺ സ്റ്റേജ്. എല്ലാവരും ക്യാപ്പും കണ്ണടയൊക്കെ ഇട്ടുക. ഓ എന്താ അടിപൊളി. ഓ അപ്പൂവിന് കിട്ടിയിട്ടില്ല. അടിപൊളി. പാ ലീനിടുന്നു. അല്ല, കീബോർഡ് റെഡിയാ? ആ, അപ്പോഴേക്കും ഈ ഒരു ഡാൻസാണ് തീർക്കാം. ഓക്കെ. ആ, നിങ്ങളെ പൊസിഷൻ പൊസിഷൻ പൊസിഷൻ. യെസ്, പൊസിഷൻ. അപ്പൂൻ്റെ തൊപ്പി കൊള്ളണില്ല. എന്താ അപ്പു? അടിപൊളി. തല വലുതാ, കുറച്ച് വലിയ ക്യാപ്പാണ്. അത് ഓക്കെയാണ്. ഓക്കെ, പാട്ട് റെഡി? ആ, മ്യൂസിക് റെഡിയാ? കൊടുത്തിട്ടുണ്ടോ? ഫാസിൽ റെഡി അല്ലേ? അല്ല, ബാക്ക് എടുക്ക്. നീನು ഇവിടെ നിന്നോട്ടോ, അവർ ഡാൻസ് കളിക്കുന്നുണ്ട് നിന്റെ പിന്നിൽ. ഓക്കെ, കൈ അടിച്ചോ. ഓക്കെ. ആ, ഓക്കെ, റെഡി, സ്റ്റാർട്ട്.
കിട്ടും മിഠായി.
ഹലോ ഹലോ ഹലോ
ഹലോ ഹലോ ഹലോ Sarajam, yes. Okay. Adayinenta papa? Sarajama ina? Huh? Okay. Number 1. Nokia classic ringtone. Number 2. Nokia old classic ringtone. Number 3. Airtel flute ringtone. And we have our number 4 is IP iPhone ringtone. And we have number 5 is Redmi MI. Number 6 is Realme C2. Number 7, Honor Huawei. Number 8 is BSNL message. Please on the comments wall for free for unlimited free songs at 56700. BSNL is connected in India. Thank you for calling. ദയവായി വിളിച്ചത് വളരെ നന്ദി. താങ്കൾ വിളിച്ച വ്യക്തി ഇപ്പോൾ തിരക്കില്ല. ദയവായി അല്പസമയത്തിന് ശേഷം ശ്രമിക്കുക. The number you have dialed is currently busy. Please try later. आप किस व्यक्ति को कॉल कर रहे हैं वह उत्तर नहीं दे रहा है. कृपया कुछ समय पश्चात कॉल करें. Number 9. Sky Twitters. Hey! Good morning, children. Number 10, the last one is Munshi. മരം ഒരു മരം പന ഒരു മരം. Saraj. Announcement. First railway. Just everyone just wait. I will set it. Okay. Railway announcement. യാത്രക്കാർ ദയവായി ശ്രദ്ധിക്കുക. ട്രെയിൻ നമ്പർ 126-24 തിരുവനന്തപുരം ചെന്നൈ എക്സ്പ്രസ് തൃശൂർ സ്റ്റേഷൻ രണ്ടാമത്തെ പ്ലാറ്റ്ഫോമിലേക്ക് അല്പസമയത്തിനുള്ളിൽ എത്തിച്ചേരുന്നതാണ്. यात्रियों कृपया ध्यान दीजिए. गाड़ी नंबर 126 त्रिवेंद्रम चेन्नई दौड़े में त्रिशूर स्टेशन प्लेटफॉर्म नंबर 2 पर आएगी. Your attention please. Train number 126 Trivandrum Chennai Express will arrive shortly on Thrissur station, platform number 2. Okay, next. Everyone just wait again. يرجمن حلرات ركاب الطائرة طيران الإمارات. رهوى رقم 123 فمتوجهة إلى لندن هيثرو. تتوجه إلى الطائرة من خلال بوابة رقم 4. Sarah. Okay. Look.
നീനുവിന് മൈക്ക് തരാം. അപ്പം നീനു പറയണ എല്ലാവർക്കും കേൾക്കാം. ഓക്കെ? ഓക്കെ നീനു?
ഓക്കെ.
നീനു, ഞാൻ കേട്ടിട്ടുണ്ട് നിനക്ക് ഭയങ്കര മെമ്മറി പവർ ആണെന്ന്. ശരിയാണോ?
ശരിയാ.
ശരിയാ? ഓക്കെ. അത് ടെസ്റ്റ് ചെയ്യാൻ എന്താ ഞാൻ ചെയ്യണ്ടേ? ഡേറ്റ് ചോദിക്കട്ടെ? ഓക്കെ. നിനക്ക് ഡേ പറയണോ അതോ ഡേറ്റ് പറയണോ? ഡേ പറയേണ്ടത്. ഓക്കെ. അപ്പൊ നീനു, മാർച്ച് 2022 17-ാം തീയതി ഏത് ഡേയാ? മാർച്ച് 2022. എക്സാക്ട്ലി. വെരി റൈറ്റ്. നിങ്ങൾ കയറിക്കോ, സ്കിറ്റിൻ്റെ കുട്ടികൾ കയറിക്കോ. ഓൺ സ്റ്റേജ്. ഓക്കെ നീനു. 1980 അത്ര ബാക്കിലേക്ക് പോട്ടെ? 1980-ലേക്ക് പോകണോ അതോ റീസെൻ്റ് മതിയോ? ഇപ്പം അടുത്തുള്ളത് മതിയോ? 20-ൽ മതി. ഓക്കെ. സോ 2021 ഏപ്രിൽ 23rd ഏത് ദിവസാ?
ഫ്രൈഡേ.
യെസ്, യു റൈറ്റ്. ഓഡിയൻസിൽ ആർക്കെങ്കിലും ഒരു ഡേ ചോദിക്കണോ? യെസ്. വേറൊരു കാര്യം കേട്ടിട്ടുണ്ട്. 2021 ഓക്കെ, മെയ് ഇലെ വെനസ്ഡേസ് ഏതൊക്കെയാ?
മെയ്
വെനസ്ഡേ 2021-ലെ മെയ് മാസത്തിലെ വെനസ്ഡേസ് ഏതൊക്കെ തീയതിയാ?
ഏതൊക്കെ തീയതിന്ന് പറഞ്ഞാൽ നോക്കട്ടെ. അതൊരു വെനസ്ഡേസ്
മെയ് 2021-ലെ തീയതികൾ ഏതൊക്കെയാ?
5, 12, 19, 26.
എക്സാക്ട്ലി കറക്റ്റ്. 2021 സെപ്റ്റംബർ. ഓക്കെ. സെപ്റ്റംബറിലെ സൺഡേസ് ഏതൊക്കെയാ? 2021 സെപ്റ്റംബറിലെ സൺഡേസ് ഏതൊക്കെ തീയതികളാ?
5, 12, 19, 26.
പെർഫെക്റ്റ്. ഇനി ലാസ്റ്റ് ഈ മാസം എടുക്കാം. ഓക്കെ. ഈ മാസം 20 ഓക്കെ ഒക്ടോബർ. ഓക്കെ, ഞാൻ മറന്നു, നീനുവിന് ഓർമ്മയുണ്ട്. ഈ മാസം ഒക്ടോബറിലെ ഒരു തീയതി ചോദിക്കുകയാണ്. 26 ഒക്ടോബർ 26 ഏതാണ് ഡേ? 2022 ഒക്ടോബർ 26 ഏതാണ് ഡേ?
26 അപ്പൊ പിന്നെ
ഒക്ടോബർ 26
2022. ഓക്കെ, ആലോചിച്ച് നോക്കട്ടെ. വെൻസ്ഡേ.
വെരി ഗുഡ്, എക്സലന്റ്. ഇനി ലാസ്റ്റ് ഒരു കുസൃതി ചോദ്യമാണ്. ഓക്കെ. ഒക്ടോബർ 9th 2022 ഏതാണ് ദിവസം?
സൺഡേ.
വെരി ഗുഡ്, അത് ഇന്നാണ് അല്ലേ? യെസ്. ഓക്കെ. ഇനി ലാംഗ്വേജ്. നീനുവിന് എന്തൊക്കെ ലാംഗ്വേജസ് അറിയാം?
ജാപ്പനീസ്.
യെസ്.
ചൈനീസ്.
ഓക്കെ.
സ്പാനിഷ്.
വെരി ഗുഡ്.
ഫ്രഞ്ച്.
ഓക്കെ.
ഹിന്ദി.
യെസ്.
അറബിക്.
ഗ്രേറ്റ്.
പിന്നെ അടുത്തത്
മൊത്തം എത്ര ലാംഗ്വേജസ് അറിയാം നീനുവിന്?
എനിക്ക് 5-6 ഭാഷകൾ അറിയാം.
ഓക്കെ, എന്നാ ജാപ്പനീസ് വെച്ച് തുടങ്ങാം. നിന്റെ പേരെന്താ? എങ്ങനെ ചോദിക്കാം ജാപ്പനീസില്? വെരി ഗുഡ്. എനിക്കറിയില്ല കേട്ടോ.
വെൽക്കം ടു റെഡ് കാർപ്പറ്റ് എന്ന് പറഞ്ഞ ജാപ്പനീസില് ഇരസൈ മഷിനി അക്ക കാർപ്പറ്റ്.
ഓക്കെ. എത്ര വയസ്സായി എന്നെങ്ങനെ ചോദിക്കുക ജാപ്പനീസ്?
അത്
അറിയോ?
ഹലോ കൊണിച്ചിവ.
എല്ലാ ലാംഗ്വേജിലും പറഞ്ഞേ.
ഹലോ ജാപ്പനീസിൽ കൊണിച്ചിവ, ചൈനീസിൽ നീഹോ, സ്പാനിഷിൽ പിന്നെ ഓല, ഫ്രഞ്ചിൽ ബോജൂർ, ഹിന്ദിയിൽ നമസ്കാർ, എന്നത് നമസ്തേ എന്ന് പറയും. അറബിക്കിൽ പറയുന്നത് പിന്നെ അസ്സലാമു അലൈക്കും. പിന്നെ തമിഴിൽ പറയുന്നത് വണക്കം.
ഓക്കെ നീനു ടയേർഡായിട്ടുണ്ടെന്ന് തോന്നുന്നു. ഓക്കെ, ഇനി പപ്പ വരുന്നുണ്ട്. താങ്ക് യു നീനു. A big round of applause. Okay, ini oru initiation was the short film. The next was the mob skit and dance by our interns or my interns, and adana inni ningal kaanan povunu.
है सुना ये पूरी धरती तू चलाता है, मेरी भी सुन ले अर्ज मुझे घर बुलाता है। भगवान है कहाँ रे तू, है खुदा है कहाँ रे तू, है सुना तू भटके मन को राह दिखाता है, मैं भी खोया हूँ मुझे घर बुलाता है। भगवान है कहाँ रे तू, है खुदा है कहाँ रे तू।
എന്താണ് പ്രകാശം? ആരെങ്കിലും ഒന്ന് പറഞ്ഞു തരുമോ? എങ്ങനെയാണ് ഈ ലോകം കാണാൻ?
നിനക്ക് നിന്റെ കാഴ്ച തിരിച്ചു കിട്ടുന്ന ഒരു ദിവസം എന്തായാലും ഉണ്ടാകും. ഈ ലോകം കണ്ട് ആസ്വദിക്കാൻ നിനക്കും കഴിയും.
नैना जो सांझ ख्वाब देखते थे, नैना बिछड़ के आज रो दिए हैं यूं। नैना जो मिल के रात जागते थे, नैना शहर में पल के मीचते हैं यूं। जुदा हुए कदम जिन्होंने ली थी ये कसम, मिलके चलेंगे हरदम, अब बांटते हैं ये गम। भीगे नैना जो खिड़कियों से झांकते थे नैना, घुटन में बंद हो गए हैं।
നിനക്കൊരു സന്തോഷ വാർത്തയുണ്ട്. നിനക്ക് കാഴ്ച തിരിച്ചു കിട്ടാൻ പോവുകയാണ്. ഇനി നിനക്ക് ഈ വർണ്ണ ലോകത്തെ നിന്റെ കണ്ണുകൾ കൊണ്ട് കാണാം.
आशियाना मेरा साथ तेरे है ना, ढूंढते तेरी गली मुझको घर मिला। आबोदाना मेरा हाथ तेरे है ना, ढूंढते तेरा खुदा मुझको रब मिला। तू जो मिला लो हो गया मैं काबिल, तू जो मिला तो हो गया सब हासिल। मुश्किल सही आसान हुई मंजिल, क्योंकि तू धड़कन मैं दिल।
Yeah, staffs for the cultural program. Staffs. Yeah, in Amrita, take over.
ഹലോ ഹലോ ഹലോ.
Fast, na, idirtho. Fast.
അടുത്തത് നമ്മുടെ കൾച്ചറൽ പ്രോഗ്രാംസ് ആണ്. നമ്മുടെ പ്രോഗ്രാമിൻ്റെ അവസാനത്തെ ഭാഗം. ആദ്യം നമ്മളൊരു പാട്ടിലൂടെയാണ് തുടങ്ങുന്നത്. പാടുന്നത് കാർത്തിക് ആണ്. നമ്മുടെ റിഫ്രാക്ഷനിലെ ലത ചേച്ചിയുടെ മോനാണ് കാർത്തിക്.
എവിടെ കാർത്തിക്? സ്റ്റേജ്. ഓക്കെ. നെക്സ്റ്റ് ആരാ? നെക്സ്റ്റ് ഇൻ ലൈൻ അമൃത. അടുത്തത് ആരാ? അലകനന്ദ.
ക്ലാസിക്കൽ ഡാൻസ്.
അലകനന്ദ ദൃശ്യ ഇവിടെ വന്ന് നിൽക്കുക മക്കളെ. ഇവിടെ ഇരുന്നാൽ മതി. ഇവിടെ അവൈലബിൾ ആവണം. ഫ്രണ്ടിൽ വന്നിരിക്കുക. ഈ വി ഐ പികളൊന്ന് പിന്നിക്കിരിക്കോ. പ്ലീസ്. ഈ വി ഐ പികളൊന്ന് പിന്നിക്കിരിക്കോ പ്ലീസ്. നിങ്ങൾ മക്കൾ അങ്ങോട്ട് വാ. ആ എന്നാൽ അവർ ഇരുന്നിട്ട് നീ ഇരുന്നു. നിങ്ങൾ ഇവിടെ ഇരുന്നു. അത് കഴിഞ്ഞായിരുന്നാ പ്രോഗ്രാം? അടുത്ത സ്റ്റാഫ്
കൃഷ്ണപ്രിയയുടെ പ്രോഗ്രാം. കൃഷ്ണപ്രിയയുടെ സോങ്
എവിടെ? കൃഷ്ണപ്രിയ പോയിട്ട്. അത് കൃഷ്ണപ്രിയ കഴിഞ്ഞാരാ?
ഹരിയേട്ടന്റെ ടീമിന്റെ സോങ്.
ഹരി ആൻഡ് ടീം ഫ്രണ്ടിലേക്ക് വരാം. ഇവിടെ വന്നിരിക്കുക. Ready.
Click here to subscribe and bell button for latest updates.
അടുത്തത് നമുക്കൊരു ക്ലാസിക്കൽ ഡാൻസ് പെർഫോമൻസ് ആണ്. പെർഫോമൻസിനായി വേദിയിലുള്ളത് അളകനന്ദ ആൻഡ് ദൃശ്യ.
प्रणवालय पाहि परिपालय परमेशी कमलालय श्रीदेवी कुरिपिंचवे करुणाम्बुरासी धीं तारा धीं धीं तारा जतुलतो प्राणमे नाट्यं चेसे गतुलतो नामशतं मूल नतुलतो नापैननी चुकुआ पेरा
നിരകളാടും ഒരു ഹരിത ചാരുതീരം പുഴയോരം കളമേളം കവിത പാടും തീരം കായലലകൾ പുൽകും കണുവലിയുമീറൻ കാറ്റിൽ ഇളഞ്ഞാറിൻ നിലയാടും കുളിരുലാവും നാട് നിറപൊലിയേകാമെന്നരിയ നേരിനാ പുതുവിള നേരുന്നോരിനിയ നാടിതാ പാടാ കുട്ടനാടിൻ നീളം കേരനിരകളാടും ഒരു ഹരിത ചാരുതീരം പുഴയോരം കളമേളം കവിത പാടും തീരം
ഹരി, നെക്സ്റ്റ് ഹരി അല്ലേ? അടുത്തതാരാ?
അടുത്തത് ഇന്റേൺസിലെ കൃഷ്ണപ്രിയയുടെ ഒരു സോങ് ആണ്.
ചെക്ക്.
പമ്പരം തിരിയും മാനസം അറിയാതമ്പിളി മയങ്ങുവാവാ ചാഞ്ചക്കം ചാഞ്ചക്കം പനിനീർ ചന്ദ്രികേ ഇനി പൂക്കവേ കുളിരിൽ
അടുത്തത് നമുക്കൊരു സോങ് ആണ്. സോങ് പാടാനായിട്ട് ഹരിയേട്ടനെയും ടീമിനെയും വേദിയിലേക്ക് സ്വാഗതം ചെയ്യുന്നു.
ഹലോ
കൃഷ്ണപ്രിയ വാ, മെയിൻ വാ, വായോ വായോ.
ഹലോ കുറച്ച് അങ്ങോട്ട് നീക്കി.
വന്നോടി പാടത്തും കടവത്തും കാഞ്ചീനെ കണ്ടില്ല. പെണ്ണവിടെ പോയിട്ടില്ലല്ലോ, പെണ്ണവിടെ പോയിട്ടില്ലല്ലോ. ഓണവെയിൽ ഓളങ്ങളിൽ താലി കെട്ടും നേരം മറിമാൻ കിടാവേ നീ അകലെ മാറി നിൽക്കാതെന്തേ. ഓണവെയിൽ ഓളങ്ങളിൽ താലി കെട്ടും നേരം മറിമാൻ കിടാവേ നീ അകലെ മാറി നിൽക്കാതെന്തേ. ഓണവെയിൽ ഓളങ്ങളിൽ താലി കെട്ടും നേരം മറിമാൻ കിടാവേ നീ അകലെ മാറി നിൽക്കാനെന്തേ. കനവുകൾ കോരി നീ നിലവുകൾ തേവി നീ പുലരാറായതും കാണാതെ പോ. വിജനവിവീതിയിൽ പരകുറിയുന്നു ഞാൻ പ്രിയതര സൗരഭം നെഞ്ചിൽ തെന്നൽ വാരിത്തു. ഓണവെയിൽ ഓളങ്ങളിൽ താലി കെട്ടും നേരം മറിമാൻ കിടാവേ നീ അകലെ മാറി നിൽക്കാനെന്തേ. ഓണം തല്ലും കായലിൽ ഓടി വെള്ളമെങ്കിൽ വാക്കുകൊണ്ടു കെട്ടിയിട്ടല്ലോ. ഒരു മകരരാവിൽ നെഞ്ചിൽ നിറകതിരു ചാഞ്ഞിടുമ്പോൾ ഓണവെയിലോളങ്ങളിൽ താലി കെട്ടും നേരം മറിമാൻ കിടാവേ നീ അകലെ മാറി നിൽക്കാനെന്തേ. ഓണവെയിലോളങ്ങളിൽ താലി കെട്ടും നേരം മറിമാൻ കിടാവേ നീ അകലെ മാറി നിൽക്കാനെന്തേ.
അടുത്തത് ഐ ഡൊണേഷൻ തീം ബേസ് ചെയ്തിട്ട് നമ്മുടെ ഇന്റേൺസിന്റെ ഒരു സ്കിറ്റാണ്. അത് അവതരിപ്പിക്കാൻ ഇന്റേൺസ് ടീമിനെ സ്റ്റേജിലേക്ക് വെൽക്കം ചെയ്യുന്നു.
ഇത് നേത്രദാനത്തിന്റെ പ്രാധാന്യത്തെ ചൊല്ലിയുള്ള നാടകം. സുമേ, എടി സുമേ,
എന്നെ രാവിലെ തന്നെ കണ്ണ് തൊള്ള തീർന്നേ.
എന്റെ ചായ എവിടെ?
ചായ
നീ ഇത് കണ്ടോ? അബൈറ്റ് അൽസലാമയിലെ പിള്ളേര് ഐ ക്യാമ്പയിൻ നടത്തിയതിന്റെ ന്യൂസാണ് വന്നിട്ടുള്ളത്. ഇപ്പത്തെ പിള്ളേരുടെ ഒരു കഴിവേ
പറയുമ്പോ നമുക്കൊണ്ട് ഒരു മോന്, അച്ഛനെയും വേണ്ട അമ്മേനെയും വേണ്ട, 4 മണിക്കൂർ ആ ഫോണ് കുത്തി നടക്കുക. ആ പറഞ്ഞപ്പോഴേക്കും എത്തിയല്ലോ.
ആ വന്നോ?
ആ ഇപ്പൊ വരാട്ടോ, ഞാൻ വീട്ടിലെത്തിയിട്ടാണല്ലോ. അമ്മ ഞാനൊന്ന് പുറത്തു പോവാണേ, അച്ഛൻ ഞാനൊന്ന് പുറത്തു പോയി വരാട്ടോ.
ഡിങ് 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 ഡിങ്.
നമസ്കാരം മാഡം, ഞങ്ങൾ അബൈറ്റ് അൽസലാമയിൽ നിന്ന് വരികയാണ്.
നേത്രദാനത്തിന്റെ ഭാഗമായിട്ടൊരു ബോധവൽക്കരണം ഉണ്ടായിരുന്നു. അകത്തേക്ക് വരും.
എന്തായിരുന്നു വന്നത്?
സർ, ഞങ്ങൾ ഐ ഡൊണേഷനായിട്ട് ബന്ധപ്പെട്ടുള്ള ബോധവൽക്കരണത്തിന് വന്നതാണ്.
ഞങ്ങൾക്കൊന്നും ഇതിന് താല്പര്യമില്ല, ഞങ്ങൾക്ക് കേൾക്കണ്ടേ?
അയ്യോ സർ, ഞങ്ങൾ പറയുന്നതെങ്കിലും ഒന്ന് മുഴുവനായിട്ട് കേൾക്കാൻ ശ്രമിക്കൂ.
ഇനി 20-30 വർഷമുണ്ട് ഞങ്ങൾക്ക്. ഞങ്ങൾ എന്തിനാ ഇപ്പം തന്നെ നേത്രദാനമൊക്കെ ചെയ്യണത്?
സർ, ഇപ്പം തന്നെ വേണമെന്നല്ല, മരണശേഷം മാത്രമേ ദാനം ചെയ്യേണ്ടി വരുള്ളൂ. ഇപ്പം ലീഗൽ പ്രൊസീജിയേഴ്സിന് വേണ്ടി വന്നതാണ്.
പലപ്പോഴും ഇപ്പോഴുള്ള ആളുകളുടെ തെറ്റിദ്ധാരണയാണ് നേത്രദാനം എന്ന് പറയുന്നത് കണ്ണ് മുഴുവനായിട്ട് മാറ്റി വയ്ക്കുക എന്ന്. പക്ഷെ അങ്ങനെയല്ല,
കണ്ണിലെ കോർണിയ എന്ന് പറയുന്ന ഭാഗം മാത്രമേ മാറ്റിവെക്കൂ.
നിങ്ങൾ ഇന്ന് എൻ്റെ കണ്ണ് വയ്ക്കും, നാളെ ഹൃദയം വൃക്കൊന്നും ചോദിക്കില്ല എന്ന് ആരാ കണ്ടേ? ഞങ്ങൾക്കൊന്നും വലിയ താല്പര്യമില്ല.
ഇത് കൂടുതലൊന്നും എനിക്ക് പറയാൻ പറ്റില്ല, നിങ്ങൾ പുറത്തു വെക്കൂ. ആ ഇടാ നോക്ക്, ഇന്നലത്തെ പാർട്ടിയിലെ ഫോട്ടോസാ. ഇത് കൊള്ളാലോ.
എന്താ പറ്റിയേ?
എനിക്കൊന്നും കാണാൻ പറ്റണില്ല. ഡോക്ടറെ വിളിക്കോ? രാഹുലിന്റെ കൂടെ വന്നിട്ടുള്ളവരാരൊക്കെ? രാഹുലിന്റെ കണ്ടീഷൻ ഇപ്പൊ കുറച്ച് സീരിയസ് ആണ്. എത്രയും പെട്ടെന്ന് പേരൻസിനെ അറിയിക്കണം കേട്ടോ.
അയ്യോ ഇനി നമ്മളെന്ത് ചെയ്യും? അച്ഛനെ അമ്മനെ അറിയിക്കല്ലേ? നിന്റെ അടുത്ത് അച്ഛന്റെ നമ്പർ ഉണ്ടോ?
നമ്പർ ഉണ്ട്, ഞാൻ വിളിക്കാം. ഹലോ അച്ഛാ, ഇത് ഞാൻ അരുണാണ്.
എന്താ
അച്ഛാ, രാഹുലിനെ അബേറ്റിൽ അഡ്മിറ്റ് ആക്കിയിട്ടുണ്ട്. അയ്യോ ഒന്നുമില്ല, പേടിക്കാനൊന്നുമില്ല. അച്ഛനൊന്ന് വേഗം വന്നാ മതി.
സിസ്റ്റേഴ്സ്, എന്റെ മോൻ എന്താ പറ്റി അഡ്മിറ്റ് ആണെന്ന് പറഞ്ഞിട്ട് വിളിച്ചിട്ടുണ്ടായിരുന്നല്ലോ.
ഇപ്പൊ എമർജൻസി ആയിട്ട് അഡ്മിറ്റ് ആക്കി രാഹുൽ. എനിക്ക് എന്റെ മോനെപ്പോ കാണും.
ഡോക്ടറെ, ഞാൻ രാഹുലിന്റെ അച്ഛൻ. എന്റെ മോൻ എന്താ പറ്റിയേ?
അവരൊരിക്കും നിങ്ങളുടെ മോന്റെ കണ്ണിൽ കൊക്കേന് വീണതാണ്. അത് കാരണത്തെ കാഴ്ച നഷ്ടപ്പെട്ടതാണ്.
അയ്യോ, എന്റെ മോനിന് ഒരിക്കലും കാഴ്ച കിട്ടില്ലേ?
അങ്ങനെയല്ല, ഒരു സർജറി ചെയ്താൽ ഇത് കാഴ്ച തിരിച്ചു കിട്ടാവുന്നതേ ഉള്ളൂ.
അന്ന് ഇന്ന് തന്നെ സർജറി ചെയ്യാം ഡോക്ടർ. പൈസ ഒന്നും ഒരു പ്രശ്നമല്ല.
താങ്കൾ വിചാരിക്കുന്ന പോലെയല്ല, ക്യാഷിന്റെ പ്രശ്നമല്ല ഇവിടെ. കോർണിയ അവൈലബിലിറ്റി അല്ല. നമ്മുടെ നാട്ടിലെ ആൾക്കാരുടെ അറിവ് കുറവ് കാരണം തന്നെ കോർണിയ അവൈലബിൾ അല്ല.
അപ്പൊ ഇനി ഞങ്ങൾ എന്താ ചെയ്യണ്ടേ?
നിങ്ങൾ എത്രയും പെട്ടെന്ന് ഐ ബാങ്കിൽ പോയി രജിസ്റ്റർ ചെയ്യൂ കേട്ടോ.
ശരി ശരി.
മോനിവിടെ ഇരിക്കട്ടെ, അമ്മ പോരാ.
ശരി അമ്മ. അമ്മേ അമ്മേ അമ്മ എവിടെ പോയി? അമ്മേ.
അയ്യോ മോനെ, എന്നോട് നീറ്റ് നടക്കണ്ടെന്ന് പറഞ്ഞതല്ലേ, നീ ഇപ്പൊ എന്തിനാ നീറ്റേ?
അമ്മേ, കുറച്ച് നേരം കൊണ്ട് തന്നെ എനിക്ക് ഭയങ്കര ബുദ്ധിമുട്ട്, കാഴ്ചയില്ലാത്തതുകൊണ്ട്. എനിക്ക് ജീവിതകാലം മുഴുവൻ തീരെ കാഴ്ചയില്ലാത്ത ഒരവസ്ഥ. അമ്മേ എനിക്ക് വെയ്യ. അമ്മേ എനിക്ക് കാഴ്ച താ. അമ്മേ
നമുക്ക് പരിഹാരം ഉണ്ടാക്കാം. ഇവിടെ ഇരിക്കും.
പോയ
കാര്യം എന്തായി?
പോയ കാര്യം ഒന്നും ആയില്ല. ഇനി 2-3 വർഷം പിടിക്കും നമ്മുടെ മോന് കാഴ്ച കിട്ടാനെന്നാ പറയണേ. നമ്മുടെ നാട്ടിൽ ഇതിനെ കുറിച്ചൊന്നും അറിവില്ലാത്തതുകൊണ്ട് കോർണിയൊന്നും കിട്ടാനില്ല എന്നാ പറയണേ.
അപ്പോൾ നമ്മൾ എന്താ ചെയ്യുക? കഴിഞ്ഞ ദിവസം 2 കുട്ടികൾ നമ്മളടുത്തേക്ക് വന്നായിരുന്നില്ല ഇതിനെക്കുറിച്ച് പറഞ്ഞു തരാൻ. അപ്പം നമ്മൾ അവരെ വകവെച്ചില്ലല്ലോ. അതേപോലെ തന്നെ അല്ലേ കാര്യം എല്ലാവരും വീട്ടിൽ ചെന്നാലുള്ള അവസ്ഥ.
നമ്മുടെ വീടുകളിൽ അപകടം നടക്കുമ്പോഴേ നമ്മളിത് കാര്യമായിട്ട് എടുക്കണുള്ളൂ. നമ്മുടെ കാഴ്ചപ്പാട് ഇനിയും കുറേ മാറാനുണ്ട്. അതിനാൽ ഞാൻ ഇന്ന് ശപഥം ചെയ്യാണ്, ഞാൻ എൻ്റെ 2 കണ്ണുകളും മരണശേഷം ദാനം ചെയ്യുമെന്ന്, മറ്റുള്ളവരെ ദാനം ചെയ്യാൻ പ്രേരിപ്പിക്കുമെന്നും.
ഞങ്ങളും ദാനം ചെയ്യും.
അടുത്തത് നമുക്കൊരു ഡാൻസ് പെർഫോമൻസ് ആണ്. ആ പെർഫോമൻസിന് വേണ്ടി നമ്മുടെ എല്ലാ സ്റ്റാഫിനെയും വേദിയിലേക്ക് ക്ഷണിക്കുന്നു.
सनन जाए रचिया करबे की रात में चुड़ी खनकाई तूने आधी ही बात में। सनन सनन जाए रचिया करबे की रात में चुड़ी खनकाई तूने आधी ही बात में। करबे की रात पिया करके मेरा जिया कह देना आज तू है मेरे साथ में। ढोलिया ढोल वागे 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 रे, ढोलिया ढोल वागे 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 रे। तारा रंगीला तारा रंग बेर जुए तारी बात काला तारा ओए छबीला तारा ओए रंगीला तारा रंग बेर जुए तारी बात रे तो काला तारा ओए छबीला तारा ओए रंगीला तारा रंग बेर जुए तारी बात रे
ഓക്കെ, ഇതോടെ നമ്മൾ പ്രോഗ്രാംസ് എല്ലാം വൈൻഡ് അപ്പ് ചെയ്തിട്ടുണ്ട്. ലാസ്റ്റ് ഒരു ഗ്രൂപ്പ് ഫോട്ടോ എടുക്കണം എന്നുണ്ട്. എല്ലാവരും സ്റ്റേജിലേക്ക് കയറുകയാണെങ്കിൽ വേഗം ചെയ്യാം. ചെയർസ് കുറച്ച് അറേഞ്ച് ചെയ്യാനുണ്ട്. പിന്നെ പാട്ടുണ്ട് ആരുടെ? യെസ്, വിനീത മാഡം. വിനീത, യെസ്. മ്യൂസിക് സെറ്റ് അല്ലേ? രാജേന്ദ്ര, കുറച്ച് ചെയർസ് പിന്നിൽ കൊണ്ടുവന്ന് അറേഞ്ച് ചെയ്യാം.
ഹലോ, ദിവ്യ മാഡം എത്രയും പെട്ടെന്ന് സ്റ്റേജിൽ റിപ്പോർട്ട് ചെയ്യേണ്ടതാണ്. ദിവ്യ മാഡം എത്രയും പെട്ടെന്ന് സ്റ്റേജിൽ റിപ്പോർട്ട് ചെയ്യേണ്ടതാണ്. ഒരറിയിപ്പുണ്ട്. ഡോക്ടർ ദിവ്യ മേനോൻ എത്രയും പെട്ടെന്ന് സ്റ്റേജിൽ റിപ്പോർട്ട് ചെയ്യേണ്ടതാണ്. ഡോക്ടർ രാജേഷ് എത്രയും പെട്ടെന്ന് സ്റ്റേജിൽ റിപ്പോർട്ട് ചെയ്യേണ്ടതാണ്. ഡോക്ടർ രാജേഷ് എത്രയും പെട്ടെന്ന് സ്റ്റേജിൽ റിപ്പോർട്ട് ചെയ്യേണ്ടതാണ്. ഡോക്ടർ ഫാരിസ് എത്രയും പെട്ടെന്ന് സ്റ്റേജിൽ റിപ്പോർട്ട് ചെയ്യേണ്ടതാണെന്ന് പറയാൻ പറഞ്ഞു.
സാദിഖ് ഡോക്ടർ വരുന്നത് റിപ്പോർട്ട് ചെയ്യേണ്ടതാണ്. എന്ത് പാട്ട് പാടുന്ന
ഹലോ ഹലോ
അങ്ങോട്ടെത്തൂലേ? അത് അല്ലല്ല, വേറെ പാടൂട്ടാ. അതല്ല, വെറുതെ പറയാം. ഫേസ്ബുക്കില് റെഡി? അതന്നെ അതന്നെ ആ സയൻസ് ആണ്. ഓക്കെ, ഇത്ര ഉള്ളൂ. വേറെ ആൾക്കാരുണ്ടായിരുന്നല്ലോ. നിന്നോളി, പാടാറിയാത്തവർ ആർക്ക് വേണമെങ്കിൽ വരാം. സൗണ്ട് വിട്ട്, സൗണ്ട് സൗണ്ട്. ഞങ്ങൾക്ക് പാട്ടറിയില്ല, സൗണ്ട് നല്ല ഉണ്ടായിക്കോട്ടെ. ഇളമൈതോ ഇതോ ഇനിമൈതോ ഇതോ ഇളമൈതോ ഇതോ. ഹലോ ഹലോ നിന്നോട് ഞാൻ ഒരു കിന്നാരം ചോദിക്കാം. ആലാരെ ഗോവിന്ദ ആലെ ഗോവിന്ദ അങ്ങാടി പാട്ടിന്റെ മേള. ആലാരെ ഗോവിന്ദ ആലെ ഗോവിന്ദ അങ്ങാടി പാട്ടിന്റെ മേള. ഇനി മിന്നലടിക്കും മേഘത്തിൽ മിന്നുമിനുങ്ങും ഗോവിന്ദ. സങ്കരത്തിൽ പാഞ്ഞെത്തി മംഗളമരുളും ഗോവിന്ദ. ബോല ബോല നിന്നിത്താരം തൊട്ടുന്ന മേരോ മേരോ നെഞ്ചിൽ തുള്ളാട്ടം. ഗോവിന്ദ 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 ആനന്ദ ഗോവിന്ദ മഹാഗോവിന്ദ. ഗോവിന്ദ ഗോവിന്ദ ആനന്ദ ഗോവിന്ദ ആനന്ദ ഗോവിന്ദ.
ചൂടുടാ ചൂടുടാ എങ്ക പക്കം ചൂടുടാ എല്ലാരെ ഉള്ളകൾ എല്ലാരെ വയറുകൾ നീ கொஞ்சம் பண்ண திண்டா റിപ്പീറ്റ് எல்லாமே உள்ளங்கள் எல்லாமே வயறுகள் நீ கொஞ்சம் பண்ண திண்டா சத்தியெல்லாம் ஒன்று சேருதானே சொர்க்கம் வரும் இந்த மண்ணிலே దేవుడా దేవుడా ఏ మన దేవుడా దేవుడా ఏ మన దేవుడా చూడుడా చూడుడా ఎంగ పక్కం చూడుడా ഞാനും അളിയനും കൂടി വീട്ടു പറമ്പിൽ പോകുമ്പോൾ വീട്ടിൽ പറമ്പത്തോട് ചേരത്തണ്ടൻ ചീറ്റിക്കൊണ്ട് വാനെടുത്ത് വന്നപ്പോൾ കുറുമണി പോലെ ചെറുമണി കൊണ്ട് നമ്മളും വന്നേ ഞാനും അളിയനും കൂടി വീട്ടു പറമ്പിൽ പോകുമ്പോൾ വീട്ടിൽ പറമ്പത്തോട് ചേരത്തണ്ടൻ ചീറ്റിക്കൊണ്ട് വാനെടുത്ത് വന്നപ്പോൾ കുറുമണി പോലെ ചെറുമണി കൊണ്ട് നമ്മളും വെള്ളക്കാരൻ വൈപ്പമ്പ്രാക്കൻ വല്ലാത്തൊരു സൂത്രക്കാരൻ തരണ്ട പോലൊരു തീവണ്ടിയല്ലേ കൂകിപ്പായണത് ആ വെള്ളക്കാരൻ വൈപ്പമ്പ്രാക്കൻ വല്ലാത്തൊരു സൂത്രക്കാരൻ തരണ്ട പോലൊരു തീവണ്ടിയല്ലേ കൂകിപ്പായണത് കാര്യം നടത്താൻ നാട്ടാര് തൂക്കിക്കൊല്ലാൻ മൈസൈസ് തന്നെ നമ്മൾ കൊണ്ടുപോകും കോഴിക്കോട്ടേക്ക് ആ കാര്യം നടത്താൻ നാട്ടാര് തൂക്കിക്കൊല്ലാൻ മൈസൈസ് അന്നേ നമ്മൾ കൊണ്ടുപോകും കോഴിക്കോട്ടേക്ക്
മിക്സർ ഇട്ടിട്ടില്ല ഇനി അത് ഇതാണ് സൗണ്ട് മൂടല്ല ഇതല്ലേ അതിന് ഈ ഡി എം എക്സ് ഇടാന്നുണ്ടെങ്കിൽ ഓക്കെ നിങ്ങൾക്ക് ഏത് കളറിൽ ഇടാ ഈ ഡി എം എക്സ് അതിന് ഇടാണെന്നുണ്ടെങ്കിൽ ഏത് കളറിൽ ഇതാക്കാം അല്ല അത് ഒഴിവാക്കിയ പോന്നാ അത് മതിയില്ലേ ഇങ്ങനെ അതില്ലേ
Hello.
Yeah, I invite all doctors on stage. Dr. Divya, Dr. Vinita, Dr. Rajesh sir, Sadiq sir, SKR, Dr. Sanjana on stage. Dr. Divya, Dr. Vinita, photo. Rajesh sir. Center. Rajesh sir, center. center. ഇല്ല നിങ്ങൾ ഡോക്ടേഴ്സ് ഫ്രണ്ടില് ദിവ്യ ഫ്രണ്ട് വിനീത സെന്റർ ലിനി എവരിവൺ ഓൺ സ്റ്റേജ് Yeah, everyone on stage now. Everyone. SMA sir പോയിന്ന് തോന്നുന്നു. Yeah. Divya. Vinita, you can come this way. Everyone on stage. Everyone. നിങ്ങൾക്ക് വേറെ വിളിക്കണോ വരെ? Yeah. All staffs, interns of Abate AS Al Salama. all staffs, interns of Abate AS Al Salama. ഷീബ ഇപ്പം അൽ സലാമിൽ ഇല്ലേ? ഇല്ല, വന്നോ എന്തായാലും? ആര്? ഞങ്ങളുടെ പണ്ടൊരു മെമ്പർ ഉണ്ടായിരുന്നു. ഇപ്പോൾ അൽ സലാമിലല്ല എന്ന് അവൻ്റെ വിചാരം. എവിടെയാണ്? ലൈവ് കട്ട് ചെയ്തോ, ലൈവ് കട്ട്. വിളിച്ചോ. നമ്മളുടെ നീനുവിൻ്റെ ക്രൂവിൽ വർക്ക് ചെയ്തവരൊക്കെ എല്ലാവരും ഇന്ന് നിങ്ങളൊക്കെ ഇതിൻ്റെ ഭാഗമാണ്. കുട്ടികളിവിടെ ഹലോ. ഞാൻ ആദ്യം അവർ കയറിയിട്ട് പിന്നെ ബാക്കി എല്ലാവരും വിളിക്കാം. അവരും കൂടി കയറിയിട്ട് ഫിറ്റായിട്ട് പിന്നെ ബാക്കിയുള്ളവർ കുറച്ച് താഴെ ഇരിക്കാം. ഇനി നിങ്ങൾ ഇന്റേൺസ് ഇവിടെ മുന്നിൽ ഇരുന്നോളൂ. ഇരുന്നോ. അല്ലെങ്കിൽ ഇവിടെ ഇരുന്നോ, ചെയറിലിരുന്നോ. ആരെങ്കിലും ഇരിക്കേ, 2 ചെയർ ഫ്രീയാ. എന്നാൽ ലീഡർ ഇരിക്കേ. ലീഡർ ഇരുന്നോ, ഇരിക്കാൻ ബുദ്ധിമുട്ടുള്ളവർ ഇരുന്നോ. രാജേന്ദ്രൻ വാ. രാജേന്ദ്രൻ, ഫെബിൻ സർ, അല്ല ഫെബിൻ വാ. അവിടെ ഡോക്ടേഴ്സ് ഇരിക്കുന്നു, ശ്രദ്ധിക്കുക. നീ അവിടെ ഇരുന്നോ. ചെയർമാൻ നിന്നോട്ടെ, കുറച്ച് പേര് ചെയറിൽ നിന്നോട്ടെ. ചെയർമാൻ നിന്നോട്ടെ. ചെയർ ബാക്കിക്ക് പാസ് ചെയ്തേ. അവിടെ ഇരിക്കുന്ന ഡോക്ടേഴ്സിന് ബുദ്ധിമുട്ടാവാതെ ഒരു ചെയർ ബാക്കിക്ക് പാസ് ചെയ്യുക. അതിന് കുറച്ച് പേര് നിന്നോളൂ.
മാറുന്ന ലോകത്തിൽ മാറ്റമില്ലാതെ തുടരുന്ന വിശ്വാസത്തിന് ഇനി പുതിയ പേര്. അൽ സലാമ ഐ ഹോസ്പിറ്റൽ ഇനി മുതൽ അബേറ്റ് AS. അൽ സലാമ ഐ ഹോസ്പിറ്റൽ. നിങ്ങളുടെ വിശ്വാസം ഊട്ടിയുറപ്പിച്ച അതേ ടീം, അതേ മാനേജ്മെന്റ്, അതേ ഡോക്ടർമാർ. മാറുന്നത് പേര് മാത്രം. ആരോഗ്യ മേഖലയിലെ നൂതനമായ ടെക്നോളജിയെ ധാർമ്മികമായി നിങ്ങളിലേക്ക് എത്തിക്കാൻ അബേറ്റ് AS. അബേറ്റ് AS. അൽ സലാമ ഐ ഹോസ്പിറ്റൽ. അഡ്വാൻസ്ഡ് ആൻഡ് എത്തിക്കൽ. മാറുന്ന ലോകത്തിൽ മാറ്റമില്ലാതെ തുടരുന്ന വിശ്വാസത്തിന് ഇനി പുതിയ പേര്. അൽ സലാമ ഐ ഹോസ്പിറ്റൽ ഇനി മുതൽ അബേറ്റ് AS. അൽ സലാമ ഐ ഹോസ്പിറ്റൽ. നിങ്ങളുടെ വിശ്വാസം ഊട്ടിയുറപ്പിച്ച അതേ ടീം, അതേ മാനേജ്മെന്റ്, അതേ ഡോക്ടർമാർ. മാറുന്നത് പേര് മാത്രം. ആരോഗ്യ മേഖലയിലെ നൂതനമായ ടെക്നോളജിയെ ധാർമ്മികമായി നിങ്ങളിലേക്ക് എത്തിക്കാൻ അബേറ്റ് AS. അബേറ്റ് AS. അൽ സലാമ ഐ ഹോസ്പിറ്റൽ. അഡ്വാൻസ്ഡ് ആൻഡ് എത്തിക്കൽ.
Abate AS, formerly known as Al Salama, is reaching new heights in the realm of eye care and education sectors in India and is the first BSE-listed company headquartered in northern Kerala. Al Salama was established in Perindalmanna in 2004 and has tremendously grown both within and outside of Kerala. Abate AS Hospitals and Opticals are renowned for providing top-notch services that earned trust and loyalty from many walks of life. The group also operates optometry, architecture, business management, interior designing and fashion designing colleges. Abate AS is opening a new world of opportunities with an ambition to open a network of 44+ eye hospitals, optical centers and educational facilities across India, Europe and the GCC. The group is ready to venture into real estate, jewelry and other fast-growing sectors, enabling sustaining investment and revenue prospects. Under the leadership of Dr. Advocate Shamsuddin Arikurian, Chairman of Abate AS Group of Companies, the dynamic and forward-thinking team, Abate AS is moving into new horizons. Abate AS Group of Companies. Grow together.
പുതുതലമുറയ്ക്ക് അനന്തമായ തൊഴിലവസരങ്ങൾക്കും സുരക്ഷിതമായ ഭാവിക്കും വേദിയൊരുക്കിയ അൽ സലാമ ഇൻസ്റ്റിറ്റ്യൂഷൻസ് ഇനി അബേറ്റ് AS അൽ സലാമ ഇൻസ്റ്റിറ്റ്യൂഷൻസ് എന്ന പേരിൽ ഒപ്റ്റോമെട്രി, ആർക്കിടെക്ചർ, ബിസിനസ് മാനേജ്മെന്റ്, BSc ഫാഷൻ ഡിസൈൻ, BSc ഇന്റീരിയർ ഡിസൈൻ എന്നീ മേഖലകളിൽ ഇനി നിങ്ങൾക്കും ഭാവി കെട്ടിപ്പടുക്കാം. മാറുന്ന പേരിനൊപ്പം വിദ്യാഭ്യാസ രംഗത്തെ പുതിയ മാറ്റങ്ങളിലേക്ക് വഴിതെളിക്കാൻ അബേറ്റ് AS ഇനി നിങ്ങളോടൊപ്പം. അബേറ്റ് AS അൽ സലാമ ഇൻസ്റ്റിറ്റ്യൂഷൻസ്. ലേൺ ടു ഗ്രോ. പെരിന്തൽമണ്ണ, കാലിക്കറ്റ്, കണ്ണൂർ, കോയമ്പത്തൂർ. പുതുതലമുറയ്ക്ക് അനന്തമായ തൊഴിലവസരങ്ങൾക്കും സുരക്ഷിതമായ ഭാവിക്കും വേദിയൊരുക്കിയ അൽസലാമ ഇൻസ്റ്റിറ്റ്യൂഷൻസ് ഇനി അബൈറ്റ് AS അൽസലാമ ഇൻസ്റ്റിറ്റ്യൂഷൻസ് എന്ന പേരിൽ ഒപ്റ്റോമെട്രി, ആർക്കിടെക്ചർ, ബിസിനസ് മാനേജ്മെന്റ്, BSc ഫാഷൻ ഡിസൈൻ, BSc ഇന്റീരിയർ ഡിസൈൻ എന്നീ മേഖലകളിൽ ഇനി നിങ്ങൾക്കും ഭാവി കെട്ടിപ്പടുക്കാം. മാറുന്ന പേരിനൊപ്പം വിദ്യാഭ്യാസ രംഗത്തെ പുതിയ മാറ്റങ്ങളിലേക്ക് വഴിതെളിക്കാൻ അബൈറ്റ് AS ഇനി നിങ്ങളോടൊപ്പം. അബൈറ്റ് AS അൽസലാമ ഇൻസ്റ്റിറ്റ്യൂഷൻസ്. ലേൺ ടു ഗ്രോ. പെരിന്തൽമണ്ണ, കാലിക്കറ്റ്, കണ്ണൂർ, കോയമ്പത്തൂർ. പുതുതലമുറയ്ക്ക് അനന്തമായ തൊഴിലവസരങ്ങൾക്കും സുരക്ഷിതമായ ഭാവിക്കും വേദിയൊരുക്കിയ അൽസലാമ ഇൻസ്റ്റിറ്റ്യൂഷൻസ് ഇനി അബൈറ്റ് AS അൽസലാമ ഇൻസ്റ്റിറ്റ്യൂഷൻസ് എന്ന പേരിൽ ഒപ്റ്റോമെട്രി. കണ്ണുകൾക്ക് കൂടുതൽ നിറമുള്ള കാഴ്ചകളേകാൻ പുതുമയുള്ളൊരു പേര്. ഷോൺ ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ അബൈറ്റ് AS ഒപ്റ്റിക്കൽസ്. ലേറ്റസ്റ്റ് ഡിസൈനുകളോട് കൂടിയ പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺഗ്ലാസുകളും അഫോർഡബിൾ പ്രൈസിൽ സ്വന്തമാക്കാം. ഇനി കണ്ണു തുറക്കാം പുതുമയുടെ പുതിയ ലോകത്തേക്ക്. അബൈറ്റ് AS ഒപ്റ്റിക്കൽസ്. ഒറിജിനൽ, സ്റ്റൈലിഷ്, അഫോർഡബിൾ. കണ്ണുകൾക്ക് കൂടുതൽ നിറമുള്ള കാഴ്ചകളേകാൻ പുതുമയുള്ളൊരു പേര്. ഷോൺ ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ അബൈറ്റ് AS ഒപ്റ്റിക്കൽസ്. ലേറ്റസ്റ്റ് ഡിസൈനുകളോട് കൂടിയ പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺഗ്ലാസുകളും അഫോർഡബിൾ പ്രൈസിൽ സ്വന്തമാക്കാം. ഇനി കണ്ണു തുറക്കാം പുതുമയുടെ പുതിയ ലോകത്തേക്ക്. അബൈറ്റ് AS ഒപ്റ്റിക്കൽസ്. ഒറിജിനൽ, സ്റ്റൈലിഷ്, അഫോർഡബിൾ. കണ്ണുകൾക്ക് കൂടുതൽ നിറമുള്ള കാഴ്ചകളേകാൻ പുതുമയുള്ളൊരു പേര്. ഷോൺ ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ അബൈറ്റ് AS ഒപ്റ്റിക്കൽസ്. ലേറ്റസ്റ്റ് ഡിസൈനുകളോട് കൂടിയ പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺഗ്ലാസുകളും അഫോർഡബിൾ പ്രൈസിൽ സ്വന്തമാക്കാം. ഇനി കണ്ണു തുറക്കാം പുതുമയുടെ പുതിയ ലോകത്തേക്ക്. അബൈറ്റ് AS ഒപ്റ്റിക്കൽസ്. ഒറിജിനൽ, സ്റ്റൈലിഷ്, അഫോർഡബിൾ. കണ്ണുകൾക്ക് കൂടുതൽ നിറമുള്ള കാഴ്ചകളേകാൻ പുതുമയുള്ളൊരു പേര്. ഷോൺ ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ അബൈറ്റ് AS ഒപ്റ്റിക്കൽസ്. ലേറ്റസ്റ്റ് ഡിസൈനുകളോട് കൂടിയ പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺഗ്ലാസുകളും അഫോർഡബിൾ പ്രൈസിൽ സ്വന്തമാക്കാം. ഇനി കണ്ണു തുറക്കാം പുതുമയുടെ പുതിയ ലോകത്തേക്ക്. അബൈറ്റ് AS ഒപ്റ്റിക്കൽസ്. ഒറിജിനൽ, സ്റ്റൈലിഷ്, അഫോർഡബിൾ. കണ്ണുകൾക്ക് കൂടുതൽ നിറമുള്ള കാഴ്ചകളേകാൻ പുതുമയുള്ളൊരു പേര്. ഷോൺ ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ അബൈറ്റ് AS ഒപ്റ്റിക്കൽസ്. ലേറ്റസ്റ്റ് ഡിസൈനുകളോട് കൂടിയ പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺഗ്ലാസുകളും അഫോർഡബിൾ പ്രൈസിൽ സ്വന്തമാക്കാം. ഇനി കണ്ണു തുറക്കാം പുതുമയുടെ പുതിയ ലോകത്തേക്ക്. അബൈറ്റ് AS ഒപ്റ്റിക്കൽസ്. ഒറിജിനൽ, സ്റ്റൈലിഷ്, അഫോർഡബിൾ. കണ്ണുകൾക്ക് കൂടുതൽ നിറമുള്ള കാഴ്ചകളേകാൻ പുതുമയുള്ളൊരു പേര്. ഷോൺ ഒപ്റ്റിക്കൽസ് ഇനി മുതൽ അബൈറ്റ് AS ഒപ്റ്റിക്കൽസ്. ലേറ്റസ്റ്റ് ഡിസൈനുകളോട് കൂടിയ പ്രിസ്ക്രൈബ്ഡ് ഗ്ലാസുകളും സൺഗ്ലാസുകളും അഫോർഡബിൾ പ്രൈസിൽ സ്വന്തമാക്കാം. ഇനി കണ്ണു തുറക്കാം പുതുമയുടെ പുതിയ ലോകത്തേക്ക്. അബൈറ്റ് AS ഒപ്റ്റിക്കൽസ്. ഒറിജിനൽ, സ്റ്റൈലിഷ്, അഫോർഡബിൾ.